Going live in another 10 seconds. Yeah, so it's 3, 2, 1. We are live to the audience platform. We can start this meeting. Over to you, ma'am.
Hi and namaste from India. It's a beautiful Friday morning in Goa and welcome to India's first virtual metabolic health conference, Low Carb Across the Globe. I'm your host, Ira Sahai, a metabolic health coach based out of Mumbai, India. It is my absolute and great pleasure to be lead hosting this grand event today, India's first low carb conference with 47 top global speakers, doctors, and organizations from 15 countries across 46 sessions and 12 hours each day across 3 days. Some of the top names, doctors, and organizations working in the low carb nutrition and metabolic health space are all going to be speaking in this conference. Each session is going to be an eye opener that will give you deep insights on metabolic health, the mainstream messaging, the myths related to diets, and everything else that you ever wanted to know. Let me welcome the chief guest of this event, Mr. Dilip Cherian, who's here with us live. Can we have Dilip on the screen?
Thank you.
Welcome, Dilip. Thank you for being with us here today.
Thank you.
Dilip is the iconic image guru of India, the man behind many of the biggest brands and people. Dilip is the man who works to enhance the narratives of corporations, celebrities, political parties, and assorted others. His interest in diets was refined during a brief stint as a restaurateur when he saw the nuances of personal preferences and served fabled desserts. He believes now that the gut biome holds the key to every individual's future, both physical and emotional. I welcome you, Dilip, and request you to say a few words about this grand event and inaugurate the conference.
Thank you, Ira. I'm delighted to be with the team that is putting together this historic event, India's first virtual metabolic health conference, low carb across the globe. I'm also delighted to be, in a sense, part of the team with Shashikant Iyengar, the well-known accredited metabolic health coach, and Anup Singh, the founder of BeLife, India's only award-winning low-carb platform. And this is the pioneering platform for low carb in India. But I'm here because I believe that people like Ira Sahai, who also happens to be my metabolic coach, are all working in niches with people who they are working with. And the world needs a platform where lots of people can understand the problem that's being tackled. India is just one country that is plagued by the metabolic syndrome. It's an epidemic here, with diabetes now at 101 million and pre-diabetics at 136 million. The burden of ill health is something that countries don't recognize and understand. I just read a frightening statistic that over 60% of Americans are obese. So the growth rate in each of the illnesses associated with any of these things is frightening. The reason I believe in the gut biome and the reason I believe in understanding the nature of inflammation and things like that are leading me to believe that curiosity must always be met with technical people who have understanding. And I think the 46 sessions across 3 days is a heroic effort. But I would not be doing justice to my experience as an image guru if I didn't leave you with one word that hopefully will resonate with all of you. Each of you work within the silos of the people who you reach and interact with. Please spend more time putting out success stories told by the people who actually have experienced the change. Please put out new research. Please spend a lot of time making sure that people outside your immediate reach have access to the wonders which you have discovered. Ira promises me that each of these sessions is going to be the equivalent of reading a bunch of books. In these fast-moving days, we don't have the time to read as many books as we ought to. But I hope that attending the sessions that you can over these 3 days will be a life-enhancing experience for all of you. Spend time sharing, because as the kids tell us, sharing is caring. So you need to spend time making sure your message gets out to a wider world, and that the wider world has the opportunity to ask experts like you questions. So it gives me great pleasure to declare this conference open. Thank you.
Thank you, Dilip. Thank you so much for these absolutely encouraging words. Thank you for being here. Thank you for associating with us. And thank you for everything that you said today. We promised we would try and reach out to more and more people. In fact, the conference itself is a service to India, to the people of India. And such a thing has never been held before. So our initiative and our effort is all directed towards the fact that we do need to, and we do realize that we need to and want to reach out to more and more people. Thank you so much for being here. Okay, let's begin our first session today, the first session of the Low Carb Conference with Shashikant Iyengar. For those, many of you would be familiar with Shashi's name, but let me give a brief introduction to Shashi. Shashikant Iyengar is India's most certified and SMHP accredited metabolic health coach. He's one of the senior most members of India's only low carb platform, DLife.in, and the man behind this event, and the co-organizer, along with the founder of DLife.in, Anup Singh, of the first low carb conference, India's first low carb conference. Welcome, Shashi, and please tell us, how and why did you think of organizing this very critical metabolic health conference in India?
Thank you. Thank you very much, Ira, for having me on the session. And first of all, pranam and thank you to my guru, Anup Singh. So Ira, this was a dream which we had right from 2017. Me and Anup, we were always thinking that we should be holding such a conference, because we have seen a lot of such conference happening abroad in US and in Europe and in many countries in Australia. So we thought, why not we have it in India? Initially, we thought of having it physical, but then later on, during the COVID time, we realized that virtual world is open to us and we can do something virtually. And then what happens was, like, since I was also employed, so I couldn't do. And the moment I left my corporate job into full-time as a metabolic health coach, then immediately within a couple of months, we decided that we will hold this conference. Immediately, we fixed up a date, we announced, and then we started it. And I think this is something which we owe to India. We should be doing such a conference, because these conferences will actually show us that there is an option beyond pills. Now, I'm not against pills, because I'm from pharma. I've been selling all this medication for 35 years. I think everything has a role in human health. However, for those who think that they want to control metabolic disorders like diabetes, blood pressure, obesity, and many various other disorders, there is an option where you can either get off pill or you can lower it. And hence we thought that we will hold this conference.
Yeah. Shashi, that brings me to the next question, which naturally is, how is it so much relevant for India today, looking at the metabolic syndrome numbers that we have? And would you care to explain why is it that it is so relevant for India, especially?
I think in the inauguration, Mr. Cherian has already rattled out the numbers, the frightening numbers. More than 100 million cases with diabetes, 136 million with pre-diabetes, 36% of the population may be having high blood pressure. The incidence of obesity, childhood obesity, fatty liver, everything is very high. And we are not counting insulin resistance at all, because usually insulin resistance is not at all measured. So I think such programs where we advocate a low carbohydrate nutrition or lowering the carb to whatever extent will help manage most of the diseases, and it will also help us understand that we can also prevent the full-blown, for example, we can prevent the full-blown diabetes by measuring insulin resistance and taking appropriate action. Now, what is appropriate action? That is lowering down your specifically your quick ultra-processed carbohydrates and excess sugars we can do. So I think India is in need for an alternate option to control metabolic disorder other than pills. So this is the main objective.
Yeah. Looking at the grandness and the grandeur of this event, Shashi, it just astonishes me the kind of lineup that you have, managed to assemble. The top speakers, the global doyens, as I always say, they're there. How did you manage to get all of them under, one roof on one platform, and at such a short notice?
See, I think first of all, I should be thanking all these speakers who have agreed to come on this platform and grace the occasion on the India's first ever low carb event which you are having. And I will say that this is a culmination of effort of last 8 years. Me and Anup, we are well known in the international circle, and in the last many years or last few years at least, we have gained a lot of credibility, and our networking is very strong. Additionally, because I have done also a lot of courses, like I have done a lot of courses on nutrition network, SMHP accreditation, I am also well known. So, and the world over, the low carb nutrition committee people, they were actually looking forward for someone doing this program. So who will do? It is only us. We are the pioneers. In DLife, we are the pioneers who can do this.
Yes.
So who else will do?
Yeah. And how is it, Shashi? I mean, I can never wrap my head around. Maybe you can dwell on it a bit. How is it that such an event was never thought of in the Indian context? Never done.
I think,
we are.
yeah. So like coming back to the point again, see, I don't know if someone has ever thought of it, but then no one has that international connect to do this. And Ira, if you see, we have fixed this in a very short term. Secondly, we had the knowledge of who is going to speak on what topic. And this is again the effort of what we have done for the last 8 years. We know that this particular doctor will come and speak on this particular doctor. And let me come back to the main theme of this program, that is low carb across the globe. I had or rather me and Anup, we had the vision of getting in maximum countries in this program. So we have 15 countries or 15 flags flying high. And we wanted to show to the world that there are medical doctors who are either practicing or advocating low carbohydrate nutrition, and that includes India also. So we have included sizable amount of doctors from India also who are either into full-time low carb nutrition, or they refer cases to many of us and they support low carb nutrition. So we have gathered all of them, and fortunately everyone responded very well. So I'm so touched by the love shown by the international community, and they were all waiting for someone from India to do. They are also so happy to see that someone has taken this initiative in India, and which we have done.
I'm sure. Shashi, there are so many sessions, 46 of them, and top speakers are there. I mean, as I said to Mr. Dilip Cherian, each session is worth reading many books. Why, for a first timer, for such an event is being done for the first time, were there any inhibitions that there would be 46 sessions? Why are there so many sessions? What was the idea behind it?
We have approached many medical doctors and many organizations. Actually, there are a lot of organizations which are also doing a good work on the low carb front. We invited them. Now, this was the first program, and while organizing, I also got a lot of recommendation that many doctors have come forward and told that please take us in this session, because in this first event, because this is happening for the first time and we don't want to miss. I really wanted to accommodate as much as possible. So I think 12 hours is the maximum we can squeeze. Yes. Let me tell you, Ira, I already have 20 to 25 medical doctors, speakers ready for second event also. I mean, it is so overwhelming. And we thought that, okay, we will accommodate as much as possible. We started with just an 8-hour concept, 8 hours per day, which really stretched to 12 hours. We didn't want to disappoint any doctor or any organization. And we kept on stretching till I think 12 hours is the maximum we can stretch.
Given the the lineup and everything about this conference, Shashi, you decided to keep it free. Tell us why.
See, I think this is a joint decision between me and Anup Singh of D-Life. We thought that this is an inaugural program, and no one should be deprived of attending this. No one. I don't even want to spend 1 rupee on this. I don't want people to spend 1 rupee on this. I don't want anyone to be deprived. Let them see. This platform itself, thanks to Imagica, this has the capacity to hold 5 to 10,000 viewers at a time. We are also live streaming it in YouTube. Millions can see. And not only from India, people globally can come in and see. So we thought that this is a small service we can do for India. What is the point? See, people charge for everything. And in our individual coaching sessions, we also charge. But we thought that this dissemination of information, it should be free of cost for everyone. People should see the top brains of the world coming in and telling that low carbohydrate nutrition is a safe option. And we are going to dispel or burst many myths in these 3 days.
I believe all sessions are very relevant, Shashi, but in the Indian context, if you would want to point out a few sessions that people must watch and not miss, would you be kind enough?
I frankly, it is very difficult for me to choose anything, frankly, because it will appear like favoritism. Because let me tell you that each and every session is designed for everyone. Each and every session. Please don't miss. Who's going to speak on this? We have endocrinologists, we have gynecologists, we have orthopedicians, we have surgeons, we have GPs, we have cardiologists who are going to come to this session. I don't want to really show that this is important, this is not. I feel that, or I believe that the entire 46 sessions are very, very important for all of us. And I know that people cannot log in for 12 hours and see. So people can pick and choose whatever session they want, whichever that interests them. But we are going to be here for 12 hours in this seat. So we are going to have a 12-hour fasting. Each one of us, the organizers.
Yeah. So, Shashi, I'm sure we are going to burst many myths, and I think we are going to change the way we look at nutrition and metabolic health after this conference. What do you foresee, the next step, the next logical step after this metabolic conference, health conference going to be?
See, this is the beginning. We are going to hold more such conferences. So this is the beginning, but not the end. We might hold physical ones. And we will hold more advanced sessions. Now this is going to be introductory into low carb. It is a broad introduction. We are going to have more specific sessions, the application of ketogenic diet in various metabolic specific disorders. It's all in the planning stage, and we have speakers ready. So the next culmination of the effort is like we are going to have more sessions. We will also do physical sessions because there's a lot of demand for physical session, and we will hold it. And at this occasion, let me tell you that to everyone that currently we are hosted in Taj Siddharthi, Goa, and we are being treated with very nice low carb keto meals, keto snacks and everything. So if at all we are going to have a future event, we will be having it in this group where we'll be served all ketogenic meals or low carb meals or whatever is our preference. So thank you very much again. At the start itself, let me thank Taj Siddharthi, Goa.
Yeah. So Shashi, just stay tuned. I would like to have Mr. Arun Kumar on the screen as well. Can we have him on the screen, please? Yeah. Let me introduce Mr. Arun Kumar. Arun Kumar is one of the senior most members of India's only low-carb platform, dlife.in. Arun has spent 35 years in pharma, was diagnosed with diabetes in 1995, and now lives a pill-free life. Thanks to following a low-carb diet protocol after joining D-Life in 2015. Very shortly, he became grain-free and lentils-free. He stopped eating them and is now, surprisingly, a full-blown carnivore. I'm very proud to say that Arun is also now under my coaching for the carnivore diet protocol. I'd like to welcome Arun.
Thank you, Ira. Thank you. Actually, let me say something about the D-Life first, then other things. Actually, I have been diagnosed diabetes in 1995, and having the pharma background, I have a lot of faith with the pills and injections and all. And I used to take pills for my diabetic remission. But unfortunately, till 2012, my diabetic drugs were going increasing. Then I was searching for that. And I made Anup Singh on a different platform, that is a UK-based platform, and they are dealing with the diabetes. There I came to know there is some other way also to remit or to reverse your diabetes. So I joined after the D-Life founded in the August 2014. I joined it in the March 2015, just 6, 7 months back after that. And I'm very much impressed with the Anup Singh's way of dealing and restricting the carbohydrate. He gave me the formula of 100 gram carb per day is to be restricted for the diabetes. And it has a lot of response to my blood sugar. So I decided within 6 months to be grain free, another 2, 3 months with lentils free, and slowly my diabetic medicines were reduced, and now there is no diabetic medicine I'm taking.
Okay.
For,
How
yeah.
low carb change your life? Because you followed low carb after you met Anup Singh and came into D-Life. How do you think that has changed, the low carb nutrition has changed your life?
See, I just want to tell you one thing that in 2012, when I was visiting my Indo, he told me that if your blood sugar will not be in control, so next time I have to prescribe insulin so that it should be controlled. That was the alarming bell in my mind. And then I start searching. Then I met Anup Singh and he told me on low carb. Low carb had changed everything in my life. First, I get rid of all the meds. Second, I get healthy. I am having more energetic. And look-wise also people are saying that you are looking younger than earlier. So these are the things low carb has changed. But basically it has changed my blood sugar control. It has changed my HbA1c, etc., etc.
Yeah.
I'm here. One thing I just like to point. I have a lot of regard for Anup Singh and Shashi because they are the old member of the D-Life along with me, and they are guiding also me how to move and how to change this diet schedule. That's what. Yeah.
We are kickstarting a very critical event today, Arun. What are your thoughts about on the Metabolic Health Conference that India is seeing for the first time? Tell us a little.
Mira, this is a historic event, and I would like to say this is India is watching first time such event in India because so far actually we are planning and Sashi and Anup are the main pillar of this event. They were planning and I know something about that, but it was really very great effort by the Sashi and Anup to bring all these top-notch speakers of the world on the low carb field and they will speak it up. So in my view, this will be the one of the landmark in Indian low carb field, low carb side. So I just hope that people of India should watch and should get benefit of this event because you also know, I also know, and others also know, India is quite metabolic unhealthy. Almost, I think, more than 100 million people are having diabetic, and more will come. This is the one side. Apart from this, other metabolic syndromes like hypertension, thyroid, and then mental disorder also, all are related to the low carb. So India will be benefited from.
Thank you so much, Arun. Please stay tuned. I'll come back to you. But I would like to take Anup onto the screen, please. Can I have him? Yeah. Welcome, Anup. My next guest, as I said, Anup Singh is a very special man. Those who have watched the podcast or those who have known him would know this. But for the benefit of viewers who are not familiar, let me give a brief introduction to Anup. Anup is the founder of India's only low-carb platform, dlife.in. He's an engineer and a gold medalist from the distinguished IIT Roorkee. He was diagnosed with diabetes in 2011, but now lives a pill-free life, thanks to his own idea of a low-carb diet in the Indian context. In 2014, Anup founded D-Life. Anup is also the man who pioneered the idea of 100-gram carbs per day in a low-carb diet for Indians for diabetes remission. This idea changed the scene of diabetes in India from being a vegetarian initially to going grain-free and then becoming an ovo-vegetarian. Anup is now a full-blown carnivore too, and I'm very proud to say that I'm his coach too for the carnivore protocol. Let's meet the founder of D-Life and the co-organizer of India's first low-carb conference, Anup Singh. Welcome, Anup.
Thank you, Ira. Thank you, my coach.
So let's begin by asking you, how and when did you found D-Life?
See, my diabetic history is from February 2011. Now, from February 2011 till I think end of 2013, I was experimenting with the idea of low carb, finally settling it down with 100 grams per day. Now, once I was successful for more than 2 years, in fact. So I thought, to take this movement forward on a mass scale. Now, the only way to do it on a mass scale is have online presence. And the first step in that direction was to launch the community. So August 2014, we launched the community, and the basic idea was to spread the message of low carb done the Indian way, because Western way, it would not work. So that's it.
Okay. Tell us the unique features of D-Life. It is India's only low-carb platform. It is India's only award-winning low-carb platform. Would you like to tell us about the unique features we have on the D-Life platform?
See, as far as the features are concerned, I don't think, as of today, there would be any parallel community in the world having all the features under one roof. Now, to highlight few of them, over the years, I mean, it's about 9 years of curated data. So 1200 plus is the Indian keto, low carb, vegetarian, non-vegetarian, carnivore recipes posted by members. So that's one plus point, which I mean, I would say that it cannot be found anywhere in the world. Now, the second was that the amount of success stories that we have, not just of diabetes. Diabetes is just one of them. Diabetes, hypertension, GERD, right? And fatty liver, obesity. I mean, if you talk of any disease connected with metabolic disorder, there is a solution. And that solution is low carb for Indians done the Indian way, which is, I would say, the D-Life's way. Now, as far as the credibility goes, there are three distinguished speakers who would be speaking in this year's conference. Now, Dr. Anwin, Dr. Gary Fetke, and Professor Tim Noakes. They have sort of, I would say, reviewed the platform. Now I call it platform. Earlier we used to call it, just a community. So if they have reviewed and have all positive comments to make, there's nothing more that I would like to say as far as the credibility of the platform goes. Yeah.
So, would you like to talk about the low-carb nutrition coaches that are currently associated with the D-Life platform, about the course? Yeah, I was just going to come to the course, Anup, but let me also talk about, the other resources. You talked about the validation and the endorsement that we have from Professor Tim Noakes and other doyens who are also coming to speak at the conference. But tell us about the how we became the award-winning low-carb platform, the only low-carb platform in India, because that is what is our USP. That is what I would want you to talk about.
Yeah, as far as the course is concerned, I think 2019 American Diabetes Association and other associations across the world, they started talking of low carb and very low carb as an option to be given to diabetics primarily. So that was a time when we thought, it's about time that we also have some course done the Indian way for Indians. And the major, I would say, the aim was to build an army of low carb coaches, because as Dilip and Shashi and everybody has said, the metabolic health crisis in India is unparalleled across the world. So right now, I think if I would be very conservative in terms of success stories, I would put the number at 3,000 plus. So, and as far as the team is concerned, yes, now I think 30 numbers they have certified, and the course is getting popular across the world, 6 nations, including India. We have got enrollees from there, and it's picking up, no doubt. And the uniqueness of the course is that post completion support is also there, which no other course in the world would ever provide. Because once you are certified, once you get your certificate, you're on your own. Now, as compared to them, we have got a dedicated community where all the enrollees and all those certified, whenever they want, they can, post their queries, get help. And as far as the content of the course is concerned, I would again say it is the most exhaustive one, and not just restricted to few articles uploaded or few videos uploaded. It's a text-based learning management system, I would call it. And if I could spell out the statistics, then yes, about more than, I think, 210,000 of words, 800 plus references. I guess around 70 odd videos, and we are not going to sit on that course. Once it is done, time to time we keep on upgrading the content also.
I think you could talk a bit more about how we are able to, or how the certified low carb coaches are able to remedy diseases on a low carb diet, because the course focuses on metabolic diseases remission through nutritional intervention. So how is it that we are able to see so many success stories in our community? You just talked about 3,000 plus combined success stories of D-Life coaches, and that's a huge number. So what is it that we are doing differently?
What we are doing differently is, as you already mentioned in the intro, that our focus or our foundation is on 100 grams carbohydrate limitation per day. Now that works in 80% of the cases, it works. But for cases which have, a long history, they have to come down to 50 grams, maybe 30 grams, or shifting from low carb to keto. Now, in Western world, low carb and keto is used interchangeably. Out here, keto is just a small subdomain of low carb. Now, why does it work? I would say, if I draw a parallel with somebody having nut allergy, the doctors would say, please stop nuts. They would not say that you keep eating nuts and carry an EpiPen injection 24/7. So likewise, diabetes, in a layman terms, I would say you are allergic to carbohydrate beyond a certain limit. So to be successfully managing it, you have to limit your carbohydrate to the threshold that we specify, which is 100 grams per day, split across 3 meals max.
Okay. I would like to take Shashi into the discussion right now. Shashi, can you unmute yourself? Yes.
Yeah.
Yeah, Shashi, we were just talking about the D-Life diploma course. Would you like to talk a bit about how, being one of the pillars of D-Life, you and Arun and Anup came up with the diploma course, and what was the idea behind it?
See, this is basically the idea of Anup Singh, of course. But then we were all there, we were all contributing something or the other. And I think I'll take a minute to, proudly show the certification, D-Life certification, which I got it back in 2020 when Anup had launched.
Wow.
So this is something which we hold with pride, and there was a need for such course in India, because the mainstream does not teach anything on low carb nutrition. Whereas if you really see, low carb nutrition is now endorsed by all the leading authorities of the world. For example, American Diabetes Association back in 2019 itself has included low carb as an option in MNT or medical nutrition treatment. Plus, even Diabetes Canada also recommends And Obesity Medicine Association USA has also mentioned low carb as well as ketogenic diet specifically as one of the options for lowering weight or causing weight loss. Similarly, even the others like AHA has also mentioned that low carb is the best way to lower triglyceride as well as blood sugars. So we have the endorsement of all the leading medical associations also. It is just that we do not know that such an option is available. And then it becomes the duty of the pioneer of low carb nutrition in India to launch such a course. Hence, Anup took the step of creating a low carb nutrition course. At probably that time, even he may have not thought that, maybe we'll create an army of low carb nutritionists in India.
Correct.
So this was that time, and he went ahead and he has done that, and now he seems to have a different vision that we will have a very big army of it. And then a later statistics, if you see, they actually show the same, the metabolic statistics. Huge number of diabetes, pre-diabetes, obesity, insulin resistance, fatty liver, and everything. So, and this is not taught in mainstream dietitians courses. So we require a low carb nutrition course, and that's where we are.
Also would like Arun's view on the D-Life diploma course, because you're also one of the founders, one of the pillars of D-Life, and you've been associated since a long time with the growth and everything of D-Life. Tell us a bit about what is the relevance of this course, Arun? How is it changing the scene of metabolic syndromes remission in India? You are on mute, I think. You're on mute.
Yeah. There are actually D-Life low carb nutrition course because I belongs to the pharma background. So I know pharmacology and then anatomy, physiology, endocrinology, everything. But in this course, they have covered almost every aspect of this metabolic syndrome, metabolic health. So if you see right from the origin of human to the human's diet. Earlier, what was the diet? Now, what is the diet? And now, what is the going to be? So these all things we covered. Second thing, which is very good thing for this low carb nutrition course, that is the special feature you can see that it is loaded with the relevant videos of leading authorities of world over. So if you are reading any chapter of this course, you will find one or two videos are there so that people can understand better. And this is the one special feature of this course. Second thing, this course is the concentrated on the low carb nutrition. So everything is taught how low carb will treat you, how low carb will be get rid of all this metabolic syndrome. So that is the beauty of this course. And third, which is the final, is that no other course in India, dietitian or nutrition course, is offering low carb. This is the only low carb nutrition course of this stature. So that is a D-Life nutrition low carb course in there. I really appreciate. I have gone through all these chapters and all the video and everything. I really appreciate it is very nicely presented in the course, each and every chapter. So that's what we are.
Yeah. Thank you so much, Arun. I think you can mute your mic now.
Yeah.
Coming back to you, I understand you were recently covered by a lot of international media that also talked about D-Life as a platform, as a course. Would you like to say a bit more about the course itself, if you're looking at doing something else, or the course that you have launched, and how people are now coming to you from various countries? I'm aware of the numbers that are coming to you now. Talk a bit about that, please.
Yeah, Ira, before I go into the course part, I would like to say, we are the biggest, the largest, and award-winning platform, low carb platform, existing as on date in India. There's nobody else, and we are successfully having cases of all metabolic issues related disorders being remitted. I would not say cured because cured is a very dicey word. Remission is the perfect word. And as far as the course content goes, yes, we keep on upgrading it based on the feedback or inputs that we take from the enrollees or those who have completed the course from time to time. And as you know, new research comes up, we include that in that course so that it doesn't appear that it is, something like an opinion being expressed, but it is a science which is being taught.
Also talk about the support that you give to your graduates. I am aware that a lot of podcasts are being done which are uploaded on YouTube, and they're
Yeah,
very
if we talk of podcast, basically, anybody who has completed the course, now we give them exposure through podcast of their case studies, case success stories that they have handled. That is one way. And the support post completion, we have a dedicated private WhatsApp group where small queries are addressed to. And if it gets into a long, I would say a long thread of interaction, then there is a community, and that community is now around 9.5 years old, and it's all I would say a curated data where no spammers or anybody can join. So that way, the community itself is a big library of reference, like how cases have been handled. What do every, I mean, see, every individual practitioner would have a way of approaching a problem, right? So in a particular thread, there are 10 or 15 people addressing the issue. So a new entrant or a new enrollee can always refer to that thread to see how people really participate or how they handle the situation in a real world scenario. Because learning is one part, then putting it to practice to be successful is the real test.
Okay, can I have all three of the founders and the pillars of tea life into one frame, and kindly unmute yourself, Shashi and Arun? And can we have the final word on the relevance of the Metabolic Health Conference that's being organized in India? And as we kick off the session just now, I'm sure the audiences are looking at, seeing and watching great sessions ahead across 3 days. So, any last words, Anup, Shashi, and Arun? I'll begin with Arun, maybe.
Yeah, this once again I tell all the people who are watching us that they should go through entire conference and they will get lot of information without reading any study or any books, because all these speakers are the world's renowned speakers of the low carb field. So they will get benefited of that. They will be get benefited for their metabolic syndromes, metabolic unhealthy syndromes. So they should watch this, and if they want to have any particular program, like suppose somebody is interested with the thyroid problem, somebody is interested with the diabetes problem, low carb problem, they can watch individually also. But I request to all the people who are watching this, they should go through this. This is very exhaustive conference. They will get a lot of information regarding this. Thank you, Ira.
Thank you, Arun. Anup, could you tell us in a few words as a parting message of this grand event that we are hosting and the first session that we are now going to close? I'll have the last word from Shashi, but before that, maybe you can probably add your bit.
See, this is a dream come true. As Shashi said in the opening session, it was a dream that we dreamt of in 2017. It took us 6 long years to reach here. And this is not going to be the first and last. There will be many more coming up for sure in different formats. So stay tuned. And as Arun said, this session, I mean, this conference is India's first and India's largest. Now we all of us, take pride in being India's first in anything that we have been doing, starting from community to being covered in media. I mean, we've been covered in media individually, collectively since I think 2014. The journey of getting coverage in media started in 2014. Now, the most prestigious one was, of course, Icons of India Award. That was conferred by the prestigious Outlook Group. And yes, this is these days are 3 days are going to be very, very hectic for all of us, but we are prepared because, as Shashi said, we wanted to give something free to India so that they know that there is a solution existing. All it needs is your willingness to participate. So I would say go ahead and watch each and every session. In case you miss because of any, preoccupation or something, then recorded versions will also be uploaded. Thank you.
Thank you. Coming back to Shashi and the man who organized it, the co-organizer along with Anup. Shashi, I think you can just, probably in detail, probably tell our viewers what they can expect in the coming 3 days. What all topics are we going to be covering? Everything about the low carb conference.
Yeah, thank you, Ira. So, see, this is I will call this as the foundational event. We are going to just touch up upon low carb in general. It is a general one. It is not very specific. I know that when we organized that, there were a lot of requests to get a lot of specifics in. But then we thought that let us touch up generally. So it's going to be overall on the low carb front, on the ketogenic front, as well as on the carnivore front also. It's going to be very, very interesting. So of late, in India also there are a lot of carnivores. Like I have 3 carnivores in my screen itself. So so we are supporting all form of low carbohydrate diet, and that's what they are going to come. Medical doctors are going to come and speak about. First, they will speak about how they came across low carb, and they have their own personal journey. They have learned low carb either for personal reason, or they have learned low carb from their patients. You will find some of the top speakers coming and telling us that they learned about low carb from their patients. They were so humble enough to learn from them, adopt it, and really change the world. One of them is, coming on top of my mind is Dr. Anvin. His session is, you are going to host this, is going to be so interesting that he has learned it from the patient, and he has really created a revolution. And we are going to see all of this. You are going to see the same success in ketogenic diet, in carnivore diet, in low carb diet, and in various other indications. What is the relevance of low carb in orthopedic segment? What is how relevant it is in cardiology segment? How much is it relevant in endocrinology segment? How much is it in GP segment? In gynecology segment? It's very, very interesting to see that low carb has touched everything and across.
Yeah.
So it's going to be quite interesting. At this point of time, let me tell you that there's one point which I wanted to tell earlier was when you said that it is free. Yeah, this event is free for everyone. But while it is funded internally, and it is funded by the entire community of D-Life. Each one of us have contributed something so that this event goes live and goes free. So that's how it is. And then at the same time, I'm so touched by the lot of other international communities who have really done something to have an exposure of this. Like, for example, we were hosted in a podcast first by Dr. Don Akopra from Philippines. So he has invited me and Anup for an interview on low carb to be, and that was really shown in his YouTube channel so that the world knows that such a conference is going to be organized. Then we are invited by Doug from Low Carb USA. So Doug and Pam, thank you. They have made a special video with me and Anup again to tell the international community that such and such show is being organized in India. And then Metabolic Health Day initiative by Nasha Winters. So they also, in their Metabolic Health Day.life website, they have put the video where 3 of us have talked, you, me, and Anup Singh. We 3 have talked there. Plus also the other communities like we have Dr. Andrea Salcido. So she has also made one video showing that we are going to launch and about her session. My friend Gina Robert, she has also made a small video during the coaching session. She has put that. And yeah, Dr. Roshni Sanghani, so she has been actively campaigning about low carb conference in social media. Thank you very much. And also Dr. Kishle. So, and there are many other Nutrition Network, not to forget. Yes, Nutrition Network again has been a big support, and we are greatly proudly endorsing the ketogenic textbook, on which we are going to now talk about in 2 sessions when Professor Noakes and Jane Bullen is going to come. So I think, and finally, I think yesterday we have seen that social media company, online media company, South First. So they have also taken our interview, me and Anup's, and they have shown it in their YouTube, plus the print media also, online print media. I think there's a lot of love which has shown to the first ever event, and we are very touched. And I think it's going to be really a historic event, and we are going to enjoy this entire 3 days. So it's going to be very hectic, but we are going to enjoy it. And you are
And I'm
going
sure,
to,
and yeah. Shashi, I was just going to make a point that the entire USP of this event is that these are mainstream doctors who are going to be talking about low carb nutritional intervention for remission of the metabolic disorders. I think this grasps a lot of eyeballs and a lot of attention from people that there is an alternative way, as you said, to find remission from any metabolic syndrome that you are suffering from. So I think this is going to be the uniqueness of this conference, and giving a different view of how we can look at remission besides the pill.
I think it's very, very interesting.
Yeah.
Remission. I will always say that in social media, everything is an option. If you want, you can get off pill. So I was in remission for almost 8 years now, and Arun Kumar here, history of 2 decades of diabetes. So I think it's a very good option, and people should know that remission of diabetes is possible, remission of elevated blood pressure is possible, and a lot of other mental condition, neurological condition. I also have a success with a bipolar condition also, healing them. So it's really is something which is, I will say that the science of ketogenic diet or low carb diet in mental illness and neurological illness is an upcoming science, is an emerging science. There are a lot of studies which are going on, and people who are updated with science will know that we are living in a very excited times where we know that a lot of metabolic conditions can be treated with low carb, and there are studies backing them up. See, low carb diet, let me tell you, is the most studied diet. It is the most, I can assure you this. And it is not my word. These are from the top leaders in this segment who have been. This is the most studied. Still, people will keep asking for more study. It's surprising. There are hundreds and thousands of studies for this. So I think now people will know that there's an option available for them.
I think for such the strong, alternative interventions and cures, or not cures, but maybe remission, I think people still have a lot of myths, and there is a lot of misinformation around scientific methods also, like you said, low carb or ketogenic and stuff like that. I'm sure people will find their answers in the sessions that we are going to be holding in the next 3 days, because every session, as I said, is equal to reading many, many books. So please don't miss these sessions. Please attend these sessions and gain as much as possible from the best low carb and metabolic health space experts in the world. Any last words?
Yeah, I think you have touched upon very relevant point.
Sure.
That is the myth.
Yeah.
What are the myth? The myth is low carb diet is dangerous. Ketogenic diet is dangerous. Saturated fat like ghee and butter is dangerous. Protein is dangerous, surprising. Protein damages kidney. Protein increases uric acid. Protein causes gout. We are the most protein malnourished people community, one of the communities on earth, and still we are so much afraid. So we will be bursting all these myths gradually over all the sessions. That, and one more thing is, red meat is bad. It is bad for health. Whereas we are actually seeing that terrible conditions like severe, like you yourself have faced severe autoimmune nephropathy, membranous nephropathy, and you have reversed it with low carb, with a carnivore diet, specifically high in red meat. So a lot of these myths needs to be dispelled, and we will do that for India in this program. See, all these things are available, but we have this session, we will try to Indianize it as much as possible, or try to speak on the Indian context, how these can be applicable and how these are useful for India. So that is our objective, and we are going to interact with them. We are going to interact with the foreign speakers, and we will understand the basics of low carb. And even there are Indian speakers also, and we will try to understand how to really Indianize this. So Indianization of everything is possible.
Yeah.
So
Yeah,
I
I
think
think
we will have an enjoyable
as you
12-hour session.
Misinformation on protein, whereas I myself am a case where my membranous nephropathy and autoimmune kidney was reversed on a carnivore diet. So my myth was broken by my own experience, which I just chanced upon accidentally. But thankfully, I found remission in red meat, in low carb, in carnivore. That goes against the mainstream messaging, actually, that protein is bad for kidneys. In fact, my kidneys were bad at that point of time, and I was able to remit that disease with high protein and with meat. So I think this was a wonderful discussion to kickstart the session with. And, I thank Anup and Shashi and Arun, all three of them, for being here.
Thank you.
Anything you would like to say, Anup, before we just close our very first session?
Yeah, on myth, one of the strongest myth is it is unsustainable, right? Between three of us sitting here, we have sustained it for more than 30 years. What else does world need? What else any naysayer need to be convinced? That's all.
Yeah. So I think we'll just move on to our next session, which is going to be another exciting session with Shashi and Anup and Dr. Roshni, who would be joining you soon. Thank you, all three of you, for being here with me. And let's begin the conference on a very positive note. Thank you.
Thank you.
I think we can take in Dr. Roshni.
I'm not there.
You can get off. Anup can be taken off and Dr. Roshni to come in. Aarti Iman, just get Dr. Roshni in the screen.
Yeah, Dr. Roshni here is not there in the main room.
Can you get her from review room? Yeah.
Yes, she's there.
Welcome, Dr. Roshni.
Hi, Shashi. How are you?
So happy to have you kickstarting the event.
Thanks. It's an honor.
And we thought that we will, while the theme is low carb across the globe, so we'll start with low carb in India. And who can be better than you, an endocrinologist from the mainstream, to start this session. So I'll start with the brief introduction of Roshni, Dr. Roshni Sanghani. So Dr. Roshni Sanghani is an MBBS from Mumbai, and also an American board certified endocrinologist and an SMHP accredited metabolic health practitioner with 10 years of clinical experience in US and practicing in India for around 12 years since 2011. Dr. Roshni runs a program-based physician supervised coaching for comprehensive lifestyle change for metabolic disease. And she is tailoring international best practices to Indian lifestyle and habits. I think this is very, very important that while we know low carb, what is low carb? How do we Indianize it? That is something she has an expertise in to create a sustainable change. Again, this is again a very contentious topic. Low carb is not sustainable. So she is doing her effort to doing a might to make it sustainable. Addressing emotional eating, very, very important in our context. How do we address this emotional eating? Social context of food. What do we do in social context? What do we do in parties? What do we do? And vegetarianism. Again, in vegetarianism, the challenge comes is in sourcing protein. So how do we really address this cultural conditioning around protein ignorance, or protein fear, as I call it, and exercise, lack of exercise. The disregard we give to exercise is very high in India, and much more. And she has now crossed that bridge of low carb into, she is now exploring various other factors. How do we integrate everything into making low carb little more successful is what I can say. And she has a lot of other knowledge which we are going to explore in subsequent events. But this event we are going to focus on low carb, and how she came into it is what we are going to do. Her practice is now medication management with the aim of de-prescribing. We have also known that diabetes means prescription of medicine. So she is into de-prescription of medicine. So she might prescribe and she might remove them as time goes on. And Dr. Roshni also has finished writing a book on diabetes reversal through lifestyle change in the Indian context, which is very important, and it's in the editing stage. So we look forward as soon as it is launched. And her Diet Doctor podcast interview about low carb in India has crossed 165,000 views as on August 2023. It's huge, tremendous. Her medical practice uses a continuous care remote model with virtual healthcare delivery using technology, communication, community, and media. Very, very interesting. She also adopts behavioral strategies, including motivational interviewing, mindfulness, and spirituality, and self-care when and where applicable. So I always say that she is the low-carb endocrinologist of India. Welcome, Dr. Roshni.
Thank you so much, Shashi. Really, really exciting to see what y'all have put together. It's high time that India takes some stage to speak about the epidemic we have in this country. Lots of work to be done. So I think you've got something moving here in terms of a movement. So thank you for that.
And we will now talk about, we'll try, see, while many of the questions might be basic and possibly will be repetitive to what you had, but I think we need to have this in the Indian context. After your practice mainstream medication for so many years, you came back to India. We want to hear the story, why and how you took the path towards low carb nutrition.
I always ask that when someone asks me this, do you want the brief answer or the long answer? Let me try and summarize what happened actually. Is this video vertical okay, or should I move it horizontal?
Make it horizontal.
Okay, that's what I was wondering. Is this better?
Much better, yeah.
Okay. So the set up. Sorry. Okay. So what happened in 2011 was we decided that we wanted to come back closer to home, closer to family. It was a personal move for our kids to know their grandparents, purely, an emotional connect. And professionally, I knew that now I'm moving, even though India is my country, I was coming back after 10 years of professional exposure away. And the reverse brain drain of medicos coming back is actually quite rare. Even now, if I look at my classmates, many of us left after MBBS, very few have actually come back from my entire group. So I thought, now what my endocrinology practice is in US, how many best practices can I carry with me, which I can customize to my population, my Indian population? And I decided that a key gap that I wanted to be filling up was to become familiar with what my diabetes educators were doing in the US. Because in US, I would prescribe, go for diabetes education. And I would manage my medication, and the diabetes education would happen by the educators. And I didn't really know what's their scene. So I started attending those classes. I realized this is very, very important. I should learn the theory of this and then listen to my patients in India, do the education myself, apply that educational concept so that I can be familiar with how the Indian diabetes experience is, because there is obviously, medicine is one part, but the cultural, socio-cultural context of a lifestyle disease, if a doctor doesn't know that, they'll be very handicapped, or any healthcare provider who does not know the socio-cultural context of their patient when we're talking about a chronic disease. So I thought this would be a great way for me to be relevant to my patient. So I took the diabetes educator course and I came to India. And from day one, I was doing diabetes education in my consults. The benefit in 2011 was nobody knew me. My practice was slow. I was just building my name after being away. Nobody knew at all who is this person. So the crowd was less. The waiting queues were less. I could take my time and really get my hands into patient files and case histories and learn from the patient's background. And one thing I noticed early, which you'll find it amusing now, is I noticed a pattern with specific to India. Is they started to say that I have switched ever since I got diabetes. I switched my wheat to millets, and I reduced my rice, and I started going for walks, and I cut my sugar in my chai, and I have 5 to 6 small meals a day. And they were very proud of these changes. They said, "This is what I'm doing for my diabetes." And I was like, "Yeah, but your diabetes is not better. You're still stuck." So the doctor hat says prescribe more medication. The educator hat says check what's going on, check the carbohydrates. Reducing carbohydrates is an option. This exists in the educator books. So I had both. And nobody wants more medication. So I was doing this face to face, negotiating with the patient. If you want less medication, can you reduce your carbs? So this actually started from 2011 because I was being the educator for my patients. And I am still guilty of, even then, going down that standard algorithm that all my colleagues have been trained. I've been trained. We had the blinders on from our mugging up of colorful flowcharts. Is when one drug fails, go for two. When two fails, go for three. If they develop cardiac side effects, go for these cardioprotective agents. If they have kidney damage, go for kidney benefits of the drugs. If they want to avoid hypoglycemia, go here. If they want to avoid weight gain, go here. If they want to avoid expensive medication, go here. And this logic just did not click for me. It's like, I don't like these options. That no patient wants expensive medicine, hypoglycemia, or weight gain. No patient should have to wait for cardiac disease or kidney disease so that the doctor can then decide a medicine to choose. It's like we're waiting for cardiac disease and kidney disease to happen and then thinking what to prescribe. I think we've missed the boat. So I would have this conversation with the patient and negotiate. Do you want to reduce medicines? These are the options, but we can also do carbohydrate reduction. And that just kept evolving till the point where in 2014, I was at Hinduja Hospital. I considered it to be one of the best hospitals in Mumbai, Mahim. And they, gave the blessing, and I started diabetes education classes at hospital. And I was the endocrinologist running those. This started in 2014 on World Diabetes Day. And I think that was a massive experience for me to now be delivering low carb education, that if you cut your 4 chapatis to 2, see what happens to your need for medicine. If you cut your this much plate of rice to 1 cup, see what happens to your need for medicine. And it was very profound. So that's the beginning, how I got into this.
There's one surprising point here. What you told is, in the diabetes education course, there is a mention that you can reduce carbohydrate, which I think most of us were not knowing. We just think that the usual high carb is being pushed in medication. Very, very surprising.
Yeah, it was there that reducing carbs is an option. It was in the educator text for a longer time. In 2011, it came into ADA much later. The ADA actually used to say that don't reduce your carbs below a certain cutoff. And I've been going back now, once you get busy, you don't keep checking when it came into the guidelines. But I know it's been in the guidelines since probably 2019 or 2020.
2019.
2019 is when I think. And in fine print, it says very low or low carb. So if you search low carb in the PDF, you won't find it. You have to search low carb. And then it comes, but it's not in the algorithms, in the colorful pages where the doctors go to check what's new in the January updates. So, but it's been there.
I think you have to search for LCD and VLCD. This is the exact term in ADA. It came in 2019 MNT, and in 2018 consensus statement of ADA and ESD. It came in 2018, and 2019 it entered into MNT in ADA. So LCD and VLCD is what you have to search. Just put Control F and search. So we were very thrilled during that time to see that it has come. And even in 2020, Diabetes Canada has also included low CHO and very low CHO for type 2 and type 1 also. I mean, these are all the updates which are there, which many of us may not be knowing.
Yes.
So what other resources you used to learn low carb is what I'm curious to know.
Well, the first thing I did when I realized that patients are telling me so much about millets, they said, I've switched to jawar, bajri, nachni. And I'm like, but your sugars are not better. What's so magical? And as an MBBS, I didn't know this nutrition background at all. And I had done my MBBS from KEM Hospital in Parel. So I went to National Book Depot, which was my go-to place when I was an MBBS student. All our brand new imported textbooks and all we would buy from there. And I went there and I told my friend at the bookshop, same guy runs the store, and I said that, do you have any book on nutrition? He's like, why do you want a book on nutrition? You're an endocrinologist. That's what I said, give me what the dietitians or the nutritionists studying at KEM Hospital and GS Medical, what are they studying? I need to know. So NIN book, ICMR book of nutritive value of Indian foods. And I have had that book since 2011. It is torn and tattered. And this book was game-changing for me. And I kept it on my desk ever since, because I was shocked that although people are making the switch from wheat and rice to millets, actually the carbohydrates per 100 gram was hardly any different. And the page has come out because I've used it so much. The page has come loose. But guess what? If you eat 100 grams of ragi, it's 70% carb. If you eat 100 grams of wheat, it's 71% carb.
No difference.
If you eat 100 grams of rice, 77 grams of carbs. So we're talking about less than a 5% difference between wheat, rice, and ragi. Same goes for jawar and bajra, 72 for jawar and bajra 67. So we're only talking about a 4 to 5 gram difference. And people were like, same thing happened with papaya. People were obsessed with papaya. And I went to the fruit section of this book, and somebody must have scrolled the book and found papaya is slightly lower than sitafal, chiku, mango, banana, all the sweeter fruits. And so people then were giving themselves permission to eat this much of papaya. So for me, low carb happened this way. The other thing, big change, was because there was no diabetes educator between me and my patient. This became very relevant in type 1 diabetes, where the insulin prescription happens through carb counting. If you're doing precise insulin prescribing for type 1, you need to give your patients their insulin carbohydrate ratios across the day for the best and most stable management. And that's something endocrinologists do. And sadly, none of my type 1 patients that I started getting in India were doing carb counting. They were just taking fixed insulin, 5 units of insulin, 5. No matter whether the patient has eaten low carb or high carb, 5 units of insulin. And this was backwards, because then the patient was spiking up and down. And I was like, this is completely insane. It's like you've come for a custom tailored shirt, and I'm giving you a ready-made shirt, and I'm saying you fit into this shirt only. I'm the tailor, but I'm making you fit into a ready-made shirt. I'm not going to customize. That was the example I gave, is I'm your insulin tailor. So because of me being the educator for my patients, I had to become very accurate with carb counting for my type 1 clinic patients. So that was a huge thing. I had to search I used to use MyFitnessPal. I use the NIN book for Indian things. Then other Indian apps have come along the way. Unfortunately, we found that there was a lot of inaccuracy in the reporting of carb counting, where you could upload your own data into these places. Like 1 cup of dal, you may say it's 15 grams of carbs. Somebody else may say it's 30 or 35 grams of carbs. So the patient would be completely wrong on the insulin dose. So I had to actually create my own system. There is one document by a researcher in the US. It's a carb counting resource for South Asian carbohydrate counting list. It's a beautiful PDF. And I used that for a long time. I would give it as a Xerox to each patient with type 1 and make them do carb counting from there. So these are the things. And then, of course, you just keep reading more to get educated. Of course, I went back and revised the EDA books, because what is carbohydrate? The list of even pulses and dals, we think of them as protein. And, vegetarians have to eat pulses and dals for protein, but it's more carb than protein. Label reading, finding hidden sugars. So you just get curious. And if you get curious, the journey never stops. Is maltodextrin, fructose. In India, this is another fascination people had, is I've left sweeteners, but I've gone for dates and khajur. Sugar-free.
Jaggery.
Yeah. Jaggery, or they'll say sugar-free, but there is dates and figs inside, dry fruits. So again, all paradoxes. People were just not aware. So these knowledge gaps, I'm like, it is sweet. How can it not have carbs? And basically it's fructose. And people think because I'm not adding sugar, it's carb-free, or sugar-free. It's not. So it's a misunderstanding. So all these myths, just in the sake of educating the patient, the learning never stopped. And the internet has been a very big resource. You have to be careful what you read on the internet. And slowly you find like-minded professionals and you start increasing your knowledge.
So what else have you done on the low-carb front certifications? Have you done some
Yes.
courses, something?
Yeah, so recently the SMHP came around, the Nutrition Network came around, and I know you and I are the first to do this. But I say, chalo, there are two. We need 200. We need 300. There's no way that one provider is going to reach the masses and the level of epidemic that we have. But it's a start, and it was a great course. I think a lot of it I had learned along the way. So I have to credit Jason Fung's books. His books in 2018, I read all his 3 books in one shot: Diabetes Code, Obesity Code, and The Complete Guide to Fasting. I was introduced to him through a conference on diabetes reversal where I was invited as the only crazy doctor from allopathy, who is promoting that there is something like diabetes reversal. A lot of my colleagues thought I was crazy, and that's okay. But I learned about Jason Fung's approach and I learned more about insulin. Can you imagine, as an endocrinologist, my understanding of insulin physiology became clearer after I read his books. And I was like, oh, yeah, insulin resistance is the issue. So I have to credit Dr. Jason Fung's writing. Because as doctors, you don't realize when time flies. And if your diabetes treatment training was all pharmacotherapy based, you're doing symptomatic glucose lowering prescriptions, you're forgetting about insulin resistance as the core problem. And I think his work really helped me wake up again to that. And then once you see that, you can't unsee it. So it was important for me to then pursue insulin resistance and get, then so many books have happened. But yes, SMHP certification, the reason I did that was to be part of a community. It becomes lonely otherwise, doing this, and at least that way you find international like-minded people, you build a network so that you can grow together. I think India needs to do a better job of collaborating on these things. We tend to be very individual, fight alone. And I think we'll be stronger together. So what you've done here is great. The fact that you've got everybody together like this, excellent.
And I also see, while you may not be knowing much about DLive, but we always knew about you. Though we may have never contacted you. We knew that Dr. Sanghani is here in Mumbai, in my own town.
Yeah.
And I also could not, unfortunately, meet you during my professional days when I was in pharma. Somehow I just missed meeting you.
Well, maybe this was the right time. Sorry.
Yeah. And then in 2020, I was the first one to get SMHP accreditation. And
Yes.
one fine day, I received a mail from Doug of low-carb USA SMHP telling that Dr. Roshni is the second one. And he introduced me to you. So that time, I saved your email with me. So I thought, okay, as and when we do this program, I'll invite Dr. Roshni for this. Very, very interesting. I think, but
go ahead.
This is a trend which we have to set, that there should be more accredited practitioners here so that the general population is serviced as an option. When low carb is an option, I always say that we can do that. So now, what is your feeling? Earlier you used to recommend medication and now you're de-prescribing medication. What is that feeling you have?
Well, I thankfully, again, this came from the Diabetes Educator book. A big paradigm shift happened in 2011, which I am very thankful to that textbook, which tells you about the patient empowerment model instead of the patient compliance model. That puts you and the patient on equal footing. You are nobody to tell the patient what to do. And I agree that I was guilty of the same crime. Is when the patient is saying, I don't want insulin, I don't want, show me another way. I'm like, no, I'm telling you, this is what you have to do. I'm the doctor, I have the degree on the wall. You're going to take insulin because I say you need it. And I was convinced. Why was I convinced? Because that's what I had studied, and that blinders on sort of feeling. But when the power empowerment model came into my hands, that felt more equal. Is they actually have autonomy on their body, on their health, on their life. When they walk out this door, I'm fooling myself if I think that just because I sat in this chair and gave them a piece of paper, they're going to change their entire life when they walk out. That's very foolish of me to assume. That is very arrogant, actually. And so it was more liberating for me to make them an equal partner. And in that, you realize if we're equal, well, I'm also human. If I get sick, do I like taking medicines? No. So why would my patient like to take more medicines? It's probably an inherent desire for most people to have better health with less medication. And I realized that this is a very rewarding thing. I'm excited, patient is excited. We are able to give the credit to the patient is you put in all the hard work. This is your, I kept stickers, Shashi, in my drawer in Hinduja. I kept stars and smiley stickers in my drawer. And when somebody would get a D prescription, I would put 5 stars, take out 5 of those stars and stick them on the prescription. There would be patients who will listen to this and remember, and they have it in their file somewhere. If I ran out of stickers, I would draw 5 stars. Is you did this. You actually, and it's very celebratory for me, for them. It's they're having better health with less medication. So that's become my tagline, better health with less medication. And since we are an Indian audience, I'm going to say the joke is I've given many talks. You know how in doctor's office in Hindi, it'll say dawakhana. I said, my practice is going to be dawa kam khana, dawa mat khana. What is the meaning of dawakhana? If you translate, it means eat medicine. So the doctor's office is where you go to eat medicine. I said, I don't want this. I want to make it a place where we can de-prescribe. So that has become my North Star.
Now, interesting is you already mentioned this earlier, but still I want to know what was the reaction of your colleagues in India? What was their feeling or their reaction when they came to know that this endocrinologist from America is coming here and doing something different and getting the patients off medication? What was their reaction, feeling, comments?
I'm going to put this in a positive light. I don't want to make it into a negative talk, but there were mixed responses, definitely. Some colleagues definitely appreciated it right away. They got it that lifestyle change is the way to go. And she's taking on something which is difficult. I did get comments from endocrinology colleagues that, hey, why aren't you prescribing this new drug that's hit the market? And I said, why is that my job? I'm not obliged to prescribe a new drug that has come on the market. That is the pharma's lookout. If they're manufacturing something, that's for them and their stakeholders. I did not come into healthcare or take my education so that I could become a drug prescriber. I came into this field so I could become a healthcare provider. And if my patients are achieving better health and I'm able to prove it, I'm not some Devi Ma with blessings coming out of my hands and we're doing some agarbatti. I've told my patients, it's not a dhoop and agarbatti clinic. We're basing this on hardcore science. If your HbA1c is coming down, your FBS, your PPBS, your cardiometabolic risk profile, insulin resistance, weight, blood pressure, it's all coming down. CRP, uric acid, all coming down with less medication. You're on the right track. So even if people said that, it's like, I'm not going to slow down because I can see what I'm running towards. Truth sort of probably keeps you going. And I think just staying on that course from 2011, 12 years now there is no looking back, right? It's like I stayed consistent with it. And the colleagues who supported me were not so much diabetes managing doctors, but they were the para-endocrinology ones, like other super specialties who needed diabetes management. They needed weight loss. That was a big category of specialists who would refer to me. Like imagine a heart specialist or a lung specialist. For protecting the heart and lungs, obesity becomes an issue. So weight loss is something they need, not just glucose management. They need glucose management with weight loss. And if you put them on insulin therapy, once all the drugs fail, they're going to gain weight. So if you want weight loss and diabetes control, then Roshni became the one. And they knew that I have time in life. I like talking to the patients. I'm not the one who in 2.5 minutes, you're in and out and you get one paper and the patient doesn't know what happened. I just cannot practice like that. So I'm going to talk to the patient. I'm going to understand their barriers to change. I'm going to talk to them about their goals, their perspective, their likes, their dislikes, preferences. And we're going to build a strategy from there. So I think colleagues have had mixed responses. Again, credit to Hinduja when I was there. They supported these ideas a lot. And the reason that I left was actually so that I could create a multidisciplinary one-stop shop experience where the dietary team or the exercise team or the stress management spirituality team, we're all speaking the same language and we have the same goal. When you're in a hospital, the resources are shared, priorities are different. They're getting, a dietitian has to speak what all the doctors want. A physiotherapist has to divide their time with so many different kinds of patients. So it's very difficult to do what I need. But I have the blessings of many of my colleagues. I think I would say it in a positive way.
So do you still have your clinic, or is it totally online? How is it?
We moved online during the pandemic. I had a clinic in Khar before that, after I left Hinduja, and I was attached to Khar, Hinduja, and Breach Candy for a while. And but my work actually hopefully keeps people out of hospital. So the goals are different between what a hospital needs and what I am doing. Now, again, there are hospitals that understand that there is a role to play in preventive health also, and that builds trust and that builds credibility. So I expect that as we go forward, more corporate hospitals will also have preventive health departments. They need to. But for me, the clinic was where I would meet my clients. Once the pandemic hit, our patients were the most vulnerable in March of 2020. The vaccine was nowhere in sight, and my staff would be traveling by train in Mumbai to come as essential health services. They would have come by train. And my most comorbid patients with diabetes, hypertension, obesity, that's my population, they would be exposed to my staff in the office when COVID was very virulent in March. So we overnight went online. I went online a week before Prime Minister Modi shut the country down, and we never looked back. And what has happened, the diet doctor interview happened during that time. And we realized that we're reaching more people across India, across the world. And, for a physical exam, they can visit their local physician if they need a stethoscope or they need a stomach to be checked or eyes and nose to be checked. They can do that locally. We're now specialized in lifestyle coaching. And with telemedicine, we've added learning video courses, app support, chat support, community, continuous care. So because of using the digital tools, we're able to give a much more enclosed and safe environment for the patient.
And I think now modern tools are available that at least for managing diabetes is what I can think is now you have blood sugar meters.
Yes,
We have
exactly.
we have CGMs. And even for BP, for blood pressure, you have all those automated machines available at a low cost.
Yeah,
People can
exactly.
get it from Amazon. They can just give you the details, load it in your app, and that's what you need to see.
That's exactly what we're doing. And we've set up dashboards where we can get the data, we can see it, and we can give feedback. And that's the whole beauty of it, is the patient data is the basis for each coaching interaction. And maybe in the future, we'll come up with some hybrid model where we can sort of have that human connect again. I don't deny the value of face-to-face interaction and in-person meetings. It just brings that human touch back. But I think I want to spend maybe a minute talking about the other things that we have done to improve human connect, which is many times missed in busy doctor consults, is this concept of motivational interviewing and mindfulness, is helping patients activate their own inner expertise. Because I could be an expert in low carb, I could be an expert in diabetes deprescription, but my expertise means nothing. It's going to stay on the wall as a certificate if I'm not able to activate these processes in the client's mind. And that has become our soft skill. We have the hard skills. We know what is low carb, ketosis, BP, sugar, medicine, etc., blood reports. All that is hard technical skills. You need those. And you also need soft skills if you're going to manage lifestyle disease. So I think that we're able to do very richly in our online model. And that probably compensates, and keeps the relationships going.
So I think you recently got some certification also?
Yes.
On
Yes.
motivational talk?
Yes, motivational interviewing network of trainers. I'm again India's first certified, Mint certified motivational interviewing certified trainer. And Mint is the motivational interviewing network of trainers, and they provide this certification. It's a long process. I've been into motivational interviewing for a long time, but I hope that we now can grow the Indian community, because this is going to be a big gap. Is how it's okay to tell people to go low carb, take stevia instead, it's good for you. But the client is going to have mental objections with all of this. And it's what we call in motivational interviewing, the writing reflex is my reflex as a helper. I want to help you. So I'm going to tell you what's right for you. But just because I tell you it's right for you doesn't mean you're going to do it. So the logic in MI is, yes, we can take the horse to water, but we cannot force the horse to drink. MI, looks to help the horse realize that the horse is thirsty. So activating or awakening self-care, because this is there in everybody. Everybody wants to be well. Everybody wants to be healthy. And motivational interviewing helps to activate those basic human qualities which are there in all of us.
Now, I will dwell a little deeper into what are the current challenges in India in terms of diet. What is those few points specifically? I seen you talking about this protein ignorance and all, and what is it about diet? Can you just discuss, because you have been in the thick of it for quite some time?
Yeah, Shashi, I started doing intakes of my clients to understand their history, right? Properly. As a medical doctor, you have to go through all the symptoms. You don't just look at FBS, PPBS if you're a thorough internal medicine clinician first. And we noticed that the most frequent complaint in our population was digestive complaints, acidity, gas, and bloating. And all of these people were protein deficient. I was tracking their macros from the beginning. I was doing it myself. I launched an app 2.5 years ago, and we're going to be coming out with the second version of the app pretty soon. So the app now does the macro counting, and I've created that database myself. But before the app, I was doing all the counts. And the irony was they had horrible digestive systems and protein deficiency simultaneously. Still, when you tell them you're protein deficient, we need to increase protein, they would say, but I have digestive trouble, so I can't take protein. And it was the most backwards thing for me, because you are already having digestive trouble without getting enough protein. So how can it be protein which is the cause? You have an inflamed, unhealthy gut lining, period. Full stop. There's no protein to blame here. You're not getting any. So I think India is doing something really wrong around protein language. Everybody thinks that if I eat a new protein, suppose a dal, or if it's a vegetarian person who takes an egg for the first time, or if it's a non-vegetarian person who takes dal for the first time, they'll tell me, or non-veg people will tell me rajma gives me gas, veg people will tell me eggs give me gas. And in my head, I'm doing the math. This is a new protein in your system. There are new interactions, new enzymes which are required. Your gut is probably not mature, not healed, not secreting the right balance. Maybe your bacterial overgrowth is happening. Sugars are fermenting lower down, because all of these people, if they're not eating carbs, they were already clear that low fat is the way to go, right? So they were low fat, low protein. So what were they eating? Only carbs. So what is causing all these digestive symptoms is all these carbs going lower down into the tract, causing all this bloating, gas, non-healing gut linings. And they just couldn't put these things together. So when you show them this, that the new protein coming in, there will be a change in your gut bacteria. There will be a change in your protein digesting enzyme secretion. Give it 2 weeks, let your gut settle, and come back. And people would call it allergy. People would say, this doesn't suit me, that doesn't suit me. So these Indian phrases, we've been gossiping about protein wrongly for so long. And guess what? Yesterday, an endocrinologist messaged me saying, my patient is protein deficient. The nephrologist is saying, stop all protein. Nephrologist. Now, lucky in Hinduja, I had a nephrologist sitting right across my room. That's the benefit of being in a hospital. You have all kinds of specialists around. I barged into his room because I was like, why are Indians getting this advice to stop whatever little dal? Uric acid is high, stop all dal. There's no logic. You're protein deficient, your uric acid is high because of insulin resistance. And you cannot correlate this way that dal is causing uric acid. So the wrong advice has penetrated so badly. And it translates to sarcopenia. Now, that's another whole area, is muscle losses. We Indians love our walks and our yoga. Thankfully, now strength training is becoming popular, I think because Bollywood has started to be more fit. But when I was a kid, none of the Bollywood actors were muscular. In the 70s and 80s, none of them had a muscular physique, right? Now, actors are considered, or even actresses are considered fit and attractive when they show proper muscle mass. So I think that has translated into the younger generation valuing it. Whatever is the reason, they're now willing to do strength training. But the Indian diabetes population, protein deficiency, or they're going to the gym with protein deficiency to build muscle and not getting the muscle result. Their muscles are completely flabby, no tone, because there's just no nutrition to support the workouts. So these are two giant areas where we need to teach people what it means to push workout. So I had to go, you asked me about my low carb upskilling. I had to upskill myself in exercise also. I had to become a personal trainer, certified American College of Sports Medicine, certified personal trainer. I didn't know. I only know what happens when the body breaks down. If you get a fracture, I know the surgical steps to fix a basic fracture, whatever is taught in MBBS, right? If you have a ligament tear, I know what is the anatomy of the ligaments. But how do you exercise and stay fit? Not part of MBBS curriculum. So I had to learn that. And I realized most people are not pushing their muscles in a way through workouts that would actually give them that muscle gain. So hypertrophy workouts, people give up before they even reach that threshold. So a lot of knowledge gaps in nutrition and exercise.
Very, very interesting. I mean, you have really combined one more aspect other than the motivational aspect. Now you have trained yourself to be a personal trainer as well as pushing that muscle hypertrophy also. And very, very rightly, as you say, in fact, most of the illnesses are actually attributed to protein, while we are actually consuming far, far less protein.
Exactly.
This is such a terrible thing in India. We are actually thinking that protein is causing it, whereas the same person is having a pathetic amount.
Exactly. And nobody counts. And I am on a lot of these lifestyle groups. I'm trying to see what else is happening in India amongst other professionals. And when I push this conversation is, yeah, fine, you want to give me a plate method. And I used to use the plate method myself, okay, is it gives people some sense of portions, is how much is going for grains or carbs and vegetables and protein. Fine. That's a good start, right? Otherwise, the ratio of the plate used to be mountain of rice or 4 or 5 chapatis and a little bit of spicy vegetable, which you're taking it like a pickle. It's so much of masala that you can only touch it with the roti and just take tiny bites of vegetables. So the plate method is a good start. But getting into the weeds of it, that are your patients protein malnourished, most healthcare professionals cannot count. Most cannot count. I had to teach myself. It's not part of MBBS. So how would you know?
I think of plates are filled with grains, 50, 60, 70 or higher. What the dal we have is very light dal.
We do it like this to moisten. I used to ask them that you take dal chawal, how much dal? And they say enough dal to get the rice to be moist.
Yeah.
As a lubricant. So the primary food is the rice and the dal is being used as lubrication.
And I think that's what I have specifically termed Indians as grainitarians.
Yes.
So we are not vegetarians, we are not non-vegetarians, we are all grainitarians.
Yes.
And now conversely, people are, if they have diabetes, they are now becoming militarians. No difference.
Militarian. Yes.
From vegetarians to militarians.
Yeah. And I have seen millets, right? Millets are a very interesting topic. A whole millet, I'm still okay with in terms of if you're going to look at how it hits the system. And I'm not going to quote glycemic indexes from Google. If you want to know the glycemic index of this versus this, eat it and check in 2 hours. That's what I tell everybody is I'm not going to take your food away. So whenever a patient asks me, can I have this? I'm like, eat it, measure your sugar before and 2 hours after, and your body is going to tell you that on October 27, 2023, what is your relationship with that food, XYZ food? You'll know your glycemic index. Why do you want to rely on the internet? And another big problem, you asked me what are the top Indian problems. I think one is protein deficiency. 2 is probably sarcopenia and not understanding muscle building exercise. 3, in the world of millets, what has happened is processed food manufacturers have taken the glorified millet and turned it into a powder. Okay. And this is my joke is y'all are so worried about protein powders. No, protein powders are so bad. It's so fake and so artificial and processed. But when ragi whole grain turns into ragi chips and ragi khakra and ragi puffs, which melts in your mouth, that you don't think is processed or powdered. Right? Ragi puttu is a powdered ragi, which is a steamed one. And the glycemic index, sugar spikes so much. One serving of ragi puttu can give you 70 carbs right there and then. And it's highly powdered, so it melts in the mouth, doesn't require any chewing. And so you need to be as diligent about carbohydrate powders. If you're going to reject protein, first check how many powdered processed carbohydrates, even if it's a millet, are you taking it as a chips or a cereal or as a kakra or as some fast food? Then you've lost a lot of the health benefits which would have come in the whole food.
And one surprising aspect is among the millets, somehow this ragi or nachani is said to be good for diabetes. And I don't know how that when the carbohydrate, net carbo, I'm not even talking about gross, I'm talking about net carbohydrate content is equal to wheat, but still it is being promoted as health benefit.
Yes.
What about the other foods like vegetarians for paneer and all? For what is it that you recommend for vegetarians? I'm very curious to know. Those who don't even eat eggs.
Yeah, I'm going to come to that. So let me reflect on what you just said before we move on. Is I think we need the government to be more diligent here. Is food labeling has started where it says diabetic friendly. I've seen bags of diabetic friendly atta, diabetic friendly rice, diabetic friendly dosa batter, which is made of millet, and therefore somebody is able to say diabetic friendly. So what is the criteria when you're telling a label to a consumer who's not of a science or a nutrition background, diabetic friendly in big bold letters? They don't read the back that it is predominantly carb inside the nutrition box. So
I
there
feel
is a
diabetic friendly sugar also.
yeah, what is this? Okay, so this is very dangerous labeling and marketing, and I hope that by creating enough more noise and movement in India, we can hold the authorities more accountable for this, because the patient is not able to go and talk to the government. Now they come and talk to the doctor. Is this good for me or not? And we are then in charge of and understanding and interpreting labels, because we are the human being in your face. You don't get to talk to the pharma industry. You don't get to talk to the food industry. You get to talk to your doctor. So we are answering questions that are not problems that we have created, right? Now, coming to your next question about how can a vegetarian get enough protein, this is an important challenge to discuss. I actually let the person first tell me their preference, and protein preference is, do you want to be, what are your cultural ethical beliefs? Because although, in your next 2.5 days, 3 days, you're going to have a lot of animal-based proponents, you're going to have a lot of keto or carnivore kind of proponents, and whatever works for the client is what we should support. So if somebody were to tell, I'll be very frank, I'm vegetarian, and if someone were to tell me red meat is your way out, I would be uncomfortable with that personally. That's my own ethical, belief system. So I will have to find my own protein goals. How will I reach my protein goals? So we do this at a very, very individualized level. Why? Because we're looking for sustainability. So just yesterday, one of my clients told me, I'm eating tofu 3 times a day, but I hate it. I was like, do you think that's going to be sustainable? That you're eating something that as you're putting it in your mouth, your brain is saying, I hate it, I hate it, I hate it. Your body will you will not enjoy the meal. And if you're not enjoying the meal, you're not going to stick with that habit. So we need to start from where the client is. Sure, if you're okay with milk products, then all the animal products of milk, which is curd, paneer, hung curd, Greek yogurt, various forms of cheese. We have Indians living everywhere. We have audience. You have an audience from everywhere. Ricotta cheese, cottage cheese, all those hard and soft cheeses, fresh ones, not the processed ones. They are very low carb sources of protein, and minimally processed, right? They come straight from the animal. Now, as long as you're okay with that, that becomes a valid source for a vegetarian. If you're going to be plant-based, then it's going to be even more challenging. And look, you have to pick your battles, right? We don't live in the jungles. We don't hunt and gather our own food anymore. We live in high rises with air conditioning, lifts, and cars, and we don't have the original life anymore. We've made some trade-offs already. So if we've made those trade-offs and I'm not growing my own food, what next trade-off do I have to make? If I'm not willing to have this, maybe I need to take a protein supplement. Maybe that's my trade-off. Within the world of protein supplements, we can be picky. Do I want one which is chocolate, banana, raspberry, hazelnut, cookies and cream flavor with 20 additives, emulsifiers, thickeners, stabilizers, artificial flavoring, stevia and substitutes which might create cravings? Who knows what these sweeteners are going to do for sweet cravings? Who knows what they do to gut health and inflammation? So then we narrow it down. Let's go for a protein supplement with one ingredient. Can you find a single ingredient protein supplement? It may not taste good, but Indians are willing to have Karela juice. Indians are willing to have methi. That doesn't taste good. So why can't a protein shake be taken in a way that at least you reach your protein targets, And I've experimented with various protein supplements, and I have narrowed down to something that works for me. It doesn't taste good, but I'm not willing to take animal protein. So then this is my trade-off.
Fine. Now, do you have any memorable cases?
Yeah, I have so many. Let me think of, sometimes what happens is we all fall prey to this, and I try to, somebody asked, should I take questions now or later?
No, you can finish off this.
Yeah. What happens is I like to look for what we call in MBBS and MD medicine. I had some great teachers, and they would tell you that to be a good diagnostician or a good clinician, when a patient comes to you with 6 complaints, are you going to give them 6 different diagnoses and 6 different treatment plans? Or are you going to look at the person as a whole and try to find a unifying diagnosis that can explain the entire syndrome which the client is going through? So a unifying diagnosis is an important approach that has helped me, is look at the person. Don't look at the kidney separately and the heart separately and the brain separately and the diabetes separately. It's all one person. And by doing that, sometimes, you get these very complex cases. So I had a young lady, HbA1c was high, on 3-4 diabetes tablets, including sulfonylureas, about to be put onto insulin, did not want insulin. Along with that, and she had the central weight gain around the stomach. Along with that, she had 2 very tough symptoms which were destroying her life. Terrible constipation, where she told us that my entire family knows whether her potty has happened properly or not. She's a lady in her mid-30s. Entire family has to check how the mood of the day is going to be based on whether motions have happened or not. That much suffering. Second problem, severe migraines. Migraines to the point that she would lose half of the month, premenstrual, menstrual, postmenstrual, 15 days of the month, flat in bed, curtains closed, needing injectable painkillers to suppress the pain, but dysfunctional. She said, I live like a vegetable half the month. And she's a very intelligent, successful professional in her work life. I'm not able to live my life. And I am an endocrinologist. I'm not a migraine specialist. I'm not a constipation or a gastroenterologist specialist. And I said, let's look at this as a whole. Let's work on what we know works. Let's address your nutrition habits, your sleep habits, your stress management habits, your exercise habits, and intermittent fasting. And we took off the sulfonylurea. We suspected that maybe her hypoglycemia from the sulfonylurea, that reactive syndrome that was coming from the sugar crashing low, eating something, might be playing a role in triggering this headache. And she noticed that pattern. So the minute we did that, her sugars started to be, of course, we did the low carb, everything together simultaneously. And that's why I want to take over the entire picture. I don't want to only look at sugars. I want to look at all your lifestyle aspects together. And she now has got a proper grip on her nutrition. Her migraines are gone. She's opened up a new business for herself. She's on her feet. She's making her decisions again. Motions we fixed with circadian clock hacks. Her body clock was completely gone. That's another thing that comes under hormones, is her sleep rhythm was fully broken. So when should the motions even happen? Her sleep-wake cycle was not correct. So the morning clock of regularity of when you should empty your bowels, her body clock was not there. So resetting her circadian clock helped with that. And this to me was sort of like an all-in-one case. We've had another patient who came with mild diabetes, a young man, IT professional. He had depression and insomnia. And I know you're also very interested in metabolic psychiatry and, mood stabilization effects of low carb lifestyles. These were sort of unintended side effects. Even the migraine was a neurology impact that came from this, so we were able to positively impact neurology and gastroenterology in the lady. In this man, we saw that by going low carb, he started forgetting to take his sleep aids at night. He used to take supplements for sleep. I told him, why are you taking this? Your body will sleep naturally, but he was nervous. He also had mood, anxiety, and depression medicines going on. Slowly, he started to forget to take those. And we never directly treated for that. I was not going to touch his medicines on my own. It's for the psychiatrist and neurologist. And yet, when we started doing the low carb and comprehensive approach for his diabetes, his mood got better. He stopped his mood stabilizing drugs and his sleep got better. Again, unifying diagnosis is when the organism or when the body starts to heal, you can see these drastic results. And a third case I'll tell you about is a middle-aged man, banking employee, living in corporate quarters away from his family. And in India, we still have this good thing, which is food normally comes from home. Tiffin or lunch dabba comes from home. We're not still into frozen or too much of buy and go. Now the fast food culture is coming, but a lot of us still carry home lunch. Now this man lives in a work accommodation, so he doesn't have his home tiffin. He has to eat in the hostel, in the mess. And he was kind of a typical Indian male who doesn't really know much about cooking. And we need to change that in the next generation. Is we all need to be comfortable cooking meals for ourselves and not be relying on food industry. But with that limitation, this man, his C-peptide was on the low side. I would not say it was in the type 1 diabetes range, but his pancreas was beginning to fail. It was becoming a burnt out looking kind of type 2 case where his C-peptide was like 0.9, 1.2 in that range. Still some insulin function there, but very little. So his diabetes was high. And clearly the next discussion was, we might need to put you on insulin. It's dangerous. If you actually have a very low C-peptide, it would be very risky. He said, let me do whatever I can to avoid that. So we went aggressive, intensive on the lifestyle change. He was he was already taking insulin, about 50 units a day of insulin, and C-peptide was low. And he wanted to reduce that dose. And yeah, that was the correct situation with him. And he wanted to reduce that dose. So he was able to come off the insulin and, of course, change his lifestyle with that same hostel, with that same mess. That was my amazing part for me. This was a man who could have given excuses or say, I cannot, it's hostel food. But he started doubling his protein and his vegetable in the hostel food and cutting his carbs to half. If it's a thali, make it half of the carbs and take double portions of the protein and the vegetable. And he was willing to do that. His banking people supported him for changing his meal plans in the accommodation, and he was able to do it. He started working out in his room. He started building muscle with his body weight first. So he was able to get off insulin even with this borderline low C-peptide.
Quite interesting. I mean, people make small changes within their control itself works.
Yes, and I should also say that microvascular complications, we've seen those things halt. So again, it's very important for us as endocrinologists to say this to the audience, is we've had them go for the retinopathy checks where retinopathy cases stop progressing. I can't say that it reverses back to fully zero. That is something which depends on how far ahead the diabetes has progressed. Once you reach very advanced organ damage, it's not possible to reverse it back. So that's the whole idea of take this as a preventive wake-up call to actually make sure that we don't reach such deadly stages of organ disease. But we've seen moderate, non-proliferative diabetic retinopathy stabilize and halt in its tracks. We've seen the ophthal say, what did you do? Keep doing what you were doing because it's not progressed. Normally, I would have expected it to progress by now. It has stabilized, okay? And just a little bit of healing process starts to begin. Microalbumin. So urine microalbumin is a protein indicator in the urine that there is diabetic nephropathy, which means diabetes is affecting the kidney. We've seen those numbers come down. Again, not because I pumped them with more medication, but because we fixed the protein intake. Again, wrong knowledge that if protein is in the urine, I should stop eating protein. That's wrong. Your protein is in the urine even when you're not taking enough protein. So why are you blaming the protein? You're eating too much of carbs. That's damaging your kidney. So when people trust that, and you have to hold their hand here, because if you just say it, they may not believe you, because when they step out of your room, they're going to get 20,000 advisors and well-wishers who are going to say the exact opposite, that she's crazy. Majority wins. Majority is saying protein is bad for kidney, so she's wrong. So you need to have that strong relationship and trust with the client. And we've seen microalbuminuria get better. We've seen it get better. We've seen fatty livers get better, completely better. Now, if you wait for all the way till fibrosis or cirrhosis, that's really a late stage. And we don't want to reach the number one cause of liver failure being lifestyle disease now. It's not even alcohol anymore. But we have seen even grade 3 liver come back. So these are some memorable cases.
Very, very, very interesting. And I think you have little hit the nail when it comes to the protein part. And as you said, it's right. Like once the patient goes, your client, a patient goes out of your cabin, literally in India, everyone is a diabetic expert, including the house help also. She will also give you some herbal tips. that you take this and then your diabetes will be cured. So this is so interesting. So there's one question which has come out actually from the directly in the link is patients will be telling, I'm afraid of fats.
Mm.
So you're going to give some food which is having little more fats, let us say eggs, paneer, curds, it has a lot of fats. How do you dispel that myth?
Yes, I then go to the videos by low carb cardiologists and I forward those because, I think and of course, even Robert Lustig has done a beautiful video recently on cholesterol metabolism. He's a pediatric endocrinologist, brilliant doctor. And I then rely on, I don't want to fight every battle myself. There are people who have been in this industry who have put the message out. And at some point, people have to decide. I mean, guess what? The AHA, the American Heart Association, has already reversed its position on dietary cholesterol, that eggs are no longer, or dietary cholesterol is not the cause of harmful cholesterol problems in the blood. They've reversed that statement years back. And still, we're passing around wrong knowledge. So my job is, I don't want to argue with you in my precious time with you, because I did not put this wrong idea in your head. So since you got educated by external factors, here's some more external factors. Consume this information and then tell me what you think. And I have to have this argument even with my cardiology colleagues. There are many who understand low carb approaches, and thank God we have some fantastic low carb cardiologists across the world who are saying this, that LDL is not the only way to assess cardiac risk. You need to look at triglyceride HDL ratio. You need to look at insulin resistance markers. And to get cardiologists to say these things so that us alone are not fighting the battle. We have to change our messaging around dietary fat for sure. Nina Tycho's, her book, The Big Fat Surprise, right? We need to make people read these things.
And one more question, how do you address this thing when people say that diabetes is genetic? Or even obesity is genetic. Some people say everyone in my family is obese.
Yes, correct. You're right. But you also inherit not just DNA, you also inherit lifestyles, you inherit habits, you inherit biases, you inherit belief systems, you inherit knowledge, and you might inherit gaps in knowledge. So everything is not destined to your DNA. There is also this beautiful new industry, or I would say field of science called as epigenetics coming, where it is DNA is what loads the gun and the environment pulls the trigger. So what DNA is supposed to be coded or expressed or suppressed or shut down would be the environmental triggers as well, the epigenetic part of it. So, you could have a cancer gene in your family. Doesn't mean you have to get cancer. So my family tree is full of diabetes. Doesn't mean that I'm just going to say, now I'm going to have diabetes. I touched pre-diabetes myself. My family tree is exactly the same Gujarati family tree. I touched pre-diabetes when I said, no, I'm not interested in having diabetes. I'm going to change what it takes. And my HbA1c, which was high in 2013, 6.3, has now come down into 4.9, 5, 5.0, like that. So, but my DNA is the same. So what is it? You can override a lot of the inherited forms of diabetes and obesity once you realize the lifestyle factors that contribute.
Thanks. Dr. Roshni, thank you very much for this enlightening session. And there are at least 300, 400 people currently watching this, not only in this platform, but also it's running live in YouTube. And probably this is world across, people are seeing it. And it is so wonderful to have an endocrinologist coming and speaking low carb, especially in all the metabolic syndrome. Thank you very much, Dr. Roshni. And I'm really obliged. And we are so happy to see you coming to this platform and talking on low carb nutrition. Thank you. Thank you, Dr. Roshni.
Thank you so much. Thanks for having me.
Thank you very much.
Okay, bye.
So we can get Dr. Andreas. Welcome, Dr. Andreas.
Hello, can you hear me?
Yeah, I can hear you. Thank you very much for joining on time.
Well, it's great to be here. Thanks for having me.
I want Anup Singh also inside here. So we are going to co-host jointly. So Dr. Andreas, I'm Shashikant Iyengar, metabolic health coach in India, and this is Anup Singh. So we are the co-organizers of the first ever low carb conference in India.
Oh, great to meet you both.
So Anup Singh is the founder of D-Life in the oldest and largest low-carb community in India. It's been there for quite some time. And recently in 2020, they also launched a low-carb nutrition diploma course also to build an army of low-carb nutritionists in India. So I think you know the challenges in India, the terrible amount of diabetes we have. More than 100 million diabetics, 136 million pre-diabetes, 36% of the population hypertensive, and many more. We are not talking about insulin resistance, obesity. This is all huge. So
yeah, I mean, it's a huge,
welcome you, Dr. Andreas. Yeah,
huge problem, and you have a lot of important work to do. That's for sure.
And I think this is the part of that initiative that we are getting you in this conference, and we are going to have a very interesting conversation on your two projects. One is the highly successful Diet Doctor, and one is the upcoming Hava, very new concept.
Yeah, exactly. I mean, I'm looking forward to talking about both of them. I think that they are very much projects that are addressing the same problem, exactly what you just talked about, the problem that is such a huge issue in India, but really around the world, right? In every country, every country on the planet, right? Where the food environment has changed a lot over the past 100 or 200 years, especially in the last few decades, I guess. And just driving all our top chronic diseases. And certainly low carb is one tool that is extremely effective for a lot of people. But with Hava, we're taking it, I think, one step further and looking at not just carbs, because carbs are still important, but also other things.
Nice. So first, I will give an introduction about Dr. Andreas Einfeld. So Dr. Andreas is a Swedish medical doctor specialized in family medicine. So he's the founder and CEO of Diet Doctor, which has been the world's most popular low-carb website for a decade. So in the past few years, Dr. Andreas has moved his company into high protein and an innovative high satiety approach. So this is the most talked about, even we are seeing in social media, the higher protein concept and the higher satiety index. It's really very, very interesting. And we'll learn from you today what exactly it is. And recently they have launched a brand new website called hava.co. It is .co. They believe that the future of eating for metabolic health and body composition is satiety. At Hava, with satiety and personalization as a key factor, they aim to make it very simple to eat. And let me tell you, Dr. Andreas, that I know that there is a lot of controversy raging on Hava concept, especially we see in Twitter X now. And I'm also one of the person who was always skeptical about why you are transitioning from low carb to Hava. We'll come to that very later. We will discuss that, but very, very interesting. But then I realized that you are giving an option for many people, and I think it's very interesting. So we'll start. Please tell us something a bit about the formation of Diet Doctor. How is it this came into conceptualization?
Yeah, well, I mean, like you said, I'm a family doctor. I used to work with patients all the time, trying to help them improve through lifestyle changes, eating better. I've been passionate about nutrition and low carbohydrate nutrition for 21 years. Actually, I've been on a low carb diet myself for 21 years. So when we talk about higher protein and higher satiety, it's still generally way lower in carbs than sort of what most people eat, right? So this I think is a key part of it. But how I got into it is just reading a lot of evidence and science and books and talking to a lot of experts. I mean, Gary Taubes back in the beginning was very influential in my thinking, as I know he's been for a lot of people, 15 years ago, and seeing the kind of effect that you can have guiding patients to improve diabetes, to lose excess weight, to improve blood pressure, to improve all kinds of symptoms of metabolic disease, right? I just became very, very interested in, like, how can you help more people, not just one person at a time coming in through your doctor's office door, but tens of people, hundreds of people, thousands of people, maybe millions of people. And of course, the internet was there, and blogs were there, and there really wasn't any good evidence or good sort of support in Sweden, where I live. So I built the most successful, together with a group of people, we built the most successful low carb website and platform in Sweden. And then was traveling around the world, meeting great thought leaders and experts, I realized that, hey, there is really nothing amazing yet in the English-speaking market either. So we launched the dietdoctor.com website many, many years ago. I guess it's 12 years ago now. And it's been an exciting journey. Obviously, we managed to build, I think, the most simple, the most trustworthy place on the web for low carbohydrate nutrition. It became the most visited low carb website in the world, and we built an amazing team around that. And yeah, it's just been an adventure, really, aiming to help more people. And yeah, it's been very amazing to hear success stories from hundreds of thousands or tens of thousands of people. We had more than 1 million people sign up for our program, and it's hard to say exactly how many succeeded beyond their wildest dreams, but quite a few.
Yeah, so that's very interesting. I wanted to know is, what is the exact number of membership you have, or how many people have benefited from Diet Doctor?
Well, like I said, it's hard to know for sure, but certainly we've had many tens of millions of people using our free services, and way more than 1 million people signing up for our program. And currently we have about 50,000 paying members, but we have a lot of free users as well. But they are the ones who support our company. I mean, we don't sell any products, no food products, no supplements. We don't take no advertising. We don't take in money from the food industry or any other industry. So we're all powered by the people.
Very, very interesting. You are running such a big organization, and there is no conflict at all with any industry, and it's purely supported by the membership fees. Very interesting.
Yeah, I mean, it's just I'm just very grateful for everybody who's supported us over the years. It would be impossible without that support.
I want to ask you a very controversial question, because in India, people think that
low
carb is dangerous, ketogenic diet is dangerous, it will damage the kidney, you will die if you do ketogenic diet. How many of your members have faced terrible consequences of low carb or ketogenic diet?
Well, I mean, I'm not aware of any evidence that it is dangerous. Obviously, nobody gets immortal no matter what they eat, right? We all face health risks, and it's hard for me to say, how many people who've been on a low carb diet has had bad health outcomes, or would they have had more or less bad health without it. We can only look at the evidence we have, right? And in the evidence we have, it seems like all the major risk factors for cardiovascular disease and kidney disease, etc., improves. So blood sugar goes down, excess body weight goes down, the good cholesterol goes up, and bad cholesterol in form of triglycerides or statistically bad goes down. So, and the blood pressure goes down. I think like all the main risk factors improve. Even the total cholesterol profile tends to improve from a risk profile. Of course, we can always discuss the LDL aspects of it, and that is the controversial part. But I would still say that if you see cholesterol as a whole, and then you also add all these other things, then everything tends to improve. Big picture.
Very nice. So Anup, you want to ask the next question? You are muted, Anup. We cannot hear you.
Yeah.
Yeah.
Audible now?
Yeah.
Yes, sir. Yeah. So, Dr. Andreas, you said Diet Doctor was launched around 12 years back. Now, my diabetes journey is around 13 years. So, when I was detected diabetic, I had come across Diet Doctor. The only unfortunate part there then was there was nothing for Indians, right? And we have a typical dietary habit, which is primarily carbohydrate loaded. So my question to you is, do you have anything India specific as of now? Addressing only the Indian population specific.
So we actually do have some India-specific recipes and a lot of vegetarian and vegan recipes in general. I actually do think that what we're doing with Hava, that we'll talk about later, is perhaps even more interesting from a sort of big picture Indian population point of view, because if you like you say, I mean, you're obviously the expert here, but there's a lot of carbohydrates being eaten, I would assume, then in India. And if we take a broader view on metabolic health and nutrition, and we don't focus specifically only on the carbohydrates, I think that there is even more potential to do something even more flexible, even more personalized for an Indian audience, when you look at all the factors of satiety that can help you eat less, but still get all the nutrition you need, all the satiety you need, feel good, and then, lose excess weight and improve all the aspects of metabolic syndrome or metabolic health.
So what are the other features of diet doctor? What all activities you do? We have seen that you're releasing a lot of videos with very top thought leaders, doctors and all. What can you just give in short about what it is?
Sure. What we intend to do is to make low carb simple. So provide everything that people need, all the basic information for anybody who needs it, but then also guiding people to specifically what to eat, what not to eat, recipes, meal plans, and even personalized meal plans where you can tell the system sort of what your preferences are, what you like, what you don't like, and your preferences when it comes to budget and many and different sort of ethnic cuisines, etc. And you get a meal plan that is tailored to you. So, and then we also have, like you correctly state, we have tons of video courses and interviews with top experts to, for anybody who wants to dive deep into learning and understanding aspects of low carb. Also for medical professionals, we aim to have quite a lot of content to teach them about how to implement this with their patients. And of course, interested, non-doctors can also read this and maybe give it to their doctors, or maybe it can help them know even more than their doctor knows, so that they can inform about what might be beneficial for the doctor to know. Yeah.
I think you have a little short course also. People can do some sort of some CME rating of small course in diet doctor.
Yes, we have a CME course as well. And so we intend to make low carb simple. And one aspect of that is to also train professionals to know the basics and to help individuals also know the medical basics should they want to.
Very interesting. See, even I have done that course because it was open to all. And I am also listed in Diet Doctors, the list of providers. It's been there for quite some time. Very interesting. Would we like to now, we can now discuss about your new concept, Hava. So, see, one thing is like, as coming back to the raging controversy and debate which we see in Twitter, that people thought that you're going to now shut down Diet Doctor and make it totally into satiety index. But then there was a lot of raging thing going on, and suddenly one day you unveiled that you're opening a new initiative or a new website totally dedicated to the satiety concept of Hava. And then I think people will be a little more satisfied now that, okay, you have one concept on low carb or ketogenic diet where they can go. Plus, they have one more option now. I think, personally, I think that's a master stroke which I did, so that all the community remains satisfied with what your pioneering basic concept remains there in Diet Doctor. Plus, you have come out with a new. So, what exactly is Hava? First, please tell us what exactly is Hava and why the name Hava came.
Sure. Just to wrap up what you just said, I totally agree. I mean, low carb is such a valuable tool. I do think that our team built the best resource in the world for that, and we want it to remain, right? And we want to make it possible for people to keep using it, and we'll keep improving it, keep making it better and updating it with new knowledge. So that's why we want to keep Diet Doctor working and keep improving that, and take our new approach because they are slightly different, and it becomes a bit confusing to have them in one place, and therefore we decided to put it in two places. So hava.co is where you will find our new tools we're building around satiety. Hava, why the name? Well, we wanted a new name, we wanted something simple, and we wanted something that has the right kind of meaning. Hava in various languages means life or life giver. And from a Scandinavian perspective, you know, Sweden, where I'm coming from, there is this old Viking collection of Viking age poems called Havamal, which is a collection of poems about how to live your life in the best way, like how to have a good lifestyle for a happy life. It even includes a lot of talking about what to eat. Now, of course, we're not promoting Viking age diets, but as a general concept, I like the idea of this being a, you know, for 1,000 years, this word hava has been connected to improving your lifestyle, living a better life, having a better life. And that's really what hava is about.
It's quite interesting. So what exactly is hava? I mean, in the sense, is it you are focusing more on this protein and fiber, or how is it?
Well, it is that, and it's more. So I think that clearly a low-carb diet works really well. It's a very, very simple piece of advice. You say, just eat fewer carbohydrates, right? And it turns out that that actually solves a lot of problems. If you eat fewer carbohydrates, you tend to also eat more of something else, which is protein, right? Anybody who goes on a low-carb diet, on average, they tend to eat more protein, which is more satiating. They tend to remove ultra-processed foods because they all contain carbohydrates. And then you get a less processed diet with less hyper-palatable, sort of super seductive foods. All the ice cream, donuts, potato chips, etc., they all disappear, right? So clearly there are many reasons why a low-carb diet works so well. But what's also become clear from the new evidence that has come out in the last 5 or 10 years is that carbohydrates is not the only factor. There are multiple factors in ultra-processed foods that are potentially problematic, causing us to eat much more. So what hava is about and what satiety is about is using all of the proven factors and then taking them together, because it becomes extremely complex with all this data about protein as a percentage of the macronutrients, or fiber as a percentage of the nutrition, or various combinations of foods tend to be more seductive, like sugar and fat together is worse than just sugar in a way. And carbohydrates and salt together in an energy dense format is worse than just the carbohydrates. So this algorithm we're building is taking all of these proven factors into account, and then taking the difficulty, the complexity, and then just making it super simple. Just predicting where foods end up on a 0 to 100 scale, like the ones that give you the least satiety per calorie, all the way up to the foods that give you the most satiety per calorie out of existing foods. So what we do is we predict, using this algorithm, where foods fall on this scale. And then we're building a product for this that makes it super simple to see where do you end up on this scale and what specifically could you do to improve. And let's say you're on a low-carb diet. Well, that's a great starting point. But it's not the only thing. And some people are not super successful on low-carb. They may not quite get to exactly all the way to where they want to go, right? And then you could actually, when you look at all the complexity behind it, you could identify what are the problematic low-carb foods that they are eating. And doctors such as us, we've done that for a long time, and often finding advice that just works. That may be eat less nuts, eat less dairy, eat less cheese. And it's interesting because these are all low-carb foods, but we have identified that in the real world, they can become a problem. And people who eat less of them tend to do better. Well, when you look at it from a satiety lens, you actually find out that those foods are the lowest satiety low-carb foods that you find among common foods, right? So you actually end up with this lens that can make a low-carb diet better. And on the other end, you end up with a lens that can make it so that, let's say people find it hard to do a strict low-carb diet, like never eating rice, never eating bread, never eating many things. It can be challenging to do that for life. Well, with the satiety approach, we can find ways to incorporate some of that and to still have a high satiety diet. So there are really two big benefits from it from a low carb perspective. Number one is it could help you do better, and number two is it could simplify your life and make it more enjoyable.
Does Hava treat carbohydrates and fats as same? Because over there we glorify fat and we reduce carbohydrate. But what about Hava? Does it treat at same? Do we reduce both? Do we keep at a median level? How is it?
I mean, the very simplified answer is yes. The more complex answer is it's a little bit more complicated than that, because it's also about the balance. And actually what tends to be the absolutely worst is to eat both carbs and fat together.
Yeah.
Energy dense carbs and fat together tends to be the absolute worst, and that is things like chocolate or ice cream or donuts or such, right? So if you want a little bit more complex answer, it's more complicated than that. And the low carb diet certainly tends to work. You can actually do a high carb but low fat diet that is low in processed foods, that is high in protein, etc. That's a little bit more challenging perhaps for a lot of people, but if you do, that can actually be quite successful as well. And the real problem is to be in the middle and eat lots of carbs and lots of fats together.
So does the satiety concept involve the micronutrients also? Because see, we have seen Marty Kendall from Australia. He promotes the satiety index depending upon the nutrient density, that a set of food which he has should have the highest number of nutrients which will satisfy a person. His satiety index will be satisfied. Do you have such concept where you also measure micronutrients, or is it based on a different algorithm?
So let me first say that I'm a big fan of Marty Kendall. I actually talk to him quite often, and I think I've learned a lot from him, and I think his concept can work really well. We do have some differences of opinion. I think that we should be very careful in relying too much on observational data, because all of these things tend to come together in foods. All of these nutrients and protein, etc., often come together in nutritious, unrefined foods like meat, like vegetables, so forth, right? And if you then look observationally, it can look like every single ingredient is super important, but that's tricky because they actually came in the same foods, right? So what we do in our satiety approach is to try to keep it very simple. Higher protein foods that are low in processing, they often come together with all the nutrients you need in the form of micronutrients. So you get that factor almost automatically by putting a lot of emphasis on unrefined, higher protein, nutritious real foods. So at the moment, we don't factor in all the micronutrients, but as soon as we have a little bit better evidence, we're very open to incorporating it. And I think, well, actually, I will change that. We do actually factor in sodium and potassium a bit already. It is possible, I think, that we'll also start factoring in calcium and maybe one or two other micronutrients. But that's as far as we go now, because we try to focus on what seems like the biggest factors and not get distracted by a lot of observational data. Let's focus on what's really proven. And I think that takes us 95% of the way, or 99%.
Yeah, Andreas, if I may ask, As you know, India is primarily a vegetarian country where animal protein consumption is pretty low. Now, does your Hawa concept, how well would it fit in Indian context?
I think it could fit beautifully in an Indian context because there is no need for the protein to be from animal origin. I think you could absolutely do a very, very high satiety diet that is also high in protein on a vegetarian basis. So beans, lentils, tofu, different kinds of other vegetarian proteins absolutely can work really, really well. I mean, there is a lot of discussion, of course, online about the bioavailability of animal versus vegetarian protein. Seems to me that this is a relatively minor factor and that you can overpower that pretty easily by just adding a little bit more vegetarian protein and you get the same effect pretty much.
Okay, as a
like
follow-up
maybe
question,
10-20% more and you're there.
okay, as a follow-up question, how much carbs would you permit in Hawa?
Well, we don't make any rules for how much protein you can, carbs you can or cannot eat. We just try to guide you to a higher satiety approach. And lowering the carbohydrates is one way to achieve a higher satiety diet for sure, a higher satiety per calorie diet. So the more you lower your carbs, the higher the satiety per calorie tends to be. But it's not the only factor. You can also get there by lowering added fats, by reducing the energy density, by adding fiber, by avoiding hyperpalatable combinations, etc. So you can end up with a pretty high satiety diet, even on a relatively high carb diet, if it's unrefined carbohydrates, high in protein, high in fiber, and with plenty of protein. So it's absolutely possible. May not get to like the absolute peak on a high carb diet, but you can get pretty far and probably all you need.
So if you may not have much capping on, let us say, carbohydrate, is Hawa more suitable for weight loss or will it be suitable for patients with or clients with diabetes? How is it? I'm very curious to know about this diabetes part or blood sugar part.
Oh, absolutely. I mean, if you're talking about type 2 diabetes, the most common version by far, like 90% of all the diabetes in the world, then I think that for sure this concept is potentially perfect because if people eat a higher satiety diet that leads to them eating less, automatically, right? They are happy eating less. They don't want to eat more. Then they lose excess body fat. The insulin resistance goes down, and then the body can handle unrefined carbohydrates much better because the insulin sensitivity is much better. So I think in the short term, a lower carb diet may have some extra benefits for type 2 diabetes. But in the longer term, I'm less sure how necessary that is. I think lowering carbs, generally a good thing, sure. But lowering added fats may long term have almost the same effect. Clearly, when it comes to medications, lowering the amount of insulin you take, then low carb is going to have an extra edge. So I'm not against low carb in any way. I think it's a maybe the most effective and the most fast way to do it. But there's also the problem with low carb in that it may be so effective that it's, you may need medical assistance to taper your medication pretty fast. And if you go on a slightly higher carb, higher satiety diet, then you don't get that rapid drop. You don't get the sort of dangerous improvement. If you like, it can be too good, a keto diet. If you don't know what you're doing, you may end up with a very, very low blood sugar, right? Blood pressure too, actually. You may have to lower your medication pretty fast. You may almost need medical support to do it in a safe way. And I think that this higher satiety approach may be a little bit slower in the beginning, but that's not necessarily a bad thing. It makes it safer on a population level if you don't have close medical support. And I think in the longer term, it may be just about as effective. We'll see with with more studies, but I think it's quite possible. Certainly, it's good. I mean, if you lose excess weight, improve your insulin sensitivity, blood sugar will be better. We know that.
There is a lot of controversy on what I see on the social platform. So when you post the satiety index, let us say, you might say that the satiety index of beef is not so much as maybe some plant food. And then there's a raging debate going on, usually we see. What is it?
Well, I mean, beef has a high satiety per calorie. All meat products are unprocessed meat is high satiety. So I'm not arguing against animal protein-based diet or a carnivore diet from a satiety perspective. It's almost impossible to fail on a carnivore diet in a way. I'm not saying it's something that everybody will like, but certainly it's effective. I think the only thing that you may want to keep an eye on is highly processed meats and added fats. That may still be like hot dogs. They tend to be often pretty low satiety per calorie. Actually, it's not a lot of protein in them. It's mostly fat and even some carbs added there. And so it's interesting. It's a side topic, but when you look at it from an epidemiological point of view, then processed meat tend to be connected to less good health outcomes. And of course, from a low-carb perspective, we've often said, hey, it's just observational, doesn't prove anything, doesn't prove cause and effect, should be fine. But I'm wondering, maybe it's actually showing the truth. Maybe it is because processed meats are generally much lower in protein, higher in added fats. Maybe they are less healthy from a metabolic perspective. I think that might just be.
I think it's very, very interesting how you show.
Yeah, Shashi, I have one question.
Yeah, please.
Yeah. Basically, Hava, I think, as far as I understand, is a workaround for people who cannot follow low carb. That is question number one. And question number two, is it focusing on gastric emptying rate primarily by adding more fiber? You're trying to be as close as possible to low carb, but without being low carb.
That's interesting questions. Well, for the first one, if it's for people who can't do low carb, I mean, I would say just if people are happy on their low carb diet, why should they change? I have no objections. If people are happy.
My question was somebody who cannot do. Is Hava for them specifically?
Well, I mean, if someone cannot do a low carb diet, then I think Hava could be a great fit because you don't have to be strict low carb. You can find different ways to reach your goals.
Okay. And the
and
second
when it comes to
question
the gastric emptying, again, I would say it's one factor. The fiber, gastric emptying, foods that are slower in digesting, less processed foods, less energy dense foods. There are multiple factors here, and yes, many of these factors are related to gastric emptying. So indirectly, absolutely, we will guide you towards foods that take longer to digest. Of course, ultra-processed, very energy-dense foods full of sugar and fat, they just pass through the system in almost no time, and then you're hungry again, right? Which is great for the food industry because then you're back to buying their products in just hours, right? But it's perhaps not good for our health.
Okay, coming back to your low carb diet, doctor, what is the benchmark or the threshold that you set for carbohydrate from population to population?
Yeah, so we try to be the number one place for low carbohydrates in diets in general, making low carbohydrate diets simple. So that means we don't say there's only one way for everybody. It's more like the lower you take your carbs, the more of an effect you tend to get from this particular intervention, right? So what we generally do when it comes to recipes and meal plans, etc., it's below 100 grams of net carbs per day. But 50 grams Below 50 grams is a little bit more effective probably, and below 20 grams is what we consider ketogenic. Of course, exactly where people get into ketosis can vary a bit, but if you stay below 20, then most people will be in ketosis.
Yeah. Thank you. Yes, Shashi.
Is AVA more tilted towards vegetarianism, or does it have more options for vegetarians?
Well, certainly the question to the answer to the second question is yes. Like it is a more flexible approach, and for anyone who is not sort of happy with a very low carb approach, then HAVA will be more flexible and more easy to do. And that may include vegetarian. Certainly, you can do a low carb vegetarian diet, but it does give you a little bit of fewer options, and it can perhaps be a little bit repetitive for some people. So with HAVA, with a satiety approach, there will be much more flexibility and very, very easy to do on a vegetarian diet. But also, also possible on carnivore. The cool thing is it's an agnostic approach, really. We're not focusing on animal or vegetable. We're not focusing on whether it's the carbs or the added fats that you're removing. We're making it based on first principle science, like what is actually proven to work. Low carb is one approach that works, but you can actually do the opposite in a way with a high carb, plant-based whole foods diet without processed foods, high in protein, etc. That can also work. So it's pretty interesting that these opposites both work. Why is that? You can't explain it with a low carb approach, right? I mean, there's a very interesting study from Kevin Hall where he compares a ketogenic animal-based protein to a vegan whole foods-based diet, and they both work. It's not clear that the low carb approach is even more effective. So how do you explain that? Well, with a low carb lens, you can't really say why is it that these opposites both work. I mean, there's another study, even funded by a low carb friendly organization, partially, NUSI, the Gardner study, where they take a low carb or a high carb approach, but they're both unprocessed, they're both low in processed foods, and people lose a lot of weight on both arms in this study, right? Low carb or high carb, they both lose equally much. I can't explain it. I can't explain it with a low carb angle, but with a satiety lens, it makes perfect sense. Low carb works, but there are other things that work too.
Very, very interesting. See, in between, I know that you had also tweeted that you lost certain percentage of body weight after following the PE diet.
Yeah, sure. I mean,
and I wanted to ask more about that. And is HAVA tilted towards PE diet? How is it? Or is it the PE diet?
So to explain, the PE diet is protein and energy. It's basically about the protein percentage of the food, and it's created by Dr. Ted Nyman. Dr. Ted Nyman works with us for full transparency on this satiety approach. So you could see it as a further evolution of it, sort of the PE diet 2.0, if you want. The protein percentage is one big factor in the satiety approach, but it's not the only one. Because what's become clear, and Ted is 100% with us on this, is that while the protein percentage is one factor, it's not the only one, just like carbohydrates, right? There's also things like energy density, like fiber, like the hyperpalatable combinations. And so with the satiety, we're trying to take all of these factors into account. Just as a practical example, if you look at the PE diet, you would say an apple is among the worst things you can eat because there's almost no protein in it, right? It would be worse than a donut, worse than potato chips, looking only at the protein percentage. But I think it's pretty clear from the existing evidence and common experience that an apple is not worse than a donut. It is actually less bad. And when looking at things like fiber, energy density, hedonics, etc., then with our satiety approach and weighing all these factors together, then you actually get that result. A donut is among the worst things on the planet for satiety. It's among the things that make you eat the most. And an apple is right in the middle. Like, even though it's low in protein, on average, is kind of average.
Very interesting. I personally think when I see all this, I think your Hava is going to be more help for Indian vegetarians. I do foresee, because you are given a lot of options, especially the tilted toward the plant-based options also. Now, in low carb, generally we say that the animal-based foods are the best, whereas you show that even the plant-based food could be equally right. So I personally think that it is a good option for many Indians also.
Yeah, exactly. I mean, that's what we're trying to do with Hava, make something that is as useful as possible for as many people as possible. And if we can build something that is helpful for many people in India who would otherwise not benefit from what we're talking about here, then that would make me very happy.
So in what stages of launch is it? I mean, Hava is already launched, or it is still in the
brand and website is launched, and we have a waiting list. So I don't have any announcements to make today, but fingers crossed, very soon. I think we have said that it should be possible to expect something this year.
And what about the other fact? I mean, other facilities, like, are you going to launch a proper app with all the details, or have you already launched an app?
I mean, that's not a secret that we're working on an app. Also not a secret that I'm extremely excited about what's possible to do now. Like, what we're building now in our app would be inconceivable a year ago. Like, it would not be possible without a team of thousands of people, pretty much. I mean, we all know that there's amazing AI technology coming online and just improving, it seems, day by day. And we can leverage that to build something that I'm just extremely excited about. It's a product that I'm dreaming about using every day myself. And I think we're going to see game-changing innovation in this field. And I hope that Hava will be among the first, or even the first, to really use it to the maximum potential. We're going to see this nutrition or food app category is going to be radically different in the very near future. And we're hard at work building that right now.
I think I personally see this as some sort of evolution which are happening. I think you are actually leading that front in evolution of low carb to a little different angle. Now, Dr. Andrea, there is few questions here which are coming in from in the front end, the portal, and which is being floated now in this message segment also. Are there any stories Dr. Andreas can share on how his education and work help the government authorities to amend food policies? Has it ever happened down there in your country that because of it, there was some amendment which could have benefited the population?
Sorry, what was the question again? Government policy?
Is there any change in government policy towards the food, or did the authorities amend the food policies because of your work on low carb front with Diet Doctor?
I really don't believe that we can expect the government to be advancing this field much. Unfortunately, governments are usually a little bit slower, and also unfortunately quite influenced by industry and by financial interests. And I think that the unfortunate fact, and I think probably the entire, or the main reason why we have an epidemic of obesity and diabetes in the first place, is that it is profitable. So the food industry profits by selling more foods at higher profit margins, right? That's just basic 101 economics. Now, if you want cheaper ingredients, you need to reduce the protein because that's the expensive ingredient. Sugar and oil is very, very, very cheap. The more of that you replace protein with sugar and oil, the more profits you'll make. And unfortunately, you can also combine them in ways that make foods extremely attractive for humans. Sugar and fat together just drives consumption. Energy-dense foods are more attractive, more hedonic, more seductive, and they're also more shelf-stable. So, I mean, all of these factors, financial, basic, 101 economics factors, they all push us towards a food environment which is obesogenic, where the food industry profits by selling foods that make us want to eat more. Right? We want to eat more, so we buy more, so they profit more. And they profit by taking out the nutrition from the food because that's the expensive part, placing it with cheap energy. So the food industry cannot fix this. They just can't. It's very easy for me or you or anybody to say, oh, they're evil. They're trying to harm people. No, they're not. They're just doing what they have to do for their shareholders. So that's their job, to make profit for the shareholders, and the way to do that is to produce obesogenic foods, right? And that's why it's getting worse every year. So the government could step in and say, now we put these laws in place, everybody has to do this and that, and we put this tax on this or whatever. But that's not going to happen, I think, in a good way, because government is slow, government is influenced by industry. So I think that the change can only come from the bottom up. That's people like us, people who are listening here, people who are living their lives and want to live a better life. And what I hope to do with our team is to build a product that makes that much simpler, that makes it much simpler to find the foods that are better for you and then help you live a better life. Foods that you still enjoy, foods that fit your lifestyle, whether vegetarian or something else, fit your budget, fit your time, your schedule, your busy schedule, whatever it is, but still leads to better metabolic health, more energy, more strength, better body composition, more willpower even. Like, you don't have to think about eating less. It just happens naturally. So you can direct your willpower on whatever is really important in your life, like achieve more of your goals. That's really what I want our company to assist with, building a product that makes that simple. Quite passionate about it. I think that's how the world improves. If we together make it simpler for people to eat better, then they will do that. And then industry will have to change, right? Because they always produce what people buy. And if people buy something else, they will produce more of that. So that's how it changes.
So there's one more question here which says that animal-based proteins are absorbed better compared to veg-based protein. So human systems readiness to process. I mean, probably they say that the question meant was, will the human system be able to readily absorb and process that veg protein? That usual debate.
Yes, absolutely. Humans are very adaptable. We can eat all kinds of stuff and prosper, just not ultra-processed foods to 100%, right? That's with all of these problems combined, they're just optimized for the wrong thing. And it becomes toxic for humans to eat that all the time. So, but vegetable proteins, absolutely. Like I said, maybe you have to eat 5, 10, 20% more to get the same effect, but you can absolutely do it.
Yeah. So India has been a vegetarian. One more question coming in. India has been a vegetarian country, has been largely eating legumes, lentils, and carbs on demand. And since you have been promoting legumes and lentil, then the question is, like, why India has become diabetes capital? Is there a misunderstanding on how we assess protein in India?
Legumes and lentils are awesome. They're fantastic. Nobody is getting diabetes because of legumes or lentils. Quite the opposite. The more legumes and lentils you eat, the lower your risk of diabetes. I'm 100% sure, right?
The question is, in spite of eating, why we are getting diabetes?
Well, I think that the problem is more in the rice, if I may say, but even more so, rice is not the worst thing. The worst thing is ultra-processed foods that are high in carbs and sugar, carbs and fat together, energy dense, very hedonic and seductive. That's the real problem. If people only kept it at eating rice, that would probably be fine too. But I mean, there are many problems, I'm sure, in India. Highly processed carbohydrates combined with added fats, that's where the problem lies.
Yeah, that's what I keep telling, that in India, we eat primarily grains. We eat a lot of grains. And possibly, or we try to source whatever proteins from grains and lentils. While the question has come, I still think that our consumption of grains are high compared to any other food. Probably we are not consuming enough lentils also. Whatever, and we are more deficient country.
More lentils, more legumes, more. I don't know. Do you eat like tofu, soy products?
Soy is not very popular in India. It's mostly, see, whatever soy is sold is more. The concept has come from the West rather than it's
right.
Not
so
very popular.
Vegetable proteins beyond legumes and lentils, what would you say is popular?
For vegetarians, yes. See, I think you should know that Indian vegetarians means we are dairy-based vegetarians. There are no traditional vegans here. We are dairy-based vegetarians. That we will take.
All right. Well, dairy, high protein dairy, that is great. I mean, me personally, this is just my personal preference. I really love high protein yogurt, like Greek yogurt, like low fat Greek yogurt is unbelievably high satiety per calorie. And I'm sure you have some version of that probably in India. I mean, it's hard to beat. It's really great.
Yeah, I think again the debate will go whether we should take full fat yogurt or low fat yogurt. But I think full fat yogurt may be popular in diet doctor. When it comes to Hava, I think it is more of low fat yogurt.
Well, I think that as long as it's a high protein version, you can go either way. But if you really want to speed up the process, if you want to lose excess body fat, if you want to improve metabolic health, if you're not happy with your metabolic health or your body composition, I would go low fat. If you're happy where you are, if you're very active, if you're a runner or something, then for sure, probably the higher fat is better value for money, more bang for your buck. So as long as you can burn it, then maybe that's the way to go.
And just one question, between LC and Hava, for same calorie, is there any difference in food volume that you have to take?
Sorry, what was the beginning of the question?
Between low carb and Hava, for same calorie intake, is there any difference in food volume?
Oh, a good question. So, I mean, I would say it depends. I think a lot of low carb foods, if you eat lots of vegetables, etc., can be low carb still. But generally speaking, with Hava, will sort of guide you towards higher volume foods. With low carb, you could think of things like adding butter to the top of all foods, or having fat bombs, or things like that. Extremely energy dense. Of course, fat is the most energy dense thing. It can still work as long as your protein is high and you avoid ultra processed foods, etc. It can still work, but I think to get an extra effect, an extra boost, it can be smart to reduce that.
I think it's very interesting. The one basic fundamental which remains between both the concepts are, I think you believe in more in the, not in the processed food. Just avoid those processed foods and depending upon whole foods. I think this is the very basic fundamental which I see on both sides of the tables.
Absolutely. I mean, if you can do that, you're probably home already.
Quite good. Fine. So you have any message for India?
I mean, from what I understand, there is a pretty terrible epidemic of diabetes and obesity, and all the poor health and poor life quality that comes with it that is spreading across India. And I think the reason is the new processed food environment we're in. It is absolutely possible to change that. There are options that are budget friendly, tasty, that fit your vegetarian lifestyle or whatever lifestyle you have. And I hope that with Hava and of course with Diet Doctor and everything that you do here in this conference, I think we can show a way for people to live a good life and have a good health and reach your goals and enjoy the process. So I guess the message is just optimism. There is a way.
And I think today we have learned, quite something about the very basics of Hava directly from you. And personally, I think that you have given us two good options. Follow low carb or ketogenic with Diet Doctor, or if you're not able to do, or you don't find it very attractive or sustainable, you have one more option where you can try. And I think, and you have given a very good option, I think, especially on the vegetarian segment is what I can see personally. I think it's quite good, and I think I wish you personally a lot of best wishes for success, that both the ventures should be doing as good as each other. Anup.
Well, thank you, and I wish you all the best with your conference. I think it's a marvelous sort of endeavor and biggest ever in India. Very exciting. We'll see, hope for a big impact.
Thank you. And Anup, you want to say something?
Yeah, that's all. That's all. Thank you for coming. And I would say, being first for organizing it for the first time. And our aim has been to get as many experts, especially doctors. We're not, bringing in any coaches and all, because the population wants to listen from what the doctors have to say. So that was our primary aim, and thank you very much for joining us.
It's been a pleasure. Thanks for having me.
Yeah.
Thank you, and really, we appreciate that you have accepted my invite. As soon as I sent my invite, you had accepted it, and you are so enthusiastic to come to India and share both your ventures. I really want to thank you again, Dr. Andreas. Thank you.
Well, thank you, and congratulations on organizing this event.
Thank you. Namaste. Thank you, sir. Thank you, doctor. Fine, you can, the next one can come in. Ira can come in, Oshni and Dr. Deepa. So we can be taken out now.
Hello, Dr. Deepa. It's wonderful to have you. Welcome to the Low Carb Conference.
Hi, Pashini. Thank you for having me.
I'd like to take a quick minute and introduce you to our audience. For those of you who do not know, Dr. Deepa Mahananda is from Sydney, Australia. She graduated from Western Sydney University in 2012 and completed her junior medical officer training in 2012. Her postgraduate qualification include the fellowship of the college for general practitioners. She's specialized in sexual health, family planning certificate. She's also done a diploma in child health from the University of Sydney. She's extremely passionate about teaching and is also a conjoint lecturer with Western Sydney University. She currently works full-time at Sydney Low Carb Specialist. During her early clinical experience, she started seeing more patients with metabolic health conditions. She's going to talk about how she got interested into low carb and what she does. She's also certified ketogenic nutritionist, credentiated by the American Nutrition Association. She's also a member of Low Carb Down Under. She's extremely passionate. For those of you who have followed her on social media, you know how actively she is promoting and following low carb, and her special interest lies in women's health. And today, that's our discussion going to be on gestational diabetes. Dr. Deepa, why don't you tell us about your journey into low carb?
Thank you for the introduction, and it's really lovely to be here supporting the first Metabolic Health Conference for India. It's a wonderful initiative that you've put together, so congratulations to the whole team. So just to speak a little bit about my journey towards low carbohydrate medicine, I graduated in 2012 from medical school, so it's quite some time now. I've been a practitioner for 11 years. And when I graduated, my passion was always to go into general practice, which is also known as family physician. And the reason for that is because I'm so passionate about preventative medicine and trying to keep people out of hospital, but also not just to keep them from sickness, but to help them to thrive. And I thought general practice was where my calling was. And when I ended up there as a registrar, a trainee, and I was starting to learn from my mentors and my colleagues, I started to realize that much of what I'd been taught in the traditional framework of how we deal with chronic disease is much like a band-aid, and it was never really reaching the root cause of illness. So unfortunately, I'd see patients who I'd give a prescription to, I'd ask them in a very cursory way about diet and lifestyle, but I wouldn't have very much effective interventions to offer to them. And then unfortunately, I would see them deteriorate or perhaps get worse over time. And it was sort of about around that time as well that I had my own personal health issues. I was diagnosed at the end of my medical school with stage 4 endometriosis, and I began to explore what are some other avenues to be able to manage my condition in conjunction with the traditional medical framework. And so thus I happened upon low carbohydrate medicine and started to learn a lot from my colleagues here in the Low Carb Down Under organization, and attended a conference which transformed my whole outlook upon how we treat chronic disease and how we optimize health. And that was in around 2017 when I attended that conference. So from that point, it's just been a lot of research and learning from my patients who've chosen to use this methodology, and learning from my current practice as well, and applying the information that we have. And as people may have already spoken about, low carb is actually not a new concept. It's been around for more than 100 years, and it's actually underpinned by our ancestral way of eating. So you could even say it's been around for millennia. So it's really about us reintroducing and educating around the concepts of how we have been, how we've evolved as humans, and what kind of nutrition looks like to optimize our own health. And to that end, we created our own clinic to be able to provide this in a very comprehensive way. So my husband, Dr. Alex Petrushevsky, who's talking later in the conference, and myself are directors of Sydney Low Carb Specialists in Sydney. And we have a dietitian, a health coach, and an exercise physiologist within our integrated team. And we work quite holistically with our patients in applying nutritional medicine that's within a low carbohydrate framework, and also putting that across, using that across the board for a wide variety of different conditions, and also to optimize health as well.
That's amazing. So you get to practice in the way you would like. We'll dive right into the topic, Dr. Deepa. Maybe tell the audience what is the difference between regular diabetes type 2 versus gestational diabetes.
So it's just the distinction with the time at which it's diagnosed. So gestational diabetes is diabetes that comes to light during a pregnancy. So it's an abnormal blood sugar that is first recognized in pregnancy, whereas the type 2 diabetes is abnormal blood sugar that's diagnosed anytime outside of the pregnancy itself. However, a significant number of those who are diagnosed with gestational diabetes are actually pre-diabetic prior to their pregnancy, and they're quite unaware of this because having an abnormal blood sugar in many ways can be quite a silent disease, and it can take up to 10 to 15 years to actually be diagnosed with type 2 diabetes. So that's the main difference between the two.
So how would a person, preventively maybe diagnose pre-diabetes before they, let's say, plan for a pregnancy?
Yeah, so one of the key things I often advise is that we should be aware of what our blood sugar is and be testing, particularly when someone is interested in preconception at that early stage, understanding what their fasting blood sugar is, what their HbA1c is, their C-peptide as well, which is a marker of pancreatic function, and importantly, what their fasting insulin level is. So these 4 biomarkers are incredibly important to the early diagnosis of pre-diabetes, and thus we can try and prevent this person and manage their blood sugar more effectively so that we don't unveil what will then may turn out to be a gestational diabetes through a pregnancy. And by doing that, we can prevent some very serious knock-on effects for both the baby and the mother. Because what happens in the situation of a pregnancy with gestational diabetes is that there is an increased risk of preeclampsia and high blood pressure for the mother, and also an increased risk of cesarean delivery because of having large for gestational age babies, meaning that babies can actually be on the larger side. They call this macrosomia. So that's an increased risk for women who do develop this condition through the pregnancy. The other main risks as well are around, unfortunately, are around stillbirth and miscarriage. And this can occur as well in at higher rates in pregnancies that have uncontrolled gestational diabetes, particularly. So where this one of the take-home messages I want people to take away from this is that having the condition in itself is not reason to panic, because it does not mean that all of a sudden all of your risks are so high. The risks actually go this high when the blood sugar is uncontrolled, and that is the key. So really recognizing this prior to the pregnancy means you've got a lot of time to be able to engage in some very proactive lifestyle measures. And then when you enter the pregnancy, particularly in that first 4 weeks, one of the issues is that we know that if we don't control the blood sugar very well, we can have a higher rate of neural tube defects. So this is the formation of the spine in the baby. And when we enter a pregnancy, if the blood sugar is well controlled, we can actually reduce the rate of this. And this is quite a powerful tool that we have to reduce this serious risk. So there's a lot that can be prevented in the preconception phase. And you might have heard of the phrase, the genes load the gun, but the environment pulls the trigger. And preconception is a hugely important phase in a woman's life, as well as her partner as well, because the health of both of those two individuals matters to the health of the sperm and the egg, which meet to form the embryo. And if we can provide the best metabolic health to both those individuals who are involved in the conception, then we know that the embryo will be the healthiest that it can possibly be, and have lower risks of experiencing problems through their lifetime, and also then future generations too, because at the moment what we're dealing with is an intergenerational issue with diabetes. So many generations being affected by diabetes because of the exposures from the time they were in utero.
That is really fascinating because, you're not just looking at preventing and making your life better, but it is also, as you mentioned, generational that would require. So just building on to this, as you already said, it's nothing to panic about, but it needs to be managed and controlled. What are the measures and how can low carb really fit into that, especially
So
for the gestational diabetes?
So the traditional management in Australia, at least, is that we often talk about diet change, and particularly at the moment, the guideline is an extension of our standard dietary guidelines. So they speak of using a low glycemic index diet with portioning control, but perhaps having snacks in between every meal to ensure that the overall caloric intake for a pregnant woman is still adequate enough for the pregnancy. But the recommendation, unfortunately, sits at the moment at a minimum of 175 grams of carbohydrate per day. And this was arbitrarily really put together based largely on studies that involved men. So using their dietary intake requirements and sort of adding on what we assume would be the amount needed in pregnancy and for the developing baby. And then we also advise about exercise because that is a powerful tool as well to manage blood sugar levels and increase insulin sensitivity. Then the next two factors that occur often is that when diet therapy tends to fail, because I feel that when we give women such a high carbohydrate minimum to achieve, they can often exceed that. And oftentimes they will find that it is difficult to actually proceed through their pregnancy eating that way. They can feel quite hungry as well because it's really low in protein and fat. When they're eating so many carbohydrates, it is almost equivalent to 9 servings of grains per day. So that then leads into potential need and use of medications such as metformin and insulin if we still cannot control the blood sugars adequately. So in a low carb framework, what we tend to then look at is out of the 3 macronutrients, which are carbohydrates, protein, and fat, the one and only macronutrient that significantly increases your blood sugar is carbohydrates. And the research is showing that even if you have a mild elevation in your blood sugar during a pregnancy, then that can dramatically affect the baby and the pregnancy itself. So what we do is to try and reduce the insulin resistance that occurs through pregnancy, and it is natural and normal for an insulin resistance to occur. So I'll just explain why that is. In the first half of the pregnancy, the woman is in an anabolic phase, meaning that she's starting to build fat stores within her body in the preparation for the second half of pregnancy, where she'll partition that fat across to the fetus or the baby, the growing baby. And that baby will then rapidly gain weight at that stage of the pregnancy. That's usually happening in the second half of the pregnancy. So the second half is where we actually have the highest insulin resistance in the woman in an effort to get this fat moving from the woman to the baby. And that's how the normal pregnancy and normal physiology of pregnancy is meant to progress. So in the whole scheme of that, the pancreas of the woman needs to actually increase its insulin production. So that actually goes up by 2 to 3 times normally during pregnancy. And when that occurs, if you're having quite a high carbohydrate load, so for instance, if you're trying to achieve that minimum 175 grams, you're at least having 45 grams of carbohydrate with every meal at a minimum in this framework. And that is it still can be quite high and provoke quite a high blood sugar if that methodology is used. And I think that's where it goes wrong for many women, and they find that they fail diet therapy and they feel then they need to go, well, their doctor's advice at that stage is usually to go onto medication. And actually, as Lily Nichols, who's a very experienced and knowledgeable dietitian in this area in America, she says that actually, you know, they didn't fail diet therapy, but the diet failed them. And it was the diet that was the issue in the first place. So in a low carb approach, we would be looking at something that is around 90 grams of carbohydrates, if not needing less in some instances, depending on if the woman had metabolic syndrome prior to entering pregnancy, or if they had prediabetes prior to pregnancy, then we may need to go lower, and this is done in a very individualized, very supervised manner. Otherwise, it's usually on average around 90 grams of carbohydrate would be per day would be a target. And even in some women, they can tolerate higher than that without any blood sugar excursions. And the emphasis then gets placed upon increasing quality proteins and healthier fats in the food, such that we can increase the nutrient density as well. Because often carbohydrates that are grain derived are quite low in nutrients unless they are fortified. So at least in Australia at the moment, we fortify the wheat flour with synthetic folate and iodine and even iron in some instances to certain foods, in an effort to prevent deficiencies across the population who may be considering pregnancy. So these are some strategies that have been used, but if you kind of think of it a bit differently, actually, we could be focusing on health promotion around the most nutrient-dense foods to assist in a low-carb framework for pregnancy. So we can do a very well supported and supervised way of proceeding with the pregnancy that can avoid gestational diabetes or even manage gestational diabetes better.
That was really insightful because you mentioned the priority in what the macronutrients are. Just diving a bit into that, are there any standard? I know you mentioned there's, it's very individualized, but are there standards for the quantity of carbohydrates that one needs to take during pregnancy?
There isn't actually any standard guideline, and you'll be surprised when you dive into the literature on this that because pregnancy has always been a difficult area of science to investigate in a randomized controlled trial way. So we're never going to have some of these rigorous trials that people will call for in this area. It would be purely unethical to be doing that. So much of the science we have is actually from observation or from animal studies. And also, as I was saying, much of the research, if you looked at, actually there was a recently published study that screened for the dietary reference intake of 23 micronutrients in more than 700 studies. And they found that pregnant and lactating women were only included in about 17% of those studies. And some of those studies were most of them were only based on men. And as I was saying, this sort of arbitrary number that we have about carbohydrates is just pulled from calculations that were just done on wide population assumptions. So that in and of itself makes it very tricky. We estimate that in a pregnancy, you may need about 300 extra kilocalories per day, in addition to like a normal outside of pregnancy intake for a woman of that age. And that's usually equivalent to one extra small snack. So it's actually not the same as eating for two people, which is what a lot of people think pregnancy is a license for, is you can eat as much as you like or anything you like. So it is really interesting to know that much of the scientific evidence that the dietary guidelines are based around for pregnancy don't have a lot of rigorous evidence there, unfortunately.
So since that's not there, it is individualized and under guidance. What should be priorities when a person would want to follow a low-carb diet and if they are diagnosed with gestational diabetes?
Yeah, so in addition to tailoring it to how they came into pregnancy, so just to recap that, if the woman had normal metabolic health, then they are very likely to be able to tolerate a slightly higher amount of carbohydrates. Still wouldn't need to be as high as 175 grams. It could be somewhere between 100 to 150, but potentially less. And then if there is a metabolic condition prior to the pregnancy, or there was a therapeutic need, for instance, they had epilepsy, or there was another reason to maintain a very low carb approach, then we can still maintain that. And then two aspects in, again, where we just don't have a lot of strong evidence to make the claims that have been made, is that there isn't much scientific evidence to limit your fat intake in pregnancy. So there's a lot of worldwide dietary guidelines that have unfortunately demonized saturated fat. And the evidence for the pregnancy guidelines arise from rat studies that enriched the rat chow with refined soybean oil. And then they went on to measure pregnancy outcomes. And then the conclusions they came to were that the high fat diets, which were soybean oil enriched, had poorer pregnancy outcomes. But what we know about soybean is it's a seed oil, and that's quite high in linoleic acid, and that's a form of omega-6 fats that has been demonstrated in abnormal ratios to cause excessive weight gain and high blood sugar levels, which is not what you want in gestational diabetes, and elevated markers of inflammation. So we can then advise women, okay, we can have saturated, healthy, naturally occurring fats such as butter, ghee, coconut oil, and all dairy fats and the fats from meat as well that are occurring in their natural environment and natural matrix. And in fact, the Journal of the American College of Cardiology came out in 2020 to support across the board that the naturally occurring dairy fats and meat fats are not the main culprit, and nor do they cause long-term consequence for cardiovascular disease. And then the other aspect is that third macronutrient of protein, which we really try to heavily emphasize in a pregnancy, because even in places like America, when I think there was a recent study, it was published in 2021, about even on average, women are still under-eating protein through pregnancy. And they found that 40% of the women were under-eating the protein in the second trimester, and 67% of the third trimester mothers actually fell below their optimal intake, which should average about 82 grams of protein per day. And so increasing the protein intake is part of the work that we would put into place, and education would put into place about where to get that protein, because having higher protein reduces your blood sugar variability. And that supports all of those vascular changes that are occurring in pregnancy as well. So that's part of what the framework would look like, is much higher protein, higher healthy saturated fats and monounsaturated fats, as well as a lower carbohydrate approach to the personalized to the level of insulin sensitivity that the person has.
So asking on, since we're talking about low carb, what about intermittent fasting?
Yes, so intermittent fasting can be undertaken in the preconception phase if there is some metabolic issue that's needing to be overcome. But it's actually not something that we recommend, and it's certainly not what I would recommend in my practice when you're getting very close to the time of conception. So what I mean by that is that sometimes it can actually take quite some time to sustainably achieve resolution in metabolic syndrome. And so if your plan is to fall pregnant within the next few years, it's actually a great time to start now, and implementing fasting could be one of those tools to help, to assist. But if your plan is actually you want to fall pregnant within 3 months or within the next 6 months, this is probably not the best time to be signaling unintentional calorie restriction, because what happens, and I've observed this occur with people, is that they may find that they will slightly start to undereat overall in case their fast, say, exceeds 16 hours. It might end up at 20 hours, and then they've really only had 2 smaller meals in a day. So it's not signaling what we need to do pre-pregnancy, which is that you've got an abundance of nutrients and that you have an abundance of energy to sustain a pregnancy if it were to occur. So once a woman is pregnant, again, we advise not to do any forced or deliberate fasting. However, if they don't feel hungry and they would like to wait a little longer until the hunger sets in, then that is perfectly fine. We also know that it's not necessary to sort of force feed because of time frames, because in pregnancy, there are often times where food aversions will occur, and there may be nausea associated, particularly in the first trimester. And unfortunately, some women get left with this for all of their pregnancy in the worst case scenario. So what we do is try and take advantage of the moments where there is an appetite and ensure that they have access at those times to the highest nutrient dense foods that they can possibly resource. And that way we can still combat that lack of overall energy, because one of the concerns is if you're nauseous and maybe vomiting, you're losing a lot of ability to take in nutrients. So I think we need to just always be really cautious about trying to get the most nutrient dense foods. So when you have a moment to eat and the nausea settles, you're not really having empty grains, which don't have a lot of nutrients, but you might be trying to favor nuts and seeds and dairy products that could be tolerated, and vegetables, as well as meat, if that's part of the way you eat, and ensuring that they are quality whole foods, so that when you do have a moment during the day where you're not feeling unwell, you're still getting the nutrients that you need.
That's very insightful on intermittent fasting, because following a low-carb diet, our satiety naturally goes up. And if we have been following it for a while, we don't tend to eat frequently at all. So
That's correct.
So I'll ask a bunch of other questions. Are there any risks or concerns associated if somebody were to follow the low-carb diet during pregnancy?
Yes, so one of the concerns that's been written into the guidelines here in Australia, and it may be similar in India as well, is that this was actually put into the Australian Diabetes Position Statement as of 2018, is that, and I quote, low-carb eating should not be recommended for pregnant women due to potential folate deficiency, which resulting in an increased risk of birth defects. And that's the direct quote from that position statement. So that's the concern that has been raised locally about using a low carbohydrate dietary pattern. Now, I went and I took the liberty of looking at what study they referenced for this, and they actually analyzed data from the National Birth Defects Prevention Study in America, and it was from 1,700 American mothers of infants where they had stillbirths and terminations with neural tube defects. And then they also looked at 9,000 mothers of the live-born infants who were born without a birth defect. So these were the controls, and they were conceived between 1998 and 2011. And what they concluded was that the women in this study with the restricted carbohydrate intake, and this, mind you, was self-reported carbohydrate intake, were slightly more likely to have an infant with a neural tube defect. So there were a number of problems with this study, unfortunately, and so it was quite sad to see that it made its way into a position statement with such authority, because if this study was picked apart, it was actually comparing self-reported food intake, and it was asking the mothers about their intake up to 24 months after delivering their baby. So it was asking them to recall what they ate up to 24 months ago, about what was eaten even before they conceived, and then what was eaten through the pregnancy. So it's extraordinarily hard to even get a reliable history about what you ate a few days ago, let alone that 2 years ago. And also one of the other issues that I feel from that study is that they used a total dietary folate intake that was expressed as a dietary folate equivalent, which was made up of synthetic folic acid and natural folate, but they chose to weight the synthetic folic acid because they were saying it has more bioavailability. Now, the problem with using that is basically missing the entire aspect about how 50% of the population have some gene variants where they're unable to methylate folate effectively into a methylated folate form that can be used by the body. And unfortunately, almost all of the prenatal supplements and then the fortified foods, they use synthetic folate. So these people with these gene variations actually cannot use this synthetic folate efficiently or effectively. And so they didn't mention that at all in the study, and so they didn't actually take that into account. So that's a big hole as well. So I think the only appropriate conclusion they could have made without sensationalizing it as a low-carb diet was just to say that a folate deficient diet, a diet of any choice that is folate deficient, may lead to a neural tube defect, and that actually is well established in the literature. So that's any way of eating that doesn't have a lot of folate. So I think just that title of the study being what it was, it got quite a lot of I guess gravity, and then it was used as the reference for this statement. And as I've pointed out earlier, many women are unaware that they're pre-diabetic before they enter pregnancy. So they may already be sitting with high blood sugars in that very critical time of spinal formation. So my counter argument is that undiagnosed prediabetes, it actually is well known and established, like that high blood sugar is established as a teratogen to the baby. And this in and of itself can cause neural tube defects and has a higher risk associated with it. So that's already an independent pathway, and this happens through some of the mechanisms of oxidative stress that occurs with high blood sugar, gene mutations that can occur at the early part of pregnancy. And it just leaves, like what that is doing is really leaving women in a very confused spot, because on one hand, we're telling them to eat lots of grains to get their synthetic folate in, which will cause high blood sugar. And then by having high blood sugar, that's actually a teratogen in and of itself, and that can also cause neural tube defects. So what we really need to be doing is actually diverting our attention into health promotion about where in the foods we can get the folate. And can we get the folate in a naturally occurring form that it doesn't matter what gene variant you have of the MTHFR gene, you can still use naturally occurring folate quite efficiently because it's already in that methylated folate form. So the sources for folate, the last time I looked at the large agricultural databases, there are plentiful amounts there and lots of places to be able to get the folate from, and including, so if you do eat meat, liver is the #1 option. But for those who are non-meat eaters, there's a lot of green leafy vegetable food sources that we can use. Lentils and legumes do feature there, but we just need to be wary that they do have a slightly higher carbohydrate intake. So if we choose to use them, we must be very judicious about putting lots of fat together with that. And then further down the list are some other sources like dairy. So dairy does have sources there for folate. And so I think if we are more practical about where you can obtain your folate from, and you take a methylated folate supplement as well as a background insurance policy, you can definitely undertake a low-carb approach, not fall into any problems with folate deficiency, and therefore not have any of the risks that the Diabetes Association sort of point out as being a problem with a low-carb diet. But apart from that big issue, there doesn't seem to be much other detraction from low-carb diets. In fact, you could almost tell somebody you're eating a Mediterranean diet, which is exactly the same, almost exactly the same: nuts, seeds, fruits, vegetables, dairy, meats, all naturally occurring unprocessed foods, and they wouldn't bat an eyelid. Yet if you say you're doing a low carb or a keto approach, then all of a sudden that's controversial. But it's exactly, it really is in the eye of the beholder as to what foods are going into your low carb and keto approach.
Yeah, the concern lies with the name, not really with the approach. Yeah.
Correct.
Can the low carb diet also help women handle their cravings and their hunger?
Yes, it can. Yes, that's a really good question, because often women will report, particularly in that second half of the pregnancy, that their hunger has just really escalated. And that's really to meet the demands of the baby who's starting to accelerate with their growth. And we'll usually find in the last half of the second trimester and the third trimester, that's where most of the gestational weight gain occurs as well. So with blood sugars that are well controlled, so you're not on a roller coaster of having high insulin, low insulin, high insulin, low insulin, and having the high sugars and the low sugars drop off as well, you find that when you get the nice control with your blood sugar, you're not ending up with cravings, because the cravings often occur when you produce a lot of insulin that pushes the glucose out of our bloodstream. And there can be instances where the body doesn't completely get that right. So you get a slight dip in your blood sugar, and that is often misinterpreted as I'm, having like a big craving for lots of food. But that was just your body indicating that there was a need to return the blood sugar to the normal territory that it should sit in. So these episodes, if we can minimize them in pregnancy, then we can actually minimize some of this extra craving and hunger that can occur. And then the other thing that can be helpful is using things that are drier. So particularly if there is a little bit of the cravings that are coming in between nausea, sometimes using drier, more easily digestible food is a easier option. And so nuts become a feature, and particularly salting those so that we can maintain hydration, because electrolytes are very important to the maintenance of our hydration status. So keeping in sodium, particularly, which comes in salt, can be quite useful to women. And then the last thing with cravings is that if you do feel like something sweet, you can certainly have starchier vegetables. So below ground vegetables like sweet potato, pumpkin, potato itself, beetroot, carrots. These are slightly sweeter, and they can often satiate the carb cravings or the sweet cravings. You can also access fruits, and there are some nuts that are much more glucose dense. So these are the cashews and pistachios. So I think those can be used, judiciously to try and curb a little bit of that hunger or cravings, and really being quite judicious about pairing that with a healthy fat and a protein, so that you can really have a full meal rather than lots and lots of little snacks that might leave you wanting more quite frequently.
That's an interesting and helpful tip for sure for people. And I know cashew is a favorite in India. So coming into the next question, when is it a safe time or an ideal time to start a low carb diet in both instances? Once they're diagnosed with gestational diabetes, or if they're on a regular, if they don't have any gestational diabetes that has been diagnosed.
So I think any time in pregnancy is a safe time. As soon as possible is really the short answer, because I'd argue that a lower carb approach is also an effective prevention, not only a management tool. So, what is already good for keeping blood sugars normal is really what we should be aiming for from the very beginning. But even if you have missed the boat with that and you're in your second trimester or you're in your third trimester, it's never too late to try to curb that blood glucose. And we recognize this effect in terms of epigenetics, which we spoke about a little earlier, because if you're undernourished in your pregnancy, or you've had maternal diabetes, gestational diabetes, and there is even overweight prior to your pregnancy, all of these things can be associated with an increased risk of diabetes and overweight in your babies. And so we really want to try and reduce that risk. And the nutrition is so paramount in every stage of the pregnancy that even if you can intervene at any point in time, you're still going to have some benefit, because it's a rapidly changing and developing human. Brain development is really key, because it is one of the organs that rapidly develops. It accounts for 25% of the energy requirements in the baby. And what we do know about lower carb approaches is that it allows for a supply of ketones to the brain. And we know that ketones are actually really a key source in a developing brain in the baby, in terms of lipids, creation of cerebral lipids, and to create myelin, which is the covering for lots of nerves. So we want this to occur, and we really want this to occur because of the healthier fats that we are providing in our pregnancy. So I think any stage it can be started and have an effect, the sooner the better.
Another question that I saw a question from the audience, and I'd just like to pitch that in here. Is the oral glucose tolerance test necessary? Would you recommend every woman to go through that to understand whether there is an undiagnosed blood sugar situation going on?
In pregnancy or outside of pregnancy? In the pregnancy, yeah. So in Australia, and I think it's the same in India as well, it's a 75-gram oral glucose tolerance test. And what that equates to is actually 18 teaspoons of sugar in one go. And just to explain for those people who don't know what the test is like, or what happens, basically you go into a blood collector, they take your blood sugar, and then they ask you to take this drink in one go. So you're just downing 18 teaspoons of sugar. Very unusual for a person who has been following a low-carb diet to do this, but someone who is following a standard dietary pattern, this may actually be on par with what a meal might be, up to 18 or 20 teaspoons of sugar in a meal. So then the blood sugar is measured after 1 hour and then at 2 hours. And then based on the values, if at least one of those is abnormal, then there is a diagnosis made of gestational diabetes, and then we go ahead and manage it much more strictly. So should all women do that is the question. And I think we have to be nuanced about who it's offered to, because it's not a perfect test by any means. And it can actually result in false positive results in women who have already been following a low carbohydrate dietary pattern for some time. So the reason this happens is because when you don't eat a lot of carbohydrates, you're actually down regulating your insulin production. Your pancreas will not need to produce as much insulin. So when all of a sudden you flood the bloodstream with lots of glucose, the pancreas gets quite a bit of a jolt, and it can take a little bit of time to produce the insulin back to account for it. And it will account for it, but it may be a little bit slower than the individual who's been consuming this amount of sugar every single meal and is quite used to being able to make very high amounts of insulin to account for that. And that actually brings up the other issue, is we can get some false negative results in these people. So often I've seen in obstetric clinics in the hospital, where we have gestational diabetes specific clinics, there's lots of women who we think are going to come back as having a positive oral glucose tolerance test, just because they have all of those markers of fatty liver disease, high triglycerides. They may be they may be obese, or they may be overweight. And there may be other risk factors for metabolic syndrome. So we would expect them to get an abnormal result, but yet the result will be completely normal. And yet I think then that's really missing the point, because we haven't actually got to the crux of it. They may have quite a lot of insulin circulating their bloodstream, and that can be pro-inflammatory. And all we're doing is measuring the blood sugars only. So I think one way to get around having to do the oral glucose tolerance test is, if your practitioner is open to it, you can use a continuous glucose monitor at the same time as when this test would have been offered to you. Unfortunately, the test is offered fairly late in pregnancy, so it's usually done between 24 to 28 weeks. And the reason for that is it's the peak of the insulin resistance in a standard pregnancy. But we could use in the framework that we use in our clinic is we offer the glucose monitor earlier. So we usually do that at the tail end of the beginning of your second trimester, if not earlier. And the reason we do that is just for women to be able to have insight into what their blood sugar is like, understand how food changes the blood sugar with every meal, understand how exercise affects their blood sugar, stress, and other components of the day, like even having a hot shower in some people can raise their blood sugar. So it puts women in the driver's seat, and it gives them control over what's going on with their body and how they're reacting. And we can use certain cutoffs that are agreed to by the associations that use finger prick monitoring for blood glucose. So we can almost assume, like just say, look, we're going to hold your blood sugar readings to the guidelines of what we would assume if it was gestational diabetes. So, we'd be hoping to get the blood sugar to those markers. And just to give people an indication what that would look like is that a fasting blood sugar should be under 5. A 1 hour blood sugar after commencing a meal should be under 7.4. And a 2 hour blood sugar after commencing the meal should be under 6.7. So if you can do that either through continuous glucose monitoring or your finger prick glucose testing, that's another alternative to going through the oral glucose tolerance test. The last one I would throw out there is, if you don't have thalassemia or if you don't have iron deficiency, you can do a first trimester HbA1c. And if that number is above 5.9, then that's 98.4% predictive of gestational diabetes being diagnosed on a glucose tolerance test. So we can already start from the very first trimester managing blood sugar as though the person already has gestational diabetes. Yeah.
So asking you on another question into the same line, what has your experience been with Indian origin people in Australia?
Yeah, so in Australia, we really do notice that women who are of Indian origin, who are going through pregnancies, actually are disproportionately represented in the number of women who are diagnosed with gestational diabetes. And I think on one hand, there's quite a bit of surprise that comes from these women, because actually the cutoffs are a bit different in India. And I think they're a little bit more generous. So in some ways, we are diagnosing more women now because our guidelines have actually gone through a bit of a change since 2015. And that was off the back of a particular trial, which was called the Hyperglycemia Adverse Outcomes in Pregnancy trial. And it was looking at a very large cohort of women. It was more than 20,000 women. And they found that even small elevations in blood sugar could actually be quite detrimental to the pregnancy. So it was for that reason we actually changed our guideline cutoffs to be how strict that they are, the ones I just described now. So your fasting sugar really needs to be under 5.1. And that has caught a lot of people. And even if you just get diagnosed with one of those markers out of the 3 being abnormal, you're already sort of labeled as having gestational diabetes. But gestational diabetes is a spectrum. And so you could be quite mild, it could be very moderate, it could be quite severe. And so actually in a lot of the women of Indian origin, they may be getting picked up just, more so here than they may have been in India, because they use different cutoffs. And I think in India, the main cutoffs being used at the moment are as per the World Health Organization, but they are also the use of other, practitioner driven choices on what cutoffs they've used as well. So we know that it's 4 times more likely for a woman of Indian origin in Australia to be diagnosed with gestational diabetes compared to other women. And I think one of the reasons this is, there's many, and one aspect is genetic, because we know that women of Indian origin actually have lower pancreatic beta cell volume. So our ability to produce insulin at the quantity or the levels required when we go through a pregnancy, and remember I said that it goes up 2 to 3 times is the normal amount that our pancreas is meant to increase its insulin production by. If we've already got a genetic limitation on our pancreatic beta cell bulk, then being able to produce this extra insulin can be difficult. And I think that's one reason why we may not be then able to control the blood sugar as well, because we're getting the influence of placental hormones, and there's a whole other amount going on there. Then I think it's also the social context, because particularly if there is lack of support, lack of education, lack of knowledge about how you can still eat with Indian cuisine, but in a lower carbohydrate approach, then you can quickly have a prediabetes unveiled, which unfortunately with women, they may not even know that they had a problem up until the pregnancy. So the experience, I think, also is it should be improved for women as well, is that we need to be culturally sensitive and appropriate with our recommendations. And I think in Australia, we've kind of been quite tone deaf about saying, okay, well, cut out all of the roti and the chapati, the idlis, everything, like it all has to go. And then you're going across to a modern Western Australian diet, which it's not really appropriate to the background. It hasn't taken into consideration the cuisine or the taste and the methods of cooking that someone is used to. And add on to that a pregnancy, and then the stress of knowing that every moment that you're not keeping things well controlled, it makes things far more difficult for the woman to achieve, and she feels the pressure of it. So that's been some of the experiences I've observed for women of Indian origin in Australia. So I think we've got a lot that we can improve with, but we have to recognize that there is a genetic component. And often women of Indian origin will tend to be having lower lean muscle mass. And that means that they don't have as much insulin sensitivity at the muscles to store away glucose and create that glycogen. And the last thing is that visceral fat tends to be a problem in people of South Asian descent. So we tend to have far more visceral fat than we do subcutaneous fat. And unfortunately, if you're going into pregnancy with a lot of this on board, that again makes your blood sugar control quite difficult through the pregnancy. So those are just some, I think, ethnicity related reasons why gestational diabetes may affect Indian women far more so. But it also means that they would actually have so much more to benefit from using a lower carbohydrate framework that's culturally and cuisine appropriate. And, seeing someone like yourself, Poshini, would be really ideal, because we're giving somebody an individualized plan that suits their lifestyle. And that's the key to sustainability, not just for the pregnancy, but also after the pregnancy, and setting them up really well.
And that just leads me to the next question, really quick. So is it safe to continue low carb during the lactation and postpartum period?
It is safe to continue it with a couple of caveats. So one is that we encourage people not to do this as a weight loss tool, because some women will come out of a pregnancy and say, I want to lose my baby weight. And unfortunately, if we use keto for that purpose, then you can actually run into some serious problems. And I'll just go through what that may look like. So it's called lactational ketoacidosis, and it's a very rare phenomenon, but it's important to be aware of. And usually what happens is it only occurs if you're quite unwell and you're doing a ketogenic dietary approach. So in the setting of gastroenteritis, or you develop a cold and you're breastfeeding and you're following keto, what happens is that you've got very high caloric requirements. In fact, it's even higher calories than you need in pregnancy. So you actually need 400 to 500 kilocalories per day extra when you're lactating, compared to that pregnancy itself, which is around 300 kilocalories. So when energy demands jump, and your amount of food that you're eating, and if you add on to that fasting as well, and that's been in the literature what has been the downfall for the women who ended up with the lactational ketoacidosis, is that I think the last published lot of meta-analyses, there were 16 case reports that they looked at. It was a systematic review, and they looked at 16 case reports in the literature of lactation ketoacidosis. And this is over the last 50 years. So there's only been 16 documented cases. And 3/4 of the women who were in these studies that developed it were dieting, and they'd increased their physical activity, and they were breastfeeding, and often it was complicated by an infection. So if we know all of those things, what we can do to safeguard from that is you can still continue with the lower carb approach. Don't do any deliberate fasting. Make sure that if you become unwell, you actually increase your carbohydrates. So you do not continue with the low carb approach until you are completely well. And that helps you to avoid falling into the pitfall of lactation ketoacidosis, which can be quite serious, and it can end up with a hospital admission in. So it is something that we can't overlook, but I think with these safeguards in place, and we often advise women to keep a ketone meter at home as well. So if they do in fact fall unwell, or they're feeling unwell, they can measure their ketones first and foremost, as well as their blood glucose, to know whether or not they're in safe nutritional ketosis or they've gone into a ketoacidosis. So that's some of the ways to make sure that the risk of that is quite low. And otherwise, there isn't a problem to continue this longer term into what we call the 4th trimester, so the 3 months after the baby is born, and longer, because the production of ketones can be really beneficial for healing, repair, mental health stability, resilience in that time when it can be quite confronting and new and vulnerable to have a newborn in the home, and when you're encountering periods of stress as well. So for all those reasons, it can be very powerful to continue a low carbohydrate approach.
Thank you, Dr. Deepa. It really was informative. We have less than 1 minute. Could you leave us with some parting notes?
So I think with gestational diabetes, don't panic if that's what you're diagnosed with, or it's something that you're advised that you have from your clinician. There are ways that you can manage this that work from a dietary perspective, and it's very important to find a supportive clinician to guide you with that and individualize it for your needs. And for Indian women particularly, this can be incredibly powerful. It can break the chain of intergenerational diabetes, which unfortunately people of our ethnicity are at far higher risk of.
Thank you so much, Dr. Deepa, for being here. It has been an absolute honor to host you at the Indian Low-Carb Conference. I would like to invite the next speaker, and I see Shashikant already here, and Tim knows that.
Thank you.
Professor Noakes, welcome.
Thank you, Shashi. How are you today? You're having a fantastic conference, it seems.
Yeah, we are so happy to have you, Professor Noakes. It's like a dream come true for us.
Good morning, Professor.
Good morning, sir. How are you today?
All good.
So
I still remember, 5 years back, you had reviewed dlife.in, and today we are, I think, we are the largest and fastest growing community of low carb in India.
Well done. Congratulations.
So you know Anup Singh very well. So you have reviewed the community, and we are so happy that in this inaugural Low Carb Conference of India, we are so happy to have you because we consider you as a guru for low carb nutrition.
Well, it's very kind of you. It's been a pleasure to be associated with you, and I look forward to the next hour.
So I'll briefly introduce Professor Noakes. Everyone knows Professor Noakes. There is no need of introduction. However, there are a lot of new people. There are a lot of people in India who may not be knowing much about you because there are a lot of people who are joined via live stream as well as live stream in YouTube also. So I'll briefly introduce Professor Noakes. Professor Noakes studied at the University of Cape Town, obtaining MB CHB degree and an MD and DSc Med in exercise science. He is now an adjunct professor at the Cape Peninsula University of Technology, following his retirement from the research unit of exercise science and sports medicine. In 1955, he was the co-founder of the now prestigious Sports Science Institute of South Africa, SSISA. For the final 15 years of his academic career, he was rated as an A1 scientist, the highest possible rating, indicating world's leading scientist by the South African National Research Foundation. In 2008, he received the Order of Makumbe Silver from the President of South Africa for his excellent contribution in the field of sports and the science of physical exercise. Professor Noakes has published more than 75 scientific books and articles. He has been cited more than 21,000 times in scientific literature and has an H index of 77. He has won numerous awards over all the years and made himself available on many editorial boards. He has authored many books. In 2003, he received UCT Book Award for Lore of Running 4th edition, considered to be the Bible for runners. Since 2011, he has written his autobiography, Challenging Beliefs, Memoirs of a Career, published Waterlogged, The Serious Problem of Overhydration in Endurance Sports in 2012, published The Real Meal Revolution in 2013, co-authored with Jono and David, as well as Sally and Creed, and following the child-focused version of the book, Raising Superheroes in 2015. The latter two are now published overseas. In 2014, he co-wrote Always Believe in Magic with Kevin and Jonathan, which is the story of UCT Tigers' journey winning the 2014 Varsity Cup. The Banting Pocket Guide was published in 2017, co-authored with Douglas and Allen, and more recently, he has co-authored Lore of Nutrition with Marika. This book actually details his journey from prosecution to innocence. We all know the famous trial which he had to undergo. Nutrition on trial is what it's known as. Following the publication of best-selling books, The Real Meal Revolution, he founded the Noakes Foundation, focus of which is to raise funding to support high-quality research of eating plan described in the book. He is now the co-founder and chief medical director of Nutrition Network and devotes a majority of time to promote low-carbohydrate, high-fat diet, especially those with insulin resistance, and on raising funds for Eat Better South Africa and research through the Noakes Foundation. He is highly acclaimed in his field, and at the age exceeding 70, he is now very, very physically active and also into CrossFit training. So, Professor Noakes, welcome.
Thank you for those kind words. Much
Welcome.
appreciated. I look forward
We
to.
are so happy that you could come to this inaugural function and at the inauguration time. And what we wanted to know was, you were there in the high carb segment on carb loading for running. You were also involved in the development of the gels for runners. How come you have changed the track from high carb to low carb?
So when I started my research career full-time 1981, I just started, well, let me go back a step. In my medical training, I was very interested in endurance sports, and I really was much more interested in sports medicine than in conventional medicine. And when I graduated after a year in hospital, I realized I'm a scientist. I'm not really a practitioner. I'm much more interested in finding out new ideas. So I immediately decided to go into sports science and started that really in South Africa. I then was appointed at the University of Cape Town, and obviously I had to develop a research career. And by that time, I had experienced hypoglycemia, low blood glucose concentration during ultramarathons. And I knew that if you took glucose at the point of exhaustion, you'd recover quite well. And the evidence was in the literature. So, and then that was one side. Then the other side was the person who became my great friend is a chap called Bruce Fordyce. And he had won our famous ultra marathon in South Africa. It covers 90 kilometers or 56 miles. He won it 9 times, which is as unprecedented. And in one of those experiences, he developed hypoglycemia, which he reversed because his father, who was a medical doctor, was helping him on the road and gave him a drink. And he asked many years later what was in the drink, and it was Coca-Cola with added sugar. And all of a sudden, he started running much faster. He was tiring, and then he recovered. And in about 1981, he came to me and he said, Prof, well, I wasn't a doctor then. He said, this made a huge difference. I can't win this race without taking sugar during the race. So I said, no, you don't need sugar. You need glucose polymer, etc. And so we started research together. And then we produced the squeezies on that basis. And they then became very popular. And let me just make the point that in an ultra marathon, it's about the only time you might need a little bit of glucose. So what we'd found was true. But then I got tied up with carbohydrates because the people were funding our research, and you've got to find something that proves they're right. The biggest worry in research is where's the money coming from next year? And I make this point very strongly, that as a professor in charge of a department, you must find research funding. And that's what happens. And so people sell out. They sell out to these interests in order to keep their careers going. Anyway, what next happened was that in that famous race, in actually the very first year I was doing research, a lady developed a low blood sodium level, hyponatremia, and she nearly died. And she wrote to me, and it said the condition had never been described before in history. And so we described it, and we worked out what caused it. She'd simply drunk too much. And why had she drunk too much? Because industry was encouraging people to overdrink. So here I was saying, yes, you need glucose, but you don't need too much water. And I came into conflict with the major company producing sports drinks in America. And I became the enemy number one, because I was saying, actually, you don't need to drink all that stuff. And ultimately, the irony is we used the research money we were getting to study carbohydrates and exercise to prove that you didn't need it. You didn't need all that carbohydrate and fluid during exercise. So eventually, as I clashed with these people, I started looking more carefully at the evidence that they were using to say you needed lots of carbohydrates, either before or during exercise. And then ultimately, and this only happened more recently, when I went back to the original data, I saw that it was associational data. And that means they found an association between two things. But associational data doesn't prove causation. And I've spent the last 2 years looking and being able to disprove that they never actually showed it. So that's the sort of background. So in the middle of all this, in 2010, December 2010, I'm feeling sick and I'm fat and I'm lazy, and I've just written this book about being over drinking, waterlogged. And the night I send the book to America for it to be edited, my brain says you must get up tomorrow morning and you must run, and you mustn't stop running again, because I hadn't been running much. So I went out, I had the worst run of my life. and I came back and I looked at my computer, and there was an advert for a book called The New Atkins for the New You by Eric Westman, Jeff Volek, and Steve Finney. And I was so angry because the book said New Atkins, you've got to eat a saturated fat diet. I said, this is so wrong. These people have sold out to whatever. They've sold out to the Atkins. And I saw Atkins as some sort of guru who was driving the wrong message. So I got so angry. I got in my car and I drove to buy a book, and they had the last copy in the bookshop. And I opened it, and the scales fell from my eyes. The scales that had been there for 33 years. Remember that. And in the end, I thought, how could I have had these scales for 33 years? And the answer was, you weren't allowed to publish anything that spoke about low carbs. It was forbidden in the literature. Anyway, there were 150 studies or something in the references. And I said, okay, well, I'm going to try it. And so 2 hours later, I said, no more carbs. And within days, I felt better. Within a week, I'd lost at least 1 kilo. And my running came back 20 years. I went back to being able to run what I had 20 years earlier. So then I thought, well, actually, they've got something. And then ultimately, I had to be excommunicated by the medical profession and by my colleagues in South Africa for promoting the low-carb diet, because they were funded by industries. The pharmaceutical industry making statin drugs, I was saying you didn't need statins, and I was saying you didn't need grains and cereals, and that's not acceptable. You can't say that. And so I had to be got rid of, and they ultimately that led to the trial that I'm sure we'll discuss later.
Yeah, Anup.
Yeah, Professor, we call you low carb guru, but we also know that you went through a lot of legal hassles. So India would like to know briefly, what was that famous court case that you faced, and why was it?
Yeah. Yeah, okay, I'll try to answer all those questions. So what happened, you've mentioned John Proudfoot and the guys who wrote the book, The Real Meal Revolution. And what happened was, Jono came to me and he said, would I write the introduction? Just 1,000 words. And at the time, I was starting to be attacked in the media by colleagues. That every week or every 2 weeks, there'd be another story in the local newspaper saying how Noakes has got it wrong. I just might make the point that I was, in sports science, I was the blue-eyed boy of academia in South Africa. I mean, there were only 2 people who were sort of considered the top scientists, and I was one of them. And every report in the newspaper was positive. It was for 30 years. I had this unbelievable record of positivity. No one ever said anything nasty about me at all. I could say, well, I said what I believed to be true, and it was generally true. But no one said anything bad about me. And then all of a sudden, when I changed my diet, it started like that. And it was first the cardiologists. And there was a whole story about Noakes as a statin denialist and a cholesterol denialist, and this whole story. And we've had enough of HIV denialism in South Africa. We don't need someone now as a statin denialist. I mean, it was too appalling. And so that was the background. And then when we wrote the book, The Real Meal Revolution, it caused a furor amongst the dietitians in this country. That what was happening was people were coming to the dietitian and saying, well, what do you think about Noakes's diet, this low-carb diet? And because they hadn't a clue, because dietitians in this country are not taught to think, they're just told to follow a protocol, they couldn't answer. They said, no, he's wrong, and this is what's right. So if they were asked, but why is he wrong? They couldn't answer that. So it turned out that the one person who really got angry with me was the head of the local dietetics association. And she started watching everything I was doing on social media and when I was lecturing in public. And in fact, when I gave one lecture in her town, she had 6 of her colleagues came and taped it because they were looking for me to say something wrong that they could report me. Anyway, ultimately, a lady asked on Twitter, she asked the question about we mothers and babies, and it was related to the weaning diet. And I said to the effect that the best diet for weaning is the low carbohydrate, high fat diet. And within 12 hours, I'd been reported to the Health Professions Council of South Africa. So the lady who reported me, this is what's so wrong, because there was no comeback on her. She could just do what she liked. And now my reputation was on the line. And I knew that I was right. So I wasn't going to stand down. And the lawyers for the opposition, they offered me I could easily say I was guilty of X, Y, and Z, and they would have made a lesser charge. I said, no way, I'm going through this thing. And I was so fortunate because I had 2 of the best lawyers in South Africa. And one of them, as you will know, is Rocky Ramdas, and he's of Indian descent. And we became like brothers. We call each other brother. We had the most fantastic time. And I think the best thing that came out of that trial was me becoming absolutely locked in with Rocky. The personality was identical. And we had a fantastic time. And Rocky is supremely clever. And he once showed me, he said, okay, Professor Noakes, let's go through a cross-examination here. So within 5 minutes, I was completely tied up. I couldn't answer anything. So but we had a fabulous time presenting the evidence, and the trial went over 4 years, and we were in court for 28 days, including 9 days where I was on the stage stand and giving evidence under oath. And what we learned was that the conventionally trained dietitians had absolutely no idea. They had nothing to come up with to say that we were wrong. It was totally one-sided. And yet the decision, the legal decision was always in balance because there were 5 people on the committee and there were 2 of them who were on the balance. And we had to get one of them to agree with us, at least. And fortunately, we managed to do that. So in the end, after 4 years in court, I won on every count. There were 13 decisions. It even went to appeal, and I won on every single account. And it was so funny because on the day I was finally found not guilty, the Dietitians Association came and said, he may have won, but that doesn't mean we're going to change anything in the teaching of dietetics in South Africa. So that's how it happened. And we won because we presented the evidence. And that was, they presented one scientific paper, which we showed looked fraudulent. And we presented 7,000 pages of evidence. And the evidence is in the book, The Real Food on Trial or Law of Nutrition. Those are the 2 books, as you mentioned. And there we describe everything that happened in great detail. I think ultimately it was the Health Professions Council wants to have total control of what doctors can say in the media, absolute total control. And we've seen that with the COVID story. They have now gone after anyone in South Africa, any doctor who said anything that countered the standard operating procedures that they were trying to promote. And so a lot of people are now currently facing difficult trials, which are very similar to what I went through, but they're defending themselves for saying something about COVID, which conflicted with the narrative. Ultimately, as I've said, the goal, if they'd shut me up, they would have shut up every doctor in South Africa. No doctor in South Africa could ever open their mouth again on any topic, medical topic in public, without risking losing his license to practice. That was the ultimate goal. Nutrition just happened to be one of the ways that they could achieve that goal.
Shashi, you're muted.
Send the request.
Yeah, sorry. Yeah, I think I was unable to unmute. There is some small glitch. So thank you, Professor. Nice and very interesting story. Ultimately, we are happy that you came out winning the court case, and I think that has set us a lot of precedence, and it has given us a lot of confidence also that the truth will ultimately win. Now, Professor, what is wrong with the current paradigm? Why is it that we feel that all these ancestral foods like meat, eggs, dairy, fat are vilified? What could be the reason? Even after so many studies also showing in favor, still we are mixed up in this.
You know, when I started, I couldn't really have believed what's happened to medicine across the globe. It is totally controlled by industry. And industry is there to sell product. And so it was very clear in the 1950s, Ansel Keys comes along and says that saturated fat causes heart disease. And he did it purely because he lost his career. I've written about this. He was quite famous during the Second World War on a study of starvation. And afterwards, he didn't have a job because he was a physiologist. He wasn't a medical practitioner. The next thing that happened was that President Roosevelt died of a stroke. And the Americans realized, my gosh, here's the president dying of a disease we can't even treat. We don't know anything about hypertension and stroke. So Truman, who was the next president, opened up and started the National Institute of Health. And his first key was to study heart disease and the prevention and treatment of heart disease. And Keyes immediately saw his opportunity. If I can now become the gospel or the guru of how you prevent heart disease, this is where I can make a name for myself. The only problem was that there was another scientist who was way ahead of him. And this person had said, I've forgotten the name.
Yudkin. John Yudkin.
No, that's correct. He was the sugar man, John Gorman, and he came up with the diet heart hypothesis, and he actually had data. But his diet heart hypothesis was different from what Keyes said. He said carbohydrates can cause hypertriglyceridemia, and hypertriglyceridemia is associated with heart disease. And too much saturated fat can cause hypercholesterolemia, and hypercholesterolemia is related to heart disease. So he had the twin things. And he then promoted that idea, and Keyes stole it. And Keyes said, no, it's not the sugar, it's the saturated fat. And then he sold that to the American Heart Association. The American Heart Association was then bought out by the vegetable oil industry in the 1960s, and they were paid a substantial amount of money. So they went from being a tiny little organization in one part of America to having a global influence. And their goal was to promote the saturated fat causes heart disease idea. That then led to a number of studies being funded by NIH. And I've looked at those studies and written about them, and they're all, if not fraudulent, they're completely without proving what they've claimed to prove. None of them showed that reducing the saturated fat in the diet prevents heart disease. And the one that I had the most interest in was the Women's Health Initiative study, and I wrote a long article because the Women's Health Initiative showed that in women who reduced or replaced fat with carbohydrate, if they had heart disease at the start of the trial, their disease rate went up, something like 60% when they were studied for about 12 years or so. But the scientists who wrote the article ignored that. They completely ignored that. They just said diet didn't have any impact, but it did. It made things worse. So, but that's the story. So that the the idea that heart disease is caused by saturated fat was accepted without any evidence. It was sold to the public by industries. And then to make matters worse, along comes the pharmaceutical industry with the statins. And they set up statins to become famous by awarding the Nobel Prize to Brown and Goldstone for discovering that people with very high cholesterol levels lack the receptors to stop cholesterol production. So they said, there you are, you see, now all we have to do is develop a drug that stops cholesterol production and will prevent all heart disease. And that was manipulated. And that then became the message. And that's what we were taught as medical students, that hypercholesterolemia causes heart disease. And by using statins that block these pathways, you can reduce your cholesterol. And therefore, you will reduce your heart disease rate. But that's a model. It's not based on hard scientific proof that happens. And that's what's happened in medicine. Medicine is now all based on model learning. You learn a model. So cholesterol causes heart disease by saturated fat causes heart disease by raising cholesterol. And that's the model. And so when I was yesterday speaking to someone, he said, yeah, but cholesterol causes heart disease. I said, no, cholesterol's got nothing to do with heart disease. So he said, how could you say that? I said, well, I've studied it for a long time. That's how I know. But they managed to sell that product to the population, and we just bought in. And we have to remember, it's a model that has never been proven. In fact, it has been disproven. But no one has the courage to say that. And just to summarize, diabetes is what causes arterial disease. There's absolutely no question. It's not the only cause. There are other causes. For example, there are some causes which are much worse. I think HIV is one of the things that causes arterial disease worse than diabetes. And sickle cell anemia is the primary cause of arterial disease. Because if you've got sickle cell anemia, you are going to get arterial disease, severe arterial disease. And it's got nothing to do with cholesterol. But if we take those examples, put them aside, for the vast majority of the people, and the vast majority of people in India and in South Africa, it's diabetes which causes arterial disease. And then can I just finish up by saying the reason I'm so strong on this is my dad died of type 2 diabetes. And I couldn't help him. I didn't know what the cause was. And just again to remind you that I have type 2 diabetes in remission. And I went in remission 10 years ago by following a low-carb diet. I should be dead by now because my dad died 10 years after his diagnosis. And I've lived more than 10 years with the diagnosis, but it's in remission. So that's why I'm so strong, because people just don't take diabetes seriously enough. And then the tragedy is what happened to my father. He lost his one leg. And once you lose your one leg, you've got 2 or 3 years to live. And that's it, because the arterial disease is so rampant. And people really need to understand that diabetes is the biggest killer. There's nothing comes close.
And that's very interesting. You have always been telling that diabetes is an arterial disease. I've read your books. And okay, now in this screen now, there are 3 of us who are in diabetes remission. Me, you, and even Anup Singh. I am for 8 years, you are for 10 years, and Anup is around 12, 13 years, Anup?
Yeah, completing 13th in February.
13, yeah. So what is it? Why is low carbohydrate still not as accepted? What could be the reason? Even though now it is there in the guidelines, in the MNT of ADA, it is there right from 2019. Why? What could be the reason that it is still not accepted?
I take my example. The reason I had to be silenced was because I'm not good for medicine. None of us, or everyone listening today, is not good for medicine, because we offer a solution which doesn't produce the sale of product. That's it, simple. I mean, one of the people who really is most critical of me is the professor of endocrinology at my old hospital. And her whole career was dependent on selling insulin. Not that she sold the insulin, but she told medical students for 30 years that the treatment of type 2 diabetes is insulin. And they went away and said, well, why do we give insulin? Well, because the professor said so. That's eminence-based medicine. And she never bothered to read the literature or the low-carb literature. And in fact, you know, I was heard recently that someone spoke to her and said, you know, I lost 50 kilograms on the low-carb diet. So she said, I've never heard of anyone losing 50 kilograms. Well, I published articles 10 years ago showing people who've lost 80 kilograms on this diet. But they don't read because it's anathema to them. They know the model. The model is heart disease is caused by cholesterol, diabetes causes whatever, and the insulin is required for the treatment of diabetes, and that's it. And anyone who says otherwise has to be cancelled, and that's what they did to me. And it's astonishing because I just don't understand how a doctor can treat patients knowing that there's a better treatment than what he or she is giving. It's unethical to the nth degree. But again, doctors are not scientists. That's why I left science, left medicine, because I didn't see any science coming through. I just saw this protocol driven. Everything is the protocol. And so you had to learn the protocol, which I couldn't do. I learned the physiology, and then I can understand why you should do X, Y, and Z if I understand the physiology. And that's why we can be right. If you understand the physiological basis, then you can give advice that is correct. Because protocol, you look at the protocol for the treatment of diabetes, it is so complex. It would take me a lifetime to study it. It's which drugs do you use when, under what conditions? I mean, just simplify it, please. Just eat a low carbohydrate diet, and that's the solution. Why learn all this other rubbish that you have to carry around in your head? So to answer the question, medicine is controlled by the pharmaceutical industry, and that's the problem. And the pharmaceutical industry needs to generate income, returns, and insulin is a major money spinner.
Really, yes. Even in India, the number one selling anti-diabetic and even number one selling brand in India is for many months in a year is insulin, the number one. Why should that be so much sales of insulin where the number of type 1 diabetics are actually less? It is all type. It is being pushed into use in type 2. Right?
Yeah.
Anup?
I must just add a very funny story. So when in 2014, I debated some of the nutritionists in South Africa, and in the audience was a cardiologist who runs the statin clinical trials in South Africa. So he's in charge of about 40 clinical trials of statins. And he gets up and he says, Noakes, you're a murderer. Because apparently someone had read something I'd written and her cholesterol was 15 and she stopped taking her statins, and he was convinced that was going to kill her. So he suddenly reappeared a few months ago and started writing me all these letters saying, you see, do you still believe cholesterol isn't the factor? Now, it turns out in the most recent journal of, I forget what, it's cardiology or something, the cardiologists are finally saying, we can now treat diabetes because diabetes causes arterial disease. And we've got these new drugs which will help reverse your diabetes. I'm talking about those antagonists, the GLP-1 antagonists. So those, all of a sudden now the cardiologists, because they can make money out of treating type 2 diabetes, will now admit, oh yes, type 2 diabetes definitely causes arterial disease. But why? Because it was only when a drug was developed, which may have some small effect, they then are on that bandwagon. And so it's just astonishing.
Very interesting.
So, Professor, there's one question. You said diabetes causes arterial disease. Now, majority of the
Anup?
Yeah.
You can speak.
Yeah, majority of the professionals treating cardiovascular disease, they do not look at diabetes as the primary cause. So why is it so? Is it because of their the old school teachings, or something which is driven by industry to sell medicines?
Yeah, I think that, again, medicine is you've got to follow the herd. That's the problem. As soon as you try and stand outside, you're going to get cancelled, as happened to me. And, I was fortunate that it came at the end of my career and I wasn't a practitioner, so they couldn't affect my income. in any way. I was a lecturer at the university, so that I had a fixed income. But if your practice depends on referrals, you're only going to do what other people are doing. And the moment you get seen to be a maverick or a conspiracy theorist, your career is finished. And I think we've seen that with the COVID and the vaccines, that people's careers were completely destroyed if they tried to say that they didn't agree with the mainstream media message. And that's what medicine's all about. If you step out the mainstream, you're in trouble. And it doesn't matter that the patients are dying as a result. No one's got the courage. You know, if I put myself in the position of the dean of medicine, because he was the person at my university who attacked me the most and wrote and really tried to publicly humiliate me and led to my trial. If I'm in his position, I have a choice. I either make South Africans healthy, and the same would be for the Indian community in India. The professors of medicine have two choices. They either make Indian people or South Africans healthy, or they destroy, if they do that, they destroy their faculty, because the faculty is so dependent on money coming from the pharmaceutical industry that the moment they say that diabetes causes arterial disease and it's not treated with insulin, they lose all the funders of insulin. As soon as they say statins are not necessary for treating arterial disease, they lose the industry, the companies that are producing statins. It's honestly as simple as that. So the leaders in medicine, the deans of the faculties, cannot dare say anything that will conflict with the message from the pharmaceutical industry. I know you're going to speak to Jane Bullen next, and she told me she went to an endocrinology conference in South Africa recently. She said it was utterly appalling. There was no science being discussed. It was just this comparison of this insulin dose to that insulin dose in these patients, and that was it.
Yeah, Anup.
Yeah, I mean, you talked of insulin. Shashi mentioned that the highest selling, medicine or brand is insulin. Now, one question that comes to mind is, why isn't insulin testing or fasting or postprandial a norm?
Because the diagnostic criteria for diabetes is probably the HbA1c and a glucose tolerance test. And the glucose tolerance test obviously only picks up very late disease, and the HbA1c the same. Only if you're going to wait till the HbA1c is 6.5, person's had diabetes or pre-diabetes for 10 years perhaps. And it's just because, again, it's the same story. No one believes that diabetes is a reversible disease. So that, and I look at myself. I had evidence that I was diabetic, but I refused to do a glucose tolerance test because I thought, what am I going to do about it? I don't want to go into medicine. I don't want to go into insulin. And I think that's the problem. So that we don't like to make the diagnosis of diabetes until we know it's absolutely established. And we've got these values of 6.5 or whatever. So we delay it. Whereas what the low-carb community brings to the party is actually the earlier you diagnose it, the better, and we can reverse it. We can completely reverse it if within a few years of you making the diagnosis, first becoming diabetic, we can reverse it completely. So that's the problem. And again, the profession's not educated in that way. When I last spoke to the medical students, I go into the lecture theatre and I said, what would you do if it was announced, if I told you that HIV was a preventable, reversible disease and you were never told about it? You weren't told the treatment. So they said, we'd be disgusted. That's terrible. So I said, what if I would tell you that diabetes is a reversible disease and you're not getting told about it? And then they suddenly take note. They suddenly realize, okay, we're onto something here.
So Professor, can we briefly touch upon this high-fat diet in sports, in endurance training, carb loading versus high-fat? What is your view? Have you published studies, something in a very short and specific?
Sure. Well, I'm glad to say that we've just published 2 papers which overthrow 100 years. 100 years of teaching and exercise physiology. So it's very exciting. And the reason we did it was because we're the first person to dare challenge the model. Remember, I said it's all model derived. So the model is that you cannot burn fat when you're exercising at a high intensity. And in exercise, we talk about low intensity, moderate, and high intensity, and we relate it to the percentage of your maximum. So the textbook says the following, that once you go above 85% of your maximum, you cannot burn any fat. You've burned zero fat. That's the textbook. And anyone can go and check that now. Go and pick up any textbook of exercise physiology, and it will say that. By chance, over a period of 4 years, we were putting people on high-fat diets and having them exercise at high intensity. And the last experiment we did, which was critical, we had people go on a high-fat diet and then do 6 times 800-meter repetition. Now, that's a very tough workout. And the reason we did it was we wanted to get their muscle glycogen so low that there was no more glycogen. And therefore, if it's true you can't burn fat, they wouldn't be able to exercise. So we predicted that, well, we didn't predict, we thought this might happen. On the 5th or the 6th repetition, when they were on a high-fat diet, they wouldn't be able to complete the 800 meters, or it would be very slow. And guess what? We found it made no effect. The diet made absolutely no effect on performance during these 800-meter repetitions. But we did one other thing. We measured what they were burning. And we found that at 85% of the maximum, they achieved the highest rates of fat oxidation ever recorded on humans on this planet. We're the first people to measure it because we went out to measure it. Everyone else was too scared. They said, no, but the textbook says this. How can you possibly think it'll be different? Well, we proved it was different. And it's so exciting because it turns out at that rate of energy production from fat, the greatest marathon runners in the world will be able to run a 2-hour marathon just burning fat, which is the complete opposite, the absolute opposite to what we're taught. That's the story. And we're currently doing experiments which are trying to finally validate why you need carbohydrates during exercise. You do need a little bit of carbohydrate to keep your blood glucose normal, but that's it. Your muscle is very happy to burn fat all day long, forever and a day. And you've got so much fat in your body, that's fine. So the world is slowly realizing this. I saw 2 days ago, someone climbed, I think it's El Capitan. There's a famous rock in the Yellowstone National Park. The first time anyone climbed it, they took 4 months. I think they would go a little bit up and then they would come down and then they'd go up and they would use bolts in the mountain. This guy made it in 4 hours. 4 hours, the whole climb, and he was a carnivore. He only eats fat and meat. So
meat, salt, water.
Yeah, that's the one. Yes.
We just read about it 2 days back.
Yeah,
very interesting, Professor. I think your courage to question a paradigm is what is actually helping us learn more. I think it's very, very interesting. I wanted to ask you next about this, Professor Noakes, about the ketogenic textbook. Please tell us something about this. Very interesting book. I'm yet to go through fully.
Yeah. So when we wrote The Real Meal Revolution, we made quite a lot of royalties. And I don't ever keep royalties. I always put them in some other trust to do something important. And I was advised I should start the Noakes Foundation, which I did. And then we appointed Jane Bullen, who you're about to talk to, as our first CEO. And she's done a magnificent job. And it was her idea to start the Nutrition Network, in which we give information and run courses for everyone all around the world. And at one meeting of the organization of our committee that runs the Nutrition Network, 2 of the senior academics there said, you know, what we need is a textbook. We have to design a textbook. And Jane said, well, what's the problem? we'll just get the 62 most qualified people in the world to contribute. And those are the people that are contributing to the Nutrition Network anyway. And so she and the team then set about that, and with brilliant editing and a lot of hard work and at great cost, I might add. It wasn't done cheaply. We produced this textbook, and that is the ultimate evidence why I was right in what I did and what I said. And what you realize when you read that textbook is that this is the most studied diet in the world. There's no other diet that comes anywhere close. That's point one. And point two is that it's the diet that works. It really works across the board of medical conditions. So this wasn't the goal, but all I can tell you is that when my university kicked me out for saying that diabetes is reversible on a low-carb diet, they accused me of promoting a sort of strange diet. I was a quack, etc. Well, that's my answer. That's the book. And the question is, when will they start teaching according to that textbook? And that's why it's there now. No one can ever say again, accuse any doctor in the world of what I was accused of, that I'm a quack promoting a dangerous diet. That's finished. Now we've got the textbook. So that's how it came about. And just to make the point that I was an editor, but I certainly wasn't the driver of it. Jane and her team at the Nutrition Network, they worked so hard. It was unbelievable how much work they put in.
But then it's simply brilliant that finally we have an official textbook. So no more people can say it's a fad diet or quackery or anything. I think it's really brilliant what you have done, what Nutrition Network has done. I'm going to discuss this again with Jane Bullen shortly after your discussion now. It's going to be very interesting. Yeah, Anup.
Fantastic.
Yeah, coming back to the insulin, fasting insulin, postprandial insulin that we talked of, is there any possibility of arriving at a consensus that what it should be? Because lab ranges are criminally wide. Fasting insulin 5 to 25 or something. Or is there any data or study which shows that beyond X it is a danger sign?
Yeah, I don't think so. I don't think we have long-term data on what's the ideal fasting insulin. That's the problem. And all I know is that the people who I trust, they say if you're fasting insulin above 6, you're in trouble. That's a lot lower than the data. And it's really interesting that when I then went back and looked at our research, because for 20 years we'd been studying carbohydrates and exercise. And it's very clear to me that once the insulin's above 6, the metabolic response during exercise is quite different. If it's below 6 during exercise, you get massive fat oxidation. But if it's 7, I mean, I'm not joking. If it's 7 or 8, you cut down on your fat oxidation. It's astonishing. The margins are so small. And I think that's why you have to get to a very low carbohydrate diet for many of us, all three of us, I would guess. We're on very low carbohydrate diets. And there's this cutoff point you've got to get below, and that's to get the insulin down. But, I take it differently. I think we shouldn't focus on absolute numbers. I think there's a totality. When I look at a person, have you got visceral obesity? If you've got visceral obesity, it doesn't matter what your insulin is, it's too high. And that's sort of my argument, is that we know the solution. The treatment is a low-carb diet, and we've got to encourage people to go on the low-carbohydrate diet. And the insulin that they get is then the outcome. We've spoken about we're all in remission, but we still don't know that we're not going to get some of the complications of type 2 diabetes. We hope so, but the one thing is that if it happens, we can say, at least I did the best I could, and that's all we can do. And I think that's the story. We should be encouraging our patients to get the insulin as low as possible, and then assume that that's going to be the best for them. And whatever that value is, that's as good as we're going to get. I want to make the other point, and I'm sure someone will make it in your conference, that sugar addiction and carb addiction are real, and they're the real problem. So that to get your insulin down, you've got to get over the sugar addiction and the carb addiction. So that's the priority, is once you treat that, then you should be able to get the person on the long-term safety. Because I would guess that the people who can't get the insulin down have still got the sugar addiction. And they're still eating a little too much carbohydrate or sugar, and they're cheating and they think it's okay. And for those of us with severe insulin resistance like myself, it doesn't work. You've got to do the best you can. You've got to get rid of as much carbohydrate as possible out of the diet. So to answer your question, I think an insulin above 6 is a problem. Fasting insulin above 6 is a problem. And to get it below 6, you've got to treat the sugar addiction and the carb addiction. And that's what I would focus on.
I think you have put it very interestingly. Though we don't have a consensus, we may not have much data. However, the fat oxidation part is very interesting. It really shows that if we keep our insulin down to 6 and below, we will keep burning fat also. While if it goes above, then possibly fat oxidation may be very less or nil. I think that's what we are facing problem. Now, we are coming to the close to the end of the session. Now, I want to ask you, how do you think low carb can help India? I think you know the statistics. We are facing a terrible metabolic condition. 100 million people with diabetes, 136 million with pre-diabetes. 36% of the population may be having raised blood pressure, not counting obesity, fatty liver, and all the other ones. PCOS, 1 in 5 women face PCOS. Why, how and why do you think that low carb can help India?
Okay, well, we in South Africa is exactly the same. You know, we have the same. In fact, I think we're now in the top 10. I'm not sure if India's above us, but I suspect they are. We're pretty close. The people have to understand that you can't eat ultra-processed foods and be healthy. That's the bottom line. And for some reason, we can't get that message across, even to intelligent people. I talk to so many people and ask them what they eat. And I say, but that's not food, that's ultra-processed junk. And they don't have a clue. So the answer is, until you get the ultra-processed food out of the way in my country, and in your country, the problem would be the rice and the maize, I would guess. And that's the not enough meat, and I understand that. So but you just got to make people realize that if you want to stay healthy, you have to make a choice. And your choice is you've got to eat real foods, and you can't eat ultra-processed foods. It's easy to say it, but the whole industries are against us, and that's the problem. Yeah.
Our situation is challenging. One is the traditionally high grain-based diet, high grain. Our plates will be 60, 70, or even 80% full with grains. And the other side of the problem is the influx of ultra-processed food. And that is destroying the younger generation. We are seeing childhood obesity, fatty liver fibrosis in kids also. And I'm seeing HbA1c of as much as 5.6, 5.7 in 10-year-old or 17-year-old kids. It's terrible.
Yeah.
I think it's going to be. So, Professor, we might take few questions. There is one question which has come is, what is your view on semaglutide and orlistat medication? Semaglutide is the GLP-1 agonist, and orlistat is one that, you know that. What is your view on for weight loss on short-term basis? This is a live question from one of the audience.
I'd say don't go down that route. I think the complications that are coming out are very frightening. And you can achieve the same if you get rid of the sugar addiction and go low carbs. The problem was that you can keep your sugar addiction if you're using these drugs, and you'll get an effect. But the moment you stop, of course, you're going to put on the weight again. So just remember, those drugs work exactly the same as a low carbohydrate diet, exactly the same. So rather do it physiologically than pharmacologically. That's my answer. And the problem, a lot of the weight loss on these drugs is muscle wasting. And then there are other complications as well. And you're not going to get that muscle bulk back again unless you eat a high protein diet and do lots of weight training. So, and we shouldn't be losing muscle mass. That's a real problem with age. So no, I would be violently against the use of these drugs. Why? Because it's just another excuse. You know, don't do what needs to be done, just rather take a drug.
Very, very interesting. And there are, I don't think there are any questions, but I want to ask you is, what struggles do you see in Indians who are there in South Africa in terms of managing their diabetes or obesity or other metabolic condition? I'm sure it must be very similar, but what is your perception? How do you see?
Yeah, I mean, Indian people have a problem in that mostly you don't like to eat meat. I understand that. The cow is sacred. I understand that. Well, I must just end up with a funny story that the Indian Consul General in South Africa became a great friend of mine over the last 2 years. And he started running, and he then came to me about his diet. And so we put him on the carnivore diet, and it was incredibly successful, and he ran brilliantly. But you can imagine it was a bit of a problem for when he had meetings and he had to eat the conventional diet again. So it's interesting that people can adapt, but it's complex. And if it's a religious issue, that's very, very difficult. And I don't know, I've got no answer for that one. The vegan issue is the same. The vegans are incredibly unhealthy because of their diet, but you can't talk to them about it because it's a religion. So I think in South Africa, Indians living in South Africa, probably there is quite a lot of meat available. So if they're prepared to eat meat, it's not such a problem. Or they can eat dairy and fish and chicken. So I suspect there's a slightly more availability of high protein real foods in this country than perhaps in India. And that might make it a little bit easier for Indians in this country to cope with their diabetes.
The challenge will be real. I mean, here, while we say that it is highly grain based, most of us are vegetarians. When I say vegetarians, we take dairy proteins. That means we have the famous Indian cottage cheese or paneer, and then we have yogurt, we have cheese. So primarily we need to depend more upon this, is what we can see. And someone has asked a very interesting question in the live screen. How can low carb diet be used as a tool to gain weight in case of a lean person with insulin resistance? Is there any solution?
Yeah, I think that's quite difficult. On the other hand, anorexia nervosa, there are now some studies where people eating the low carb diet are doing very well for the treatment of anorexia. So if there's an eating disorder, I think that the low carb, particularly more meat-based diet, would be helpful. But to put on weight would be okay if you needed more muscle, then this is the diet that you want. Can I just finally add that carbohydrates are totally non-essential. You do not need carbohydrates. And so people think that they must eat carbs to build muscle. You can't build muscle from carbs. There's absolutely no way to do that.
And I guess the answer to the question, as you say, is high protein and go and build your muscles. I think that will be the proper way to gain weight, and in the right manner, instead of eating carbohydrate and loading up on the body fat. I think it's very nice. So, right. Professor, we are coming to the end of the session, and what is your message to India?
Yeah, well, we face all the same problems, and we just have to change at a global level and make people realize that processed foods are the problem. And if we're ever going to get on top of the obesity, diabetes epidemics, we can do it. We know the cause, but we have to address the food environment. And that's a problem, because we're fighting ingrained industries which are there to sell product. So the only answer is go back to the traditional diets. And in India, it's the diet from the north. There was a very famous researcher, McCarrison, who came out to India in about 1920. And he was told by his Oxford professor that the most interesting studies on nutrition could be done in India, because you had such a variation of foods and had the different somatotypes or body types. And they argued that the body types were better in the north because they were eating meat and and dairy. But as you came south, the more wheat and rice was eaten, there was more ill health. So India has always been a very good example of the effects of nutrition on health and body status. And so it would be great if the Indian president could come out and say it's time to change the diet. It needs someone at the very highest level to make that point, and for governments to start making it very difficult for companies to sell these processed foods at in such a wide range across the board.
Very interesting. Thank you. So, Professor, I wanted to personally thank you for coming in this occasion, in this first ever event, and speaking to India. We are grateful to you and for your knowledge which you are disseminated not only today, but for the kind of work you have been doing for years and the kind of initiatives you have been taking. Thank you very much, Professor. Anup?
Thanks. Yeah. Thank you both so much. It's been a great pleasure, and good luck with the rest of all the work that you do, and strength to your arm, and maybe you can still change all of Indian eating patterns.
One at a time. One at a time is what we are doing. Thank you, Professor.
Thank you.
My pleasure.
Namaskar. Jain, welcome. Welcome.
Thank you so much. Hi. Good to see you both.
So, Jain, let me introduce Anup Singh. So, Anup Singh is the founder of D-Life, one of the largest and oldest Indian community community which propagates low carb and change the life of thousands of people. Very big community with lot of Indian dishes, and of course, 2020 they have also launched low carb diploma, low carb nutrition diploma in India, more Indianized one.
Yes.
So, yeah, Anup.
Yeah, welcome, Jen. Welcome to the first ever and the largest virtual low carb conference.
Thank you both so much for this vision and for bravely flying the flag. I know it's a lot of work that goes into this, and Shashi, we've been watching the incredible work that you've been doing, and when you kind of first thought this up and actually imagined it possible, and here we are. Well done. Thank you for having me and us. Such a privilege.
Thank you. And I'll introduce Jain first. So I think most of us might be knowing, but many in India may not be knowing. So Jain Bulan is the managing director of Nutrition Network, and as a chief operating officer of the Noakes Foundation, she established Eat Better South Africa alongside inspiring colleagues and Professor Noakes, and she believes in building a strong collaboration in the nutrition and science. After realizing the dichotomy between brand research budgets and human health research, she decided to leave the formal research world, committed to bringing her global experience in big biz research, systems, and policy changes expertise into new areas to affect human health. So Jain Bulan is an MBA in Chevening scholar, high deep in marketing and international relationships graduate. In her MBA at Leeds University, she focused on regulation of marketing to children in the food and fast foods categories, later conducting pan-European media research and strategy evaluation in this area for various global health bodies and brands. As an extension of a collaborative vision for the future of human health and better healthcare system, she co-founded Nutrition Network and has been its managing director since it was founded in 2018. So Jain, welcome to India's first pioneering largest low carb conference called Metabolic Health Conference. We are so happy to have you.
Thank you so much, Shashi, and thank you both of you for your vision and for doing the work that needs to be done, pioneering the way in India, which needs the support, needs the change and knowledge to be brought there.
So what has gotten you into low carb world? We are very curious to know.
So I have had a lifelong journey with insulin resistance. Of course, like most of us, we didn't know what it was for probably the first 20 years of the process. So I've been kind of in the category we now know as pre-diabetic insulin resistant since, I would say probably since childhood. Realistically, it was first actually medically detected and diagnosed as PCOS when I was about 20. But the signs, when I look back, were there long before that. And from that time on, so from sort of around the age of 20, quite young, I went on the journey of trying to get it right and fix it, of course, as most of us did. And that was totally, for many of the years of that journey, the wrong place, the wrong application of how to fix it. So it started with, the low GI diet and the low fat diet and the high, very, very high carbohydrate diet, and on it went. And of course, as it progressed, the more the disease progressed, the more extreme I became. So I went through a phase where I became vegetarian and then almost vegan, eating a very higher and higher carbohydrate diet that was perceived as healthy, more and more whole grains, fructose in my coffee and tea, because that was the healthy solution, of course, which led to non-alcoholic fatty liver disease down the line. We now understand why. And on it went. My metabolic disease progressed. So eventually I got to the point, which I know you both have, and I was just listening to Prof. Noakes also before this talking about it, where I fortunately, I never tipped into full-blown diabetes, but been very close over many times in my life, and eventually found low carb at some point along that journey twice, and twice had incredible results, and then gave it up because I was worried about, cancer, health, like early on in the journey when it was still the Atkins and no one understood that you could actually reverse diabetes. It was like, well, this is working, but oh my God, it's going to give me cancer and kidney disease. And it's so dangerous that I'm just going to do it for a short intervention and then go back, which of course continued for many, many years. And like most of us, it took us up to 20 years. So eventually I, through that long journey, did come to the Noakes Foundation and suddenly got it really, really clearly, particularly working with and inspired by Prof. Noakes, who is just such an incredible embodiment of a low-carb lifestyle and such an example to so many of how to do it correctly and how it can work over the long term. So that was what led me here and led me to the Noakes Foundation, wanting to get out of big business, out of corporate, out of the place that is the main driver and contributor towards global disease.
Fine. So, yeah, Jen, you briefly described, how you landed up at Noakes Foundation. Now, the next question is, what's your work responsibility there, basically? And what is your aim?
So at the Noakes Foundation, our aim has, for many years, since it was founded in 2014 by the Noakes family, and Prof. Noakes shared a little bit earlier about why it began, which was that he had reversed his diabetes, and he had obviously had a very big story and journey of indebtedness or wanting to fix things for himself in his own health journey from his own father's story. And then from that, it led to a need to want to give that back, the knowledge back, and make it more accessible to everyone. And I joined a year later in 2015. I was the first employee with, sort of not realizing, I don't think any of us at the time realized what we were getting ourselves into necessarily. But we started something. We looked at the research, and originally it was created really to fund research. So that was what we did in the first year, was we got some really, really good funding in. And we had 5 full-time students that we funded at the University of Cape Town, which is where Prof. Noakes at the time still had an office in the Sports Science Institute there. It was before the Sugargate moment where his profession rejected him. And at that time, we were very research focused. But what happened quickly from there was when we started to really look at the research, and the research that was being done had been done, and we intended to do, we identified a couple of flaws with it, or gaps with the research. And the one was, of course, that it had been done on a very specific segment or demographic, which meant that it had been done mostly on men of a certain age bracket that were sort of a certain health statistic. And it hadn't included the ethnic and demographic diversity that we see in South Africa. It hadn't necessarily included women in that research. And in particular, the research groups and sample sizes had been small because the funding wasn't there. And that was my first big absolute shock, was I came from a much more corporate research read into that heavily funded research environment. And when I first started to look at firstly the sample sizes and then the budgets, I thought that there were a couple of zeros missing. Like I just couldn't believe that it was possible that such important research had such tiny budgets. It just made no sense. It was like, how is it possible that advertising research can have these enormous budgets, like 100-fold bigger than research that is into the future of human health and the actual optimal diet for humanity? So there's and we all know it. I mean, there's a huge problem in terms of the funding of research for the good work. So that was the big moment that I had where I just went, this can't be possible and we have to change this. And very quickly after that, I met with a woman called Iodia Sampson. She's an actress from the Cape Flats in our area, an incredibly passionate human being who understood that our poorer communities in South Africa had not had any access to this science, and they were the ones that needed it the most. I also met with a woman, an amazing woman who you know well, Shashi, Dr. Hasina Kaji, and at the time she was working in the largest government hospital in our city in Cape Town. It's a hospital called Grooteskieu. She was heading up the high care unit there, and she had the same vision. So the three of us met, and all three of us agreed that something had to be done very quickly on the ground, on the grassroots level. So the research was commissioned, things were going on a high level, or what sort of a more systemic policy change level. But what about the rest of the country? And what about the people in South Africa that at the time were just basically dying without even being diagnosed correctly? And that's across the entire spectrum of chronic disease in our country, but particularly diabetes and, sort of arterial vascular diseases that are associated with diabetes. A lot of the time people are not diagnosed, and when they get to the point of diagnosis, they're so far along the line that there's almost no hope left. And then at that point they were arriving at a hospital in a very, very acute scenario, and were being sent home with our standard dietary guidelines as their treatment and as their long-term kind of support system. And that, we all know, was what was killing them in the first place. So we created what's called now Eat Better South Africa. And that was very much from the support of the Noakes Foundation that agreed to pilot and fund one study, or one program actually, with a group of about 60 women that lived in a township near Cape Town, and that was suffering from sort of typical, metabolic disease symptoms. And that was where it began, was we said, well, we've got to do something different. It's not only about the research, it's actually also about just taking this work out educationally into the world so that people can get access to the information and start changing their lives. But we don't have time to wait for medicine to change.
So in Eat Better South Africa, I mean, are you providing some food or something? How is it? What exactly is it?
So what we started with was a 6-week program where we went into a community, as I said, this group of 60 people that signed up, and we gave them the tools that they needed to adopt a ketogenic or a carbohydrate-restricted diet. And that meant starting with quite a big panel of bloods, pulling out candidates or patients that needed medical treatment. So obviously anyone that was on any kind of, sort of hypertensive or diabetic drug that needed actual tight removal or restriction over the program, and anyone that needed like extra special attention was treated by a physician or doctor. And the rest were seen weekly by a nurse who did the basics like blood glucose and hypertension, and then very importantly, weight and waist circumference. And that was the sort of foundation of the program, was that people would come together in a community hall once a week, and we would bring in, they would share, of course, that we would look at their bloods, we would look at their glucose, we would talk to them, we would bring in motivational and educational speakers. And we did not give them food, but what we did do was our diet. They wrote up a meal plan of what they had eaten for the days before the intervention, and then we adapted it very importantly to what they were already eating. So we absolutely didn't go in there with the Real Meal Revolution book and say, right, you all have to give up everything you're doing and start eating butter grass-fed steak. It was very much like, okay, well, you're eating porridge and, ultra processed food, and this is what your diet looks like right now. And how can we change what you're eating so your plate looks similar, but it's a lot better? So that was the intervention. And the first one, or the pilot, was incredibly successful. Like, it was beyond our wildest dreams, actually, that we imagined that it could work so well. And because it did, I think we've run over 35 interventions now, which we still call them pilots, because we're still learning as we go. And we've never reached the scale that we would like to in terms of how we know that this works. We now understand, 8 years later, that it is a very, very sustainable and easy to adopt, easy to teach, and affordable intervention. So we believe it's the solution and the replacement to the treatment of chronic disease to some extent, or it's certainly the preventative approach that state healthcare should be and could be taking, which is very, very affordable. So in our country, we've brought it down to what we call 13 rands, South African rands per day per person. And that equates to, in US dollars, that's about 70 US cents a day for food. So it can be done, a ketogenic and diet and intervention can be done on very small budgets and with very careful consideration for communities that don't have access to expensive, fancy keto foods and supplements. And I think that's why it's really interesting to share this information with the Indian community, because there is that perception that a ketogenic diet or a carbohydrate restricted approach is expensive and it's for the wealthy, for people that have access to all the really expensive foods. And that's not the case. In our experience, it can be quite the opposite.
Let you say that the steak or meat is costing less than porridge, or is it costing same? How is it?
Sorry, so a steak homemade is costing the same as porridge? No, definitely.
Does it cost the same as porridge, or is it cheaper, or is it costing more? How is it?
Significantly more. I mean, like way, way more. So we're talking probably 10 times more, but that's not the only solution. So what we find is that there are a lot of other alternatives that we can use that are low carb and are significantly healthier than this kind of ultra processed, high carb, refined grain porridge that a lot of people are eating. So in South Africa, it's maize, it's something called millipap, which is a maize, a very, very refined, decolored maize product that is like almost pure sugar carbohydrate, refined carbohydrates, which we know is ultimately sugar. And what we can look at is ways to, and it's very, very cheap. So that one of the main reasons for eating that is price point and accessibility. So it has a very long shelf life. It's quite easy to cook. And then the other aspect to that is that there is an understanding or a belief that that is a traditional food. So culturally, it's kind of happy food for a lot of South Africans. They want to eat that, and they don't feel satisfied if their meal doesn't have a significant percentage of pap in it. And I think in India, it's the same with kind of things like rice and naans and bread-based things that go with your main meal. So a lot of the work has been to change that. And part of that has been to create substitutes for that. And it's also been, more recently, it's been ways to educate people so that they get that bowl better without necessarily getting it 100% perfect. So we go for eating better, not perfectly. It may be that we get 60% less refined carbs on that plate, and there are still some, but at least the macros are balanced better, and there's a better variety and diversity on the plate.
I think that's very interesting. See, like you told that even if they reduce by certain percentage, even if it is 40, 50, it's still a win for them.
Yes.
From whatever 80 or 100% carbs they have. I think it's an excellent thing which is happening. And now we'll come to very interesting topic, that how was the idea developed for launching Nutrition Network? What all went behind it? What was the objective of coming out with Nutrition Network?
So as from the Noakes Foundation, where it really began was that we had this little list on our website of low-carb practitioners in South Africa. And we had probably like 10 people or less on there. And of those 10 people, I think I went to 2 or 3 and kind of left and thought like, what are they doing on this list? They don't really understand, like it was probably an argument or a debate more than a consult. So it was disappointing and unsatisfying for me as a patient personally, and then I'm sure for thousands of others. And then what we found was that most people, because of this unsatisfying experience, were coming to Prof. Noakes directly, trying to actually get him to answer their medical questions, which he, of course, had. I think when I joined, there were probably like way over 3,000 sort of things that he was keeping, wanting to respond to people, really like important questions that they hadn't been able to get answers from medicine, and they were desperate. So it was this question of, well, what are we going to do with all these patients, and how are we going to fix this problem? It then evolved into a more pressing matter, which was that with Eat Better South Africa, we were taking groups of people through a low carbohydrate intervention, and we were needing referring doctors. So we would go into a community, somewhere around the area that we operate in, and we would have to find a doctor and then try and train and convert a doctor to understand the science so that we could get them to treat the patients during the program. It was quite hard work, and it involved Dr. Kaji, who was our medical director at the time, doing a lot of driving and actually taking on a lot of those patients herself, because there was no one else, or there were very few other people locally that understood low carbohydrate science. And yes, of course, a lot of people did. But we weren't confident that they actually knew enough to really take a patient through a reversal process. And that's ultimately what we were heading for and wanted to achieve. So we as a foundation decided, okay, this is what we have to do. We have to train doctors. That was where we needed to start. And we started with Dr. Neville Wellington, who has a very, very early progressive practice in the process of diabetes reversal through diet, and Dr. Hasina Kaji, who came from a more state healthcare physician's perspective of wanting to help underserved communities. And we decided that we were going to try and train a handful of doctors in South Africa, so that within a year we would have a group of people that we could refer patients to. And what happened instantly was that it was actually a global solution, not a local solution. So we were very lucky. It, of course, was quite a difficult time for us, because we didn't realize how much of a need that was in the global community when we launched in 2018. So that first year we trained many hundreds of doctors. And since then, we've trained over 7,000 practitioners around the world in over 100 countries. So it grew very, very quickly. We were very lucky that we took this risk. We decided to do it. And it was very much created as a way to fund the Noakes Foundation and the really important work that we wanted to do there on the research. So it fulfilled that goal to a large extent, or to some extent. I wouldn't say we've done as much as we could have and wanted to. But that's where it began, which was really with just seeing a need and wanting to fulfill it for our own support structure locally.
That's very interesting. So you say that this was founded for the purpose of educating doctors.
Yes.
And then you started educating us coaches also.
Yes, so that came a little bit later on. So we were very much medically focused, and we still are to a large extent. So, medicine was the first thing that needed to change the most, perhaps, I would argue. And our kind of founding vision positioning was to change medicine one practitioner at a time. And we really felt that we needed to find places for patients to be supported. It was really from a patient's eye. It was like, I'm going to say from my own eye, I was an angry patient, because, once I got the science, and I'm sure you've both been through this, it was like, I thought back to all these kind doctors. Doctors are always mostly kind people that really want to help their patients, that had given me the wrong advice for 20 years. And firstly, I was like angry at them. And then obviously unpacking it more, I realized that it wasn't their fault. They were doing what they were taught. And then it asked the question of, well, what is wrong with what's being taught, and how on earth are we going to change what's being taught? This can't carry on. Like, we've got to intervene here. I want my son, who's now 15, to actually have like healthcare that understands metabolism and understands diet. And I want his children to be treated in a way that is going to give them the opportunity to have a healthy life. and not be an obstruction. And that it's almost like medicine has somehow become an obstruction to health. So we changed in 2018, we were founded, and about a year or two later, we changed our vision from changing medicine to changing healthcare. And that was important because that's where coaches came in. And we realized that we can't do this without coaches, and that behavioral change and lifestyle cannot be changed by a doctor. People go to doctors when they're in an acute stage in their lives, when they're ill, when they're diseased. And that gives doctors an immense amount of power, of course, to really shake a person up, to shock them, and to make them make a decision to change. But then they leave with their packet of pills and a diet sheet, and they head off home in shock, and they probably go past the shop and grab, either a Coca-Cola or a McDonald's or something that is what comforts them, because that's how they got diabetes in the first place. And then what? And then how do we actually change? And coaches are one of the most important pieces of this toolkit. So we call our coaches advisors. Advisors are just that first stage, which is just a person like anyone out there that wants to offer advice, whether it's to their husband and wife or to their church community or to their school or anything like that, or to their business. So we have a lot of people that work in policy or government or structural systemic places that want to know how to advise about nutrition in an informed way. So that was sort of where we began with coaches, as we said, let's offer people the opportunity to advise others on their health or their diet, but not in a way that's medical, in a way that just brings the science in. And of course, then you were one of those. Thank you for trusting us with your knowledge. And I know you've done so much and have trained in so many areas. So you're such an incredibly informed, embodied coach. But of course, then what came from that was that we realized that's not probably enough for people like you that want to really take it far and actually make bigger changes with patients and walk the line with them. And that was when we started to do a much more intensive certification, where we really, once someone's done that, we know that they know the science and they know how to change, actually implement meaningful change. There we go. And that's what leads to that. It's a long journey. But once somebody has got that qualification, we know for sure that they are able to manifest and implement meaningful change for a patient or a client. And that comes with healthcare and with medicine. So the vision behind that was that coaches and doctors or physicians work closely together on a patient to support them change their lives for the long term in a sustainable way.
Very interesting. And it is not only, it is local is a small part. You have gone global. I mean, we have a full colleagues and groups across the globe. Like in this coach practitioners, we have made friends. We are there into WhatsApp from across the globe. We have formed a sort of alliance also. And can you tell us more about what are the different courses available? See, coach practitioners is an advanced one, where you select a few people and who can do. What about the other courses? What exactly are they? What are the other courses? Hello.
Shashi, my apologies. I lost you.
There's some signal issue. So what are the different courses which are available? We know the coach practitioner is an advanced one. What are the other courses available?
So we have, since 2018, we have actually produced 36 CME trainings or CPD, depending on which country you're in. And those trainings are quite diverse in the nature that sounds like so much, and it has felt like a lot, but the reason we've taken so many trainings is because of the need for them. So as we've gone, we've realized there's a gap here. Science keeps evolving. The story and the science keeps changing. And with that, we've had to keep bringing out trainings. So our sort of foundational trainings we have a training called Ketogenic, which is obviously based off the book. So it mirrors the book and it's seen as an adjunct training to the book. And that's really the basics for medical professionals. So it looks at it's kind of the 101 of therapeutic carbohydrate restriction. We also have applications of that are specialized. So we have a dietitian's version of that and a nurse's version of that, that are a little bit more tweaked. Obviously dietitians deal with different things. They need different kinds of collaborators, and nurses the same. So the nurses is very hands-on. It's wound care. It's very practical. And also nurses, I just want to mention nurses, because nurses are one of the most important pieces of the healthcare puzzle that are very, very underestimated. And we really want to support nurses in as much way as we can. Nurses are the people that have actual conversations with patients when they're hospitalized, when they're crying, when they're really at their most vulnerable. The doctor or the physician comes in quickly and they're busy, and they, rub the patient's shoulder and give them a script, and they don't have the time that it takes and the care that it takes. So nurses are very important, as are dietitians, of course. So that's our kind of foundational training. And then attached to that is the advisor training, which is the basic training for coaches or advisors or lay people. So a lot of people like personal trainers, people that work in sports and sports nutrition, people like yourself that have come from business and want to influence, do that training. And then from there, we've gone into specialized training. So we have things like the basic sciences, that's a new training. We have things like women's health. We have clinical applications and clinical practice of LCHF. We have diabetes reversal training. We have an obesity reversal training. These are slightly shorter trainings. An important one that we have, which forms one of the foundational trainings on the Society for Metabolic Health Care to become an SMHP or an MHP, is an ethics training, which helps healthcare workers understand better how to work with media and with communications around communicating sort of the use of low carbohydrate science in medicine. And that's important because so many people have felt very isolated, very targeted, very afraid to talk about the science because they're worried that they're going to have to go through what Prof. Noakes went through. They're also worried about they're not sure what they can and can't say about nutrition. So for a very long time, if not forever, doctors have been seen as not being allowed to talk about diet in medicine. So they are not allowed to talk about the diet with the patient, and they are told to refer a patient to a dietitian. And there's this sort of overt, exaggerated separation between medicine and diet. And it's a huge problem because, people are seeing a physician or a doctor for a health problem, and the doctor's concerned about talking about the patient's diet, which is in most cases of chronic disease, one of the primary drivers of the disease. So this is, we want doctors to have, particularly doctors, but a lot of other specialists in other areas, to have much more confidence in the way that they talk about the importance of diet in treating patients and in medicine again. So it's an empowerment. The idea is to re-empower around diet. We've also got some slightly more neurological psychiatry type trainings, and then also one training which is for patients, and that is designed for a doctor to give to their patient when they're diagnosed, so that the patient can kind of reverse themselves. In principle, that was designed by Dr. Neville Wellington, and based on his incredible success story with hundreds of patients over years, to reverse their own diabetes ultimately. And the doctor's there as a guide, and to prescribe, or ideally to deprescribe medicine, but ultimately a patient's journey is their own, and it's up to them. So I'm not diabetic, but I've got a CGM on my arm at the moment, and I'm trying out new things as we go and testing it, and bringing in a few little treats that I like, and then being shocked and horrified, and in some cases not shocked, and going, okay, well, this is okay for me and that's not. And that's the empowerment journey. That's how we change health for the long term, is we learn ourselves. And doctors, many of the doctors that we work with are actually doing this because their patients sent them to us, not the other way around. Going through some of the other courses, we've got a really important training that I wanted to mention for the Indian community, which is called the Eat Better training. And that's a group facilitation training that is based on our model that I talked about earlier, Eat Better South Africa. So it's exactly what we did with these groups in our local community. And why it's relevant to India is because we have similar problems or dynamics within our socioeconomic structure, where we have, a very, very high Gini coefficient. We have the wealthiest people in the world and the poorest people in the world sitting and living very closely to each other. And this was designed for the poorer, or what we call kind of the community people in our country who have very limited budgets. So it's for anyone that's interested in supporting those communities to eat better. We actually decided we're going to offer everyone that's based in India on this training 80% off, so almost free, hopefully, if they want to do that training. I've got a code here for you if you want to use it, which I can share with Shashi later. So we'd love you to just do it and see if there's a way that you can apply it. We would love to see it. Eat Better India. It doesn't have to be Eat Better South Africa. Like, how can you get India to eat better and to support, we don't want to see more than 100 million diabetics in India. That's more than any country should ever have to face. We also have sports nutrition. We've got a training around resilience that came out of COVID, is how to bring resilience into your lifestyle changes. And then a very important training, I think, probably one of our most important trainings we've ever brought out last year, was called Addictive Eating, where we, for the first time, along with our global community, realized that we can't just be going on and on about the science, and that we had to start offering addiction support. And not everyone calls it addiction. So we've called it addictive eating. We like to look at it as behavioral change. But ultimately, diabetes is this function of addictive or behavioral or emotional eating. In many, I'm not saying that's the case for everyone, but perhaps more than 80% of diabetics have a problem with eating, or an eating disorder that needs to be addressed. So that's an important area that we are growing into the next year with some other more customized trainings. Women's health is a very specific area. I'm just going through our list. There's so many trainings that I'm not going to go through all of them. We'll be here all day. Another important product of ours is our community. So we have a community that's kind of the cheapest way to engage with the Nutrition Network. You don't have to spend hundreds of dollars. What we try to do is to make our trainings affordable and add value. And our community came from our community asking for a place where they could be in community. And as you said, you talked about your group on your coach certification, how you've become like I don't want to use the word family because that might sound a bit cultish, but how you've become a support system for each other. And what we saw was, before low carb, in 2018, or even in 2014, when the foundation first began, the people were very isolated. So like Prof. Noakes had to really kind of be he is a bit of a rebel, but he had to be quite rebellious in his decision to, as a patient and as a practitioner, because he's both, ultimately we all are, or all practitioners are also patients to themselves. He had to be very rebellious, and he had to go through a hell of a lot. A lot of unnecessary trauma, and he had to do a lot of work with his family and his colleagues around acceptance. And I think many people that have been adopted a low-carb diet have had this problem. And I know certainly in India that's even more exacerbated because of the combination of vegetarian and high carbohydrate plate that you eat. So you're going to a social gathering, community eating, and then the outlier. You're the different one. And it's even more so, even much more so, I'm going to say 10,000 times more so for practitioners. So isolation was one of the biggest challenges that our practitioners were facing. And they were, somewhere in the world alone in a hospital that did not support actually thought that what they were doing and talking about was illegal potentially. And then what? Like, how on earth do you navigate this? And what do you do? And who is your community? And is there anyone nearby? It's like a lot of people had no one near them or in their country or even continent necessarily that understood their language and that could give them advice. So a huge part of our global community that so many of us, there's so many incredible, and this is an example of that, is there's a community of people that have found each other. And how do we support them? We create beautiful events like this. So thank the both of you that are such visionaries in this. But then how do you, in India, which is what you're doing, and Anup, what you're doing is you're creating a local network of people that can be there to support each other. And it's only through numbers that we're going to actually change the future outlook of human health. It's only when everyone understands the science, and it gets down to like school teachers. Actually, I mean, my son came home 2 weeks ago with the food pyramid in his book, and he's kind of clever enough to know when not to talk about low carb, and he just fills it out with the carbohydrates, the whole thing at the bottom, because he wants to get full marks and he doesn't want to fight with his teacher. But it's like our schools here are still teaching that food pyramid with the mass. Almost 50%, I think it's more, 60% of the diet is refined carbs and grains. And, not a lot's changed yet. So communities are important. We have one solution, which is a community platform where there's good conversation, where there's good dialogue. We don't find Facebook and places like that are ideal, even though we're all there all the time and we love to talk about it. The majority of our participants do not want to be on Facebook. They don't want to be on our listings page even, because they're still scared. So that's a tiny percentage of the people that have done our trainings are actually listed as having done our trainings. They're still somewhere in the world being quiet about this knowledge. And that's a huge injustice.
I think many from our own D-Life community have done courses in Nutrition Network. It was very interesting. And from the Nutrition Network group itself, we have some speakers. We have Dr. Andrea Salcedo coming in tonight in India. We have Dr. Nurzetti, Dr. Carlos, to name a few. So
amazing.
All of us, Dr. Louis Philippe, how can I forget? So she's also going to speak on the last day. So from the same community, we have a lot of medical doctors in favor of low carb is also going to speak. Yeah, Anup.
Amazing.
Yeah, then you had shown, given a brief glimpse of that textbook.
Yes.
Textbook. So can you please, talk more about what all efforts have gone into getting it 2 stands, basically? Everything.
Yes. So I know Prof spoke quite a bit about this and the amazing story of kind of why we did this, which I think is obvious. There's something about this, which is feeling the actual weight of something in your hands and having it to turn through. And it didn't feel real to me. I mean, it took us 4 years almost to publish, to go from kind of start dates, not conceptualization was before that, but from the date that we actually signed contracts and it was a go, to this point that this actually arrives on our desks. And it seems like a long time, but when you look at what's in it, it makes sense. We've got 68 authors, 11 editors, 2 managing editors, and a million other hands that went into the production of this. So I don't see it as ours necessarily. I see this as like a project of the collective that allowed us to put something together big enough and solid enough in terms of referencing that we actually have a huge, convincing, heavy 540 page 1.8 kilograms. And I know this because I had to leave 2 of these at the airport when I was traveling to America recently, because I was about almost 4 kilograms over and I had to take them out. So I know their weight. That's what was needed. It's like, I don't see this much evidence in any other diets that I've ever seen before. I haven't seen the science behind the low-fat, calorie-restricted diet that is this weighty and this solid and this significant. So we knew it was important that we had to go there and that we had to actually print and cut down trees to make this point. Even though our community has known it for so long and has been working in this field. So it's very easy when we're working together and working with our colleagues in an environment where we all agree. But out there is mainstream medicine that is still teaching, that still filters through into children's textbooks having the wrong food pyramid there. And that means that for the next 20 years, those people are still going to typically end up with diabetes because of what they've learned now. So this is a long-term game, and I think we're all in it, So 4 years to write the textbook isn't long in terms of the fact that it takes between 20 and 40 years to change a system. And that's what we're trying to do now. So we're trying to say there are flaws in the way that medicine has evolved and adapted. Unfortunately, somewhere along the line, it went from all the beautiful visions that we see in the Hippocratic Oath, which is why many of the people I know came to medicine, is they really, really do believe in the values espoused by, Hippocrates and when medicine began, which is really to put the patient's life first and to support health. And there was a lot about nutrition back then in the very early days when medicine began. And somewhere between then and now, well, we know what's happened. And we can't blame, because every time we've gone to the shop and chosen with our wallets what we want to buy, we've been part of the system and we've supported the wrong choices. So this is one of the important pieces of getting acceptable science on the right desks, hopefully in a sustainable way, so that people will start to use this and look up conditions. So what we've done in this textbook, quite carefully and with immense respect to the editorial team that really, really spent years talking this through and structuring the contents very carefully, is we have almost every kind of scenario. I mean, of course, it's not all comprehensive, because we need probably another 5 versions of this book before we could actually include every application of therapeutic carbohydrate restriction. But what we've shown is that iceberg that a lot of our amazing lecturers often share in their talks, and that Prof. Noakes often uses, which is that the tip of the iceberg, which is diabetes, obesity, and chronic disease, what's going underneath, what those different illnesses and disease profiles look like along the range of it, from insulin resistance to full-blown diabetes, and what sits under them, which is everything from neurological disease to cancers to everything else, cardiovascular, not everything else, but so many other things, from cardiovascular disease to, I mentioned cancers, to a whole range of neurological and musculoskeletal and immunological considerations and diseases and challenges that we face, and then how we're actually going to use these to treat patients. So in principle, a doctor could have a patient at their desk today, and they could, instead of going and picking up the Merck manual, which is basically a pharmaceutical listing of a disease matched to a drug. So they can, it's very easy. I mean, I've been to so many doctors in my many, many years of health challenges where they've gone, oh, okay, you've got this is the blood results. And then they've picked up the Merck manual and they've looked it up through the index and they've written a script and said, right, this is what you need to go to the pharmacy, go and buy this is your solution. And we've ended up very, very addicted to medications and to the concept that medicine is what's going to reverse disease in this modern world. And unfortunately, we now know that that is not the case, and that in most chronic diseases, medicine doesn't really work. So what we're hoping is that the doctor will maybe look at the Merck manual as well, because there's nothing wrong with medication in the correct application, but look at this and go, okay, well, this person is looking, rheumatoid arthritis can be treated for acute problems with, very often it's with an opioid, which we know is addictive and kills people. But at the same time, let's look at a therapeutic dietary medical protocol alongside this that is heavily referenced, heavily evidence-based, and the patient's going to go home with at least a couple of options. And what we hope is that's through the range of medicine. So, from the functional medicine, where they're going to go with maybe just a diet and a couple of supplements, and all the way through to the very, very allopathic range of things, where they go home with the script is the most important, but there is attached to that script a couple of other things that are dietary and that are consideratory and that are going to bring in different perspectives. And that's all that, certainly for myself as a patient, I'm not angry anymore, but all I wish was that I'd had other options presented to me at the time, and not just you must take metformin. It's okay, well, what is metformin? And, there was very little around that. You could take metformin, or berberine, or you could try like changing your diet in this particular way and doing a lot more exercise and addressing your trauma and stress, which was one of the huge drivers of my particular condition. No one really told me those things. So it created a huge amount of anxiety for me because I moved from South Africa to England when I was 20 something, a couple of years after I was diagnosed. And in England at the time, insulin resistance was not recognized by the NHS, the National Health Service, as a condition or a medical condition that needed treatment. So I would go to my local GP and he would go like, oh, your blood sugars are fine. And they didn't test for insulin or for anything else. In those days, they didn't test for HbA1c even. And then I would say, well, okay, but my doctor in South Africa prescribed me with metformin. Can you give me a script? And he'd say, no, definitely not. Like, that's for diabetics. And then, 20 minutes later, I would leave there either in tears or feeling like screaming because it was like pointless. And then I would come home once a year and get a 1-year script and take back a year of metformin because there was this anxiety now that like, oh, I have to be on this particular drug because that's the only thing that's going to help me. Meanwhile, of course, now I know that that's just one thing, and I didn't really need the metformin necessarily. I just needed advice and knowledge, and no one gave me that. I really had to work very hard to find it at huge cost to my own health, at huge financial cost and at huge emotional and burdensome other costs to actually get to the answers, as did you. I'm sure both of you did too. You didn't just have them presented to you. You had to go really far and be quite rebellious and argue and fight and just to get this knowledge. So let's hope that our next generation of doctors at med school and our children don't have to fight the way that Prof. Noakes had to fight. I mean, I'm talking about how I had to have a little argument with my doctor, but Prof. Noakes had to go and sit in front of a basically the global media was at his trial there, kind of trying to gun him down. It was extremely traumatic. He plays it sometimes, but it was a 4-year grueling battle that nearly tore him apart and tore a lot of the being of who he was. It put it into question and put his integrity into question. And I mean, he just did this because he saved his own life, ultimately.
Very nice. And I think this is, as you say, that this book is heavily referenced. So people cannot say that this is not a well-known science. People cannot say it's a fad diet. People cannot say it's a scam, fraudulent. Nothing people can. Now that we have a textbook, and that too published from Elsevier, it is an official textbook which medical doctors can refer. And I think any one of us can always use now this book as a reference. I think it's a pioneering and big breakthrough which has come from Nutrition Network. I think hats off to all the contributors, all the doctors who have contributed, the editors, and as you say, millions others who have put in a lot of hard work in really getting this together. I think it's hats off. It's a big thing.
So I'm almost imagining going back 20 years now when I sat at that first doctor that diagnosed me, and just imagining that like he'd had this there as well as the Merck manual. And that's hopefully what we're going to imagine into the future together, is that like we really do change the way people are treated by medicine and the way that health is seen. And there are options given to patients early on.
Thank you. And so, Jen, we are almost coming to the end of the session. And what is your message to India?
So I would say to India that you don't need to have these 100 million diabetes. We know that it's probably double. So when we see a statistic about diabetes, 100 million, we know it's at least double, because there's at least more than 2 of that are along the range pre-diagnosis. There is going to be some changes that will have to be made in what your perception of tradition is. But it doesn't mean you have to give up traditional diets. You don't have to change what your sort of understanding of like community eating and tradition is to be healthy. And you can find a way to be healthy within the system that you're living in. So, and Shashi, you are the example actually, and you are the living message. So there's the message right there. Look at you're a person who has fully reversed diabetes, and who is living an incredible life. So you've probably given yourself an extra 30 to maybe, knowing you, 100 years extra that you wouldn't have. You would likely be dead or dying by now if you hadn't found this. So I think my message is to keep an open mind and actually just to eat better. So it's to eat better India. Like, don't think that you have to go the whole way. Find ways to change small things on your plate. Find ways to eat, if like halve the rice and bring in something else there. Eat half the chapati or eat half of the naan or things that have got a lot of refined carbs in them, and bring in Indian food is one of the best, most incredibly diverse foods in the world. So, like, don't fall into that trap of believing that you have to eat a high sugar, highly processed, ultra processed food diet. I mean, that's wrong. And that's a function of like decades of kind of cost cutting and challenges in the food system. So be a part of the change, ask questions around what you're eating, and then be demanding when you need to be, and say no to certain things. You don't always have to say yes to the food that is put on your plate or that everyone around you is eating. And sometimes that means, upsetting a couple of people and doing things a little bit differently at certain holidays and festivities and things where there is a particularly high carb environment. How beautiful. What an opportunity.
So I am 8 years in remission, and Anup Singh here, he's more than 12 years now. And I learned everything from him. It's due to. So Anup is here for, more than 12 years, Anup, in remission?
Yeah, completing 13th in Feb.
So amazing. He never even took any single tablet of metformin. He was so adamant.
Jen, when I started low carb, there was no reference available, in the sense no one was there to handhold. Now, obviously, as you said, Mark Manuel refers. When I went to him, he said, if you're going for low carb, high fat, you will have multiple organ failures within next decade.
Yes.
And here I am still alive. So that speaks about the credibility of the diet and medicine free.
Amazing, Anup. Wow. So just to the two of you, obviously, Shashi, we know each other quite well. And Anup, I know your work, and I've been watching your amazing work that you're putting out into the world, and you're both such incredible pioneers. So I feel so grateful to be in your company and to be able to offer whatever support that we can and that I can to really support India. India is an incredibly important country to me in my heart, and I know to most of the world, but particularly to me as a lifelong yogi and sort of follower of a lot of Indian cultural belief systems, in particular Ayurveda and other things. And it's like, we can't see India falling apart and, it's kind of dying of diabetes. Like India is a place where health is actually manifest and comes from in the world, and where people from all over the world go to find health. And this work is so important, and what you're doing is so important. So as I said earlier, we would love to support anyone that wants to do our Eat Better training, which I believe could just be applied to Eat Better India. Like, I think the applications and the switchover aren't that difficult to make. It's a very culturally designed and informed program. We've got a code, it's EBSA, EBSA India. And if you purchase the Eat Better group facilitation training, you get 80% off, which is the best we can do. That's like below cost. So it's kind of almost free to anyone that wants to, that's at the summit and that's based in India, that thinks that they might be able to bring those ideas into their local community. We would love to invite you to do it and to see what you think, and to let us know what you think you can do and how you can work, obviously, with the two of you and with us in any way that we can support global health.
And then certainly it is something, I invite Anup Singh, and there could be a collaboration between D-Life and Nutrition Network. Maybe Anup and Jen, you can design a course which could be useful for the global community. No doubt D-Life has a local nutrition course for Indians, but what about many doctors would like to know how to treat an Indian patient, because Indian patients are very tricky, not very easy to handle. So our cuisine changes every 100 kilometers. So I think maybe Anup and Jen, we can design something which is mutual, something we can design for the Nutrition Network platform. I look forward for this.
Well, we've got so much to learn from India. The world has got so much to learn from India about how to eat how to bring flavor and joy and community and connection into food and eating. So I think that's an amazing idea.
Thank you very much, Dan, that you can spare 1 hour for India and come and share the pioneering work that has been done in Nutrition Herd, in network, in being a global educator on low carb, as well as taking the initiative of getting the first textbook. Thank you.
Thank you.
Thank you both so much.
Namaste.
Looking forward to the rest of the weekend. Bye-bye.
Thank you. So we can get Poshini and Dr. Westman.
Good, yeah, thank you. Today we have with us Dr. Eric Westman here. Dr. Eric Westman, welcome to the Metabolic Health Conference.
Thank you very much. It's my pleasure to be here. Thank you for having me.
It's really a pleasure for us to have you here. For our audience, I'd like to give a quick and short background about who Dr. Eric Westman is. He doesn't really require any introduction, but Dr. Eric Westman graduated from Stanford University. He did his MD from the University of Wisconsin, Masters of Health Sciences from University of Kentucky and Duke University. He's an associate professor of medicine at Duke University. He's a board-certified doctor in obesity and internal medicine. Dr. Westman founded the Duke Keto Medicine Clinic in 2006 after 8 years of clinical research regarding low-carbohydrate ketogenic diets. He is the director of the Duke Keto Medicine Clinic in Durham, North Carolina. Dr. Westman has published over 100 peer-reviewed scientific publications. He is also the founder of Adaptive Life Academy, which offers various courses to understand various aspects of low-carbohydrate diets and ketogenic diets, and its many applications. He has also authored multiple books: End Your Carb Confusion, The New Atkins, Keto Clarity, and Cholesterol Clarity, to just name a few. Dr. Westman, definitely I'm a huge fan as well, but welcome, and just a brief introduction. And I'd like to let you know that I've segmented this conversation into the scientific aspect. Then we'll talk a little, tackling on the negatives or the myths around keto diets, and finally jump into the context of it for Asians and Indians perspective. So do tell us how you came across low carb and keto, and what really convinced you.
Sure. Well, we have to go back a few years to 1998. So 25 years ago, I'm working as a general doctor at the Veterans Affairs Hospital. So it's what my training is in internal medicine, and the Veterans Affairs system is all over the country. It's not insurance or private pay. It's actually part of the governmental health system. So I'm treating people, and I guess I was an unusual internist in that I was interested in prevention. And so when I saw two people fixing themselves, basically losing weight on their own, and I had tried to help people lose weight. You have to lose weight, sir. You have to lose weight, and I send them to my staff dietitians. It never seemed to work. So when I saw two people closely in time losing over 50 pounds each, I was curious, and I asked, "What did you do?" And so can you imagine the doctor asking you, what have you done? Well, it happens a lot now, but back then, one of the gentlemen, remember, they were veterans of the war. That's the Veterans Affairs Hospital, and they were mostly Vietnam veterans that I was seeing more specifically. But one gentleman looked at me and he tried to shock me. He said, "All I did is eat steak and eggs." And oh my goodness, and you lost 50 pounds doing that? I don't believe you, But then he introduced me to the Atkins diet, basically. And I went to the bookstore, I read about it. You could pick it up at the bookstore. And he actually was a doctor working in New York City, but everyone around me, I started asking, my other friends would say, "Well, you don't want to use that. Don't even study it, because the cholesterol will go up." And this is kind of like the first response you might have today, if this is your first impression of looking at this approach. So for me, 25 years ago, I thought, when my patient came back again, he lost the weight and he kept it off. And I said, "No, you shouldn't do this because your cholesterol will go up." He looked at me. He said, "Why don't you check it?" And I thought, well, why not? It's a hospital where they'll do the blood and they'll draw it and they'll check it. His cholesterol went down. And so 2 in a row, the cholesterol levels went down in these people. Everyone else said the cholesterol would go up. So I'm thinking that there's a saying that, I smell a rat, or, if lightning strikes once, like it's a rare event, it just struck twice in the same spot. And this is not supposed to happen. So I was curious, and I thought, like most people, well, you would seek out information, and you kind of, what I did is I reached out to Dr. Atkins. Even he had a clinic and an address. I wrote him a letter, and asked him about your diet, Dr. Atkins, and he calls me up on the phone, and I kind of had forgotten that I wrote the letter because I'm busy with other work. And he kind of says, "Well, what do you want?" And well, I had several patients on your diet. Of course, it wasn't his diet in the end of the day, but we all blame people for your diet, and they lost weight. And he said, "Well, good. That happens every day, in my clinic." And so we went back and forth, and I said, "Well, you need to do research. Where's the research? There's no research in your book." And he said, "Well, why would I want to do research? I've been doing this 30 years. I know what I'll find if I do research." And I said, "Well, Dr. Atkins, no one believes you. There's this big disconnect. Everyone thinks you're doing something that is harming people." And I think that got him, and he solved the issue himself by saying, "Come to my clinic in New York City." Now, so in the US, that's a 2-hour flight by plane. My staff wanted to go to New York City to have fun for the evening. So it wasn't hard to convince them to go. I was researching something totally different. And so I spent a day in their clinic, and I saw the charts of people coming in, and the cholesterol numbers getting better and the weight coming down. And at the lunch hour, I said, you need to study this. I'll do it for you. Here's a proposal. And so they funded us to go back to Duke and Durham, it's a totally separate place, separate entity under a university setting, to do the first study. And, so it was published in 2002. The 50 people on the Atkins diet or low carb diet, we didn't call it Atkins in there, although we cited him as funding the study, which caused some ruckus in the review process because the reviewers said, "We're not used to seeing studies funded by doctors." But when I asked Dr. Atkins, he said, "Nobody else ever asked us to do research." So the disconnect was so big that when I came back to my hometown university to do the study, my colleagues said they probably hired Broadway performers, actors, to be patients, and they duped you, they fooled you. And I said, "No, I really don't think that's true," because I saw the people, and well, it might have been true. Well, but so any good researcher wants to study it themselves before telling the rest of the world that it works. And so that's what we did. We did one study after another, randomized trials, and then Jeff Volek, Volek, at the same time was starting to study the same low-carb Atkins diet, but in a different way. He did very close studies, giving people food, even having them come back. And I was doing the outpatient in a clinic, obesity, diabetes studies. So over the last 20 years now, there's even a textbook that the South African group did a great job of being the senior editors of that. And we contributed chapters in the textbook on how to use the low-carb diet for diabetes and for obesity treatment. And now, through the lens of 20 years and being skeptical at first, and so I knew it could work because 2 of my patients did it. And so you might be in that situation where, oh, well, it can work, but it's not going to be healthy. You can't do it in the long run. Well, I've satisfied myself to a fairly good clinical scientific degree, at least over the last 20 years. And then doctors, were using this back to 1860, really. And then if you take the big view, humans probably were eating this way for hundreds of thousands of years before the agricultural revolutions occurred around the world. So I'm pretty confident now with our own clinical research, our own clinical care, even, that you can use a low-carb keto diet in a clinical setting or even as a healthy way of eating without concern about the safety. Don't worry about the cholesterol level. And if it does go up, there's a high likelihood the good cholesterol went up as well. So I talk a lot about the metabolic syndrome aspects of the blood, that you want to look at triglyceride and HDL. And so now, my clinic has, 5-month waiting list at a 5-month queue to get in the door. And that's one reason why we started a company to teach people online. And I'm teaching more people online than in the clinic, but I can't reverse all of the different diseases without seeing people one-on-one. So that's another pearl, is that if you're trying to reverse diabetes and obesity and metabolic issues with this diet, you want to do it under medical supervision with someone who knows how to de-prescribe the medicine to do it in the safest way. Now, I've had people come in and tell me they took themselves off medicines and they're doing great. It's possible to do that, but I want it to be as safe as possible. So through the years, I was roped into being in the leadership of an organization called the Obesity Medicine Association. So I started teaching the low-carb diet and keto diet as it's called today. But our approach is not using all of these new keto products and drinking oils and butters and specialized salts and things. You don't need that. Remember, my start in my studies were done around the year 2000 as a beginning, and it was using the Atkins method, which was from 1970 to 2000. This is way before there were apps, way before there were ketone measurements, way before there were specialized apple cider vinegar things. And so I don't incorporate any of those things in my initial teaching. In fact, I erase the fact that people are doing that as much as I can, because if you're drinking oils and butters and coconut oil and all, you're going to have to burn through that oil first. If you're trying to lose weight, it makes it more difficult, and it makes it more difficult to reverse diabetes as well. So we have a term called internet keto, which is the use of all of these really kind of untested things. And the keto diet that I teach in the office really is another version of what was called Atkins induction or protein power, the books that doctors used from 1970 to the year 2000. And I'm very curious about adding on ketones and other products, but they really haven't been studied yet to the degree that I use them in my practice. So I'm pretty much the old school, real food, no biohacking. You don't have to measure anything, because if you keep the carbs low enough, you're going to be in ketosis. You don't have to measure it. If an airplane is coming down and you feel the deceleration and you see people getting bigger, you don't need to know the altitude. Now, today, a lot of people want to know the blood sugar reading or the ketone reading, but the method I teach doesn't require any of that. So after starting my own clinic, I have to say I have a great job. I mean, I created my own practice, and people are happy because in general, they're getting better. I have students and residents and visiting doctors who come. Just looping back, that's how I got involved. Dr. Atkins asked me to come to his office, and that was brilliant because there were so many barriers that, so you may be looking at this and saying, no, that's not possible because of that, because of this. Well, you're welcome. Oh, right. If you can make the trip to my clinic, or maybe we can find a clinic, model clinic in your country where it wouldn't be so far to travel. But I have to say, I have had people travel from around the world to just come to my little office and see what we do. I can also teach people on Zoom, doctors at a doctor level, how to do it. And it's really pretty simple. And that's going to be one of the reasons why you can't believe it. You know, it's too simple. And I know it's so simple. Well, it's kind of, I now say it's kind of like the doorknob or the aqualung scuba tank. It's so perfect in design, you don't need to change it. And so the method I use was made so well that I really haven't had to change it very much. And the key is to keep the total carbohydrates really low so the body fat can start burning pretty much automatically. And that's, I'm just going to end on a final sort of, don't worry about this. Everyone goes into ketosis. If you don't eat for 3 days, your body starts burning the fat that it has on its body. This is normal. And in fact, it's probably a survival requirement to be able to go for periods of time without food. So when someone says that it's harmful and it's going to kill you, I just kind of shrug and say, no, there's no evidence for that. In fact, it's almost like, would you design a phone when it's low on battery? Would you design it to self-destruct when it's no? So my phone says, you know, do you want me to go into safe mode or low battery mode? I said, yeah, you know. So when you don't have carbs around, after 3 days, everyone goes into nutritional ketosis. It's normal. And so it's really, I think, not a secondary fuel system or a backup fuel system. It can be the primary fuel system and actually therapeutic for reversing so many chronic medical conditions that my doctor friends just use medicine to palliate and to manage. And so I'm a fixer. I'm a they have a saying, a DIY, do it yourself. Yep. So, you know, you give me a piece of yard work to do, I'll be out there digging and I want to fix things. And my doctor friends don't fix much with their medicine in terms of chronic medical disease. So if you're struggling as a doctor or frustrated, learn about this, and it's transformational for doctors. One of the most influential TED Talks was done by Dr. Sarah Hallberg, and she came out and you know, she's a former aerobics instructor, and so she looks, you know, really healthy, and she said, I have the best job in the world. You know, and then from then on, the TED Talk just gets better. And so doctors actually regain their interest in helping people. And if you went into the medical or health field wanting to help people and you find that you're not, and there's another tool. Of course, the secret weapon is food. And so then most patients now come away saying, in fact, yesterday, this fellow said, that's not what I expected in the clinic meeting you. And well, I hope it was a good thing. And he said, oh yeah, it's a lot better. You know, he thought he was going to have shots and pills and all this. And all I did is give him a food list and explain that you can be a fat burner by not eating carbs.
And this is why you call it the prescription strength of the keto diet, because you see the application of it in all areas. How does it really differ? Is when you look at the science, how does keto diet really differ from a low carbohydrate diet?
So the carbohydrate level can be graded, or there's an amount of carbohydrate in the diet. So let's say you start at 0. If there's no carbohydrate in the diet, the body has to find some fuel, and we store our energy as fat on our body. So the body will start burning burning fat if the carbohydrate level is 0. So a typical American diet is like 300 grams of carbohydrate, and an apple has 20 grams, a cupful or fistful of rice has 40 total grams of carbs, and a slice of bread has 15 total grams. So if you're eating bread and pasta and rice, the carbs add up. And so a low carb diet is defined starting at about halfway there. So 300 is typical American, 0 here. So 150 carbs a day is starting to get a low carb, but it's not keto. It's not ketosis. So you get down to 50 grams. Some people will be in ketosis. If you're active, you're young, you might be in ketosis. And ketosis just means fat burning. But when you get down to 20 total grams a day, just about everyone will be in ketosis. So we defined this in a paper, the American Journal of Clinical Nutrition. I'm the first author, Westerman et al., the year 2007, where the 50 gram is low, very low, and then very low keto is under 20. It's individual. So some people at 30 total grams will be in fat burning mode, and you can check for that. But the hunger going away and you're starting to lose weight, you're in ketosis. But that might shock you if this is the first time you've heard about low carb keto diets. Like taking a Band-Aid off very quickly, a plaster or a Band-Aid. If you do it all at once, cut the carbs all at once, it's less painful, and you might crave for a day or two. The worst thing you can do is have, I'll just have a little rice. I'll just have a little bread. That's like smoking a little bit every day. And you can't quit smoking if you smoke every day. You haven't quit. So actually we do a cold turkey, getting all of the carbohydrate out all at once. And that's kind of the method that it has stuck for Dr. Atkins years ago, Dr. Eads, Dr. Bernstein, who uses this for type 1 diabetes. The studies now in the medical literature that are being done are starting with this very low level, and they work really well. 20 years ago, some of the studies started with higher carb and they lowered it, and it didn't work so well. And some studies started really low and then increased the carbs. That's like lowering the dose of the medicine. And so these people had no clinical experience. They were researchers, so they just dreamed up a protocol and read a book on how to do it. When I visited Dr. Atkins, he kept the carbohydrates very, very low until you reached your goal. When a lot of the researchers started following what the book said, they didn't take the time to talk to the doctors. When as a doctor myself, I felt compelled to learn from the doctors who had used it. And so if you go way back, our first paper, Yancey et al., 2004, randomized controlled trial, low carb versus low fat. The results we got with the low carb diet in numbers of weight loss, kilograms, is better than the other studies because we kept people at a higher dose of low carb diets. Now, those studies have all been put together in meta-analyses. And what's curious is there, I think, 4 meta-analyses now. And I don't know why people keep doing meta-analyses, but so there are studies of studies, summarizing them and averaging them. And pretty much across the board, the low carb diet works better than low fat diets for obesity and diabetes. It's not to say that low fat diets can't work. So don't get me wrong, and it's not a competition. We want to find things that work for people, and there are people who can do well on other approaches, but this one, according to the science, is more powerful in the hands of the researchers and in my clinical experience too. So in my practice, people will say, I've tried everything. So you start getting into this practice, don't worry. People will say, I've done everything. Well, they really haven't. but they'll say that, and I did Atkins, and then I'll say, well, you haven't done keto with me, or you say you haven't done Atkins with me, because a very important element is the support and the follow-up. And so the classic story is, I did Atkins, I don't know, 15 years ago. Well, that was when our studies were coming out. It actually had a social blip, and then it stopped working. And I'll say, well, did you stop doing the diet? And they'll say, well, yes. And well, because there was no one there to help them stay on it. And so now doing it with a simple system, it's important that the system be simple. When life gets busy, people are not going to want to take time to do your little tweaking. They're going to want the big picture view. And then the support. Over the last few years, I've learned a lot about sugar and ultra-processed food addiction. And some people absolutely need that support for the coaching, and then the role modeling and the explanation of, why do I self-sabotage myself, doctor? I'm doing well, and then I'll just want to eat the rice or the bread, and I can't stop. And what's interesting is sugar addiction or ultra-processed food isn't just sugar. It's just as likely to be the savory sides of foods, the pasta, the rice, even fruit. And that causes my fruit, I thought fruit was healthy. And I'll say it can be healthy, but in the context of a low carb diet, when you're trying to burn your body fat, you're going to have to burn through all that fruit before your body fat's going to start burning. And then people, and then the next question, of course, is, can I never have fruit again? And I say, yes, you can. So there's a weight loss process, and there's a weight maintenance process.
Yeah.
And so I reassure people at the beginning that it's not forever. We're not going to lock you up. And when you get to this point of reaching your goal, I want to be there to help you understand how to very slowly add back carbohydrates, the ones you really like, and not just the gratuitous munching in front of the television, that this can be erased pretty quickly. But so there's a early process of the teaching, teaching the mechanics of the diet. There's the longer term social, how do you work it in your own life? This doesn't have to be expensive. I have had many people just eat at fast food restaurants like McDonald's and Burger King and Kentucky Fried Chicken. And I don't eat at these places, but this isn't me doing it, right? So I teach the foundation, and people will find their own sources of food, which I guess is another thing you wanted me to address. You don't have to have super clean food. You don't have to search out the avocado oil, which is hard to find in our area, and it's very expensive. You don't have to have the grass-fed beef in our area. It's kind of hard to find, and it's expensive, and it makes it out of reach for so many people. So what I teach is kind of known on the internet as prescription strength keto, but then also lazy, dirty keto, not in a bad way. It's in a good way. It means that you don't have to spend a whole lot of time doing this, worrying about it. And in fact, if lazy means people are doing the work for you, then that's great. Think of it as a positive thing. And if it's dirty, just means that you don't have to worry about the super clean food all the time. You do the best you can. I don't want you to, really have unhealthy foods, but I don't obsess so much about the internet does in those areas.
That brings me to our myth section, and I really want to get I'm a big fan of Westman Reacts, so I'm hoping for a question for Westman Reacts series. And how do you respond, or how do you react to the concerns about the environmental impact of the high-fat, animal-based ketogenic diet?
Yeah, and that is a common concern, especially among young folks, the youth. They're being trained or indoctrinated in the idea that animals not only contribute to climate change, but a popular element that I hear is that they're unhappy and against the unethical treatment of animals. If you're growing them in cages and feedlots and things, I mean, I have to agree that I want to promote changes in the way meat is produced so that it's humane as much as possible. It doesn't bother me. Humans, at least a subset of humans, have always killed animals for sustenance, and I'm very grateful for that. I as a grew up in the Christian church, Christian religion, and I'm very thankful. We pray at meals, and so it doesn't bother me personally, but I know it bothers a lot of people, the ethical treatment, and I hope that changes. The other element of the climate change is more complicated than people are making it. And it's unfortunate that so many people kind of just are almost it's like mind brainwashing into thinking that if I have animal products, it's going to worsen the climate change. There are a couple of movies documentary films that I highly recommend that address this. One is called Sacred Cow, and the other one is called The Biggest Little Farm. The first one has to do with the climate change and low-carb diets. The second one is just a dramatic story of people who reinvigorated soil with animal dung. So the topsoil on Earth, when you get into the detail, and I look to Peter Ballerstad as an expert in this area. He gives talks about this. He was talking to me years ago about how actually you need ruminants and you need ruminant agriculture to feed the topsoil of our planet. And so if you just go into plant-based kinds of things, that we're destroying the topsoil. Now, I'm getting a little bit out of my clinical setting. Can you tell? My strength is reversing diabetes, but one of the last talks that I did with Peter is he pointed out that the climate carbon footprint of medical care, of hospitals, of treating diabetes, of the drug development, all that, way outweighs the implicated climate change of food. So that if you could reduce diabetes by changing the food, you would reduce the carbon footprint by people not having to have hospitalizations and buying drugs, and the drugs are being developed and things like that. So that was an interesting kind of twist on it that I hadn't heard before, because we're not just talking about eating meat, we're talking about reversing and preventing disease and human suffering. So I think there are a lot of ways to be healthy, and you can actually use low carbohydrate principles within a vegetarian context, so that you just don't want to have a lot of the sugary things. You want to stick to the vegetables and the combinations of vegetables that will give you total protein. So I'm not. I will do a Reacts soon. Thank you for talking about my Adapt Your Life YouTube channel, and I'm proud to have gotten a play button on the wall. But I'm responding. I'm kind of protecting the keto space now. So if someone is just saying blatantly false things about keto, and there are a lot of people that do, I'm reacting and trying to give a scientific response, which means you have to prove that it's harmful. You can't just say it. But there's no one out there. There's no company protecting the word or protecting it. If you said a drug was bad, the company's going to come after you and tell you that you can't say that, right? So anyway, I'm glad you're watching that. I've had a pretty good response so far. I'm new to the idea of YouTube, and once I got comfortable talking in front of 1,000 people. We don't do that anymore because of maybe that'll start up again.
What about any incidences of fatalities due to prolonged keto lifestyle? How do you react to that?
Well, I have to say I've had people die. That's what happens. They're not dying of heart disease that was the first prediction that everyone would get heart disease. I mean, even within her first study was 6 months long. And one of the, well, you might give them a heart attack. Well, I don't think so. I talked to these other doctors, and I believe these other doctors. And so people do get old or have other issues that go on, infections, and until a clinical group has a cohort, I still would hold out that there needs to be a combined analysis with other groups who are actually following a low-carb diet at a low-carb level. The studies of people going into databases, and there's a UK database and there's a US that, all over, and they pull out people who say they're doing keto or even have under like 30% carbohydrates. They're all being lumped together, and then the analysis for disease and longevity includes people who really aren't eating a very low carbohydrate or keto diet. So those analyses are fraught with problems. And no, I don't think that at the time point we're at, I don't see changes that look like things are going down. I mean, so that's another, if you're looking at something and you're going and everything looks good, one day it's just not going to change, right? So what we're doing, and what I do for the atherosclerosis question, the atherosclerosis, of course, is the process that leads to narrowing of the arteries. It could cause a heart attack or a stroke, is I have people measure those arteries directly, so that if someone's worried about being on a keto diet, even if they have a high LDL level, we have the good fortune to have resources there's a company that goes around to measure your ultrasound of your neck and your belly, the aorta, and I have people measure those things as a protection against the idea that this is safe forever, because we don't know. And I'm honest about that, and without any comparative studies, people who say their diet is best and makes people live longer, they don't know either. Having studies or books like the Blue Zone or the China study, which was just an observational study, these really don't tell you, like an experimental trial can, that people are living longer. It's people want to believe that. They read the books and the studies and pull out the information that supports their preconceived notion, I'm afraid. The animal studies that on my channel I downplay, don't look at them, but there are a couple animal studies of mice on keto, and one of them found that the mice lived 10% longer. And so if a human could live 10% longer, that's 10 years. That's a big deal. But then that I'm very cautious, and you can't take the animal work and extrapolate it to humans. That most of the time it doesn't play out that way. But what I'm seeing now with 20 years of me personally not eating any carbohydrates and a growing cohort of academics and clinic population is, for those who are doing it, they're doing well, they're thriving, they're not regaining weight, they're not getting diabetes, they're not getting heart disease. But for me to be able to, as a policy, say you're not going to get heart disease, you'll live longer, we don't have those studies yet. I can't say that yet.
Dr. Westman, just digging a bit onto one of the points that you mentioned regarding LDL, and we have Dr. Don Akoppa, who is also a speaker in this conference, asking us a question. So I thought, let me pick that question from the audience. It says, he asks, is there still a role for statin among your patients with elevated LDL?
Well, so that's a great question, and I get that question almost every day in my office, in my clinic at Duke University, where I work. And I think there is a role. So I'm a classically trained, I don't know if that's the right word, medical internist who I was taught to believe that statins were great for everyone, and that you just give insulin for diabetes, and I don't do the insulin for diabetes anymore. That you want to take people off the insulin. For type 2 diabetes, the insulin's already elevated in the blood. But getting back to the cholesterol, the more I look into the cholesterol as a mechanism and as a implication, the cause of cholesterol on the arteries is more complicated than just the LDL. So I've fallen out of the belief that it's just LDL. But if you use a medicine like statins or that lower the LDL, they also do other things. And so there are pleiotropic effects of statin drugs, the anti-inflammatory aspects of it, that in good studies, although they had to be large studies to find small effects, what you want is a study that's so small you don't need many because the effect is so big. But the mainstream, I would be way out of sync with my medical mainstream if I said that statins had no role. So I think as secondary prevention, if you have had a heart attack or a stroke, I think there is pretty good evidence. If you're a carb eater, remember, under that umbrella, because I'm treating now people who don't eat carbs, and that has an anti-inflammatory effect of itself. So I think of the low-carb diet as an anti-inflammatory drug, so to speak. It has an anti-inflammatory effect. Whether adding a statin will improve that anti-inflammation, I think it might. And so I just explain to my patients that here's the risk, the benefit. There's actually a website that the Mayo Clinic put up to help you make a decision about statin use. And so I'll pull that up and go through, here's the benefit you'll get. And I try to make the informed decision by the patient. Now, most patients will then just look at me and say, well, what would you do? I try to explain, but so I'm still believing that, if you don't have any side effects from statins, that's another sidebar, that, yeah, if you've had heart disease or stroke, there's probably a role to stay on the statins. And yet I don't think that the driving LDL down to 0 is a good idea. My colleagues in cardiology tell me that. They say, well, we want to get the LDL down, and 30 is one level. LDL plays a role in human nutrition that most doctors and most cardiologists have never been taught. So LDL cholesterol take vitamins and take cholesterol around the bloodstream. In an aqueous blood environment, the cholesterol would just go, so it has to be packaged on a fat-soluble transport. You can think of it as a delivery truck. And so if you drive LDL down to 0, what you're doing is you're not allowing your body to give vitamins into all of the different tissues. And this is where the side effects come in, and why you see a lot of people, oh, you're on a statin, take this to counteract all of that. So that's my long story answer to sure, there's a role, but not everyone needs to be on statins. And if you don't have vascular disease, so my practice has evolved to, well, let's see if you have vascular disease. So someone recently was 70 years old, eating a typical American diet, now on keto for 2 years. We check the arteries with ultrasound. You do the coronary calcium score if you have that available. If that's all squeaky clean and the LDL is elevated, do you want to give a drug to somebody who doesn't have the disease that you're trying to prevent? Do you want to give chemotherapy and radiation therapy to someone who doesn't have cancer? This makes no sense. So we can personalize, and it's almost like these tests then you go and it gets you out of the blanket treatment of statins for everybody, because our guidelines generally in the big health systems would give you a statin if the LDL was up. So I'm way past those guidelines in my clinical practice. And guidelines are they're always reactive. They're always going to be a little bit behind the times. Think of it that way.
Since we have about 17 minutes left, I'll jump into the perspective of India and Asia. What has your experience been with people of Indian origin in the United States, maybe in your clinic?
Yeah, well, I have to acknowledge that most of the people in my clinic are American Caucasian, African American, but now we have a growing number of people who have emigrated from India. And I understand that many people use the vegetarian sort of ethical and religious approach to food, which is fine. So I just explained the glucose and insulin story, which is what leads to obesity and to type 2 diabetes. You want to keep the blood glucose and the insulin down. You can choose foods that you like. And then I have 3 books on my shelf that are vegetarian diet books. And so I just say up front, my method that I learned is meat, allows for meat eating. And, but if you eat eggs, that's going to give you a great source of complete protein. What I want to do is have you look for these keto vegetarian options. In fact, I tell people to follow the Instagram groups from India directly. So that they can communicate directly. In the internet's an amazing thing in that way for people who are in this space in India, and they can get the latest information about how to eat in a way that you keep the glucose and the insulin low. And it just means moderating the amount. Sure, you could have some bread. Sure, you could have beans and rice, but you can't have a lot all at the same time. And if you're going to be really doing strict keto, well, that's another element. I don't really know that everyone has to be so strict keto. You may be able to lose weight or reverse diabetes with being keto-ish, at the 50-gram level where so I don't recommend that people measure for ketosis. The goal is to actually just reverse the medical process. So I would use a different teaching source for the foods because that's not my strength. And then to just say that you may be able to not have to worry about being in ketosis. If you're active and you're young, generally you can have more carbs and you just don't want to have as much.
Right. And this, Indian sources, when you talk about it, a lot of vegetarians, I grew up a vegetarian. So, there's a lot of, as you mentioned, cultural aspects to it, religious aspects to it. And D-Life is having a huge forum where the information and courses to equip people to help and guide and support people at the right time. Dr. Westman, please talk to us about Adapt Your Life Academy and how that started, where does it cater to? You can give us more information about that. And as well, if any one of our viewers want to know more about you, where can they find you?
Thank you. Well, we started Adapt Your Life as a company to just get the information out to as many people as possible. So I was approached by an entrepreneur who said, doctor, how many people have you treated? And I said, well, 8,000 people. It's great. And he kind of looked and said, have you heard of the internet? You could probably treat 8,000 people in a day, not in a career. So the ability to scale up the information and get it available to so many people has been a great pleasure. And so the Adapt Your Life Academy, adaptyourlifeacademy.com, started with one course, which is called Keto Made Simple. And it's the kind of approach that we've been talking about, keeping it simple. You don't use all of these internet things. It has its roots basically back in the Atkins diet, Keto Made Simple approach that we teach. And then we started getting other people to do courses for us. So we have a course specifically for stalls. Stall Slayer is the course by my co-author on End Your Carb Confusion, Amy Berger, who has her own website and all. And then we've started getting other people, Dr. Eads, they're making a protein course for us. So we're going to be launching that next year. I have a course on type 2 diabetes that we just filmed this year. And so the platform is on the internet. You get access anytime you want. The videos have PDFs, so you could watch videos or read, and we target specific conditions. We've taught, again, I teach more people now online than I do in my office. Of course, they're not as sick, but it's really been gratifying to see that. So adaptyourlifeacademy.com. I do have a website called ericwestmanmd.com, ericwestmanmd.com, and there it directs you to either a page, we call it page 4, because it was the 4th page of the handout and it kind of got out there on the internet, page 4, or it directs you to a book, the End Your Carb Confusion, and now there's an End Your Carb Confusion cookbook. And then it also directs you to the Academy if you want more intensive coursework to support what you're trying to do. So we're trying to teach people with a minimal, just a page or a book or courses, just to try to get good information about low carb, keto, without having to buy extra foods. And it's just kind of crazy to see what people have done. Did you remember the people selling products, when I think you really just need to eat excellent food? You'll get everything you need.
That's really nice. So I think we can jump directly into asking some of the questions from the audience. And I really do want to thank you for being here. And in a minute, I'll also invite Shashikant. One of the questions that has come up here, and I'm also curious to know, do you have any upcoming books, Dr. Westman?
Well, my efforts have been put into doing videos for the Academy. So my latest book is called really my first solo book is End Your Carb Confusion. And I think that's going to be the book for a long time, until there's new research to say you need to do something different.
All right, there are a couple more questions, and I know we have Shashikant here. Since we have 10 minutes for the questions, Shashikant, shall I go ahead and ask the questions?
Yeah, first of all, you can ask, then I'll give a vote of thanks later on. You can ask the question. Very interesting question from Dr. Don.
Dr. Don, we are getting really good questions from him. Do you agree that giving prolonged exogenous insulin is more harmful than helpful to patients with insulin-resistant or type 2 diabetes?
Well, so if someone has insulin resistance or type 2 diabetes, their insulin level is already elevated. And if you don't believe that, just check it a few times. I don't check insulin levels because I just know that's the pathophysiology. So it really makes no sense to add in more insulin when the insulin level's already high. So in our area, my endocrinology colleagues have shifted over toward medicines that don't cause weight gain, like insulin. They're starting to use the GLP-1s and the GIP combinations, and they're kind of using the weight loss, diabetes weight loss drugs, which targets the underlying issue. So it will lower the insulin level, and that's the right thing to do. So I'm not a fan of insulin. I work really hard to get people off insulin or to transfer them over to a different medication. But the low keto diet reverses type 2 diabetes. It's just a matter of time. And the Hallberg paper with the Virta Health company behind it is the best clinical trial evidence of reversal of type 2 diabetes with a keto diet.
That was, thank you. I'm sure there are so many questions here. One more question that I see is, in your book, Keto Clarity, you have mentioned that when your body craves carbohydrates, it's demanding fats. What is the physiological, could you explain the physiological reason behind that?
Well, that we don't really need carbohydrates. It's not an essential nutrient. That's a language from biology and biochemistry and nutrition. We need amino acids and proteins. We need fatty acids. And so I think part of that is trying to persuade people to not fall into a craving for the carbohydrate, because that's just going to perpetuate the craving for the carbohydrate again and again. The worst thing you can do if you're trying to quit smoking is to have a cigarette to relieve your craving for the cigarette, because you're just going to keep smoking. So actually, I don't know the exact mechanism for that. I think we're using that as a persuasive tool, that you may crave something, but you're really wanting something that your body really needs.
All right. And the last question, and then we can have Shashikant back here. Is ketogenic diet suitable for everyone? Are there any side effects? I've heard of people who are depressed need more carbs and can't really go cold turkey to keto.
Well, if you think about what our body needs nutritionally, if you do it correctly, we call it a well-formulated, adequate protein, not high protein, keto diet. I think eating real foods without sugars and junk foods is healthy for everyone. I know that surprises some people, but children are born in ketosis. And when you feed them carbs, they go out of ketosis. So after 3 days, everyone goes into ketosis if you don't eat carbs or you don't eat food. So I think it's fine for everyone to do, as long as you're learning from someone who's teaching it in a healthful way that has science evidence behind it. There are a lot of keto hucksters out there who, it works for me to drink and eat butter all day long and ghee, and like, no. So you want to follow someone who is teaching it in a way that has been scientifically shown to be healthy. I think you get all the nutrition you need. In fact, we now have a childhood epidemic of obesity and type 2 diabetes, and it's not because of the fats. It's because of the sugars and the starches. So I have no concern. Even I have patients who are in their 80s and 90s, and there's some really interesting preliminary research saying this might actually be good to prevent or delay Alzheimer's and neurodegenerative problems like Parkinson's disease. And so I have no problem using this across the lifespan.
Just to add on to that, what is the, you already mentioned this, that keto diet is safe, babies born in a ketogenic state. Would you still recommend putting children onto a keto diet?
Sure.
All right.
Yeah, and we're pulling our hair out because the American Pediatric Association just came out with we'd rather have people get weight loss surgery than do a low carb diet for children. It's like, no. So the guidelines are way behind the clinical reality, I'm afraid.
And Dr. Don here says, Dr. Westman is my rock star idol. So he's sent a lot of emotions with that. And one last question, I think, what's the emphasis on fiber?
I don't really talk much about fiber. You know, we in our method, we give people 2 cups or 2 fistfuls of leafy greens for the salad, and then 1 cup of a non-starchy vegetable. That could be broccoli, cauliflower, green beans, asparagus, and there's fiber in that. So they're really getting about 3 cups in our method. I don't enforce that every day, but it does help with regularity. And then the science has not been strong to say that fiber is important for medical prevention. And I know it might make you have more regularity, have a bowel movement more frequently, but the studies to say give fiber, you have less cancer, those didn't pan out. So there was that early thought, and then when the randomized trials were done, it really didn't help. So I don't talk much or worry much about fiber.
All right. Thank you so much, Dr. Westman. I'd like to have Shashi here, Shashikant Iyengar, and I know he would like to thank you as well.
So, Dr. Westman, thank you very much for accepting this invite. So you could spend 1 hour for India. And I fondly recall our podcast we had 3 years back, somewhere in 2020, we had a podcast we did for D-Life. And personally, of course, I have done your Keto Made Simple masterclass also. So I'm so happy And the brilliant part about this particular session is we call it ketogenic diet for 20 years of keto diet. And in India, people think that if anyone does keto diet, they are going to die the next moment.
I know.
Kidney failure will happen. So how many of your clients, your patients have died of kidney failure?
Well, actually, one of my most grateful patients lost 100 pounds while on dialysis. So, I mean, he had already lost all his kidney function, so it wasn't an issue. But there you have to be careful because you have to keep adjusting the weight of dialysis down. So, I've used this in people who are really medically ill, even the heart pumps, their heart has failed so much, they put in a metal box that's like a pump to pump the blood around. I have patients who have those, but I'm an internist with that background. I'm medically trained to handle that, but I really see no risk, especially compared to drugs and surgeries and things like that. This is a great medical tool. I practice the best internal medicine that I ever have, and my secret weapon is food.
Thank you very much. What is your last couple of lines message to India?
Well, don't be afraid. 25 years ago, when I first approached this information, I was afraid. And yet I had the resources to collect information, collect data, do studies. Now those studies have been done all around the world. Believe what you see in front of you, not what other people fearmonger and say is going to happen because they don't know. Make sure they prove that there's something bad, in it before you believe them. And that I guess the final word of what you eat really matters. And don't go down the path of sugary junk foods. It's not. Most people can't handle it. Some people can. That makes it confusing. But it's the sugar and the starches that get digested to sugar and the foods that are made so you can't stop eating them. That's the problem. It's not you. So it's not the patient. It's not your client. It's the food that's made that makes it impossible to resist. Once you get out of that, it's much easier. And keep it up. I'm so thrilled to hear that you're still at it. And once you get the bug, this is like a mission, isn't it?
Thank you, Dr. Westman. Thank you very much, and namaste from India. Thank you.
You're very welcome.
So we can get the next guest in.
Bye now.
We can get in Kalyani ma'am, Mr. Archit Kaul.
Archit will.
Ma'am.
Mayur is getting a little late,
Okay, no problem.
so we can start, but I don't want to keep anyone waiting.
Shilpi ma'am.
She's here.
Yeah, please get her in also. Admin. Fine. So, okay, fine. So, yeah, so welcome all. Welcome to the India's first low-carb conference, and I'm so happy to have this special session, which is a tribute to Mr. Kaizad Kapadia. So, Mr. Kaizad Kapadia is actually my guru for the first certification. So, I did sports nutrition in 2019. So, Anup is my first guru. And then we also have Mr. Kaizad as my guru. But this was my first certification. So it's very, very close to my heart. And I'm so happy that, we can have this special session in tribute to Mr. Kaizad. And I'm also very happy, Kalyani ma'am, that you could spare your time and come. Archit Kaul, and it's my guru. So Shilpi ma'am is my guru. And Anup, you want to say some words?
Yeah, welcome to India's first and the largest, I would say, low-carb conference. And incidentally, I think once I had attended or heard of Mr. Kaizad Kapadia while he was in Indore, and we got a brief, view of his diet while he had spoken. So that's about it.
And during that time in 2017, me and Anup, we were thinking that, one day, as and when we have a
Yes.
low-carb conference, we
Yes.
will invite Mr. Kaizad. So that was our vision that time. But then unfortunately, it took a lot of time for us to organize this from 2017. Finally, it's now 2023. But then that time we were thinking of physical, but now we thought that we'll make it virtual with something we learned. So I'll first introduce, I'll say some words about Mr. Kaizad. So he's regarded as the India's first professional trainer. Mr. Kaizad started his journey into fitness industry in 1987 as a bodybuilder and as a power lifter. He's widely recognized as the individual who formalized and brought respectability to the fitness sciences education in India. So in 1993, Mr. Madhukar Talwalkar initiated the PEP, Personalized Education Exercise Program, and Mr. Kaizad Kapadia was appointed as India's first professional personal trainer. So he established India's first gym named Exert the Gym in 1999, which met the international standards and featured the most elite fitness equipment brands. Exert significantly transformed the landscape of gym industry in India, leading to the widespread trend of professionally set up gym. Therefore, if we now observe how gyms are established in the fitness industry, the credit goes to Mr. Kaizad Kapadia's vision on which he has done. Mr. Kaizad Kapadia also worked on empowering women in India. He conducted seminars on women and weight training to demonstrate that lifting weight does not make women bulky. Instead, it helps them become more stronger and leaner. So if you see women lifting heavy weights, the credit goes to Mr. Kaizad Kapadia. So I will now, first of all, now we all see that Kaizad sir as the guardian angel who is watching us over, and which were aptly depicted even in our promotional posters. So today we have Miss Kalyani Kapadia, madam. Kalyani Kapadia, fitness journalist, began with a love for sports and physical fitness. She discovered the passion during fitness course led by the renowned Mr. Kaizad. This marked the start of a career in the fitness industry, which later extended into the vocational education. In 2003, she co-founded K11 School of Fitness Sciences with Mr. Kaizad, Devki Kimji, and Mayur Sabnis, creating a pioneering institution, which we all know. Her commitment to nurturing a passion for fitness, guiding aspiring personal trainers, fitness professionals, and nutritionists, sport nutritionists specifically, in providing the lifelong support to students, which defines the leadership. Under Ms. Kalyani Kapadia's guidance as a CEO and director, the K11 School of Fitness Sciences takes the role of educators to the heart, what sets K11 apart is the commitment to its student. Education doesn't end when the course is completed. K11 students are welcomed back with open arms, guided and supported as they venture into the fitness industry. This dedication of the success of the students is the core value of K11's ethos. So Ms. Kalyani Kapadia takes pride in K11's highly efficient system operation and the school's ability to ensure a high quality education experience for the students. The effectiveness of these systems also facilitates the scalability of business, making growth not just achievable, but a seamless endeavor. So Ms. Kalyani Kapadia's journey from the sports enthusiast to the leader in fitness education reflects her dedication and unwavering commitment with a deep appreciation for the education. Thank you and welcome, Kalyani ma'am.
Thank you. I first would like to thank you and Mr. Anup to, felicitate Kaizad and tribute him, because it's something that he started, and for you guys to reach this level of conducting worldwide conference and appreciating its efforts means a lot to me. I'm so greatly thankful to you.
So we also have with us Mr. Archit Kaul, who is the HOD of Nutrition Sciences Division K11, and also my guru Shilpi Arora. So she is the K11 researcher and senior lecturer. So welcome all of you. Please, I'm so happy to have all of you here today.
Likewise, Shashikant.
So please tell us about Mr. Kaizad Kapadia's transition from fitness education, from fitness to the education part. So what really made him come into this field? We always thought that, okay, they are bodybuilders, they are more into gym.
Okay, so I'll tell you that I've known Kaizad since 1996. Okay, so I had joined a course called LM Fitness Academy, and he was a lecturer over there. And so we had only 4 lectures by him, and that's all on exercise science. And I mean, I didn't find it adequate, so I kept on calling Kaizad and pestering him about the knowledge. And then he called me to work out with him. And when we used to work out with him, he would teach us. So, he would teach us about every single movement, why the particular movement has to be like that. So I think he had those genetics in him about being the teacher in any format. So once we started setting, then in 99, I started working with him in the gym called Exert, as I have mentioned in Kaizad's intro. And I was a trainer. He's been the manager over there. And there also I saw whichever inquiry would come for joining the gym, he would not just take money. And, it was actually easy back then. We used to charge 24,000 for 1 year gym membership. And people were literally queuing up to make the payment, but he would not just take the payment. He will make them sit down. He will make them understand why you are doing why I would take your membership. So the educating factor has been there since the day I think I have seen Kaizad. There has not been a time that we have met him and not had a chance to learn anything. And I've been privileged to have spent my life most of the time with him and learned a lot of things from him. The main from kind of in fitness education transition happened when in 2003, we wanted to start a school for fitness professionals. So what happened is we used to manage that time own gyms. So we were a gym management consultants and we had 4 to 5 gyms under us. That means we needed about say 50 trainers at any given point of time. And so whenever we used to set up a new gym, we would take 10 students, 15 people, train them and appoint them as trainers. But once we realized that it's going to be a continuous affair, Devki came up with the idea of setting up a school. Kaizad and Devki both came up with the idea of setting up a school, but Kaizad said, I cannot do it without having a practical lab. So then Devki had a place near Santa Cruz where we are right now. And this is how the transition from a fitness professional to a proper educationist that started. And from then there is no looking back.
Very nice. No, so tell us something about his concepts toward the exercise science and the correct nutrition. So whenever I hear correct nutrition, I know it has come from this table of K11. So please tell us about that.
So one thing that Mayur will explain the concepts of correct nutrition, but I would like to tell you one very nice.
Before that, can I request that? Yeah, he has now come. Mr. Mayur
Yeah.
is.
So I just want to say one nice incident that had happened. And so Kaizad would normally, in 2011-12, we adapted this correct nutrition to ourselves. So that Shilpi will explain a lot in detail, but I'll tell you how it happened one day at home. So I would always wait for Kaizad to eat, dinner, to have dinner together. And its timings never used to be fixed. It would be always erratic. So one day he came home at 12 o'clock and I said, what took you so long? So he said, I'm reading a book. So I know he was a voracious reader. So I said, okay, but you can't get so lost that you've forgotten to come home. So he said, no, it's the kind of subject that I know it's going to change the face of Indian nutrition and we have to destruct our course and this and that. And so I said, okay. And then he mentioned few names. So first thing was, I think I heard from him was Gary Toms and Eric Westman. And then he went on talking about it, and then funny thing is he would love eating chapatis that time. Okay. And I would make him hot chapatis. And I started making the preparation. He's saying, no chapati from today. I mean, that man didn't even take 1 hour to accept the new concepts and apply it immediately. So I said, no chapatis. And I was a rice eater and he's been a chapati eater. So he said, no chapatis from today and no rice for you today. So I said, today or onwards? So he said, today and onwards. So that is the funniest. I mean, I found it that you just read it and you are applying it. So, it was the thing that I wanted to share, that how it happened. So Mayur would talk about his exercise concept, and then Shilpi will take over the next
Yeah,
question.
so let me introduce Mr. Mayur. He's a director and vice president of K11 Institute. So yeah, he can explain. Mayur has to be unmuted. Someone has to unmute him.
Yes, sir. I have sent the request.
Yeah.
Yeah. Hi, good evening. So Kaizat was always into strength, and his main emphasis was strength training, because Kaizat started working out at the age of 15. That's when he first visited a gym, and he got hooked on the iron bug hit him. He was a freelance personal trainer from 92, 93 till 99. And we are talking about the early 90s. Way back then, at least in the Indian fitness industry, a lot of emphasis was given on cardio and mobility work, and strength was not emphasized. And Kaizat was a strength freak. His entire idea about lifting weights and resistance training, whether for a geriatric or for women or for a young person, guy should be to gain strength. So that is what he got hooked on to. Even when Kaizat used to compete, Kaizat sir did compete in bodybuilding as well. His whole idea was muscle could be built whether with light weights or heavy weights. It was always to test his strength. That is how he used to train. And in strength training also, the emphasis was also always on movements which are unsupported multi-joint movements. So anything and everything that you would do in the gym should have a carryover effect in day-to-day life. That's what his thinking was. So yeah.
Yeah, so I think the concept of nutrition on the reduced carb or low carb. Shilpi ma'am can explain.
Yeah, so Shashikant, I would like to say how exactly Sir's journey began. Like, how did he get into the fatty protein concept, and what was the trigger for him to get into all this? The trigger or the main factor was the insatiable thirst for knowledge. And then because as ma'am mentioned, it like he was a voracious reader, an avid reader, and that led him to dig into more and more of many of the eminent low carb mentors like Gary Tops, like Dr. Eric Westman, Professor Dr. Noakes. And I'm glad most of you have already, they're there on your platform right now. That's a very recommendable job which you have done, Shashikant, to bring together the entire scientific community on one platform, specifically in India. That's a tremendous job in terms of the metabolic conference which you're having. So yes, as a conscientious listener, he being our mentor, an excellent teacher, a charismatic speaker. When he used to write, it used to be like, we would say, a gifted writer, a meticulous researcher. What set Sir apart was basically his logical mindset in terms of he could distinguish between the facts and so-called trends which were there, like fad diets and all. So that led us to dig more into the scholarly articles and the work of these eminent people, and then critically analyzing what all has been written and understanding the science behind it was our forte, that we could take it at that time, at that particular time. Another thing was wherein the mainstream scientific community or people in the conventional schools of dietetics and colleges were, it's the skepticism, right? It's the skepticism which had decreased. The skepticism, I would say, had decreased, but Sir had that power to take a stance and say what was right, and how the nutrition, which is a dynamic subject, has taken a course. Sir could take a stance at that time, come what may the challenge. So his ability to change quickly, his ability to change with time was again one of the main traits, I would say, that led us to the current K11 nutrition course which we have. And I think Archit would agree with that he was, yes, a gifted writer, and his most admirable trait to adapt to the change quickly, from rotis and rice to this kind of eating pattern, which Kalyani ma'am said.
Right. I think it's quite inspiring, and I think he was someone who was, I think he took a very quick decision, is what I can say.
Right.
Very, very fast decision.
He would never think twice before reversing something that we've been teaching for 10, 12 years. If he's found something better, he would just change that. That is what happened with the nutrition course also. He's just changed over a period of time.
So there was something, I wanted to ask one more question specifically on what was his special awards and accolades in the field of fitness industry? What are the different kind of unique awards which he has won?
So I can read out that to you.
Please, yes, please.
1 minute. So he was recognized by Men's Health, India's leading health and wellness magazine, as best personal trainer in 2014, awarded the 2016 Leaders Award in Education Sector by 24 MRC, awarded as nutraceutical and health rewards by achieving excellence in educating and producing world-class fitness professionals in 2016, organized by CIMS Media, awarded as the fitness education leader as 24th Business School Affair Devang Mehta National Education Award, awarded as the Pride of India 2016 by World Consulting and Research Corporation for its contribution to the health and fitness industry, recognized by World Health and Wellness Congress and awards as the 100 most impactful healthcare leaders in industry, awarded by the Fitness Excellence Award FEA 2017 for its exemplary work in the field of education in the fitness industry, awarded by CIMS Media in 2017 as Pioneer in Performance Nutrition, awarded as by the Economic Times Champion of Fitness 2017-18 as a leading educationist in the field of fitness sciences, awarded by the FEA, that is Fitness Excellence Award 2018 for changing the face of fitness education. His school was awarded in the Best Fitness Academy at the Swabhiman Khel Ratna Award 2019 and awarded as Parsi Ratna in 2019 in the field of fitness education by D.D. Mehta Memorial Trust.
Huge. I think I feel that it is always an unending list because the kind of work he has done and the kind of pioneering work he has done is what I'll say.
I have not included many of it in this list. I have only taken up what are actually the, what he's received for educating people. So rest all I have removed from the list.
So there is one of his student has published an article called Science Protector. So yeah, who will speak on this?
I think
very interesting.
Shilpi is best because she's worked with Abhinav on that project. So she would be the best person to talk about.
Yeah, Shashikant. So Abhinav Vithalrao Patre, we all know him as a researcher. Currently, he's director at the Research Department for Public Health India. How did he get a chance to be with Sir? That is, we have a master training course. So master training course, the entire year he could spend with Sir, and he could understand in the close vicinity what actually are the traits of a core scientist. So that's how the most fascinated thing, again, I was talking to you about the skepticism. So that is the one thing which made him understand more about Sir, that he could take a stance against the conventional wisdom which was there. And then he came up with an article. He authored an article which was called as the Science Protector. I think you have read that only. And that was actually published in the International Journal of Medical Science and Current Research. So if I have to talk to you about the admiration which we had towards Sir was like way beyond. I won't even have words to express that. But if I have to talk about Abhinav in detail in terms of the kind of education which he got after the K11 School of Fitness Sciences, that was wherein the curiosity developed. And then he went all the way to England. So there was a course which was MS in Applied Public Health from a renowned university, which was Alcan in England, wherein he did his MS from there and is currently the director at Public Health India, which is again promoting all the researches pertaining to the low carb. So specific to India, the low carb researches wherein he's working upon. And his master thesis also promoted the low carbohydrate policies in the United Kingdoms, officially the dietary guidelines and received distinction in whatever thesis he had presented. So a tremendous work from his side, and it's the legacy which we all are trying to take forward. Whatever we have learned, we just want to spread the right kind of awareness to the entire population. So I think we are all on the same page in synergy, working towards a common goal.
So I would like to add over here, I mean, apart from what she spoke about, Abhinav, what Kaizad is work towards is developing leaders in nutritional, particularly nutrition and exercise sciences section for us. So Mayur has contributed towards developing exercise science lecturers to the max for K11, and Kaizad always worked on developing, of course, with the team. When I say Kaizad, it's always a team of lecturers that have supported him. So he had a vision. So in 2014, Kaizad removed his face from K11's advertisement, and I was the one who was fighting, you know, being his wife and CEO. I said, why you're removing? So he said, no, K11 has to stand on its own, and it should not be attached only as my face, you know. So he did that decision, he took that decision in 2014, and it was a very wise decision on his behalf, because he established K11 as a bigger brand. He is a brand himself, and he's always going to be, so that I don't doubt. But being a brand yourself, having that clarity of separating something from yourself is a big lesson to me as a business leader. So what I'm thankful of to Kaizad, being with him for so long, it's creating a world-class teachers team which can take this brand forward, you know, which is not so. I always used to tell Kaizad, there is no K11 if there is no K. But as I said, he had the vision of separating himself from the brand. He proved me wrong, and K11 will continue remembering his K.
Yeah.
Shashikant, I'll just like to add a few things. So there were a few qualities of Kaizad sir, like Shilpi ma'am, Kalyani ma'am, Mayur sir have mentioned. So one quality, I'll not speak much about it. It's already done. So it's the adaptability thing that he always had. And whenever we as teachers or even as a student, in fact, I remember if I used to come up with something, there was always this humility to any scientific evidence. And he did not used to take a lot of time. He will just change in a split second also his own stance. Even when I was a new teacher, for example, at K11, when something logical was said, he will quickly change his stance. And he was truly a scientist in that regard. And many times, actually, what we are teaching in the nutrition course or elsewhere also, like you see, it's very, very unpopular. It's very, very against conventional wisdom. And what used to happen was teaching these things are extremely difficult, not easy to a person. But he had a very kind of, I would not say in that sense, a strict demeanor in that sense, but a very assertive demeanor he used to carry also with him. He was always very, very compelling. And that's why he could actually convince people also. And he was a very, very, I would say, psychology he used to get of people, the mindset part. And the nutrition is actually to teach, the mindset has to be actually taken care of. You can't teach this kind of nutrition without taking care of the mindset part. So as in many of the other sessions also, people have focused on that part. This is something which Kaizad sir used to do it very, very well. And now we have a lot of these success stories around in India as such. People are already following the correct nutrition, the fat protein nutrition, fatty protein as you would used to call it. And not just for weight loss, not just for fat loss. People are doing it for the muscle gain aspect also, even for sports and other performance. So that is one thing that has been happening now.
Archit.
Yeah.
Sorry to interrupt, but apart from his marathon seminars, his professional one-on-one consulting with clients have gone on for 10 hours.
Yes.
So one of the sessions that started in the evening, and he just landed up the following morning at his place. It went on for almost 8-10 hours. Mindset change.
I recall during my course also, it will go well past midnight, 12 o'clock.
Yeah.
No breaks, full of energy.
Break.
And he will always do what is right for the student and somehow get it to the student. That is something which always stood out.
So today in the session, Dr. Eric Westman said that, so you can't do this. I'll have little rice, I'll have little, little fruits. And so same thing Kaizad used to repeat that you have to just switch. There is nothing having small quantities. So I was so pleased to see that Eric Westman repeating maybe he said it first, but I've heard it from Kaizad first. So I loved Dr. Eric Westman's session today.
So Eric Westman, of course, has been here for 20 years.
Yes.
25 years rather. It's quite big. So there is one question here which I'll ask. It has come in the front end. K11 is K11 branch available is K11 present in Chennai? This is the question.
So we have earmarked certain cities. Chennai is one of them. So we will be definitely planning for Chennai.
Shashikant, there's a reason we are not there in Chennai, Dubai, other places. Earlier, when we started off in 2003, it used to be Kaizad sir and I who used to take the classes and conduct teacher training programs. Right now, we've got a team. I am there, Archit is there, Vivek Rajput is there, Manisha is there. A whole team works on that. So teacher building process takes us about 6 to 8 months now.
Right.
So the limiting factor is the teachers. So yeah, we will come.
We have earmarked that city.
Yeah.
We have definitely from south. We have earmarked.
You have a strong criteria for teachers also.
Yes. Having said that, anybody from Chennai, they can as far as the nutrition course is concerned, they can definitely do it online.
Yeah.
And the personal training course, DPT course, the theory can be done online. And for practicals, they could come. And we could also try and work around something where we can fast track the practicals. Instead of 25 days, we could probably finish it off in 3 weeks without compromising on the number of learning hours. Yeah. So all those options are there.
Thank you. We are almost coming to the end of the session. I'll just share some of the photographs which were sent. I think we will have to see these photographs as a memorable one for Kaizad sir. So thank you very much. Thank you.
Thank you.
I know this half an hour doesn't do justice to Kaizad sir. We will have one full hour session to talk on the reduced carbohydrate or fatty protein diet.
Fatty protein.
A subsequent session, and we'll want someone to come and talk on this.
Sure.
Since this entire event is focused on the disease part.
Yes.
So in the next session, next event, we will have it on nutrition in fitness sciences.
Performance.
Great.
Fitness
performance.
Thank you. Thank you very much, Kalyani ma'am. Thank you very much, Shilpi ma'am.
Thank you,
Mr. Anup. Mr. Mayur, thank you very much for attending the session today. I'm so happy and I'm so obliged.
Thank
you. Thank you.
Bye.
Thank you.
Bye.
Nasha, welcome.
Thank you, Shashi. Good to be here. Thank you.
So we are so happy that that we can ultimately see you, and that you accepted this to attend for this session in India's first low-carb conference. And of course, this is basically, I know that you have a big story behind you. such a brilliant story, and we will hear more about this in subsequent sessions. For this, we have invited more of you to understand what is this Metabolic Health Day, which you have, we had it in October. So before that, so I'm Shashikant Iyengar. So you can call me Shashi in short. Metabolic health practitioner in India, accredited by SMHP. And this is Anup Singh. So Anup, you can introduce yourself.
Yeah, just to
you as well.
I'm Anup, and I'm founder of dlife.in, which has now grown up to be the largest and the fastest growing low carb community in India. It's an award-winning platform, and we are now focusing on creating, an army of low carb coaches.
Yes.
So that's in short.
Oof, that's beautiful.
Welcome to India.
Very, very humble. So we too are we are type 2 diabetics in remission. I am for 8 years, and he's more than 12 years. He's into 13th year. Pillless, no pills.
Wow, you guys, amazing, wonderful to be here with all of you.
And his army of metabolic health coaches, which is creating, are having diverse successes. In fact, in our group, we are having one success even with cancer case. So we'll talk more about it later on. So it is very diverse: diabetes, blood pressure, obesity, weight loss, PCOS, mental health. I personally had a success with bipolar case and plus other cases also. So before proceeding ahead, I think we have talked too much into it. I'll give a proper introduction of Nasha Winters. So Dr. Nasha Winters' first experience with cancer was at the age of 19. She was diagnosed with stage 4 ovarian cancer and given only few months to live. The metabolic approach to cancer stemmed from her early decades of personal and professional experience in the field of integrated oncology. So Dr. Nasha is a licensed naturopathic doctor, ND, and is a fellow of the American Board of Naturopathic Oncology. She is the global healthcare authority in integrative cancer research. Dr. Nasha is the most sought after speaker and consults with physicians worldwide. Welcome, Nasha.
Oh my gosh, what an absolute honor to be here with all of you. I feel, as I was telling Pasha in the breakout room before, that this time it's now, and I'm so proud that you are leading the charge of this and that I get to play a tiny, tiny role in it. So thank you for having me.
Your tiny role is going to become very big because we have a live case of cancer in remission. So it's big. And this 30-minute may not do justice to that, but I can assure you that your session is really fascinating, is going to be. So please tell us more about yourself and also the unique story of battling cancer.
Sure. So as you noted, cancer was my foray into metabolic health space for, at this point, 32 years. As of October 21st of this year, I have been 32 years past my expiration date. So I get to be here with all of you. And metabolic health, this arena continues to inform me, continues to be my teacher, and continues to humble me every day at the things I've gotten to learn. And so I've moved from the role of being a patient to a student to a doctor to a teacher and a consultant and an ongoing life learner and co-creator, which is what we are all getting to do here together. And so for me, in this community, I heard a little bit at the end of the last session that you've already gotten to hear from one of my colleagues, Dr. Eric Westman. Brilliant. And I'm sure many of you have already talked about this, but I think when people think about metabolic health, they immediately, they might think about obesity. They might think about diabetes. In standard of care, we define it as sort of these 5 metrics of like hip to waist ratio and blood pressure, lipids, those kind of insulin, or just not even insulin. They don't even look at that, typically glucose, general stamina, and sort of muscle mass. And yet it goes so far beyond that. In fact, at its core, at its very foundation, is that metabolic health is the foundation for all life and all conditions. And so at its very core is that little organelle within our cells, the mitochondria. So I'm sure you've had a lot of mitochondriacs, specialists in this arena, speak to this and the biochemistry of this. But how I like to explain it to my patients and to my colleagues is that our mitochondria are like these little receivers of information. That's all, right? And they're sensing the environment in, on, and around us. And that's in all things. That's beyond just food, which is what we're heavily discussing here, but it's also water, air, light, energy, emotions, toxins, medications, but also, good things too. Our cells take in the good information as well. And once those organelles take in that information, they translate it and then send information and signaling back out into the body. And that is the driving force behind the creation of health or disease. And so though my area of expertise happens to be in cancer, because cancer and I became very close early on in life, I have found over my 3+ decades career that this is the same conversation I could be having if I was a diabetes specialist or a PCOS specialist or an autism specialist or an Alzheimer's specialist or a bipolar specialist. And to your point, I wish we'd kind of stop siloing out the titles of the disease and just call it what it is. This is a metabolic condition. And so it's an honor to hear this echoed back in this room and beyond, that I think we're finally getting to that point to recognize the root of all the major illnesses that bother us today, that take our lives today, that extreme burden on healthcare costs today are all metabolic in nature.
Very interesting. Very interesting. Yeah, no.
Yeah, Dr. Nasha, please tell us more about this Metabolic Health Day that you came up with, and what are all the activities that you've done on that day? And that's the beginning.
Love it. Well, this summer I was on my whirlwind speaking tour. I was in 6 countries over 6 weeks with 9 lectures. And I've been doing this kind of regimen. I speak anywhere from 30 to 40 conferences a year all over the world, but something changed this year. Because I go around beating the drum of metabolic health, mitochondrial health, oncology, cancer prevention, the core that all of our diseases bothering us today is metabolic. But I felt like for decades, it landed on deaf ears, or I was just preaching to a very small choir. But something changed this summer, you guys. Something changed where every single conference I went to, all over the world, Switzerland, UK, Maldives, all over the United States, Canada, Mexico, every single place that I went, the discussion had some theme of metabolic health. And it just like hit me in the forehead. It was like, wait a minute, finally, we're saying and hearing the same thing. And so when I came back at the end of that trip, frankly, fired up and inspired and feeling hopeful that we're making some headway, my team and I at the Metabolic Terrain Institute of Health started to figure out, hey, we've got pizza day and margarita day and breast cancer awareness months. And we thought surely there's a metabolic health day. So we started searching because we thought, let's do some cool events around that. And as we started looking, we realized this doesn't exist. It's incredible to me that with this being our true pandemic globally, that this day or month or whatever does not exist. And so our team, 6 weeks before the 10th of October, so the first inaugural Metabolic Health Day was 10/10/23, just shy of a couple weeks ago. Within 5 weeks, 6 weeks, we decided to go online, register this day. We're going through the legal processes to make it official. We decided to reach out to as many people that we know in this space and help us and create a movement. And in a matter of weeks, you guys, we brought in over 70 foundations, family foundations, corporations, individuals, medical practices, researchers, products, companies that are all very, very, very much in the metabolic space in all of those different silos, from mental health to diabetes to obesity to cancer to just all the things. And we managed to pull off the inaugural International Metabolic Health Day on 10/10, which our numbers have shown us that we reached over 6.4 million people. So I am pretty darn proud of what started as 0 as of the middle of August, end of August, ended up reaching 6.4 million people. So with that, what that's done for our community, the Metabolic Terrain Institute of Health in general, and the partners that joined us, including Metabolic India, you guys coming in on this process as well, being one of our founders, founding voices of this, is we are already starting to make plans for next year's 10/10. And so exactly what you're doing here is one of the things we want to see. We want to see regional conversations, and people like Low Carb USA have been doing that. Another one of our dear, dear colleagues, and the Metabolic Health Practitioners program they've created that Shashi is part of. And of course, Noakes Institute, like all of these foundations, everybody's doing it, but we've all kind of been siloed, doing them on little tiny islands by ourselves. I feel like thanks to the globalization of social media and whatnot, that we've all completely linked arms. And my goal is next year, I don't want to hit 6.4 million. I want to hit 60 million. And so that's the goal I've put out and put charge to all of the other 70 foundations. And we hope we double that number people involved by next year. So those are the things we have, and we want to start having some meetings with those 70 different people that were involved to brainstorm on how we can really start to make this a meaningful day, if not month, of awareness every single year, and not just awareness, but action oriented.
Very interesting. In fact, your posters and flyers were all very interesting, and that was shared by your staff or your colleagues, and we had been floating it in social media daily whenever they send. So whether it is Twitter X, whether it is Instagram, whether it is Facebook, or it is in LinkedIn. So we have been sharing it, even in threads, we have been sharing it on daily basis.
Yes, thank you. And we hope that it continues. We've continued even these 2 weeks out. We are still getting massive reach. People are signing up for more information. We're really looking at how do we capture this and how do we take advantage of the energy and momentum. That's why I love that this timing of your event was already seeded when this happened. So it's like we're keeping that ripple going thanks to you and people like Doug Reynolds and people like the Noakes Foundation and everybody else moving this out, that we just keep this tide moving.
And that is why we did not call it as a low-carb conference. We called it as a metabolic health conference. So
exactly.
This is the change which we decided instead of calling it. Though it is a low-carb conference, however, the name is Metabolic Health Conference. So that is the very metamorphosis which we had. So it's really nice. And what do you know about India? I'm very curious.
Well, I love that this question. In fact, in the breakout room, Pasha and I got to speak a little bit. My first time, so I'd had a long-term dream of going to India. My first time to India was in 1994. A few years into my diagnosis. India was on my bucket list to see before I died. There was just some deep love affair that I had with your country before I ever put my first foot, forward on your land. And at that time I was traveling in the north. I spent some time up near Delhi and Agra and all sort of the touristy environments, spent some time in Ladakh and northern India, trekked in that region. I will tell you from the train rides and the conversations I had, because of my own cancer diagnosis, I was asking people. I was also there seeking other providers in sort of integrative oncology. And in 1994, cancer was virtually not an issue. I didn't find anybody with cancer. I didn't find any experts in cancer. No one seemed to know anybody in their families with cancer. I had a few people talking about, they would talk about, I have a touch of the sugars on some of the train rides I had. So there were some little tiny murmurings about blood sugar issues, diabetes, but I didn't see the obesity. I didn't see any of those things. This is in 1994. Fast forward, after I finished medical school and my boards, I was pretty burned out and decided to go and spend some time, because I'd been studying Ayurveda for about 13 years. And I wanted to go and mentor and intern with some of my teachers in India. So I spent 4 months in southern India in Kerala and I was telling Pasha, I went up into the Nilgiri Hill region as well and spent a large chunk of my time in that part. And the conversations were starting to change. I was on a 36-hour train ride from Mumbai all the way to the south tip of India. And this family that I shared my car with, she was reading, because we started talking, and she was dealing with diabetes. And we were talking about my story with cancer. At that point, I was, almost 12 years out from my diagnosis and doing really well. And we had this beautiful bond with this family. And she was talking to me about her diabetes. She actually gave me a book. I tried to find it this morning, but I think it's still in my storage unit. And it was like a really old school Ayurvedic book about diabetes. And she was even telling me it was virtually unheard of. No one in her family had ever had it. And now she's telling me this, we're drinking chai on the train, right? Which is, at that time, when I was there in 1994, it was chai with a little bit of milk and virtually no sugar. When I came back 10 years later, it was literally like having a glass of sugar milk with a little bit of tea. And I thought, has my palate changed that much? Because by that time, I was a good decade into low carb lifestyle for my own healing, that I thought perhaps my palate had changed. And I was watching her just drink cup after cup after cup of this. And my brain was like, how is that not connecting? Flash forward again in 2013. This breaks my heart every time I think about it, but I had an entire family from Pune come to me online, a virtual interaction. They came to me originally because mom, the mother, and why they came to me is because of my history with ovarian cancer. Their mother was diagnosed with terminal ovarian cancer. When I started running labs on the mother, her vitamin D levels were 6. You can't be metabolically healthy at a level of that. Her insulin levels in US ranges were in the 30s. Her hemoglobin A1C was 10.2. Her glucose levels were in the hundreds, which I don't know what that equates to in European terms, but she was so extremely diabetic and had no idea, right? And one of the key drivers of ovarian cancer is insulin. Insulin growth factor is one of the key drivers. And then to talk with the husband and the 2 daughters that came in on the visit, they were like, we're here to help whatever we can. They'd read, at that point, my book hadn't even been out, right? So they didn't know anything about me. So we started on that process and got her completely into remission, completely in a matter of months. But the change was difficult because here's this white woman from America telling them that the way that they've been eating for the past 10,000 years was not working for them anymore. And I was so relieved that I heard everyone talking before I came in. I'm like, oh, because it's very difficult when you sit there and explain the food of today is not the food of yesterday. The activity of today is not the activity of yesterday. The environment of today is not the activity or the environment of yesterday or generations previous. And so it's not our food's fault that it's a hot mess now, but it is a hot mess. And in as such, it creates a hot mess in us. And so that was one of the big stories. And a few years later, when my book came out, that family read my book, came back as a whole because mom was doing really well, but now dad has hepatic carcinoma, very aggressive liver cancer. He was given months to live. We managed to keep him around for several more years beyond that. And then the other daughter, one of the young daughters, not quite 30, diagnosed with breast cancer. And the other daughter, younger daughter, had polycystic ovarian syndrome, which was the precursor to ovarian cancer. And so I'm looking at this whole entire family unit that's so sick. And luckily at that time, there were very few, if any, resources in how to do a carb restricted diet in an Indian population. And so I had, from my years of Ayurveda study, from my understanding of carbohydrate restriction, I had a pretty good idea of how to start to manipulate the diet. Not an easy venture, guys, when the whole entire culture is based on pulses, right? And so for that, I was able to get the entire family, all of which were diabetic, all of which their vitamin D levels were low, all of which they had all the patterns. The kids, the daughters were getting more and more obese, all the different things happening here. So that's been my journey with India over 20 plus years of watching it being virtually unheard of, to a little bit of talk about diabetes, to an entire family riddled with cancer and diabetes together. And so it became a passion of mine. And when I started hearing murmurings, and my director of education, Janet Ottersberg, made contact with you, Shashi, about all of this, we jumped at the opportunity because, as I said, my heart and soul has been very much in love with your beautiful culture, community, and country, that it's just devastating to watch this sort of, I mean, I think a mass extinction is maybe a harsh set of words, but I'm very concerned that is what we're witnessing.
We never knew about your connection with India.
So, you didn't. Oh,
so good. I asked it. Very, very interesting to see your approach. And maybe this 30-minute doesn't do justice. We will have, in the subsequent program, we are going to call you for 1 full hour to understand the metabolic link to cancer. Yeah. Because we always think it is something genetic, it is associated with something. We really don't realize the link of insulin and blood sugar to it.
Exactly. And so that's the bridge in the future for sure.
and as you rightly say, the incidence of diabetes is raging here in India. You must have already read some of the reports online that more than 101 million are having diabetes, 136 million pre-diabetes, 36% of the population may be having hypertension, 1 in 5 having PCOS.
Wow.
obesities, childhood obesity, central obesity is the key here. We may be lean, we may not have high BMI.
Right.
But that central obesity is seen. The classical definition of metabolic syndrome is seen in Indian people. Raised triglyceride, low HDL, raised blood sugar, slightly raised blood pressure, and central obesity. Classic. So this metabolic syndrome, the entire concept fits really into India.
Yeah. Yes, and you are all leading the charge to change that.
Yeah, that's what we are doing, like one at a time. One patient at a time, one client at a time. And Anup will also say what he is doing to battle this raging metabolic disorder. Yeah, Anup.
We've been basically, as you said, Indian diet is pretty carb loaded. And so the whole idea of launching DLife.in around 9 years back was to slowly get people educated on what low carb is. And once that has happened, then we focused on, creating an army of low carb professionals.
Perfect.
So that's it. And as you said, you've got 20 years of, Indian association, more or less. So I would request you to, what would be your message to India on this first, on the occasion of this first low carb or metabolic health conference?
I think I've alluded to it a little bit in our discussion this morning or this evening for you, and we have to get away from the dogma of our culture, and we have to look at this data, which, as I alluded to, was just because this is the way you, your parents and your grandparents, your great-grandparents, your great-great-grandparents have eaten for millennia at this point, that is no longer serving you. And as our bodies are unable to metabolically adapt to the changes we've made to our food sources and to the environment around us, we have to adapt to overcome those modern additions that have really bastardized our endocrine system. And so we have to be willing to let go of some of the ideologies that came at a right time and place, but is no longer the right time and place. And so my ask is that folks are willing to be emotionally and intellectually flexible as they face sort of the harsh realities of the soil that we had come from for many, 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 many moons is now the soil that's making us sick. And so that would be my hope, is that folks are willing to look at the data to help them overcome some of the dogma.
Very nice. So we will keep collaborating. Is what I can say, Nasha, that we will keep collaborating. Collaboration between Metabolic Health Day, Nasha Winters, maybe Metabolic Health India, Metabolic Health Conference with DLife. So we will keep collaborating. We will keep planning some activities so that your message also reaches India, and our message also reaches globally, because the Indian diaspora, the people who are abroad, they follow a similar pattern, and they suffer similar consequences. It is not that someone who has gone abroad, they change. They don't change. We as a culture are addicted to grains. That is one aspect. And the influx of modern processed food this is creating a mess in children and the younger generation, is what I can say. So, and thank you for posting our video on this event. That is where me, Anup, and Ira Sahai, our media head, we had made this video especially for Metabolic Health Day, so that people across the world knows about this conference, because this conference is not only for India. It is a global thing. It is out there in YouTube. People can just log in and see, and recording is going to be available. And this is the inaugural session, and we are going to have much more interesting events in the coming times.
I love it. And I was telling Posh in the breakout room that I will be in India potentially twice this year, at least once, either in March or November, and potentially twice. And so I definitely want to keep these collaborations going, because the Metabolic Terrain Institute of Health is committed to global metabolic health. And even though we are, because of my own life experience, seem very cancer centric, at the end of the day, as I mentioned in the beginning, it's all metabolic centric. So we're here to help. We're here to support you. We are willing and very happy to accept all of your support as well. And I'm honored for this opportunity, Shashi and Anup. Thank you so much.
Thank you, Nasha. If you come to India, please message us. So depending on where you land up, there will be some one of us in some state.
I will take advantage. And that is the one thing I tell you, I have had the most amazing hospitality and support in your beautiful country. So it's an honor, and it will be an honor to return. Thank you.
Thank you. Thank you. Thank you, Nasha. Thank you.
You're welcome.
So we can get the next guest in. Dr. Sean and Mehak.
So I think you need to unmute.
Sir is unmuted, but he's not audible.
I cannot hear
There we
him.
go. That should be better. How's that?
Now it's there.
That's wonderful.
Well, good evening. It's good to be here. Thank you guys for inviting me. It's a real honor to get to speak to a sort of a different audience than I normally talk to. So thank you.
Thank you, sir. Thank you. It's an honor for us to have you over.
Is there particular things you wanted to discuss?
Yes, sir.
Okay.
Yes, sir. For which I had already sent you the details on those questions, but they're basically with regards to your own lifestyle, your own carnivore diet, what got you into this lifestyle, and about Rivero is what I wanted to learn from you. So there are a couple of things that I have lined up in questions, and they're just very basic ones in terms of the carnivore diet.
Sure. Well, I mean, if you want to ask, my own reasons for doing this were purely out of health. I mean, that's I think the major reason why we have to eat is to support our health and acquire nutrition. And as I had reached, sort of the midpoint of my life, I was probably in my mid-40s, and I wasn't where I wanted to be metabolically, health-wise, and so on and so forth, despite being an athlete that was training extremely hard. The diet just wasn't supporting my health goals. And so I looked to various different ways of, trying to fix that through nutrition. And so the initial thing I tried was what most people are told was I cut fat back very low. I ate a lot of vegetables. I ate, lean sources of protein. And it worked in the sense that I was able to sort of, get leaner and lose weight, but it was unsustainable for me. I found that to be I was pretty miserable, to be honest. And so after about 5 or 6, 7 years of experimenting with different diets, low carb diets, at some point, I stumbled across a group of people just consuming, a lot of meat, basically. And I thought that was quite strange, and as everybody does. But I was willing to try it. And once I tried it, I realized that I responded very well to that diet. And it's now coming on. I'll be starting my 8th year here next month. And so, that's kind of an overview in that. And since that time, I've of course seen, gosh, I cannot tell you, thousands upon thousands of people have now adopted this kind of style of eating. And very commonly we see just a reversal of all sorts of, health-related issues, whether it's diabetes, whether it's prediabetes, whether it's obesity, whether it's mental health issues, whether it's autoimmune issues, things like arthritis, skin diseases, things like that. We've seen tremendous success. And so obviously that's something as a physician I'm interested in, because that's the whole reason I exist, is to sort of try to help people with their health. And so that's kind of in a nutshell, so to speak, my introduction into this.
Nice. Beautiful, sir. Thank you so much. But yes, I would like to also put across my introduction to you, to the viewers who are watching us probably for the first time. And for me, you have always been a mentor. I have been very, very religiously advocating and proposing your diet, lifestyle that you've been teaching us all throughout Instagram and, of course, your Twitter now. So I'd really like to let the guest tonight, the viewers tonight, know what my guest actually does. So Dr. Shawn Baker, I believe you are an world champ athlete and orthopedic surgeon and the author of the bestseller, The Carnivore Diet. So I'd really like to bring the spotlight onto Dr. Shawn Baker tonight. Shawn, sir, you have been the carnivore king for about 7 years now. Am I right? And you, just as you said, you're going to be entering your 8th year, advocating this and practicing it so religiously. Of course, I see all the kind of foods that you eat, and I try to replicate as much as I can living here in India. In India, we don't have access to cow meat, beef. The only thing we have access here is goat and buffalo meat, knowing that cow meat is creme de la creme. So can you tell us what is the most preferred meat in the United States?
I guess the question is, you said, what is the meat that we eat in the United States? Or
what is the most preferred meat, commonly preferred meat in the United States?
Well, in the United States, chicken is the number one meat that is consumed, by the population numbers by far. Beef would be probably second, and then we have lamb, lamb, sheep, mutton, and then of course pork, and then seafood, of course. So by volume, chicken has surpassed beef, and it's done that since about the 1980s. And so I don't consume a lot of chicken. I prefer, and I know there's a lot of religious prohibitions around beef in India, of course, but I think mutton, I think lamb is a wonderful. It's every bit as good as beef as far as health benefits. Now, some people have different taste preferences around that. Buffalo certainly would be acceptable. I think that for some reason, and I think there's maybe some evolutionary perspective on this. Ruminant meat seems to be, an animal that ruminates, whether it's a sheep or a cow or a buffalo or a deer or something like that, seems to have a little bit of extra nutrition that is beneficial to us as humans. And I think if we go back to our evolutionary roots, we all were hunters at some point, and the most efficient things to hunt were big, large animals. If you think about, particularly with the technology that was available, it was mostly just close range spears and things like that. Range technology, the bow and arrow and different throwing devices weren't really prominent until about 80,000 years ago, at least based on the evolutionary records. And so prior to that, a lot of hunting was done close range. And if you can imagine trying to acquire a lot of food, like chasing birds around with a spear, is not going to be very efficient. And so I think we initially hunted large animals, butchered them, ate them, and that's part of how we kind of adapted as a species. So I think there's something to be said for that. It's not that, and I've seen some people that have successfully, done chicken, and because I know chicken is going to be obviously very available in India. Probably as one of the major sources. Of course, you've got the vegetarian population where eggs and dairy are quite prominent. So those are all, in my view, acceptable. Depending on compared to what else you have. Because I just heard your last guest talking. I caught the tail end of that, talking about metabolic health, and as you know, currently in India, I think something like 11% of the population is now diagnosed with diabetes. That's equal to what the United States rates are, which are horrible, by the way. And behind that is probably another 40% that are pre-diabetic. And so you see that it just wrecks the population health. And I think it's a problem with obviously the overall food selection, what's available. And I know there's a lot of people where, there may not be much choice. Sometimes your financial situation dictates what you can afford to eat. And you're kind of, in some ways you're stuck, but in other ways you do get to make choices on how you spend your capital.
Absolutely, I would agree to that, because many a times when we tell people to switch to these kind of lifestyle changes, the first question that they put out is, we can't afford it. So that's something I always tell them. You can always choose better foods over choosing medications. So if you look at it that way, these kind of foods are really not expensive.
Yeah, I can't, like I said, I can't speak to the cost of what chicken costs in India because unfortunately, I've never been there. Hopefully one day I'll get to visit at some point.
Sure you will.
I think one thing that is becoming more and more clear is the protein requirements are probably much higher than even the United States. Our RDA for protein is 0.8 grams per kilogram, which is, just barely enough to keep you alive. And my understanding is in India, a vast majority of the people don't even get that much. There's something like a significant percentage of the population doesn't even get the US RDA, which is already probably half of what it needs to be. I think the more reliable data, the more for thriving is closer to double that. So 1.6 grams per kilogram. And then if for some reason you want to be an athlete or put on more muscle, then even perhaps in some cases higher, depending on what else is in your diet.
What is the limit that you would go to in terms of protein? Is there like the RDA says 0.8, but is there something that you would say maybe like a 3 gram or even beyond that is fine?
Yeah, it's interesting. There was just a recent study that just came out looking at people that want to put on muscle and lose fat simultaneously, which is hard to do in many cases. Traditionally, when we're told when we want to put on muscle, we could be going a little bit of a caloric, increase, and so we have to eat more protein, but we often put on fat. But to lose weight, lose body fat, and gain protein, there's studies out there supporting something like 2.5 grams per kilogram or up to 3 grams per kilogram, which is quite a bit of protein, and that's probably about what I consume, somewhere in that neighborhood. I weigh 250 pounds, which is about 120-ish kilos or so, 118 kilos, somewhere in that range, and I consume probably 300 grams of protein a day, something like that.
Wow,
I'm very active as well. So
yes, I do see that, of course, on all your videos that you have been doing a lot of resistance training and you're an athlete. So yes, absolutely, that requirement is justified. I totally agree with that. I would also love to know, Doctor, I came across this study in the Science Journal in which you conducted a study involving about 2,029 adults who followed a carnivore diet for about a period of 6 months, if I'm not wrong. And I read this in the Science Direct Journal. It stated some very interesting numbers in terms of the improvement in their health. There were 100% diabetics that came off injectable medications, 92% going off insulin completely, and about 84% going off oral medication. This is commendable. I really want to hear your insights on this.
Yeah, so that study, actually, I didn't conduct the study. I just helped to sort of facilitate it, I suppose. And David Ludwig at Harvard University was a senior author, and that Belinda Lennertz was the primary author. And they took 2,029 people that were following this sort of carnivore style of diet, and at minimum they were 6 months, and some people had been doing up to 28 years. So it was quite a long period of time. And yeah, in general, pretty much they generally all did very well, minimal side effects, but the diabetes data was quite compelling. And you're right that anybody that was on any kind of injectable medicines, things like SGLT2 inhibitors, GLP-1 receptor agonists, they came off those 100%. The type 2 diabetics, 92% of them were able to come off completely off of their insulin. And then even metformin, 84% were able to come off things like metformin or other oral meds, which is, there's very few interventions that have been that powerful, so it's just shows you how effective diet can be for some of these things. So a lot of people are told, hey, you've got diabetes, you're going to be on this pill for the rest of your life, particularly when it comes to insulin. And then they're constantly just injecting themselves, over consuming carbohydrates, injecting themselves, and it results in all kinds of complications, whether it's amputations, blindness, kidney failure, cardiovascular disease. That's another issue that as you know, in India, there's a lot of cardiovascular disease now, which goes hand in hand. And I think if we think about, cancers, cardiovascular disease, mortality, all of it is funnels into what's going on with our metabolic health. And that is basically some form or fashion of diabetes, inflammation, gut health, which is also very important. All those things are sort of contributing to this.
Yes, absolutely. In fact, in India, this is one of the major issues when you're trying to get people off medications. That included my own mother, who's been diabetic for almost 30 plus years. And she's always been told to, only take medications and medications over and over and not make a dietary lifestyle change. So this is one of the common issues, yes, we do face here. And only with a change in lifestyle, if people can understand, this can be, taken care of. I had another question with regards to your patients, as you are also a doctor, an orthopedic surgeon. What is your approach with your patients as it relates to these nutritional changes? Do you actually, explain to them the benefits of a carnivore diet, or then do you just take them step by step, further into it? Or is it depending on individuals, case by case?
Yeah, I think that, while I'm a huge advocate of a carnivore diet, I think it can be wonderful for a number of conditions. It's not necessary for everybody. I mean, there's certainly people that can get better just by removing sort of the ultra processed foods out of their diet, sort of cutting back on perhaps some of the grains and refined carbohydrates. Those things are tremendously huge. Now you've got to replace them with something. And so I think in my experience, if we look at how effective a diet is, number one, you have to do something that you like. You have to enjoy the food, and you have to also have to not be hungry all the time. If you're hungry all the time, you're never going to stick to any kind of dietary plan. So we talked about that, and in many cases, they find various animal products to be quite a good. They provide quite a great sense of satiety, and this is where some of these new drugs that are out there, you guys may have heard about them, the GLP-1 receptor agonists, the Ozempics, the semaglutides. They basically mimic, in a way, a lot of what consuming meat does, which provides the satiety and impacts these so-called incretin hormones in a very similar fashion. And so the problem with them is, it's if you continue to eat sugary, grain-based foods and you take these drugs, you end up with some side effects, which can be problematic and harmful in the long term. So I think particularly for people with autoimmune conditions, which are becoming increasingly prominent, like Crohn's disease and ulcerative colitis, the first thing I would do is go to a strict elimination diet. The gut is so impacted by our nutrition. I mean, we have physicians that don't seem to understand that, which is bizarre to me. I think for certainly food addiction, which a lot of people suffer from addiction to ultra-processed food, particularly sugary ultra-processed foods. It's very challenging to get off of that without sort of abstinence in many cases. And so it's like if you had somebody who was, struggling with alcoholism, you would not tell them just to have a couple drinks a week. That wouldn't make sense, and it wouldn't work, quite honestly. So I think there's certainly definitely people that will benefit from a very strict approach. But beyond that, what our company, like you mentioned, you alluded to, Rivera, we're licensed in all 50 states in the U.S. Hopefully, we'll have an international presence in a few years. But our approach is basically to move those major problem foods as a transition and then see what we need to do. Now, some people will have to go very strict and maybe go to a carnivore diet for a period of time. And that is something that, in my experience, has been quite effective at relieving a number of issues and sometimes resolving it completely. And then if they want to, they can sort of incorporate and reintroduce other foods if they want to. Some people don't want to. Some people are so happy because it's such a simple dietary strategy. You think about it.
Less stress.
A lot of people spend a lot of time and it can be quite anxiety provoking thinking about food, planning food, preparing food, shopping for food, and then they eat their meal and they're immediately thinking about their next meal.
Yeah.
So with a carnivore style of diet, it's very simple. You're like, okay, well, how much sort of meat am I hungry for? Maybe some steak and eggs, and that's it. And it's not hard. It's not challenging at all. It's quite simple.
Yeah, that's amazing. So you probably would just go out, let's say, and you have your menu very set. Is that what it is? It's just steak and eggs. You really don't have to think about anything.
Yeah, my diet is very, quote unquote, boring, and some people would consider it boring. But yeah, I will have a steak for breakfast and and probably one for dinner. And I might add a little bit of Greek yogurt or something, depending on what I'm trying to do with regard to, if I'm trying to get leaner or put on weight. It depends. And so that's most of, in the last, like I said, it'll be going on 8 years soon. I've probably consumed 97% of my calorie has just been through steak. I mean, that's not an exaggeration. And the other 3% has come from eggs, a little bit of dairy products like cheese, and then a few other, maybe some seafood, maybe a little bit of chicken and pork occasionally. And then very rarely, I mean, maybe a few times a year, I might have a little piece of fruit or even a piece of dessert. But it's my diet is almost exclusively, in my case, beef. And I know it's not available in India as for many people. But, if you look at the, again, population statistics, in the United States, we consume 100 kilograms of meat per year. And in India, it's something like 5 kilograms. And so even though many Indians consume meat, I think the majority are not vegetarians, but even still, that the amounts are so small. One of the smallest amounts in the whole world, I think, next to like Bangladesh. And you're seeing the results of that, I think, in the fact that you have such high, and it's what's being replaced with it. And we're seeing all this, like you said, you've got so much palm oil that has flooded you correct me if I'm wrong, but I think palm oil has largely supplanted things like ghee and butters and things like that.
Absolutely. We're clearing fats all the time in India, and we've replaced it with refined oils. And then, of course, we are looking at our lipid reports, and we're blaming the fat for it. So that's one of the major issues that's really soaring here in India. Lipid reports are high, our blood pressures are soaring, our HbA1cs, and yet people are just okay eating medications and trying to just suppress these symptoms and not take care of it. But they just don't want to make a dietary lifestyle change.
Yeah, I don't know if it's a systemic issue like it is in the United States, where, it's probably easier just to give people medications than to actually change the food system, because that's challenging to do. Now, like I said, if this, I mean, individually, you can make your own decisions, and that's what, you have to sort of, I encourage people to do their own, to invest in their own health, because really no one is going to take care of you, so to speak, in a way that they should, and you have to take care of yourself, and you have to be invested in your own health. And I think, at the very least, experiment with these different styles of life, because if you are sick and you're continuing eating the same way you've been eating over and over again, don't expect a different result. And you probably look around and see all the people, it's probably pretty predictable. You see people as they age, we expect them to get more arthritic and, hunched over and slowed down, and their ability to do anything.
Yes.
Their ability to do anything is quite low, and that's not how it has to be. I'm approaching, I'll be 60 soon, and I can still run and jump and wrestle with 20-year-olds and all those things. And it largely has to do with, well, two things. One is I'm active and I train, but my diet allows me to do that. Adequate protein. I don't eat a lot of foods that otherwise would be inflammatory, which would cause me, the inability to do those things. And I think particularly, if I had to point to it, I think grains and sugars are a huge driver of, as an orthopedic surgeon, orthopedic problems, arthritis, tendonitis, some of these neuropathies and things like that. We see, degenerative disease in the spine. These are all, in many cases, driven by diet.
Yeah. So that's what my question was, that being an orthopedic surgeon, incorporating this kind of a lifestyle has shown you results with your clients too. I'm sure it has.
Yeah, absolutely. This is something that, early on in my orthopedic career, people would come in. I remember people come in telling me that they felt that, eating bread would cause their knee pain, and I didn't believe them. I said that you're kind of crazy. I didn't believe that, because I wasn't trained about that. But now, in retrospect, these people, I think, were not only right, but it was more than that. It's a very a lot of people just think that, I twisted my knee 20 years ago, and that's why I have a bad knee or something, or maybe I'm carrying a little bit too much weight. And that is an important point. When you carry excess body fat, and I know in India there's a lot of people have these little pot bellies. Not really, we don't have the gigantic obesity like we have in the United States, but even that excess little body fat around the middle, if you're a male, is driving inflammatory problems. We have these inflammatory cytokines or adipokines that are coming from the fat tissue, and that makes your whole body achy, and it makes you not feel good. And so, absolutely, diet impacts. I think a lot of even arthritis in particular, which is so common, is really just an orthopedic consequence of metabolic disease. And I think that it took me a lot of years to realize that. And many, not all, but in many cases, I've had patients where I literally had them signed up for surgery to replace their knee or replace their hip, and we changed their diet and their pain went away to the point they no longer required surgery. And that was, I thought, really, that's when I had my first aha moment. This is about 10 years ago when I was putting people on low-carb diets, and all of a sudden I was canceling surgeries. Now, that's something maybe a hospital doesn't like because they depend on those surgeries to make money. But at the same time, I thought it was wonderful that we were able to avoid these major surgeries with diet changes.
Yeah, I think even a low-carb diet really helps to a great extent, and especially here in India, because 90% of our plates are on high carbs. So even if we come to low carb, if not carnivore, I'm sure we can make a difference here. Doctor, recently I read about you making a dietary shift to a ketogenic lifestyle. I would want to know the reasons behind this change and the lessons that you have gained from this, if that could help us too.
Yeah, well, I mean, as I mentioned, I'm active, and I was wrestling with some much younger kids than I was, and I ended up, unfortunately, injuring my neck. And so I have something called cervical radiculopathy. So one of the nerve roots was being impinged upon. So it was causing quite a bit of pain going down my right arm, and numbness, a little bit of weakness. And so my diet, while carnivore, was not necessarily ketogenic, because I tend to favor a little bit higher protein approach. And I eat a lot. I don't do a lot of fasting typically, because I'm trying to maintain muscle mass. And so there is quite a decent amount of literature that shows that a more ketogenic style of diet is particularly helpful with neuroinflammatory conditions. And so this is a perfect condition for, I think, a higher percentage or sort of a more of a ketogenic type of style. And so I just shifted the protein down slightly and increased the fat up a little bit, and then consumed a little bit less food. And that has helped, reasonably well. I mean, it's not the only thing I'm doing. I'm doing some rehab therapy and things like that. Exercise is actually quite helpful. Regular exercise helps just in most conditions. But that was the reason for the shift. I'll probably maintain that probably for a little while longer. And then I'll probably go back to a little bit more protein, because like I said, I personally feel that lean mass is important for a number of reasons. And we know it protects us from cancer, heart disease, dementia, diabetes, all these things. And plus it makes you functionally more competent. And so quality of life is better. And so that is my sort of strategy for aging, is to hang on that. The lean muscle you have is it's literally metabolic gold, if you want to think about it that way. Having lean mass and replacing sort of like excess body fat with lean mass was one of the most effective health interventions you can make across the board for just about any sort of outcome you're concerned about, whether it's mortality, like I said, cardiovascular disease, cancer, diabetes, on and on.
Lovely. Also, doctor, in terms of HbA1cs and putting diabetes to remission, would you recommend a carnivore diet? Because again, I read about your own HbA1cs coming to 5.2, one of your tweets that you mentioned, and eating 112 pounds of meat a week. Well, the reason I asked you this is because meat has been so demonized in India, and so widely demonized in India, that we've started relating every problem with meat. Meat causes cancer, meat inflames the gut, meat rots in your gut, and all sorts of things. So there is a lot of unlearning that we really need to do here in this country, and this is why I when I was reading your tweet that you mentioned, your HbA1c has come to 5.2 in spite of consuming that much of red meat. these are the significant challenges that we are facing. If we can get some insights on this and how we can address this.
Yeah, well, I mean, I want to, it's interesting. You mentioned, people thinking meat is inflammatory. Well, I mean, they're just literally within the last 2 days, Baylor University, which is in Texas in the United States, just published a research paper looking at red meat consumption, specifically in inflammatory markers. And they found that there was no evidence that it caused any inflammation. And the only time it does is in the setting of obesity. And so it's really the obesity that's driving the inflammation. So if you do a meat-based diet, whether it's carnivore or close to carnivore, with, if it's with lamb, chicken, buffalo, whatever you want to do, and you reliably are losing body fat, your inflammation is going down. And that's usually what I see. And so I think in the context of, yes, if you are consuming a junk food diet, refined processed carbohydrates and meat at the same time, then, it's still whatever's causing the weight gain. It's not the meat. And typically, if you put somebody on a pure carnivore diet, they're going to get leaner. I mean, that almost invariably happens for almost everyone. There's few exceptions to that. And so with regard to diabetes, exactly the same thing. What I see consistently is that, and this is the thing, we've got so much bad nutrition science out there. Most of the nutrition science is this so-called epidemiologic studies, these associational studies where they're not testing people on a meat-based diet. They're testing people that eat a lot of junk food and then saying, well, it must be the meat. And it's clearly, that's not the way you want to test something. You don't, if you wanted to test the effects of a drug, you wouldn't give them 30 other drugs at the same time and say, well, there's no way to figure that out. And so what we do have, the unique insight that a carnivore diet has given us is the unique effects of meat. And when we do that, their diabetes goes away, their blood pressure normalizes, their body fat gets better, their inflammation goes down, and they feel better across the board. So meat is clearly not driving a major driver of disease. Now, the only exception to that would be is if you could somehow consume it in excess to where you gained a lot of body fat, but that usually doesn't occur. It's usually what's accompanying that. It's the refined grain products, the sugars, the oils and things like that are often utilized. And so, but meat itself, you think about it, humans would have never evolved if meat was killing us. We would have never made it as a species. I mean, we relied on that as long as humans have been around. And I don't know what the perspective is in India about human evolution. I know from my perspective, Homo sapiens have been around about 300,000 years. And prior to that, we've had the different other Homo lineages, Homo erectus, Homo habilis, going back to almost 3 million years. And those records indicate meat was a huge part of our development as a species. And so had meat been something that was bad for us, we would have died off. Like, it's kind of interesting. We do have some primates that sort of tried to progress things like Australopithecus robustus and boisei, which were vegetarian or vegan actually, and they died. They couldn't make it in, and they could not make it in the world, and so they died off and they went extinct.
Yeah, vegan diets, the most common all around that you see. What is your advice or your say to those who follow a vegan diet? I do see a lot of your TikToks and I do see a lot of your memes that happen on Instagram, but I really want to know, what is your advice to somebody getting on this vegan bandwagon?
Well, I think, again, I don't think it is the most efficient or effective diet for health. And if you do it for, if you have some ethical belief, which unfortunately, I think those are a little misguided, but irrespective of that, if that's what you're going to do, then please focus on getting adequate protein. And I think you're going to have to eat a little bit more protein than someone on say a meat-based diet to get the same level of quality. It's very challenging. Most vegans will have issues with B12, certainly. Even sometimes supplementation may not be effective. There are a lot of other things in meat that are beneficial: carnitine, carnosine, creatine, anserine, taurine that you're not going to be consuming, choline that you're not going to be consuming on a plant-based diet. And so you're going to have to maybe supplement those things in addition if you want to have your best chances. And again, if your diet is 20% food and 80% supplements, maybe it's a problem. Yeah, I'm sort of exaggerating a little bit there, but certainly please do strength training. Please increase your protein intake to a very adequate level, because that is a real challenge. And I don't know, like I think in India it's probably even more so, because I don't know how much access you have to some of the more, I guess, refined protein products that are sometimes available here.
Protein is really a major issue in India because, like I said, we fear protein, we fear fats, we fear protein because we feel that kidneys are going to be damaged, and we fear fats because we feel we're going to increase our lipids. So these are a couple of the major issues that we are fighting as yet here today. And yes, we're trying to do it, maybe not, trying to put everybody on a carnivore diet, but trying it with low carb and then trying to explain to them the benefits of how these diets can help. So I think we're kind of, US and India is probably sailing around the same boat.
Yeah, I think the point about protein harming the kidneys is something that should be addressed, and I think that's a misconception. It goes back to probably the 1980s, the so-called Brenner hypothesis, where Dr. Brenner was doing experiments on rats, and he found that rats on a high protein diet did develop glomerular damage, kidney damage. However, they've looked at that pretty extensively. Stu Phillips, really wonderful paper in, I think, 2018, 2019, large meta-analysis looking at higher protein diets and kidney damage. And so really there's no good human data that shows that. Now, when a kidney is failing, yes, it will spill protein, but it's not the protein that's causing the damage. It is, again, the diabetic pathophysiology in most cases, and so, and I actually see people with chronic kidney disease that go on a carnivore diet or a low-carb, higher protein diet, and they reduce the inflammatory grains and sugars, and their diabetes gets better, and their kidneys actually recover. They reverse their kidney disease in many cases. And so protein is not damaging the kidneys. So that is a problem. Now, a lot of times the way we measure kidney function, the most common way is often something called a serum creatinine. And that is, it's kind of what we've done for a long time. But in the context of a higher protein diet, creatinine can merely mean you have more muscle mass, or you're consuming more protein, or you're exercising very hard. And so in those situations, if creatinine is elevated, it may not be a problem. There's a better test called cystatin C, and I don't know how widely it is available in India, but that will give you a better estimate of your kidney function. I often tell people that they'll see their glomerular filtration rate go down, their serum creatinine go up, and they'll be told that they have kidney disease. And we say, no, do the correct test. And they almost invariably come back with, no, it's actually normal. So I think and many physicians need to be trained on that. They're not aware of how to actually accurately assess renal function in someone on a higher protein diet. It's not that the creatinine is necessarily a problem in that situation. So it's a matter of education. And when your physicians don't know, the population doesn't know.
Absolutely right. Yeah, this is one of the fears that we need to keep, teaching people of and trying to convince them and counsel them on the protein really doesn't cause high uric acid. And that's another problem, high uric acid. Everything that they talk in terms of kidney is related to protein, even if it's uric acid. So the moment they see uric acid elevated, they will stop the protein. And this has been a problem because this information comes to the general public from the white coats. So then that becomes a little, problematic in terms of we trying to explain to them the other way. And they said, no, you don't know anything.
Well, let me just, and I don't know how much reverence the general population has for physicians in India, maybe quite a bit, but I will tell you, physicians get it wrong a lot of times. As a physician, I know we've been wrong many, many times, and people have been harmed for that. So I think if what they're telling you doesn't match your own personal experience, you might want to just sort of reconsider if the physician, because physicians are wrong very often. I think that's something that people need to understand that. And I like I said, I will say the only thing I know with 100% is I'm wrong about something, and I think that's just, I think that's a fair statement. We can't know it all, and we're often wrong. But what I will say is that you have to be your own advocate. I mean, don't just take, if something is not working for you, don't be afraid to say, hey, look, this is not working well for me, and I need to make a change, because the physician, they don't have as much invested in you as you do. They don't have as much so-called skin in the game. You've got to take health into your own hands in many cases.
Yeah, that's so true. Doctor, what position would you place meat on a dietary pyramid? Would you say that it has all the essential nutrients for human survival and optimal health?
Yeah, I would say that, actually. I think you can live a long, successful, healthy, functional life on a purely meat-based diet. We've known that for many hundreds of years. In fact, this goes back to the times of when they were exploring the polar continents, and it came into people where that was basically their life. Free of disease, functioning, doing well, life expectancy just as good as what was known at the time. Now, of course, they're living in very hospital times. They had high infant mortality rates. They had a lot of violence and things like that they had to deal with. But they were living just as long as anyone else, and so you can do that. I think that it should make up the majority of nutrition, and I think everything else is just, maybe I like to call it flavor enhancement. If you want to have the vegetables and things like that, or fruits or spices, can be just to make it more interesting, if that's what you desire. I know India is a culture where spices and seasonings are very, very prominent. You've got I've had plenty of Indian food over the years. I know it can be quite delicious, but I think if you shift the focus to the meat and off the carbohydrates, the grains, it's going to provide tremendous benefit for your health and your quality of life.
Yeah, I would agree to that, because last 3 years since I made a shift to the carnivore diet, it has been completely meat-based. But yes, living in an Indian household, I've had parents, I've had family who eat the way I eat also. But then I've had to incorporate a bit of spices, and I've had to incorporate a bit of, Indian cultural spices, so that we get that taste and that palatability for foods. So yes, I have been doing it, but there's been absolutely no grains, no sugars, no beverages, no sugary beverages. So it has been a meat-based diet, but keeping in conjunction with the addition of spices. That's the only thing I have been doing it for the last 3 years, and it's been very, very beneficial in terms of everything, in terms of inflammation, in terms of gut health, in terms of sleep. There's a big shift I noticed even when going carnivore. Sleep got so much better, it's got so much peaceful.
Yeah, I think that there are, as I mentioned, there are many reasons to do this diet. And I think for most people, having some spices is probably fine. There are some people where those things could be problematic for their gut. And in those cases, they just have to avoid that. But I think, yes, you can certainly do a meat-based diet and use the various spices that you enjoy. And you just have to be objective and say, how are they actually treating me? How am I feeling? What's my gut function doing? Do I have any inflammation associated with that? Because some people will have issues with that. But I think many people will tolerate it just fine. And again, it makes it more, again, we're talking sustainability. You want to do something that you enjoy. And if the prospect of eating a plain unspiced piece of meat sounds awful to you, then that's not going to work for you. So you have to be able to work it in a way that's enjoyable to you.
In your taste buds also. Absolutely. What is your take on fruits and vegetables? Because this is one of the topics that's really so sensitive, in India. The moment you tell somebody to get the fruits out, oh, I'm going to be missing the minerals and the vitamins, and all of that starts. So I want to know your views on that.
Well, yeah. So, the reason that we sort of revere fruits and vegetables is, because we think they have these, and they do, they have these sort of quote unquote phytonutrients, which have sort of maybe anti-inflammatory properties and antioxidant properties. But what we don't realize is that actually ruminant animals, grazing animals, actually have those very same compounds in their body to a degree. And in fact, they have a more varied diet than vegetative diet than we. They can consume plants that we cannot consume, and so they actually have extra phytonutrients within their fats, within their tissues, in various concentrations. And so you get all that through animal products anyway. There's a great paper from a guy named Stefan van Vliet when he was at Duke University, and they looked at this and they found that meat itself, he was looking at beef in this case, but you can extrapolate to goat, mutton, lamb, whatever, it doesn't matter. They have something like 50 to 70,000 individual nutritional compounds within, including many of these phytonutrients. And so are fruits and vegetables bad or dangerous for you? I don't necessarily say that, but I think some people are sensitive to them. I think diabetics, particularly if they're consuming a lot of fruit, is going to have an impact on their hemoglobin A1C and blood glucose. And we know that running high blood glucoses for long periods of time undoubtedly causes complications, whether it be kidney disease, blindness, leading to the awful, amputations, which I've done, unfortunately, many of those through my career. So I think that, again, this is another one of those things that you have to objectively assess your own personal tolerance to these types of things. Some people can eat vegetables and they're fine. Other people, it causes a lot of gut issues. It causes a lot of distension, bloating, pain, irritation. I personally, I don't even enjoy them, which maybe sounds strange, but I've never really enjoyed vegetables, and so I don't really consume them. So I'm happily not consume it. If you really like them, you just have to assess, which one am I tolerating well? And if we look at, if we consider nutrition for what it should be, it's something that nourishes our body and doesn't harm us. It doesn't cause us pain. And if we look at it through that lens, because, if you like, every time I go to this restaurant or have this particular dish, I feel awful afterwards, well, that's a signal that maybe you shouldn't be eating that. We sort of accept gut discomfort, bloating, gas, pain, belching. It's not, it really isn't. You wouldn't accept that in any other system in your body. When your knees hurt, we know something's wrong. When we have difficulty breathing, we know something's wrong. When our chest hurts, God forbid, we know something's wrong. So when our guts hurt, there's something wrong. It's either your gut is broken in a way, it's disease, or the food you're consuming most likely is the problem. And a lot of times what breaks the gut is consuming, chronically the wrong foods anyway.
Yes, absolutely. In fact, this has been a personal case because my own family, my own husband had this issue of rectum bleeding for quite a long period of time. And I remember taking him to the doctor, and we used to consume tons and tons of salads and fruits and vegetables. And he kept having this kind of bleeding. And I remember when I took him to the doctor said, oh, you need to stop off all his red meat, no chicken, no mutton, no lamb, nothing. And that's when I was just transitioning into the carnivore, kind of researching and learning more through your research papers and your books and other YouTube videos. And I said, I am going to do something different and see how this is going to work. And touch wood, it's been about 3 years now. He's had no such signs, no such symptoms, absolutely no bleeding. He is just a carnivore. He eats just 2 meals a day, pure meat, and it's all just sorted off. So this is one of the things, like what you said, you have to do it for yourself objectively to see what happens to your own gut and how your gut is handling it.
Yeah, the whole concept of, meat is going to cause damage, particularly in our colon. If we look at and we've got really good data on this, meat is completely absorbed in our small intestine. It doesn't even get into our colon. And so to sort of blame problems of the colon on meat is kind of silly. I mean, if you talk to anybody that's had what's called an ileostomy, where the colon has been removed, and you see what's coming out of that, it's all vegetation. It's vegetables, it's grains, it's never meat. Meat is completely digested in the small intestine. So it has very little impact on the large intestine. And so if you have colitis or ulcerative colitis or, things like that, where you're bleeding from your rectum, so to speak, it is most likely not coming from meat. It makes no physiologic sense. If anybody understands basic gut anatomy and physiology, it's pretty clear. Now, why do we associate? Again, we have this associational data. We have, and much of that data has probably come from U.S. populations. It's just been, it's sent over to India to use. And again, we have people that, when we eat meat in this country, it's usually in the context of a hamburger patty with French fries and a crappy sugary drink and, a hamburger bun. And that confounding is what's likely leading to this problem. It's not pure meat, like you said. Interestingly, like if you go to the data on meat consumption in parts of Asia, particularly East Asia, Japan, China, Korea, things like that, they looked at meat consumption in the context of things like cancer and found no relationship whatsoever. The only reason that relationship holds up is in the Western countries, where we consume meat in the context of basically junk food. And, and we have this so-called healthy user bias. We've been told for 50 years, red meat is bad for you. So if you continue to eat red meat, you're more likely to smoke and less likely to exercise and more likely to drink alcohol and on and on and on. And that confounding bias is probably enough. Now, if you have someone like me who doesn't drink, doesn't smoke, exercise, eats meat, you're most likely going to be quite healthy.
Yeah. What about organ meat? I have never seen you eating organ meat. Why?
Well, I don't enjoy it, so I'm not going to eat a diet I don't enjoy. I mean, this is, it's like, well, if I've got to eat something that I find not enjoyable, I'm not going to do that diet. Organ meats are obviously they can have concentrated sources of nutrients, vitamins and minerals and things like that. And that's certainly true. What I have seen, and again, I'm one of the guys that has been around for a long time doing this diet, and I interact with people every single day of my life that do a carnivore diet, and I've collected data on these people. I've got data on 12,000 people doing this diet. Ask them, do they consume organ meats or not? And there's no difference in the outcomes, really. I mean, they're not better, they're not healthier, they don't reverse disease at any greater rates. The Harvard University study, which you mentioned earlier in this talk, they found the exact same thing. Organ meats are not necessary to be successful on a carnivore diet. Now, can you consume them? Sure. If you enjoy them, and in a lot of cultures, they use them as sort of particular dishes. There's nothing wrong with them in a way. I mean, there's some people that suggest that maybe you could overconsume them, but I think eaten in moderation, they're fine, but are they necessary? I would disagree with that. I don't think so. And that's just based on the observation of, many thousands that do fine without them.
Absolutely, because even at times I do enjoy organ meat, but then there are times that I will not probably take them for months together. And there's nothing that I have really missed, or I feel that I have missed out if not taken organ meat. What about...
Yeah, I mean, well, go ahead. Sorry.
No,
I was just going to say, the people that have been doing this, like I said, I'm coming into my 8th year. There's people who have been doing this for now many decades. And when you talk to those people, they all are the same of opinion. Says the organ meats are not necessary, and most of them don't consume it. And so, maybe early on when you're particularly malnourished and you're coming from a state where you've been eating a poor, low quality diet for many decades, sometimes the organ meats can help to bring you to sort of a normal level of nutrition. And then after that, you find that you don't desire them, you don't crave them. And so perhaps it's one, if you have a particular craving for, say, lamb's liver or something like that, then maybe you should eat that. But then if you no longer desire it, then it's probably not needed.
It's not needed. Yeah. This is one of the reasons I love the carnivore diet, because it's so flexible. I mean, it's your choice. Nobody forces you to eat anything. And plus the satiety levels are so high that there's nothing that you can overeat.
Yeah, I mean, it's hard to overeat. I won't say it's impossible because, but I mean, I think for most people, they find that when they eat, and I don't know what a typical serving of meat in India is, but if you sat down to consume, say, half a kilo of meat, I think many people would be like, oh, I can't eat anymore, I'm full, that's
me, yeah,
that for me. I mean, I routinely will sit down to a meal of 1 kilo of meat. And I know that sounds kind of bizarre, but I mean, like I said, I'm a big person. It's very easy for me to do that. And I don't gain weight even consuming that much, and sometimes I'll do that twice a day. And I've done so for many years, and I maintain my body weight very easily.
What about nose to tail context in terms of carnivore diet or a lion diet? What is your...
Well, I mean, that's certainly, again, that's basically just including the organ meats and maybe using like things like bone marrow, which is quite flavorful actually. Yeah. There's nothing wrong with that. Again,
is it beneficial? Bone marrow and broth?
Yeah, it can be. I mean, it is, I think, one thing that I guess in general for people, if you're with regard to broth, if you're transitioning to a low carbohydrate in general, we know that our insulin levels will come down. And that's probably one of the benefits, arguably. And when those insulin levels come down, what it does is it tells our kidneys to stop holding on to so much sodium and so much water. And so we see a reduction. We end up sort of have this so-called diuresis where we lose all this excess water. Now, sometimes, you have to replace some of that. So the bone broth can be a good way to get your minerals, and those minerals are what keeps us hydrated. If you just drink pure distilled water, your body will immediately just get rid of it. It needs those minerals to keep that water in our body because we want to have a certain concentration, so-called iso or sort of osmolality in our blood and in our tissues. So yeah, they can be beneficial. There's nothing wrong with them. I mean, marrow can be a wonderful accompaniment to a meat. A lot of people make marrow butters and things like that, which are quite delicious. So that's something that is a very tasty, quote unquote, type of organ meat. Marrow is. It's quite delicious, actually.
Yeah. What is your take on fats, as in cooking in fats? Because again, India has this fear of cooking in ghee, cooking in coconut oil. And now that we're seeing a very slight rise with a very few people cooking in tallow, for myself included. So I started cooking meats in tallow. What is your take on this?
Yeah, I mean, traditionally, prior to about, I don't know, the early 1900s, the majority cooking fats in the world were animal fats. And I know India has a rich culture of cooking in ghee, which is a wonderful, wonderful fat to cook. And it's got a high smoke point. It tolerates high heat cooking very well. The tallow is also great. I mean, it's got a good flavor. I mean, animal fats generally taste better, I think. Duck fat, goose fat, tallow, lamb's tallow, lard in some cases are all high quality fats. They don't oxidize very well. They tolerate heat very well. So they're great. They're great. I mean, all these new oils that we've introduced, clearly they were not part of the human diet for most of our existence. So, because we can go back in time and argue about, did humans pick berries and eat tubers and how much meat were they consuming? But we know unequivocally we were not eating canola oil. We were not eating palm oil. Those things those products never existed until modern processing. And the same thing with the ultra processed foods. I mean, these are all foods that we are not anatomically designed to consume. Now we can consume them, and the processing makes it cheaper and it makes it more accessible and provides more calories, but they're presenting to us in a way that our body is not accustomed to. We're not physiologically adapted to that. And in many cases, I think in most cases, it's leading to these diseases of modern civilization. And the expectation that by 40 you're going to be sort of have arthritis and slowing down and not be able to participate in things is a false expectation. That is very common, but it is not normal. It's by no stretch of the imagination. You should be, in your 60s and 70s still able to run and jump and play. I mean, that is what I think the human experience is supposed to be. You can't imagine that spending half of your life suffering in misery makes any sense at all. It's not how we're designed to be as a species. There's no other species that spends half its life, limping around and miserable.
And they just blame it on age and genetics. So, I'm getting old, so that's fine. This is going to happen while I age, and I don't know how they have accepted this.
Yeah, I mean, and it's, you look around at all your friends and your sort of, your peers are all aging and slowing down. So you expect that to be normal, but it doesn't have to be. You should be able to do many of the things you could do as a young adult or even as a child well into your 5th, 6th, 7th decade. I mean, that is something that, I believe is attainable for many people.
Yeah, true. Sean, India also has many professional athletes. And what would you say in terms of the carnivore diet or a meat-based diet in terms of maintaining peak performance for them? Because again, this myth here is that carbohydrates are essential, glucose is required for a run or a marathon. And I see so many marathon runners now becoming diabetics.
Yeah, that is unfortunate. We are seeing a lot of, particularly endurance athletes, marathon runners that have high levels of vascular disease. And the question is it the chronic cardiovascular exercises they're doing, or is it maybe the diet that supports that? Because a lot of runners are consuming all these sugary gels and are eating very, very high carbohydrate diets to support that. And so maybe that's not the best strategy. There certainly are many now professional athletes, including endurance athletes, to include power athletes, to include strength athletes that are adopting carnivorous or nearly carnivorous diets and having wonderful success with that. I think when it comes to recovery, and I'll pick on India a little bit. You're the most populous country in the world. You just surpassed China recently. So 1.4 billion people. If you look at Olympic gold medals, you've got very, very small amount, and I think the diet is part of that. You're not consuming enough, and you're just not consuming enough animal products and not enough high quality protein to support high level athletics as a country in general. Now there are exceptions. Obviously, there are people that are going to be that are going to do well, and obviously things like cricket, which is that the national sport, that you've had quite good success in that. But I think that absolutely meat should make up a major percentage of an athlete's diet. High quality protein. Whether or not you choose to consume carbohydrates or not are kind of, one, dependent upon the sport you're doing, two, dependent upon your personal preference. If you are going to do a so-called carnivore diet as an athlete, you can expect it to take, maybe 6 months to make a full transition before you start to really feel it. But I've seen everyone from American professional football players to, combat athletes to ultra marathon runners to triathletes to we just had a rock climbing guy, break a world record as a carnivore. We've got guys on the U.S. wrestling team. I mean, many athletes now that are finding a carnivore. What's the Norwegian soccer player Haaland, basically a carnivore diet, one of the most prolific goal scorers, in recent times. And so, yes, it is becoming more and more popular among many athletes.
Fantastic to hear. And thank you for that note. I want to know your views on fiber. Now, this is another myth we are fighting here. Fiber. No fiber causes constipation. Meat causes constipation.
Yeah, meat, well, I can tell you that I have normal bowel movements. I go to the bathroom pretty much every day. Fiber, in my view, is, and I just saw a wonderful presentation by a gut microbiome researcher basically saying we think we may have overplayed our hand on fiber. We're finding out that, some of the benefits say, like, we will ferment fiber into these things called short chain fatty acids, which are supposedly going to protect the mucosal layer and things like the colon. They found out that amino acids can do that. We can consume them directly. Long chain fatty acids can do that. Ketones in the context of a low carb diet can all do that. So the fiber sort of has been a little bit overhyped in many ways. I think it is conditionally beneficial, and most of the benefits of fiber are in the context of this high sort of junk food type diet. So if you're eating more fiber, you're probably eating less sugar. Basically, I mean, that's kind of what you're seeing. Yes. But if you don't consume sugar in the first place, the fiber is not going to provide any additional benefit. And honestly, in some cases, fibers can make things worse. Now, if you look at constipation specifically, there was a great study that came out, about 8 years ago, looking at, there's a guy, Paul Mason, has done a nice presentation on this, and he shows the results of the study quite well. But, a zero fiber diet was actually curative of chronic constipation. And, some people look at this problem. If constipation is like a traffic jam, adding more cars to that traffic jam is not going to help. And so what you want to do is fix the neuromuscular problems that are going on, and fiber is not the solution to that. It's usually eliminating inflammatory things. But meat has been very beneficial for gut health, in my view, and in my experience, because I've seen people with chronic inflammatory bowel disease, or irritable bowel syndrome, rather, inflammatory bowel disease, reflux, all those things get better on a meat-based diet. And so the fiber in many cases has been counterproductive, and it's been overprescribed. I think it is, again, its benefit is largely to move otherwise junk out of the diet. And beyond that, I don't think it has that much benefit.
Yes, absolutely. Thank you so much. Thank you, Sean. Such amazing insights from you, and for me to learn as well. Well, as much as I would love to continue our conversation, I guess we'll have to save a little for the next time. Thank you so much, Sean, for being on our show, and thank you for your presence. It is an honor to share screen with you, and I'm hoping to have many more conversations up again with you. Thank you.
Well, I'd love to do that. Thanks, Mahek. Thanks, and Shashi, thanks for having me. You guys have a wonderful rest of your conference, and have a good evening. Okay.
Thank you, sir. God bless you.
All right. Bye-bye.
Thank you. Bye-bye. Thank you, folks. And let me hand over the session now to our next guest, Dr. Ken Berry, and the host, Ira Sahai, wishing them all the best.
Lily.
Yeah. Good evening and namaste from the amazing city of Goa, India. And welcome to India's first low-carb conference organized by Shashikant Iyengar, India's most certified and SMHP accredited metabolic health coach, in a joint initiative with the founder of India's only low-carb and award-winning platform, DLife.in. This evening, I have a very, very, very special guest with me, Dr. Ken Berry. Hello, Dr. Berry. I think you're on mute. Yeah, needs to be unmuted.
All right. Sorry about that. I'm with you now. Thank you for having me.
Yeah. So I will just introduce you for the benefit of those who have not known you, but I think that's very unlikely. So Dr. Ken Berry is an MD, a family physician in Tennessee, and is affiliated with the Henry County Medical Center. He received his medical degree from the University of Tennessee College of Medicine. He's the author of the bestseller, Lies My Doctor Told Me, which exposes myths and misleading health advices from well-meaning doctors, such as avoiding fats and red meat. He also has a very popular YouTube channel by the name of Ken D. Berry, MD. Dr. Berry's own health dramatically improved when he embraced a ketogenic diet, and he's one of the most powerful voices now on low carb and especially on carnivore. Welcome, Dr. Berry.
Thank you so much for having me. It's a pleasure to be with you guys this morning here, this afternoon there, and I'm happy to answer any questions you guys might have for me.
Yeah, my pleasure to ask you a few questions. Although 1 hour seems too little, and I'm a big fan and a big follower of yours, I would love to have more sessions, but let me just kind of rush through, the basics at least. Dr. Berry, please tell me, being a mainstream doctor, how did you come into low carb?
Well, the way I discovered low carb is that I became very, very obese and pre-diabetic. Okay. And when I discovered that process going on in my own body, I started following the American Diabetes Association recommendations very, very carefully, because before that I was just eating whatever junk I could grab, because I was very busy working in the emergency department of several local hospitals and also my full-time clinic. And so I didn't have time to really think about it. But when I developed prediabetes and became severely obese, I thought, this is disingenuous of me as a doctor to be obviously obese and obviously metabolically unhealthy, and then go into patients' rooms and counsel them on how to be healthy. That didn't feel very genuine to me. And so I thought, I need to fix my own health if I'm going to counsel other people about their health. And I tried the American Diabetes Association diet, and I actually gained weight and became more pre-diabetic. And it was at that point I thought, well, maybe I've missed something here. And so I really started digging into nutrition research and reading alternative hypotheses about what causes diabetes and obesity. And in the process of that, I discovered primal diets, paleo diets, low-carb diets, and then ultimately a ketogenic diet. And then now ultimately for the last over 5 years, a carnivore diet. And that journey is what completely reversed my prediabetes and completely reversed my severe obesity. And they both went away. It's almost like my body knew exactly what to do when I stopped feeding it the high carbohydrate, slow poison food that's recommended to most of us, if not all of us, and started eating the ancestrally appropriate food that was full of animal fat and animal protein. That's where my body seemed to thrive the best. And when I started recommending that to my most severely obese patients, it worked for them as well. And so that's when I started delving into anthropology and paleoanthropology and archaeology, because I thought, it's probably very, very important what our ancient ancestors ate, because they are us. We came from them. And so we should probably try to mimic their diets. And when I delved into that research that most doctors never read, I found that it's very well known and very well understood that before about 10 to 12,000 years ago, everyone ate fatty red meat. they ate meat, they ate seafood daily if they could get it. That was the go-to food. That was the optimal food for human health and human reproduction and human longevity. They knew to eat the meat. They knew to eat the organs. And it's only with the agricultural, I call it the de-evolution, but some people call it the agricultural revolution, we started to subsist on different grains and different beans and legumes and peas. And we can see very clearly in the anthropomorphic data that we got shorter, that we got less healthy, our bones became weaker, our dental health suffered greatly, our brain size actually shrunk when we all adopted a beans and rice diet, a grains and legume diet that was very unhealthy for us. And so that's kind of my backstory of why I'm here and where I came from.
Yeah. Oh, that's amazing coming from a mainstream doctor. I mean, that's mind-boggling. Thank you for that. And Dr. Berry, you've been the biggest proponent, or let me say you have used the term proper human diet. Tell us something about it. Are you implying that what we are currently eating as a species is not the right diet or is not the proper diet? What does that imply?
Yeah, absolutely implying that. So I wouldn't be boisterous enough to use a term like the proper human diet if I didn't think that there was substantial research in multiple fields of study to back that up. And indeed, when I was first recommending a keto and a carnivore diet to my patients and to people online, I had never used that term. But the more I delved into the anthropology and the archaeology and the paleoanthropology, it became self-evident that there is a proper human diet, and it is a spectrum of diets. Okay, it's not just carnivore, it's not just keto. I think that very many people on the planet, depending on their DNA, depending possibly on their gut microbiome, depending on their age, their other health issues, they need to eat somewhere on a proper human diet spectrum. And so a proper human diet avoids all sugars, both definitely added sugar, but many of the naturally occurring sugars, if you eat them daily, it's going to cause weight gain. It's going to cause your blood sugar to be too high. A proper human diet contains no grains whatsoever. And I know for many people, they're like, wait, no, my doctor told me that rice or wheat or millet or amaranth or sorghum or rye or sabudana, is that right? Or nachini or barley. These are healthy. They're full of vitamins and minerals. When in fact, nothing could be further from the truth. They are devoid of the main vitamins and minerals that you need, and also of the amino acids you need to build proteins. And in many cases, they contain a large quantity of anti-nutrients that keep you from absorbing any vitamins or minerals that they may contain, and also can lead to quite a bit of inflammation, either in the gut or in the joints or in the skin, or it can manifest as mental health issues, anxiety, depression, and other mental health issues. Grains are a fallback food. Grains are a starvation food. And so I tell people all the time, if you're literally on the verge of starving, then you should eat all the grains and all the beans, because they will keep you from starving. Absolutely. But if what you're trying to do is optimize your health, grains and beans and legumes, they play no part in that. A proper human diet is nutrient dense. That's the reason we eat food, is not for calories. We eat foods so that we can get all the amino acids to build protein and all the fatty acids that our brain and body needs to function optimally. We eat to get minerals and we eat to get vitamins. That's why we eat food. Well, many people eat food for pleasure, and that can lead to problems. Many people eat food because they think, oh, well, my doctor or dietitian said I should eat more amaranth or millet or quinoa. And that's not based on any meaningful research in any field of study. A proper human diet by design is low in carbohydrates. So there may be some people who believe in a vegetarian diet, and I think for many people that's fine, as long as you're including eggs and seafood and at least butter from dairy in your diet. I think that if you focus on eating the lower carbohydrate vegetables and you avoid all the grains and all the sugar, a vegetarian diet with no more than 100 total grams of carbohydrates a day and plenty of fish and plenty of butter or full fat cream and plenty of eggs with the yolk, always with the yolk, then I think for many people that's a beautiful diet. People think, no, wait, eating rice, wheat, millet, amaranth, sorghum, that's part of my heritage. That's part of my tradition, my family tradition. And here's what I would say to people. If you go back 100 years, yes, that may be true. But if you go back anywhere from 300 to 500 generations, then regardless of what your religion is currently, regardless of what your family tradition is now, if you go back 300 to 500 generations back in your family tree, all of your grandmothers and grandfathers were eating meat as often as they could, as often as they could find it, as often as they could kill it. Meat is the ultimate ancestral food. Homo sapiens sapien, that's what human beings are, have been eating meat for just as long as they have been breathing air and drinking clean water. That is how ancestral red meat is in the human diet, regardless of what your ancestry is, regardless of what your religion is, regardless of what country you live in. If you go back far enough in your family tree, all of your people ate meat as often as they could eat it.
Yeah, thank you. I just heard you mention sabudana. In the Indian context, Dr. Berry, carbs form almost 50 to 60% of the plate. I mean, that is considered food. So either you're eating rice or you're eating roti, or you're eating things like sabudana even during fasting. So that's quite relieving to hear. The fact that you gave about how carbs should be used and what you can do to get closer to the proper human diet in the Indian context, where most people are vegetarians. Do you think in today's metabolic health context, the proper human diet becomes all the more relevant because we are dealing with a series of metabolic epidemic, and that's how close we could come to finding remission if we understand the proper human diet better?
Yes, absolutely. I think the degree to which we have ignored a proper human diet is the degree to which we develop metabolic disease as an individual, as a group, as a society, as a country, as a species globally. If you can read the works of Weston A. Price, a dentist who traveled the world looking at kind of secluded ancient populations of people. Anytime they ate grains, they sprouted the grains, they roasted the grains, they fermented the grains. Anytime they ate soy, it was always fermented, right? They knew that they needed the nutrition from grains because they couldn't get enough meat, but they never just ate the soy. They never just ate the grains. It was always fermented or sprouted or in some way treated to decrease the anti-nutrient content and the inflammatory nature of grains. And you mentioned the Indian subcontinent, and I've become a very big armchair student of archaeology and history. And when you look into the history of India and the British colonialism and basically the subcontinent of India was a slave to the British Empire, if you just want to use plain words about it. And so in any slave population, they're encouraged to eat the grains. They're encouraged to eat the beans because the slave owners, the masters, they want all the meat for themselves. And so there are multiple examples in Indian history, which I'm not an expert on, but I've read enough about it so I can see the broad outline. The Indian population was subjugated and was severely mistreated by the British Empire. And the British Empire basically raped the Indian subcontinent. And they left the Indian population with the grains and beans because that's what any dictator, that's what any slave owner feeds to the slaves is grains and beans, because it's the cheapest food you can feed them that they won't starve to death. And so so for many people, I've spoken with many people who live in India, and when they start to read the history and actually realize, oh no, wait, 500 years ago, we ate meat all the time. And then if you go back 1,000 years or 10,000 years, everybody ate meat every single day they could get it. It was not part of a religion. It was not part of a caste. It was not part of any of that. Everyone ate meat as much as they could get their hands on. And I think so many people in the Indian society, and I speak as an outsider here, just someone looking in, so many people are deluded by the misteaching of the British Empire. They're basically, they've been tricked by the colonial power of the British Empire to think that, oh no, beans and rice, that's my ancestry, that's my heritage. No, it's not. That's the slave diet you were fed, because that's all the British Empire thought you were worth.
Correct. I think I resonate with you, because this has been part of the history, and I recollect reading it exactly the same thing. Because grains are a very cheap source of energy, or carbs are a very cheap source of energy. So meat was largely reserved for the so-called elite people. And also that agriculture is a recent phenomenon. Like you said, we've been eating meat for the longest time, maybe since as long as we existed, because there was no agriculture there. So I quite, resonate with that. Dr. Berry would like to ask you as a next question, how did you decide to become a carnivore? I mean, there are various ways to do a low carb. There could be keto, there could be, in the Indian context, ovo vegetarian,
Yep.
How did you decide to go carnivore? And you have been one of the biggest proponents of carnivore. In fact, I started my journey on carnivore after I started following you. And I myself was a case of membranous nephropathy of the 3rd stage. And I reversed my condition by going fully carnivore. So I'm quite thankful that, I found you. I would like to know from you why you went carnivore.
So as I was adopting the low carb lifestyle, I was losing weight. My hemoglobin A1C was coming down when I adopted the ketogenic style. So if you think of a Venn diagram, then low carb is this big circle, right? And it still needs to not include grains and not include sugar and not include vegetable seed oils. But then if you decrease the carbohydrates even more, that becomes a ketogenic diet. And then if you decrease the carbohydrates even more, that becomes a carnivore diet or a ketovore diet, right? And then if you decrease the carbohydrates as much as you possibly can, that's a carnivore diet, just meat and eggs. And so a carnivore diet is actually a subset of a ketogenic diet. It's a subset of the low carb diet. It's just the lowest carb version you can possibly eat. And for many people, it's also the least inflammatory diet that you can eat as well. And so many people with chronic kidney disease, with glomerular nephritis, with polycystic kidney disease, when they eliminate all the plants from their diet, that's the thing that causes their kidney health to improve. That's the thing that makes the kidney condition go completely away, not counting any permanent damage that was already done by the improper diet. Their kidneys now have a chance to heal, and their kidney function invariably increases. It improves on a carnivore diet. Now, I don't think everybody needs to be a carnivore, but I think everyone would benefit from doing at least 90 days of carnivore. It's the ultimate elimination diet, because you're eliminating everything that's potentially inflammatory. You're eliminating everything that would potentially raise your insulin level too much, that would raise your blood sugar level too much. And so I don't think everyone needs to be a carnivore. I think some people can be an ovo-lacto-pescatarian and do great if they're eating low enough carbohydrate vegetables and avoiding grains. But some people like me, I tend to fatten very easily, unlike most people in India. Most people in India can just live on sugar and grains, and they'll have tofu, which is thin on the outside, fat on the inside. And so just looking at them from across the street, you think, well, that gentleman or that lady looks very healthy. They're very slender. But when you check their fasting insulin level or their A1C or their inflammatory markers, you find out that they have a lot of visceral adiposity. They have that little belly pooch, right? Even though they're very slender, their A1C is a little high and their fasting insulin is very high. And so even though they appear outwardly to be slim and healthy, they're actually metabolically very ill. And only with checking certain labs that many doctors don't check, like the fasting insulin or a C-peptide, you can't find this metabolic disease. If you just check a fasting blood sugar, that may be normal, but you've got to go deeper and check more labs than many doctors are willing to check. And so that's how you uncover that. But a proper human diet absolutely includes the carnivore subset. Everybody would benefit from 90 days, but not everybody needs to be carnivore for the rest of their life.
Thank you. Dr. Perry, can you, this seems to be some confusion for a lot of people as far as keto and carnivore are concerned. Would you just clarify if one can be on keto while being a carnivore? How is that possible? Is that possible at all or no? And what kind of people do you usually see in your practice who benefit mostly from these two protocols?
So you can absolutely be in ketosis for the majority of the day if you're eating a carnivore diet. The way you get into ketosis is to lower your carbohydrate intake. If you lower it down to 20 or 30 total grams of carbs a day, that's a ketogenic diet, and you're going to be in ketosis for most of the day. If you lower it even more, that's carnivore, and you're going to be in ketosis for much of the day. Now, a lot of people get confused about this. They think carnivore and keto are two different things, where actually carnivore is a subset of the ketogenic diet. And I've had discussions with multiple PhD human metabolism researchers like Professor Ben Bickman, and they say by definition, you're on a carnivore diet, it's the lowest carb option there is. You're going to be in ketosis for most of the day. You may not be in what some people would consider deep ketosis, but you're still going to be in ketosis for much of the day. And you're going to be able to derive all the health benefits from that. The people who are going to benefit most from carnivore are people who want to lose excess fat quickly, who want to lose visceral fat quickly. It's a godsend for people with autoimmune conditions or with gut conditions like irritable bowel, Crohn's disease, ulcerative colitis. It absolutely makes those conditions either go completely away or go into complete remission where they have no symptoms whatsoever. People with severe reactive arthritis and autoimmune arthritis, rheumatoid arthritis, psoriatic arthritis. These people notice on a carnivore diet, it gets drastically better. And so many people who are they start out wanting to do carnivore for 90 days just for the elimination diet aspect. They feel so good at the end of the 90 days that they're like, I'm just going to keep doing this. And that's how I came to carnivore. I was very strict keto. And I kept hearing about Sean Baker, your previous guest. And so on my Facebook page, I said, hey guys, let's do 90 days of carnivore. Let's just see what happens. And all my adult life, I'd suffered from severe gastritis and reflux and heartburn. Took 2 Nexium every day, like 2 Prevacid every day, 2 Prilosec every day to control the symptoms. On keto, it was 80% better. I could just take a little over-the-counter something every now and then for it. But after that month of carnivore, it dawned on me I have had 0 heartburn for the last 30 days. And so that was kind of a wake-up call for me that maybe carnivore is the way for me. And so I just kept doing carnivore. I kept tacking on another month. And now it's 5.5 years. And in 5.5 years, I've went from having severe daily constant heartburn that was so severe, it would interfere with my ability to speak. I would have a hoarse voice, have to clear my throat. Now on carnivore, I have not had heartburn reflux in 5.5 years. I don't take anything for it ever. I never wake up with heartburn in the middle of the night. It doesn't matter what spices I eat anymore. I can eat all the spices and all the herbs. They don't cause the heartburn as long as I stay on a carnivore diet. So there's so many people who are just at their wits' end. They're suffering very, very severely, and they think there's no hope, and they've tried every little foolish fad diet there is, and it's only when they try carnivore that their eyes are opened, that their body wakes up and begins to heal. And that's why, I tell anybody, if you've tried all the different diets that your doctor recommended, that your dietitian recommended, that your religious leader recommended, and you're still suffering from these chronic inflammatory health conditions, try 90 days of carnivore, and you may be very pleasantly surprised at the results.
Yeah, I think I quite resonate with this answer as well, because my autoimmune was cured. Although I started off as finding remission to my condition. But I think by the end of the journey, I was so hooked on to the magic that carnivore created in my body. It totally reversed my autoimmune condition, and wherein the doctor had told me that he may, take me for a kidney transplant. So I was at that stage, and it reversed on a full carnivore diet. So I completely, agree to that. Dr. Berry, tell me, in India, as we understand, you may be knowing about it, the scene of vegetarianism is very different from the West, where vegetarianism in the West is usually veganism. But in the Indian context, there are vegetarians who are ovo-vegetarians, ovo-lacto-vegetarians, or pure vegetarians as well. What do you think is wrong with a fully plant-based diet, if at all? Why is that a problem?
Well, if your plant-based diet, your vegetarian diet, if it includes grains, then you're going to have all the problems we talked about previously. Grains are not part of an optimal human diet. They're not part of a proper human diet. Neither are beans or legumes or peas. These are not soy. That's not part of a proper human diet. That's the starvation diet that you were taught was your heritage. I think that there are many people who will do just fine on an ovo-lacto vegetarian diet. And I really, really wish that they would include some fish in that, some small cold water fish that live on algae or plankton, because those fish are so nutrient dense and they're so ancestrally appropriate that if they were an ovo-lacto pescatarian, I think that the predominance of their diet could be vegetables, not grains, not sugar, but real vegetables. And then eggs with the yolk, always with the yolk, some butter or ghee, and then fish once or twice a week. I think for many people, that's going to resolve so many health problems for them. And I think it's perfectly doable for probably most people on the Indian subcontinent, but I don't think it's appropriate for everybody. I think everybody can start there, right? And then if you're still having health problems, then you probably need to tighten that up more from low carb to keto, and still include some very low carb keto friendly vegetables, but increase the amount of the fish and the eggs with the yolk and the butter or ghee, and see if that doesn't resolve the condition. And then I think some people, even from the Indian population, you're going to have to be carnivore if you want optimal health. And so there's this concept in medicine and nutrition, human health, called the normal distribution curve. And this is every scientist knows what that is. So there may be some people over here who could do low carb, ovo-lacto pescatarian and have perfect health. Most people are going to have to get down to 20 or 30 total grams of carbohydrates a day for optimal health. Then there's a few people over on this end of the curve that are going to have to be ketovore, which is 10 total grams of carbs a day or less, or carnivore in order to enjoy optimal health. And so many people out there don't even know when I say optimal health, they don't even know what that means, because they've been so sick, so miserable, so fatigued. Their brain's been so cloudy and foggy, they can't think straight, that they get used to feeling that way. And they're like, I guess I feel okay. I don't know. I guess this is normal. The only way you're ever going to know what's normal for you, what's optimal for you, is if you do the 90-day carnivore challenge and do just carnivore for 90 days And then at the end of that 90 days, if you're like, I don't feel that much better, I felt just as good on ketovore or keto or low carb with no grains, no sugars, then okay, good. Go back. Then you've got this spectrum, don't you, Ira? You've got a spectrum to choose from, and you can say, okay, I'm going to try 90 days of carnivore. And if Dr. Berry's right, then great. If he's not, I'll go back to keto, or I'll go back to low carb, ovo-lacto pescatarian, and I'll stay there because that's where I felt best. And either way, you win and I win because you're eating a proper human diet. You're not being tricked or misled by a previous colonial power or by a multi-billion-dollar multinational food corporation.
Correct.
You're not being misled and tricked and fooled. You're actually experimenting with your own body, your own physiology, and saying, no, I tried that diet. I was sick and miserable the entire time. But when I tried this spectrum of a proper human diet, I felt amazing. That's your body telling you that's where you need to be, and that's where your diet needs to be.
Yeah. So what are some of the commonest, because in India, as you said, you're talking about adding fish, but here that's an issue because vegetarianism means no meat, not even eggs. So people do not admit there can be or there are deficiencies on a fully plant-based diet. Could you expand on it a little more and tell us about the commonest deficiencies that are found in the Indian context if somebody is eating a fully plant-based and a grain-based diet, and how likely is it to occur, and why people on a carnivore diet are better off in terms of metabolic health, in terms of healing faster, energy-wise, and everything else, the difference between the two spectrums?
Yeah, there's a long list of possible deficiencies you can develop on a strict vegetarian diet.
Yeah.
The most common by far are vitamin B12 deficiency and iron deficiency. And I think iron deficiency is quite a problem in the Indian population. And then not to mention iodine, vitamin D, vitamin K2, vitamin A, vitamin E. All of these things are found predominantly in animal-based foods. And so people who are eating a predominantly plant-based diet are either not going to be getting access to these nutrients at all, or, as I said earlier, especially in grains, there are anti-nutrients because the plants do not want you to eat their seeds because the seed is their reproductive organ. That's what will keep that species from going extinct. So they put all kinds of phytochemicals and anti-nutrients in there. And so when you look up on a food database, how much of this or that or the other, how much of this vitamin, this mineral are in rice or wheat or millet or amaranth or sorghum or rye, it might say a certain amount, but very often your body cannot access that vitamin or mineral because of the anti-nutrients, the lectins, the phytates, the oxalates, the saponifins, the phytoestrogens contained in that. And so even though it's in there, maybe if a chicken ate that grain, its digestive system could get that vitamin or mineral out. The human digestive system doesn't have access to that because of the anti-nutrients and the phytochemicals. And so I understand that, people make decisions based on religion or based on what they think is their family heritage or what they think is their culture. But in so many cases, in America and in India as well, what we think is our heritage or our culture is basically just what our grandmother was taught by television commercials or by magazine articles. And she thought, oh, okay. And then she started cooking that way. She taught your mother how to cook that way. And then you grew up eating that way. Now you think that's your heritage or your culture. You think that's the right way. But in many, many cases, it's a complete delusion. It's a trick that large corporations, they're trying to make billions of dollars, and they don't really care about the health of your grandmother or your mother or you. They just want your money, right? And so, but many people, many grandmothers and mothers, they believe what they read in the newspaper. They believe what they watch on television. They think these people would never trick me. These people are my friends. I can look up to them and respect them and trust them, when in fact that is not true at all. Your health will suffer if you fall for these pseudo cultures, these pseudo traditions that are really, if you look back in your family closely, you'll find they're only 5 or 6 generations long. Before that, nobody in your family ate that ever. That was a trick that your great great grandmother fell for, or your great great grandmother was starving to death because she was living in a political climate where she had no power. She was effectively a slave or a serf or a peasant. She had no power. She had no ability to feed her family what she would have fed them otherwise. So that became the family tradition or the heritage, and it's not even real. It's a false paradigm that was either forced on her or was marketed to her from the mass media.
Yeah. Very interesting answer there. I mean, Indians will find it very relevant. The common messaging, Dr. Berry, that pre-diabetics is not dangerous. I'm mentioning diabetes here particularly because India has 101 million diabetics and another, I think, 136 million pre-diabetics. And as a metabolically unhealthy country, largely, people do think that pre-diabetics is not that dangerous. How true is it? And then we come, to the next part of the question. Please clarify.
Yeah, it's not true at all. It's not even a little bit true. It's false. But think about this, Ira. If I were a doctor who believed in a plant-based diet, who believed in a vegetarian diet or a vegan diet, if I believed that, then I would have to tell my patients, oh, pre-diabetes is not a big deal. Having a high fasting insulin level called hyperinsulinemia, those are not dangerous. I would have to say that because the majority of my patients would have pre-diabetes, wouldn't they? Just like we see in the Indian population. If you eat a diet full of grains and full of highly processed ground up grains and sugar and vegetable seed oils, you're going to have some degree of pre-diabetes. And so if I were a doctor who believed in my heart that a vegetarian diet was the best diet, I would have to discount pre-diabetes. I would have to say, oh, that's no big deal. Don't worry about that. That's just a bunch of foolishness. But when we actually look at the research, it's been proven very, very clearly that long before you develop type 2 diabetes, which is an A1C of 6.5 or higher, when you've got that A1C of 5.9 or 6.1, and your doctor's saying, oh, pre-diabetes is not dangerous, when you actually look at the research about pre-diabetes, it's been proven in multiple studies to be causing kidney damage, heart damage, brain damage, liver damage, fatty liver, fatty pancreas. All of these things are happening. But the human body is so strong and resilient that you may not have many symptoms. Even though you're pre-diabetic and you have hyperinsulinemia, you may feel relatively normal. And you may have that little belly pooch, but you may be very thin otherwise. And so that's the problem, is it's been shown clearly in the research that permanent damage is being done when you're pre-diabetic. When your A1C gets above 5.6, you are doing permanent damage to every little artery in your body. And the tiny arteries and the arterioles and the capillary beds, that's what feeds every cell, every tissue, every organ in your body. That's what feeds it. And if you're damaging those tiny blood vessels, that's damage, and that's going to build up. And at some point, you're going to have a severe complication. Obviously, you're going to eventually develop type 2 diabetes. But along the way, long before, maybe 10 years before you develop type 2 diabetes, you're doing damage to your body by eating a diet that's full of grains and full of fruits and fruit juices. That's doing permanent damage to your body. And that's very clear in the medical literature that pre-diabetes is doing damage. It is not benign. It is not innocuous. It is not safe to be a pre-diabetic.
I think somewhere people have also settled with the fact that diabetes is genetic, and they don't give much consideration to what we are eating and also the immediate factors that may trigger the condition. So largely they get away with the doctor telling them, or the people around them telling them that diabetes is genetic. So they're kind of okay with that, and that's how it doesn't become such an alarming situation, pre-diabetes. Could you just shed a bit of light on that? Is it genetic or how is it?
Yeah. So there is a small genetic predisposition to develop prediabetes or type 2 diabetes. That's absolutely true. That probably accounts for somewhere between 1 and 5% of your risk of developing prediabetes or type 2 diabetes. But the 80% cause, what causes 85% of prediabetes and type 2 diabetes? It's the food. It's the grains, it's the beans, it's the fruits, it's the fruit juices, it's the desserts, it's the snacks. That's what's causing it. And so if you have a 1% risk factor for developing prediabetes or type 2 diabetes genetically, and you eat a very low carbohydrate diet or a keto diet or a ketovore or a carnivore diet, you will never develop type 2 diabetes regardless of what your genetics are. And if you start eating a keto, ketovore, or carnivore diet while you are a type 2 diabetic, you will reverse your type 2 diabetes and you'll have a normal A1C. So yes, there is a very small genetic component to prediabetes and type 2 diabetes. Some people develop it easier than others. I'm one of those people. I develop prediabetes very easily if I eat too many carbohydrates. But as long as I keep my carbohydrate intake low enough for my personal physiology, my genetics, potentially my gut microbiome, my A1C is beautiful. My fasting insulin is beautiful. I don't have prediabetes anymore. I reversed it, and I'm able to keep it reversed for the rest of my life by eating low carbohydrate enough for me. And that's what the people have to understand is prediabetes is dangerous. Everybody knows type 2 diabetes is dangerous. You might have a little genetic predisposition, but that is not your genetic destiny. You're not destined for that. You can absolutely control that small genetic risk by eating a proper human diet, somewhere on the proper human diet spectrum, and you will never develop prediabetes, and you will never develop type 2 diabetes. And if you already have it, you will reverse it back to a normal A1C and back to a normal fasting insulin.
I have so many questions, Dr. Berry. I think I'll keep you for the next session as well, if you agree. But quickly, I mean, I have so much to ask you. Maybe we can just kind of hurry up a bit. Your views on veganism. Your views on veganism.
Veganism? Yes. I think that when somebody's eating a vegan diet, I call that the first step to a carnivore diet. The going vegan is the first step towards adopting a proper human diet because it means you're thinking about food. You're making choices, because the average person in the United States definitely, and probably many people in India, don't even think about their diet. They just grab whatever's the quickest, whatever's the cheapest. They're busy. They're trying to be successful. They're trying to grow a business, or they're trying to support their family. They don't think about food. They just eat whatever the corporation puts in front of them. That's the cheapest, right? But when you make the leap and say, no, I'm going to be a vegan, I'm going to be a vegetarian, at least you're thinking about food. And I think that's the first step, is actually caring about food and thinking about the food you put in your body. And so I love it when somebody goes vegan. I love it when they adopt a vegetarian diet, because I know now they're thinking about food. And if you're thinking about food, then you're going to start looking for patterns. Oh man, when I eat this, I have severe bloating. When I eat this, I have gut problems. When I eat this, my arthritis flares up. When I eat this, I get acne, or I get my eczema flares up, or my psoriasis flares up. And so then they're like, well, maybe I shouldn't eat that. And that's good, because you're thinking about food. And that's what I want everyone to do, is I want you to think about every bite of food before you put it in your mouth. And so invariably, when somebody adopts a vegan diet, not for religious reasons, but because they currently believe that's the healthiest way to eat, at some point, either a few months in or a few years in, they're going to develop vitamin and mineral deficiencies. They're going to realize, I'm not getting enough real animal protein in my diet that's healthy for me. I'm not getting enough healthy fatty acids in my diet. I'm not getting enough DHA, EPA, the omega-3 fatty acids. I'm not getting enough of that. I need to add more. And so many vegans, what do they go to? They start taking supplements. But my question to you would be, if there is a food that contains that vitamin or mineral or fatty acid or amino acid, and it's very uninflammatory, and it's a food that your ancestors 300 to 500 generations ago, they ate it every chance they got, then why wouldn't you just eat the food instead of taking a handful of supplements? And that's the final inner conversation that happens for somebody who says, yeah, that was foolishness. I'm going to start eating either a ketogenic diet or a ketovore diet or a carnivore diet, because there's really no reason not to once I start really thinking about this and once I start listening to my body's feedback.
Okay, Dr. Berry, what are your views on this is for people, India, we hear this a lot. Red meat is bad for you. Eggs are bad for you, especially with yolk. Saturated fats are bad for you. So anything that happens to you, like in my case, membranous nephropathy, the first thing that I was told was to go low on protein. In fact, there was no dietary protocol given, and that was amazing because I was draining protein from my body and there was no dietary protocol on protein given. So to all those people who say saturated fats are bad, eggs are bad, yolks are bad, red meat is bad, please give out a message and so that they can understand this better.
Yeah, there's so many people out there, so many doctors and dietitians saying those sorts of things. But the problem is there's no research that backs that up. The only research that they can point to is epidemiological research that uses food frequency questionnaires as the data point that's the data they collect. And that kind of research is known in the scientific community that it cannot prove causation. It can only show a possible association. And in many cases, like the World Health Organization says that eating red meat causes cancer. All of the research they use to support that opinion is observational epidemiological research. There's not one randomized controlled trial. There's not one robust research study that they can point to that says, see, when you add more red meat to someone's diet, their risk of this, that, or the other goes up. The same goes with type 2 diabetes. There are so many doctors that say, oh, saturated fat and red meat will increase your risk of developing diabetes. Well, there's a new study out that shows that that's the randomized controlled trial meta-analysis shows that there's no association. And this is a randomized controlled trial. It says there's no association between eating red meat or fatty red meat or saturated fat and diabetes, none at all. But in the news media right now, I just made a YouTube video about this on my channel. There's this study that every newspaper is talking about, oh, red meat causes diabetes. But when I looked at the research, and I talk about this on my YouTube video, it's an observational study. It's a prospective cohort. And go ahead.
Yeah, sorry to interrupt you. I think you recently tweeted about the Harvard study, I think just last week or this week.
Yep.
And tell us how. I mean, coming from Harvard, this is amazing.
Right. And so many people look up to Harvard. They look up to the American Diabetes Association. And I think there was a time in the past when that was a rational thing to do. They were the experts. They were the smartest people in the room. You should look up to them. But when you actually look at the funding of the Harvard School of Public Health, when you look at the funding for the American Diabetes Association or the American Heart Association, these people have been co-opted. They get millions of dollars every year from the big food corporations. They get millions of dollars in donations from the big pharmaceutical corporations, right? And they call it donations, but if somebody were giving you millions of dollars a year and they said, hey, we need you to, have a study that says this, that, or the other, you might be liable to put out a study like that. And like the Harvard study, for example, that I tweeted about, that you mentioned, that I also have a YouTube video about. When you look at the hazard ratio that they found, it's foolishness. It's less than 2, which in any scientist knows that's background noise. That's scatter. That's not even, that doesn't even show a possible association. That's just random noise in the study. And good scientists don't even look at a hazard ratio of 1.4. They would ignore that and say, well, that study didn't find anything at all. I'm not even going to publish it. But the Harvard School of Public Health not only published it, but they've been proclaiming from the rooftops that red meat causes diabetes. Here's a new study. But when you dig into that study, it's complete and utter rubbish. And so Walter Willett, who's one of the professors at the Harvard School of Public Health, he's a vegan, and he believes in a vegan diet, and he promotes a vegan diet. And I'll bet you money he has investments in plant-based companies. And I know that him and his department get millions of dollars of research grants every year from the big corporations. And therefore, he believes that a vegan diet is the most healthy diet. But I don't think that the average person like me and you and all the viewers, I don't think we can trust the Harvard School of Public Health anymore. I don't think we can trust the American Diabetes Association or the American Heart Association any longer. I think that they've effectively been bought off. They've been paid off. They've been bribed to say certain things, and they've been bribed to not say other things. And I think that's a big problem. And it's not the average person's fault. It's not your fault that the Harvard School of Public Health is saying these things, but it is your problem. And if you're eating according to the American Diabetes Association, American Heart Association, or the Harvard School of Public Health, and you've got prediabetes, and you've got TOFI, thin on the outside, fat on the inside, you've got visceral fats, you've got chronic inflammation, you're the one suffering. They're not suffering. They're making millions of dollars, and you're the one suffering. So it's you who's going to have to make the decision. Should I continue to follow these people who I thought were honest and earnest and very intelligent, or should I try 90 days of keto or 90 days of carnivore just to see if Dr. Berry's right? It's just 90 days. What's the worst that could happen? So they would say, oh, it's going to damage your heart or cause cancer or this, that, or the other. But there are hundreds of thousands of people right now all around the world eating a carnivore diet every day. And if red meat was truly as toxic as they say it is, as dangerous as they say it is, then thousands of people every day in the carnivore community would be developing type 2 diabetes, wouldn't they? They'd be developing colon cancer, bowel cancer. They'd be developing heart disease. Every day there would just be thousands of carnivores falling off the map because they died of a heart attack or they had kidney failure from the type 2 diabetes. But what we see invariably in the carnivore community is people's A1Cs going back to normal. Their type 2 diabetes going completely away. We see in the carnivore community every day that their coronary artery calcium score or their CT angiogram of their heart arteries improving. If you recheck it every year, it gets better and better and better. We see kidney health. We see creatinine levels and estimated glomerular filtration rates, EGFRs, getting better on a carnivore diet, not worse. So there's a huge disconnect here. And I think it's going to be ultimately up to the people to decide, what diet am I going to try to improve my health? Because right now we see with the epidemics of prediabetes and type 2 diabetes, and in the United States of obesity, of high blood pressure, we see all these things of chronic inflammation in the joints, in the gut, in the skin, the chronic mental health epidemics. What we're being recommended right now, what's being advertised to us, is not working. In fact, it's dangerous. It's dangerous for you and for your family. And when you turn away from the mainstream narrative, when you turn away from the corporate paradigm of eat lots of grains and beans and drink lots of fruit juice and eat lots of desserts and snacks, when you stop all that and just eat a proper human diet, your health starts to improve immediately. Then you'll be convinced. And then you'll say, oh, okay, I get it now. It's not all about health. It's all about the money.
Dr. Berry, we have just 5 minutes left, and I have so much to ask you. Let me just come to a very critical question. In India, people usually consume very little protein, and as they age, the popular belief is that you should bring down the protein consumption. It is very low. And this, when you age, you further stop taking protein. How critical is protein as you age?
Protein is one of the most vital nutrients you can consume. And actually, as you get older, you should eat more protein, not less. and you should be eating the most ancestrally appropriate form of protein, right? And so we've been Homo sapiens sapien for thousands and thousands of generations. We've been eating meat, we've been eating seafood, we've been eating eggs for all of those generations. And so as you get older, if you want to remain vigorous, if you want to remain active, if you want to keep your bones strong and you want to keep your muscles strong, then you need to be eating a proper human diet with plenty of animal protein in it. Now, if you're ready to be an invalid, if you're ready to go to the nursing home, if you're ready to be the grandmother or the grandfather that none of the grandkids want to go visit because all you do is sit in your chair and complain, then eat a low protein diet. That'll get you there. But if you'd like to be that grandmother or that grandfather that the grandkids can't wait to go see because you're out in the backyard kicking the football around with them and you're out wrestling with them and playing with them and going on hikes with them, then you better eat protein and you better not be afraid of it. And a large percentage of the protein you eat every day better come from eggs and from the flesh of animals, because that's the protein that is the most absorbed, the most usable, the most assimilated in the human body. You want to keep your bones strong. You don't want to develop osteoporosis. You want to keep your muscles strong. You don't want to develop sarcopenia. You don't want to be in a nursing home having some stranger making minimum wage, taking care of your personal hygiene. You want to be able to take care of your own activities of daily living. And the way you do that is by eating lots of animal fat and animal protein, keeping your bones strong, keeping your muscles strong, keeping your mind strong, so you can take care of yourself and also take care of your family as well.
In one line, Dr. Berry, what would your message be for India especially?
Stop believing the lie. Grains and beans are not health foods. They are not optimization foods. They are starvation foods. They are fallback foods. They are the food that a colonial slave driver convinced your great-great-great-great-great-great-grandmother that's all she had access to. And so rather than her say, well, I'm feeding my family this inferior slave diet, it feels better and sounds better to say, oh, this is our heritage. This is our culture. It's not. If you go back even 300 generations, no one in your family ate grains and beans. They ate meat and eggs and seafood and some plants, of course, yes. But the grains and beans played no role in their diet whatsoever, regardless of your heritage, regardless of your family tradition, regardless of what your religious leader taught you. It's not true. It's very clear in the anthropology and the archaeology.
Thank you so much, Dr. Berry. I can never, have enough time to ask questions from you. Totally flawed, totally better advice, totally, in the know of so many things now that you've clarified for the benefit of our viewers, the common myths that you've busted, the things that plague India, the belief systems that we have that stop us from following the proper human diet, be it religious or whatever. Thank you so much for coming. Thank you so much for speaking to us. It was a wonderful session with you, Dr. Berry.
It was a pleasure and an honor. Thank you so much for having me.
Thank you.
Hello. Am I audible, Dr. Lenskis?
Yeah, you're perfect. I can hear you perfect.
Perfect. Yeah. Welcome to India's first and largest conference on metabolic health as well as low-carb nutrition. This is turning out to be a mega event, and we are very excited to have you. So thank you so much for joining us. It must be a good morning there. So I'm going to introduce you for the benefit of those who may not know about you. but a lot of us have been following your work and we are big fans. So let me quickly launch into the introduction and then we'll kick it off. So hi everyone, Dr. Brian Lenskes here. He's based in San Diego, US. He's an internal medicine doctor and specifically focused on clinical nutrition. He runs an independent practice, which is called as Low-Carb MD in San Diego, California. He has been voted as one of the top doctors of San Diego for several years. And he specifically uses the power of nutrition and lifestyle modifications to help patients attack root causes of chronic diseases. And what I really love about him is that he always values the patient's freedom of choice. He always speaks about that online and wants all of us to be better informed. He's a panel expert on Diet Doctor, and he is using podcasts to create public awareness on a wide range of issues, health, fitness, and more. And I should mention both those podcasts here. One is the Low Carb MD podcast, which he co-hosts with Dr. Tro, and the other one is Life's Best Medicine, right? And by the way, he leads by example. He dropped more than 50 pounds himself following the right nutrition and lifestyle changes, right? So I'm very stoked to have you here, Dr. Lenskes, and welcome, and let's get into the discussion.
No, Mandar, thank you so much. It's such an honor. I've been a fan of all the work that you all are doing, and what an amazing lineup. I was teasing you before we came on that someone must have called in sick for me to get in, because you have the top of the top here, and it's just amazing to see that you could pull it together. It's hard to get all these big names like Professor Noakes and Ken Berry and Sean Baker. It's just such an honor to speak after them.
Thank you. All powered by D-Life's Anup, Singh and Shashi, as you know. So I'm a team member just helping them out. So what I want to kick it off with is you have had your personal transition, changing your own lifestyle habits, adopting the low carb way. So maybe why don't we start there, and also what specifically the benefits that you saw?
Yeah, I was in standard medicine, for 15 years or so before I had any inkling of looking at these things. And just as a background for me in high school, I was overweight as a kid. Food was the center of our universe in my family, and people drank and smoked and didn't really take care of themselves. On my mom's side, all my uncles died in their 40s and 50s of cardiac disease, diabetes complications, all these disasters. I was like, I don't think I want to end up like these guys. So in high school, I played football, and I'm not that tall, so I had to gain weight to play football with these big guys. And then I had to lose weight for wrestling season, and I was wrestling, 40 pounds difference between the two seasons. So, it's terrible for your metabolic rate and everything else to starve yourself and run and, to work out really like Biggest Loser type stuff. And then as I got older through college, we would take study breaks and eat pizza. Then we, take a study break, and we associated that eating with peace. And so I started gaining weight, and I was practicing, for 15 years at this point. And I was slowly gaining weight every year, even though I was exercising, 5 or 6 days a week. Generally, I've never been lazy sitting around, but I was thinking, how could I be gaining weight? And my sugars were in the pre-diabetic range, following the American Diabetes Association diet, and exercising. And I know I'm not cheating. So I know it's, obviously sometimes cheating, but for the most part, I was sticking to that. And, I believed all those things. And then what happened is I had a patient who came in that lost 40 pounds. And I said, it worried me at first. I said, what happened? What are you doing? He said, you're not going to like it. I'm doing something called the fast diet. I said, well, what's that? And he said, well, on Tuesdays and Thursdays, I basically fast. I eat only meat and vegetables, no carbohydrates those days. And I said, okay. And it was like 500 calories on those days or less. And I said, well, if you're eating 500 calories on Tuesday, then Wednesday you must eat twice as much. And then I asked him, what about the other days besides those 2 fasting days a week? What do you do? And he said, well, I eat whatever I want. I said, well, pizza and soda. He goes, yeah. I said, well, that can't be right. And I said, so if you don't eat on Tuesday, you must be starving on Wednesday and eat twice as much. And he said, no, I'm not hungry those days. It's so weird. And then I stopped drinking soda, and I stopped eating this. And so he started feeling better. I thought, that's weird. So I started researching, and I come across Jason Fung, of course, and he's talking about insulin resistance and fasting and how we could rest the pancreas a little bit and we can get metabolically healthier. And then, I started looking into it more and more. Then I come across Professor Noakes and Gary Fetkin. I'm like, oh, these guys are going through trials because they're telling people not to eat sugary cereal for breakfast. And I thought, this is crazy. How can that possibly be? And then within 6 months, I had 11 of my patients come off insulin because they were asking me what I was doing. And I said, well, I can't officially tell you, but it's not the standard of care, but this is what I'm doing. I'm just telling you, I'm doing intermittent fasting, cutting my carbohydrates out and eating real food. And so then I started seeing the differences in myself and patients. So I started going down the rabbit hole, and I went to a conference, Low Carb USA, and it was like 10 minutes from my office. So I thought I'll just go see what these crazy people are talking about. And then I started seeing oncologists and and kidney doctors and cancer doctors and heart doctors. And I thought, wow, this is not just like some hocus pocus few doctors talking about this. There's more doctors out there doing this kind of medicine.
Very interesting that you mentioned actually so many types of doctors and so many types of diseases, right? So I want to ask you, somebody may have said to you, insulin is just one hormone, right? But how do you explain to them the core role of insulin as well as insulin resistance and how it touches, so many of these diseases?
Well, I use different analogies to explain it. Jason Fung uses a suitcase analogy. And so basically, getting down to, like, especially in the Indian and Asian population, if you think about it as storage units, a place to store your if you're buying stuff at the grocery store and you need storage units to store everything you're buying. Some people don't have very many storage units. So if you can't put things in the storage units, which are your fat cells really, then sooner or later what happens is you need to have a bunch of people to help you shove more things into that storage unit, and that's insulin. So when the insulin starts going up, we know the storage units are full, and that's a problem. So when people are watching their diet and exercising and not eating as much sugar, then the storage units are half empty. So if someone has a lot of, like Sean Baker as an example, or Ken Berry, they have so much muscle mass that if they want to eat extra carbohydrates, it goes to their muscles. Well, a lot of people in the Indian and Asian communities don't have a lot of muscle mass. So then they run out of storage. So they can weigh 130, 140 pounds and still get type 2 diabetes. And this is something so unusual to us. One of my first patients that I started thinking about this weighed 150 pounds and he got type 2 diabetes, and he was very active. So I thought, how can he possibly have diabetes? He has only 400 pounds, like what we normally see. But he ran out of storage units earlier, and he was hiking across the Grand Canyon and he was very active, but all day long, all he ate was carbohydrates because he didn't care because he wasn't gaining weight. But then all of a sudden he got full-blown diabetes. And so we had to look at his diet. And once we changed his diet and took out he was drinking sodas all day and because he thought he needed the sugar for energy to go across on these big hikes. And once we stopped that, everything normalized within a month or so. And I've seen that with some of my people of Indian descent and Asian descent, when they start cutting carbohydrates and doing a little bit of weight-bearing exercise, it's amazing how their metabolic health changes dramatically. And so really one of the biggest thing I look at, and honestly, for the first 15 years of my practice, I never checked an insulin level because I didn't understand why we would do that. But now you understand that we have at least 10 or 15 years before someone gets the diagnosis of diabetes. That insulin goes up and up and up, and the body just stops listening to insulin and says, look, my storage units are full. I cannot put anything else in here. Stop buying things. Stop eating sugar, right? And so if we stop eating sugar, then we empty out our storage units, and then we can put that sugar in there easily. Hopefully that makes sense too.
Yeah, definitely. I think it's an interesting analogy. And what you mentioned about the lean diabetics, right? Or people who visually look lean, but they are metabolically unhealthy. I think that is an important point for all of us Indians, because we may assume that, hey, I'm healthy or I'm quote unquote fit, right? Because I'm doing some physical activity. So I think this separation of what you're able to do from a fitness point of view versus your metabolic health and then tracking insulin, I think that is spot on. Amazing advice there for patients as well as physicians. So one more thing I keep noticing is that, a lot of times we are told to just discuss the symptoms is what we mainly discuss, right? Just suppress those symptoms, take a pill for something. And I noticed that in your approach or what you talk online also, you really try to go to that root cause and, educate patients on that. So what are the different kinds of conditions that you have been able to handle because of this approach of, attacking the root cause?
Yeah, and honestly, my root cause has changed over time because, a lot of the stuff we're treating is the symptom, right? So Dr. Unwin and his team showed that if we got people's insulin normalized, then salt wasn't raising their blood pressure anymore, because insulin acts on the kidneys to make you hold on to salt. So when someone cuts out the sugar, right, and exercises more, their insulin levels come down. As the insulin level comes down, they can urinate out more salt in their urine. So their blood pressure gets better. So that's one thing we track is blood pressure. We can get low blood pressures by dropping, people are on a bunch of medicines to bring their blood pressure down because of the effects of insulin. So insulin doesn't just work on the sugar system. It also works on the kidneys. And it plays a role in a lot of body function. So yes, the surprising things that we took heat for early on, Tro and I were both noticing in our practices that when people went low carb or on a ketogenic diet or a carnivore diet, their mood got better. Or they would say, yeah, I don't crave alcohol as much. And you think about it, there are studies showing that inflammation in the brain and chronically inflamed people are more depressed and anxious. Poorly controlled diabetes is one of the biggest risk factors for depression. And people don't realize that. And sometimes you don't know the chicken or the egg. But what we've done is there's studies that have shown that diabetics get poor sugar control first, and then they get depressed. It's not because they're depressed and they don't care about their sugars anymore. And then once they get depressed, they really don't care and everything goes out of whack. So, cancers we're looking at, if we get the metabolic health, Chris Palmer from Harvard, when I first heard about him, I thought he was crazy talking about treating schizophrenia and bipolar disorder with dietary changes, but now we're seeing it in the mainstream and we're seeing publications. So a lot of it we were observing. The problem is when we observe something, it takes about 100 years for that to go into practice. About 50 to 100 years. So it's definitely a challenge that we're facing. But there's so many underlying conditions that people with joint pains, their inflammation, Sean Baker is an orthopedic surgeon, and you see people's, I've had people that were scheduled for a total knee replacement go low carb or keto and their knee pain goes away and they cancel the surgery and their sugar's normalized and they feel great. And so it's kind of like the joke in the United States is like, the country Western songs, people talk about losing their house and family and everything gets terrible. So it's like we're playing that song backwards. People start out really bad and they get better and better and better. And when we first talked about it, at, even Low Carb MD episode number 10 and 13, we talked about addiction. We got attacked by doctors all over the world saying that we were crazy and we should have our license revoked for even thinking that diet had anything to do with mood. Now the data is clearly on our side. We knew what we were saying clinically, but it takes time for the science to catch up.
It's an amazing benefit, right? So it's not just what we consider as mind and body separation, but your diet is having an impact on both sides.
Not only that, it goes both ways, right, Mandar?
Mm-hmm.
If people are stressed and they're stress eaters, they eat more. They eat more sugar and they get more stress, and then they eat more to try to calm their nerves. And there's definitely studies showing that initially when insulin goes up, it makes you feel good. So if you eat candy, you feel better for a little while. But what happens is over time, just like with alcohol and other drugs, is you need more and more to get that effect. So eating one cookie doesn't do it for them. Now they need 10 cookies. Now they're going to eat the whole tray of cookies. Now they're going to gain more weight, and then they get depressed and anxious. And so food becomes their friend. And some of the studies with bariatric surgery with gastric bypass is, as a matter of fact, this week I had a conversation with someone, and he says, oh my goodness, my sister had a gastric bypass. After that, she cheated on her husband. She started smoking. She started drinking and all this because she couldn't eat cookies, which were her drug of choice anymore. So, a lot of people have been talking about the bariatric surgeons have noticed even after surgery and people are losing weight, but depression goes up, drug use, smoking, everything else, every addiction gets worse because they still have that problem in their brain. But if we can fix that with a low carbohydrate diet, then they feel better. So they don't need a cookie. They don't need all these things. If you go get a massage or you're doing something you really enjoy, you don't say, okay, let's stop what I'm doing and go eat something, but if you're depressed and anxious, you want to go grab a cookie. And that's, for a lot of people, that's a root cause of what we're seeing, is that their underlying is they're not happy with life. They're stressed, they're tense, they're not sleeping. And all of a sudden food becomes their comfort, as it did for many of us.
Definitely. Do you, so just so that we all have a context of when you're saying the BP will come down and normalize and some of the other symptoms are improving, what sort of a time period are we talking of?
It's variable. It really is. I've had some people, they have to really work hard because the insulin is so high that it takes a while for it to come down. The good news is we can make an impact very quickly. I have people, sometimes we'll check an insulin 2 weeks apart and we'll see that it drops in half. So if I'm going from 37 down to 16, I feel a lot better about that. because their pancreas is resting, and they're not going to burn out their pancreas, because sooner or later you can't keep up making insulin, and then you get diabetes. So yeah, it's variable, but we're showing about 90% of people, when they get their insulin under control, their blood pressure gets better, and there's other factors involved, obviously, like stress and not sleeping, and trying to get that whole. As a matter of fact, my company, my clinic here is, I have Arizona Metabolic Health and San Diego Metabolic Health, because I realized early on, just changing to a ketogenic diet or a low carb diet doesn't fix a lot of the problems. Because if you're on a perfect diet, but you're not sleeping and you're stressed and you're tense and worried, and drinking at night and smoking and all those other things, factors, you're not going to have the results as much. As we have to focus on the whole metabolic picture. And just as a quick aside, Ben Bickman, who's a researcher at BYU, who's a good friend of mine now, I met him at a clinic, and at that time I was working 18-hour days in a standard medical clinic, busy all the time, staying up late, working on my charts, getting up at 4 a.m, going to work, getting home at 8 p.m, every day. So 18-hour days most days. And I was at a conference. I ran to Ben Bickman and I said, "Hey Ben, look, you're the expert on metabolic rate and all these things. If I want to live a long life, what do I have to do?" And he said, "Oh, Brian, that's easy. 5 things." I go, "What are those 5 things?" He said, "Number 1, don't work 18-hour days and be stressed and running around crazy." I'm like, okay, what's number 2? Get enough sleep. You need 7 or 8 hours. If you don't get those, and I was like, "I don't think I like your rules, professor, because I'm 0 for 2. And he said, "That's why doctors die before everyone else. Doctors die younger than most people, right? Because we're stressed and tense and we don't take care of ourselves." So next he said, eat real food, cut out the processed food. Next he said, don't smoke or drink to excess, right? And then he said, exercise regularly, like what we're doing right now. And you say, okay, if I can do those things, the rest is not really in my control. There are some genetic factors, of course, but a lot of it is, okay, what of those 5 things can I work on? Some people are doing great on the diet, but they're doing terrible on the other 4. So if they work on their sleep or their stress or their exercise, some people are exercising a lot, but they're eating all sugar and candy at night. So it's really putting all those 5 things together, as many of those as we can. Sometimes it's out of our control. If we have a stressful job and we have to work long hours sometimes, okay, how do I compensate for that with the rest of those other 4?
Very interesting. So people are going to need quite a bit of handholding when you do this with them, right? So what's your approach of coaching them and taking them through this journey? Because I imagine that they are not going to be able to flip this switch very quickly. They will need a lot of guidance.
Yeah, some people really flip the switch quickly. And as we talk about root cause, what I found, and this is borne out throughout recent years in medicine, there was a study called the ACE questionnaire, adverse childhood events. And these events, when you look at them, basically it says, were you in a poor family, an unstable family? Was someone drinking in your family? Did someone say you're the worst kid ever? Your brother's smarter than you? Like all these things, suicide, sexual abuse, physical abuse, emotional abuse, poverty. And or one family member in prison, when they add these up out of these 10 questions, if you score 7 out of 10 on this, your life expectancy is 20 years shorter than everyone else, right? You're more likely to be obese and diabetic. And then you turn to food for your comfort because you didn't have comfort from your parents. So there's a lot of things that we, in medicine, especially in the US, that we've neglected, that we kind of don't realize the impact. So walking around stressed all the time, your body thinks something's going to go wrong. And if you're stressed and tense and you don't take time to meditate or pray or play with your kids or go out with your dog, whatever it is, if you don't take that time, your body thinks something bad's going to happen. So if your body thinks something bad is coming, it makes you store more fat. Because it's saying, okay, if you're not gonna be able to eat for a month, if the economy is going to drop, then I want to make sure we get, that you have enough nutrition. So even some people, and there's a study that I was amazed by when I saw this, is if you cut your calories to 1,000 calories a day, which is a starvation diet, and you're sleeping 4 hours, a majority of your weight loss is muscle mass. But if that same person sleeps 8 hours, a majority is fat mass. So why? It's because if you're a terrible hunter, your body says you're a terrible hunter and you're up all night trying to hunt and you can't kill anything, then I'm going to get rid of your muscles so you don't burn all your fat away and die. Well, most of us are trying to burn our fat away, right? So we have to get better at burning that fat. How do we do that? We put on more muscle mass and we decrease our fat mass. So hopefully that answers your question. Are there other?
Right. So, and clearly it takes some effort and involvement from your side, a lot of handholding.
Yeah, a lot of those things. Like, that's why I like what I'm doing now. I'll have an hour with the patient, or a half an hour at least, and we can sit down and say, how's the marriage? How's things at home? How are your kids? And you can get a sense of how people are doing outside of just the dietary stuff. We also use continuous glucose monitors, so I can see people's sugars 24/7. So I can look back and, we're working together and we'll say, well, what happened on Wednesday? And most of my patients are very good at putting down, I ate cookies on Wednesday afternoon, or I did. And so we can look at that, and the patient knows themselves. So having a continuous glucose monitor, I don't know how much access you have there in India, but for us, it's not too hard to get that in the US. I know in Europe, it's hard to get. But when people see that, they say, oh, they told me sourdough bread was fine or rice was fine. And when they eat rice and they see what their sugars do, or non-bread, if you're eating a lot of that, or mango juice or whatever it is, we'll see those sugars go crazy high. And then we say, oh, it's because your storage units are full and you don't have anywhere to put it. So people understand this concept. So sometimes we're just being social. And I think what you're doing here is so great, because what I do every 2 weeks with all of my patients is we have a Zoom meeting just like this. And we can all talk, say who's struggling, who's doing great, who's struggling with what. And they all help each other. So they sit back and watch my patients say, oh, I used to eat cookies every night too. Here's what I did. I started going for walks with my wife, or, I stopped drinking alcohol, or whatever it is. And everyone is supportive and helpful. And some people will come in and say, I had a horrible week. I was stressed out because my mom was sick and I just turned to food. And everyone says, oh, I've done that before. And so you're not when you think you're the only one, it's a problem. And that's why what you're doing is so important, to let people know, okay, there's not just 2 doctors doing this kind of medicine. There's thousands and thousands of doctors around the world getting great results, and so having that community is really key. And I'm so fortunate in where I am, is that I can say, hey, in 2 weeks we're going to go for a hike, and who wants to go for a walk? And the people who are really athletic can go in front, and then the slower people can, and then we meet halfway and everyone talks and shares stories. And they could ask me questions about biology or whatever they have questions about. But really, it's really important to have that human connection. I think that's something medicine, at least in the United States, has absolutely lost. People see a different doctor every time they go to the clinic, and no one knows them and what their struggles are. So really seeing the person as an individual, because reality is there's not a one size fits all. That's something I learned. Some people can eat more carbohydrates than others, and other people, if they're diabetic, you really got to be strict on the carbohydrates and exercise, and really just trying to make our bodies healthier. So just trying to get, if you make it too difficult, people say forget it. I'm like, I can't do that. But if you say, well, if you're drinking 3 Cokes a day, can you go down to 1 to start? Whatever, we meet the person where they're at. And so I have a team that is knowledgeable on supplements and different things, different tricks that may help us to improve metabolic health faster.
Yeah, I think your patients are lucky to have you as well as the team, because that human connection, as you said, and also your approach of treating the patient and not just the symptom, with a quick pill and sending them their way, and truly trying to spend that time and involving various aspects of their life in their treatment. I think that's simply amazing. So thanks for elaborating on that. So do you typically start with these patients by first telling them this logic or the underlying biology, or how do you warm them up for this approach?
Well, fortunately, the blessing to me is that a lot of my patients select me because they hear what I'm saying. And they say, well, you know what? I'm ready. I want to get healthier. What do I have to do? So a lot of doctors don't even talk about nutrition, because over the years, they've given bad advice, right? They said, eat 6 meals a day, eat sugar all day long, so your sugars are balanced. Like, wait a minute. Like, when you're on insulin, we're dosing your insulin dosage on how much carbohydrates you're eating, right? So if you don't eat any carbohydrates, you're not going to need that insulin for a type 2 diabetic. So that's where you start realizing, oh my goodness, there's a lot of misinformation out there, and it's hard to overcome. And that's why when I was watching Gary Fettke, by telling people not to eat cereal for breakfast, to eat eggs instead, and you see their sugars normalize, people are smart, right? So once they can see their sugars, once they can see it getting better, it's not my opinion. It's what happens physiologically when you're doing that, right? So when people exercise or they put on muscle mass, they're going to see their sugars improve, and they feel really good about that. They go, okay, I have something. And when you see your insulin coming down, your triglycerides, your HDL coming up, going the right way, you feel a lot better, and your A1C is coming down. And so it's just such an honor to practice this kind of medicine, because surprisingly, I will see, these things surprise me all the time. And I'll call experts and go, Ben Bickman. Like the first time I saw one of my patients, we got her diabetes under control and she was scheduled for a total knee replacement, but I couldn't clear her for surgery because her sugars were so high. And so I said, look, we got to work on either put you on insulin, which I don't agree with, but it will get your sugars low enough if you're not going to change your lifestyle, because she was eating horrible foods every day. Like she's Latina, so they were eating tortillas and desserts every day, 3 times a day. I mean, rice all the time, soda. We got her off that, and within 6 weeks, she had lost 35 pounds. Her sugars normalized. We took her off 3 blood pressure medicines. And I said, okay, you know what? We made a deal. I'll clear you for surgery. You're at a good sugar level. And she said, wait a minute. I said, what? She said, I don't need surgery. I said, what do you mean? She stands up, does squats in my office up and down. And she said, I'm running up and down the bleachers every day at the high school. I was like, you got to be kidding me. You were crying 6 weeks ago and you couldn't move. And so she canceled her surgery. She's doing great ever since. So, it's those things when you realize that we can really impact a lot of different conditions, not just getting the sugars under control. And one of the biggest surprises that I saw was the improvement in mood and anxiety and stress. So if people are smiling and laughing more and having more fun in their relationship, then they're going to live longer. That is definitely a contributing factor to all of what we're talking about.
It is so multifactorial, right? And it must be amazing to see, that thing click in their minds. And then, when, as you said, they don't then take it as your opinion or, just some one doctor's advice, but, I think they really experience, and it's just super to hear. So, but do you still get, some questions or pushback? So, I mean, I'll just ask one or two that I keep sort of hearing in these circles, right? So, for example, low carb will mean, hey, I'm going to have to eat significant amount of fat, but isn't that bad for me? A, won't that make me fat? Or B, won't that worsen my risks of heart disease? So, how do you address some of those questions?
Well, I think the important thing, I have several slides that I show people. I say, okay, here's the numbers, decide for yourself. And what they showed, there was one from the country of Colombia, and they took everyone who came in the hospital with a heart attack. And they said, what could we have predicted this heart attack coming? So they took the people who had heart attacks and compared them to the people who didn't have heart attacks for a year. And what they showed was that LDL cholesterol made no difference. That risk ratio was 1, meaning if you had high cholesterol, you couldn't look at that alone and say, is this person at risk for heart attack? Then they looked at total cholesterol. There was no correlation. Then they looked at high blood pressure, doubled the risk of a heart attack. Why? Like we talked about already, high blood pressure is associated with high insulin levels. So if you look at a high insulin level, it was almost a 700% increased risk of heart attack. And no one looks at that. Why? Because we have a statin drug we could throw at people when say your LDL is high, here's a statin drug. Keep doing what you're doing and we'll put you on a drug and you can live your life. Well, you got to make some dietary changes. There's a reason your LDL cholesterol is high and your triglycerides are high, right? So if with insulin, we don't have a drug we can put on other than metformin. But the thing is, nobody's checking it. So the cardiologists, I show my slides, and one of the biggest risk factors for heart disease is low HDL, the good cholesterol. So if that's low, there's a problem. And if your triglycerides are high, we know that's a problem. So focusing on just LDL, we have, there's studies going on now where, for instance, if I have a patient who fasts for 3 days, their LDL cholesterol will go the highest it's ever been. And Dave Feldman has shown that. And I've done that with my patients. When I see their LDL go crazy, I'm like, how long were you fasting? Oh, I fast for 2 days before my labs. Okay, let's just eat normal for a couple of days and see what happens. Because this energy model, I'm pretty convinced of that with Dave Feldman. I have not seen an exception in my practice yet where if someone's very lean, for instance, women with anorexia who starve themselves or eat very low calories, their LDL cholesterol is 1,200 a lot of times. It's incredibly high. But when they start eating again, it totally normalizes, right? Because now the body's not panicking, trying to kick out all the fat from their storage units to run on. So if you're running on fat as your fuel source and you're actively losing weight, no matter what, people don't talk about this very often, but whether they're on Weight Watchers, whether they're exercising, if you're losing weight, your LDL cholesterol goes up. Why? Because it's coming out of storage where you don't see it. It's like letting things out of the storage unit, then you see it, but you're not storing it. You're burning it as a fuel source. Who cares? Right? It's the excess energy that becomes a problem. So yeah, in the ketogenic diet, some people will take in 10,000 calories of fat a day. That's not a good thing either. You want to have this balance. And so you're making sure you're getting enough protein, prioritizing protein, and then, adding in fat for satiety. So if you're having olive oil. And one of the I actually interviewed a doctor of Indian descent that works in the Silicon Valley area in San Francisco. And I said, what do you do with people that are of Indian descent with diabetes out of control? And he said, well, we talked about eliminating the non-bread and the rice. And I said, what do you do if they won't give up rice? He said, well, I try to do like cauliflower rice mixed with regular rice, make sure they're using ghee, because their heart attack rates go way up when they're using vegetable oil, because everyone told them it was healthier. So when they just switched back to ghee, they did better. They had decreased strokes and heart attacks and all these things. So it does play a role. And then he said, funny enough, he said, if they won't stop the rice, I'll have them eat fried rice, right? Because the fried rice, believe it or not, has butter, it has fat source, has things, and it lowers the sugar levels compared to regular rice, because there's less rice in fried rice because you have the carrots and the peas and whatever you're putting in there, and meat maybe. So yeah, it's really a challenge to get people to change their lifestyle, but there's such a fear. And then when you look at the data, and there's studies coming out with these lean mass hyper responders, and that's going to be really interesting to see what the results are. But routinely in my practice, I do a coronary calcium score, which will look at cardiac disease. There's coronary angiograms that we can do if we're really concerned. And it's amazing how little disease people have with super elevated LDL cholesterols that are athletes, that their insulin's normal. But for me, one of the biggest things was I was at a conference, and Ivor Cummins, known as the Fat Emperor, was showing me data on this insulin. I thought, this is crazy. This slide, the one I just discussed, I thought, this is crazy. There's no way. And he said, go back to your practice and check your insulin. So I started checking insulin. All of my patients who had cardiac disease, strokes, peripheral vascular disease, blockages of their arteries, they all had high insulin, all without exception. I'm like, wow, we got to look at the insulin. So my first priority now is getting the insulin under control, and then we could worry about LDL if we need to. I'm not anti-statins or other dietary changes, but I think the point is, let's minimize the risk for that patient. And if it's high and we don't have a good answer, we need to look at that. But it's surprising, especially in people who are morbidly obese with their visceral fat, as you were saying, are full. When we lower that, their LDL cholesterol gets better. When we lower the visceral fat. So visceral fat, what happens if your storage units are so full, it starts leaking out sugar and fat and all these things into the bloodstream again. So when you start losing weight and emptying your storage unit, your body goes, oh, we could put some more stuff in the storage unit and put it there. So that's why, people have a misconception. It depends on what energy source you're burning. So if someone's on a strict ketogenic diet and they eat carbohydrates for the weekend, on Monday, their LDL cholesterol will drop by 80 or 90 points, because now they're burning sugar as fuel source and puts the fat into the fat cells, if that makes sense.
Yes. I think, Dave Feldman's research has nicely shown that, right? That primary job is to carry that energy. So thanks for elaborating on that. And you also mentioned prioritizing protein, right? So that's the other question that I wanted to ask you, that, do you have patients who have, that misconception or apprehension about eating protein because they have heard that, hey, it might damage my kidneys, etc.?
Yeah, it comes up all the time, and you look at it. So, all I can say is, okay, let's look at Sean Baker. Like, he probably eats more protein than anyone that I know. His kidneys are working fine. His labs are normal. So, it's been addressed by Jason Fung, who's a kidney doctor. It says, look, eating more protein doesn't damage the kidneys. And then you have all these muscle guys, the weightlifter guys who get huge muscles. They're eating a ton of protein to maintain that. Most of us can't even eat that much protein to be that, that's the biggest issue, is trying to get enough protein in. And that's the other side of the coin, is some people are trying to like force protein all day and all night, just eat as much. But if you're eating a healthy diet, you're going to get enough protein. You may have to, add a little bit of meat here and there, or some eggs or egg whites if you want. But there's ways around it. I have patients who are vegetarian that we work with. Vegan is more challenging, because if I can get someone to eat eggs, they can put muscle mass on, they can get a good protein source. It's hard to find a vegan source of protein that doesn't have a lot of carbohydrates along with it. So that's the challenge. We're trying to figure that out. I know Ben Bickman's been doing work with some pea proteins to purify it and get the toxins out, and hopefully he'll have a product soon that helps people with that. But it's one of those things that I think most of us can't eat enough protein to cause any damage at all. You just can't eat it. You get so full that you can't eat a lot. And that's the other thing with calories where we get confused is, for instance, Lay's potato chips, you know, a big bag, a family-sized bag is about, I think it's around 2,600 calories. In order to get that much in meat, you'd have to eat 6 or 8 ribeye steaks, 8-ounce ribeye steaks. Like no one could eat that and then go out to dinner afterwards. But you could eat chips all day watching a soccer game or something, and then all of a sudden you want to go out to dinner afterwards. So it's not all just about calories; it's about satiety, getting full of what you're eating. So for me personally, I don't add extra protein to my patients, like say, you know, eat whey protein or, you know, protein shakes and powders. I do use Health Code and Keto Chow for people who really like shakes and they don't have time to make things. So having a good protein source with good fats involved is definitely helpful. And in my seniors, I do that because there's a high caloric intake. So, but they're also getting avocado oil and coconut oil, and they're getting, you know, ghee, and they're getting healthy stuff like apple cider vinegar with that. So I feel good about that instead of the commercial products that you see for seniors is just all the seed oils and terrible stuff, and they get metabolically sicker, and then they mentally decline. So it's amazing when people get their nutrition right, what happens to the mitochondria and their energy level and their focus and their memories getting better. It's a miracle to see.
True, true. Sometimes we accept some of these as just a function of age, right? I mean, people sort of say to each other, hey, you know, I'm 60 or whatever, and, you know, or sometimes even 50 these days. And people sort of accept that level of ill health, which they really shouldn't. But it's great that, you know, because of you and several doctors like you, we are seeing the light. And I think they should learn from that. Another question I had was, do you see patients who are suffering from gout or, you know, higher uric acid, etc., and have you been able to?
Yeah, honestly, I haven't seen that, but I've talked to experts with regard to gout, and it's very interesting, the physiology. One of the biggest risk factors that people don't talk about is high fructose corn syrup, right? That's a huge risk factor. So what happens is the uric acid, which builds up with gout, if you change the level of uric acid quickly, or there's a drastic change very quickly, you can get a gout attack. So if I put people on, so for instance, if you keep having gout attacks, and I say, okay, I'm going to put you on something to lower your uric acid. When I do that, I start really slow, like every third day, and then go up to every, because if you change that level too quick, boom, you get a gout attack, and then you're in pain, and you have to take, you know, steroids and anti-inflammatories to fix that problem. So in the early stages of a ketogenic diet or a carnivore diet, the ketones compete with the uric acid for excretion. So your uric acid can transiently go up, but over time it goes way down below where it was before. So I don't see people with chronic gout problems that are on a ketogenic diet. Personally, I've never seen it. So, you know, theoretically, you know, and it can happen. For instance, someone with high uric acid, and they eat a bunch of shellfish, like shrimp. If they eat an all shrimp diet, or beer, you know, things like that, we'll see it come out. But you know, most people, when they start eating a low carb, their sugars and their fructose goes down so quickly that we can maintain them without getting a attack of gout.
Perfect, perfect. You sort of made a mention of, you know, genetics a few minutes back, so I wanted to get your take on that. So I sort of hear two almost extreme things, right? One is that, hey, you know, my earlier generations had these metabolic disorders, so I think I'm destined for that. That's one. Or the other is, you know, they didn't have it, so I'm, you know, I'm safe. And I sort of, it doesn't ring true, but I wanted your elaboration on that.
Yeah, I think there's something called epigenetics, right? So if you're stressed all the time and tense and don't sleep, you're more likely to get diabetes. As an example, in the U.S., the Navy SEALs, there was a study I read about when they were sleep deprived. If they put them on sleep deprivation for 4 days, they started getting insulin resistant. And these are the fittest of the fit. So, you know, if you're living a poor lifestyle and you're smoking and drinking, like you don't help your odds of not getting it. So if you have a genetic predisposition, for instance, if someone has a genetic predisposition to getting cancer and they smoke and drink all day, well, their risk goes way up of getting that cancer. So if you have a genetic predisposition to cancer, but you live a clean, healthy lifestyle and you stay away from the drugs and you get enough sleep and you watch your rest and things like that, then people can prevent it. So in my family, that's what I was looking at with all my uncles dying at a young age of diabetes complication. I thought, wow, if I do what they're doing, I'm going to end up the same way they're ending up. Because what they would do is say, well, and this is the problem with Western medicine, is they're doctors. And I saw it. And I witnessed this before I even went to medical school. I said, this doesn't make sense. But My aunt would say, oh, her sugars are out of control. And she's, she checked her sugars 300. Oh, I'm just going to have to shoot a bunch more insulin, but I can still have my cake because the insulin will make my sugars go down. Well, it's making your sugars go down by shoving all that into your fat tissue, into your brain, into your heart, into your feet, so then you start having all these complications of overload of sugar, right? It's a big problem. That's what that's why if you want to look at your risk of heart attack and stroke, I would forget about the fat to start with and go, okay, if I'm diabetic, I got to fix that problem. That is the number one risk factor, no question about it, metabolic disease. And when we see it, there's no argument on that. You can't say that. But if you have high LDL cholesterol and you have diabetes, disastrous, right? It's really bad. But if you can bring your sugars down and bring your and your LDL goes up as a result, and your insulin, triglycerides, HDL, every other marker is getting better, you have to look at the big picture.
Mm-hmm. Right. So I think summarizing your point on the HDL, we want a high HDL, right? We want low triglycerides. So that should, and of course, good control over our insulin resistance. So we want to be insulin sensitive. And then, as you said, then worry about, others factors which may be or may not be in our hands, like the genetics part of it.
Exactly. And I think that's the important part, is looking, okay, what's the most likely thing that's going to cause my patient to die? Let's fix that first. Like, if you have termites all through your house, you don't repaint the outside of the house, you fix the termites because your house is going to fall down if you don't fix that. And that's what we have to look at, the big picture, rather than every doctor, they look at LDL, like do a little hole, and that's what they're looking at. They don't look at the whole big picture and go, okay, what's the whole process here of what we're dealing with, and how do I make my patient healthier? Because I'm telling you, no one talks about stress and sleep and all these other things. And if you look at the data, people who have a better metabolic health and are enjoying life and laughing, I see people every day. And one of the biggest questions I ask that stumps people, they can't answer, I'll say, hey, what do you do for fun? What do you enjoy doing? And they look at me like, I'm trying to survive. And I know in India, it's way harder because people have it's hard. People work hard. And so it's so hard to say, yeah, I don't sit and laugh or play with my kids or go look at the ocean, because you feel bad because you have so much work to do. And that's why I decided to leave my practice where I was making a lot more money, is because I realized you can't work 18-hour days and then take care of your wife and kids and family and have fun and go and do things, right? Because if you're always on this overdrive, it's not good for the body. No animal is stressed continuously. And interestingly enough, something I learned that I never really thought about is, when animals are stressed, they won't eat. So if you have a dog and you take them to a new environment and they're not sure of the environment and you put their food down, they won't eat. They look around to make sure everything's safe and they guard everything because they don't want to be eating when there's something bad. And a deer's not running from the lion and says, okay, I'm going to stop and eat something. But when we're stressed and we're upset with our spouse or we're upset at work, we want to eat something because it makes us feel better temporarily, right? And then in that same setting, our gut isn't ready to take that food because when it's stressed, it decreases blood flow to the gut. Then people have stomach pain. So some of the stuff you're talking about, all these things do feed on each other, and so be able to relax, take a breath all the time. As a quick aside, just yesterday, I had 2 patients come in and they went on vacation and they ate more carbs than they normally do, but they lost weight. One of my guys loses 5 or 6 pounds every time he goes on vacation, because he could just relax and go to the beach and go for walks, and he's not stressed sitting there at his desk all day worrying about, making phone calls and doing things. So yeah, there is a lot to be said about the whole lifestyle, not just what we're eating.
Yeah. So I have also seen sort of people really view it at a very superficial level, right? And in fact, they will make comments like, hey, I'm supposed to take my injectable insulin now, so I have to eat, or for that pill, I gotta eat. So it almost sounds wrong, because it's like, but how do you look at it, or how do you explain to them that they are not really killing the fire, they are just waiting for the hose?
Yeah, it's so frustrating. It's so frustrating because a little kid, if you talk to them, they get it because they haven't been brainwashed by the system yet. But for me, one of my partners at my old office was the endocrinologist. He treats diabetes. That's what he's trained to do. So when I started doing low carb and taking all my patients off insulin, he says, Brian, what you're doing is so dangerous. And I said, why is it dangerous? He said, because people get low sugars. Why would they get low sugars? Because if you give them insulin and they don't eat, their sugars will go low. I was like, okay, then you don't give them insulin. Well, if your patient who's on insulin, how do we dose it? And I asked him, how do we dose the insulin? By how many carbohydrates you're eating. So how many carbohydrates are you eating for breakfast? We give you that much insulin to cover that meal. Then at lunch, how many carbohydrates? Your snack. And so we're shooting insulin all day. And the more insulin you shoot, you get more insulin resistant. So then you need more and more to bring the sugars down. So I said, okay, if your patient wakes up in the morning and they're sick, they have the stomach flu, they can't eat breakfast, how much insulin do you give them? He said, well, you can't give them insulin if they're not eating. Okay. How about lunchtime? They still can't eat. How much insulin do you give them? Well, you don't give it to them if they're not eating. How about dinner and they can't eat because they're sick still? Well, you don't give them insulin. I said, okay. So instead of being sick, they're healthy when they wake up and they decide to have some eggs for breakfast. How much insulin do you give them? None. Why? Because they're not eating carbohydrates. So are you treating, like you're saying, are you treating the drug with the diet? You're telling them to eat more carbohydrates so they don't get low sugar because you're giving them a drug to lower their sugars. It makes no sense at all. And that's what we do in the hospitals. They put people on, they're diabetic and they go in the hospital for surgery and they put them sugar in their veins. And they say, oh my gosh, their sugars are going high. Well, you're giving them sugar all day. Stop giving them sugar. Give them saline and you don't have to give them insulin. Then they give them insulin and sugar and it's a disaster. So yeah, absolutely correct. It's such a backwards thinking. It's like they're thinking about low sugars and we're thinking it's like, okay, if you don't eat the sugars. And even the other thing that's very interesting on this is a lot of people will say, well, when they eat their cereal for breakfast and their pancakes, they get low sugars before lunch. And they say, oh, I have to eat more sugar because I get low sugars if I don't eat sugar all the time. Well, if you stop eating sugar, then you don't get low sugars because the low sugar is coming from your body's insulin going. It's the same thing. If you eat a bunch of donuts for breakfast, your sugars go high and then insulin goes up and overcorrects and it goes low. And you go, oh, I need some chips. Then you eat chips and it goes up and down. So all day it's going up and down. But if that same person eats eggs for breakfast with some vegetables, they're not hungry until after lunchtime. They go, oh, I don't need lunch. I'll just eat dinner when I get home because they're not starving all day. So hypoglycemia is an issue. And so people who have hypoglycemia frequently are more likely to get diabetes because they're making so much insulin, they get insulin resistant, then they get diabetes. Hopefully that makes sense.
Yeah. So they are, as you're describing, they are always on that, roller coaster and you are helping them come off of that, right? Instead of just, correcting one with the other. So those two wrongs are not making a right, basically.
Exactly right. Yeah, exactly right.
Also wanted to ask you, what are some of the key interesting research findings that you are observing in this, overall low carb space that you are most excited about, that you are sort of looking forward to?
Yeah, there's so much out there that I'm so excited about. The more that comes out every day, it's like, oh my goodness, this is confirmatory. This is confirmatory. This is confirmatory. So what I'm really excited about, I think probably the most is the mental health. If we can prevent one of the scariest diagnoses that we can get is dementia. When you can't think anymore and you're a burden to your family. So, these studies that they're doing with on metabolic health with Chris Palmer, it's very important. Depression, anxiety, stress, all those things are huge, huge factors. And we think about the diabetes part of it, but I think when we step back and we start saying, okay, metabolic health, meaning getting the mitochondria, the power centers of the cell healthier, and people say, I feel my energy is coming up, I feel better, I don't feel like I have to eat all day, I'm able to go and do things, and I'm laughing more. And when you see someone's life get better, that who wants to live longer if you're miserable and unhappy and you hate what you're eating and you feel tired all the time? People want to have energy and they say, I feel like going hiking. If I get it, like my patient I was telling you about, when she was inflamed by eating so much sugar, her joints hurt. Like, you think she's going to go exercise? But when you feel great, you go, I feel so good. I want to go walk. I want to go do something. I have energy. And now I can go do stuff. And it's a misconception that, people are lazy and then they get obese. A lot of us have worked hard and exercised and done all the right stuff, but we ate terrible diet. And we can't outrun a bad diet. You can't run enough to, like my patient who got diabetes when he was 150 something pounds because he was eating so much sugar, his body just said, I can't take it. I can't keep up anymore, and stop making insulin. So once he rested it again, then he can start making insulin and getting healthy. So it's a big picture, but I think those are the most exciting studies I'm seeing. And then, the decreasing of cardiovascular disease. I'm really intrigued by what Dave Feldman's doing. And once we have data to say, yes, look, these people are having hugely high cholesterol and they're not dying of heart attacks, we feel a lot better about our position. But until then, we have to say we don't know. I don't know if I see someone with the LDL cholesterol of 1,000, it worries me, and I want to intervene on that. And sometimes it's adding more carbohydrates into the diet if they're very thin, and they do better. And exercising a little less sometimes. If people are exercising 4 hours a day, sometimes their sugars are crazy high. So we decrease their exercise, increase their carbohydrates, and they get better because their body's not so stressed anymore trying to look for energy. So it's really just individualizing it for each person. And I think the more and more research that's coming out, we're seeing study after study that's showing that people are doing better from a diabetes standpoint. And all we can do is say, okay, like I heard Dr. Berry talking about the study from Harvard saying that meat causes diabetes, and if you look at the data and you look at your continuous glucose monitor, you realize that's a crazy statement. Because I could always make an argument if, for instance, if I'm super low carb and keto and I go for a huge run and I work out really hard and I ride my bike up hills, my sugar goes higher than anything with that. Because my body says, oh, you need sugar. I'm going to make some sugar and kick it out to you. I'm not getting low sugars when I'm exercising. I get high sugars. So you could look at that and say, well, exercise is dangerous because the sugars go up. Well, no, that's how the body reacts to strenuous exercise or stress. I see people who are stressed all the time, their sugars go up. When they're calm, their sugars come down. Getting a massage or doing something you enjoy. So I think the more data we have and the more clinical experience, that's what I'm excited about is things like what Dr. Unwin is doing over in the UK and seeing people lowering their sugars and insulin and their quality of life gets better and they're laughing again. I think we went into medicine to help people, not to manage symptoms for the rest of your life and, do amputations and put you on dialysis and try to keep you alive and you're miserable the whole time. We want people to have a quality of life. And like you said, so many people just say, well, you're getting old. So, that's what you expect. And then you see, people in their 90s who are out hiking and working out. I had a guy, we were riding our bike and a guy, he had to be 90 and he's ran past us on it, just running. I go, wow, this guy, he's not sitting around watching TV all day and saying, okay, I'm old. You keep fighting and doing what you can to make yourself a little bit healthier.
True. So true. So that's quite inspiring to know. So from your, all the examples that you gave, one question that arises is, can something be done to include more of this, when our doctors are being trained, in their syllabus or while they're in medical college? What's your take on that?
It's a hard thing. I think over the last couple of years, I've realized that medicine has been hijacked. When you have it's a hard thing. Like the American Diabetes Association, if you look at their funding, it's on this side it's pharma, on this side is big food, right? So pharma says eat all the food you want, eat chips and crackers and all that, and we can shoot you with drugs and we can help you. And the food says, well, you can eat all of our stuff and then you can just take the drug and then you'll be okay. It's like, well, the stuff doesn't disappear when you're eating terrible foods all the time. So there's a conflict of interest, and it's hard because if all of a sudden the ADA comes out, the American Diabetes Association, which everyone in the world is basing their recommendations on, it says, you shouldn't eat cereal. Then the cereal company says, okay, we're not sponsoring you anymore. Then they go bankrupt, right? So it's hard because once you get this conflict of interest, it's hard to get out of that. So what do you do if you're in charge of this corporation? Because the reality is we're advocates for our patients. And unfortunately, once you're taking money from other sources, then you're no longer objective and you lose your perspective. So I think that's what's happened with a lot of organizations. Now they're kind of hostage and they can't really say anything. Says, if I'm sponsoring your if I'm paying for this meeting and you start saying bad things about me, I'm like, you know what? I'm not paying for this anymore. So then you guys, so that's what I mean. There's a huge conflict. And so that's why, when you look at nutritional education, a lot of the big foods like, Coca-Cola does most of the funding for sports medicine research, and they say, well, just exercise more and you could drink Coke all the time. So it's a conflict of interest and it's a problem. And I think that's something that, some of the good doctors are really looking at, saying, how do we fix this problem where there's not because the reality is when you're doing a low carb or ketogenic diet, there's really no money to do a ton of research on that because, none of us want to fork out all of our money to do a study when clinically we're seeing the benefits. So all I can say is like, here's 50 of my patients, you could talk to them and let them tell you what their life is like, right? And so that's why we did low carb MD, to get more doctors. And what you're doing is getting more doctors to say, yeah, this is what I'm doing and here's what my results are. You can look at my charts, you can see the data that speaks for itself. And that's ultimately what Professor Noakes and Gary Fettke did, is they said, look at our charts, look at our data, look what we're saying. And they said, okay, you guys, but they went through 3 years of torture to get there, but they had the courage not to back down and say, okay, because they gave them both the option. You could just walk away and not saying anything and we'll just let these charges drop. And then they said, no, we'll fight you, because they knew, and if they don't fight, we're not talking right now.
Yeah.
Right. Because we're not going to take I'm not going to go through 3 years of trial and deal with all that stuff. But they had the courage to stand up and say, look, the system's wrong. And so until doctors stand up and say, hey, look, the system's wrong, when I put people, because I saw it too. You put people on a high carbohydrate diet and their sugars go higher and you go, well, this doesn't make sense. Put them on eggs and they get better. right? Give them a steak and they do better, or fish and they do better. So, I think we're all going to evolve over time, and we're going to say, oh, eating too much fat might be a problem. Let's eat more protein. Eat more protein is a problem. Let's get this balance right. So ultimately, it's an individual thing, because the end of one experiment, like for instance, for you, what works for you? It doesn't matter what works for Sean Baker. We're not Sean Baker. So when you talk about the genetic component, like you can't, I heard someone just recently say this, and I kind of liked it. You can't take a Basset Hound, which is a big, thick dog, put him on the treadmill, then it becomes a Greyhound, which is really super skinny. But they could be the healthiest Basset Hound they can be. So some of us are never going to have six-pack abs and have muscles like Sean Baker, but we could be as healthy as we can be, and we can go for hikes with our grandkids, and enjoy our quality of life. It's not all about looks; it's about metabolic health, right? To ultimately. So it's just figuring out where you want to be and what quality of life you want to have. Most people don't want to be in the gym for 14 hours a day. They want to go live their life and go have fun, right?
True. Yeah. Perfect. No, I think this is so inspiring listening to you. I'm sure both for all our viewers as well as your peers and colleagues. Let me invite Shashi to come back just to say a few words.
Dr. Brian, thank you for accepting this invite and appearing in the pioneering event of India, Metabolic Health Conference, and the first low-carb conference. Thank you. Really indebted to you, and so happy to have you in this platform.
Oh, I'm so happy to be here. Thank you both. Thank you so much. And it's amazing what you pulled together. I mean, you did such a great job. So I'm really happy for you. And I saw the next speaker, and man, every speaker you've had is just amazing. So it's so great to get the word out. And I appreciate you. Like, we all do our part in our part of the world, and say, okay, I'm going to try to educate doctors, and you're going to try to educate the masses. And I think we all work together, and it's amazing what we can accomplish. And when people hear the stories and see it and see their family members doing better, that's what's going to win people over, the results that we see, and so it's fun, for my practice, I've never advertised. I'm like, you know what? If I can't do it on word of mouth, then I don't belong in medicine. If I can't get enough patients say, hey, look, I'm doing great, I'm happy, I'm feeling good, then, I shouldn't have to advertise on the news every day to try to get patients, because word of mouth. And so what you're doing is so important, because, when you reach one or two people, they reach 50 people. So, thank you for what you're doing. And for, it's hard to put all these doctors together and get the timing right. So it's amazing what you pulled off. So my hat is off to you both.
So it's a joint effort between me and Anup Singh of D-Life. So he's my guru, and this is a joint venture that we have done it together. And plus, of course, the entire team is with me. I mean, this is not a one-man or two-man show. This Mandar and then a lot of others on the back end who are all working together to make it happen. And in this program, we wanted to invite only doctors and low-carb organizations, because Indian public will believe doctors only. So we wanted doctors from different nations to come and tell that low-carb is safe, and the organizations what work they are doing in the low-carb front. So highly obliged. Thank you very much, Dr. Brian. Thank you.
All right. Thank you all. Andrea, good
Thank
to
you
see
so
you,
much.
Doc.
Thanks. Bye.
All right. Thank you.
Thank you.
Hello.
Hi, everyone.
Hi, Dr. Andrea. Such a pleasure to see you. We're so happy to be hosting you here. Welcome to India's first mega event on metabolic health and low-carb nutrition. And welcome to India.
Thank you. Thank you so much. This is just incredible. I'm so honored to be here and to be on this list of wonderful speakers and wisdom, truly, that is going to be shared with the world. So thank you so much. And thank you and hello to all of my Indian family. And I'm just so happy to be here. So what an honor. Thank you.
So Dr. Salcedo, let me just introduce you. We from the D-Life family have connected with you earlier and we've spoken quite in depth on women's health, but I'd like to take a moment and introduce you to our larger audience as well. So Dr. Andrea Salcedo is a gynecologist and obstetrician practicing in California, USA. With 20 years of experience in her field, she also specializes in metabolic health and uses low-carb, high-fat diet as an adjunct in the treatment of abnormal uterine bleeding, irregular periods, polycystic ovarian syndrome, and many other gynecological problems. She's currently an assistant professor of obstetrics and gynecology at Loma Linda University of Health. She was also the medical director of General Gynecology Services. She's a medical expert at Osteopathic Medical Board of California. She's a medical consultant at the Noakes Foundation and a Nutrition Network certified practitioner. She's certified by the American Board of Obstetricians and Gynecologists and the American Osteopathic Board of Obstetrician and Gynecologists. So Dr. Andrea has also published quite a few research papers, predominantly on women's health and abnormal uterine bleeding. Two of her papers are carbohydrate restriction therapy and how it helps in prevention and treatment of abnormal uterine bleeding, insulin resistance and other risk factors of cardiovascular disease among women with abnormal uterine bleeding. These are the two papers that she's published. She's also a practitioner of low carbohydrate lifestyle and strongly recommends it to her patients, along with using it as part of her therapy. She's highly skilled in her field and is known for her exceptional medical expertise and compassionate patient care. She goes by her Twitter handle and other social media handles as the Conscious Gynecologist. So Dr. Salcedo, that's a lovely handle, the Conscious Gynecologist. I think it makes so much sense when you're not just looked at as a doctor, but you're so conscious about so many other parameters that are missed by regular medical experts. So firstly, I'd like to ask you a bit more about yourself in terms of how did you get in touch with low carb? How did you adopt it and start believing in the LCHF paradigm?
Thank you so much. That was a really big introduction. And I think, wow, how do I have all this time? But I really do appreciate it. Thank you, Shashi and Anup, for the opportunity, as well as Anjali for your time. Yes, I am a full scope OBGYN. I do surgery from cesarean to hysterectomy. I deliver babies. I take care of women all through their phases of life. Just yesterday, I saw a 10-year-old and a 75-year-old. And so there's a huge range of problems in women that I take care of. But really what I think when we're looking for our purpose and trying to figure out what we're going to do in life, we think about what keeps us up at night, right? What are the problems that we're trying to improve in the world and in our own, sphere of influence. And to me, I was starting to feel frustrated with routine gynecologic care because when I was in training, I was able to have, I was married and had my first son, and it was very easy. But then when I graduated and I became practicing in a very busy practice, I was making a lot of money and I was just really flexing my clinical skills. And I just couldn't get pregnant and I couldn't figure out why. And I was having normal periods, but they were really heavy and very painful. And but I thought because I was having regular periods, I should be able to have a baby very easily. And I ended up with a big endometrioma, which is like a big blood-filled cyst on my ovary. And I got it removed, but I had to lose my ovary as well. And my gynecologist, just like most gynecologists who have wonderful intentions, recommended that I be started on birth control pills. And I just didn't accept that. I just felt like there has to be more. All this training, years and years, there has to be more, because birth control pills didn't make sense for me. I was trying to have a baby. And so I decided to really take a close look at my life, and probably a lot what Dr. Lenski's was describing right now too, is lifestyle management, looking at stress. And I quit my job and I decided to focus on myself and reduce a lot of the stress. And not 4 weeks after I quit my job, I got pregnant, and I had a miscarriage, but 2 weeks later I got pregnant again, and I was able to conceive and had a wonderful delivery, and it was no problem. And wow, that just was such a very interesting lesson for me to learn that, wow, I was able to kind of figure out my life. And I started looking at nutrition and how that really did play a role in my balance. And I started looking at gluten-free diets and looking how that played a role in my endometriosis, and it helped a lot. But in the States, a lot of the gluten-free alternatives end up being a lot of corn and grains. And I still was having struggles with heavy periods, even though I didn't feel too symptomatic as I was before. And I ended up starting my job at Loma Linda, which is a wonderful institution of learning and lifestyle. And I wanted to have another baby. And when I got pregnant with my third, I ended up getting gestational diabetes. And I was 120 pounds and 24 weeks pregnant. I couldn't figure out why I had gestational diabetes, and neither could my colleagues. And so, I mean, my 1 hour glucose test, and I don't know if there's what the conversion is in other areas, but it was 197. It was really high. And so I couldn't figure out, I was eating grains and chicken and low fat. And I just was like very surprised. Well, I was personally determined not to go on insulin. And so I started reducing a lot of the carbohydrates, even though that isn't standard of care. And so I really, really, really was strict and reduced and a lot of the simple carbohydrates, and even the quinoa and the grains and the rice and the brown rice. And I became probably, too low, but I don't know if that's even a thing, but it felt absurd in where I was at that time. But my son was 6.5 pounds, about, little less than 3 kilos, full term. The delivery was super easy. And then during my postpartum recovery, I just started diving into how there was such little information that women needed to help really reduce those risks of gestational diabetes, chronic medical problems in gynecology. And so that's when I found the Nutrition Network. The Nutrition Network started teaching me that the organs receive inflammation, just like, the kidneys and the liver and the heart, and they receive organ damage from hyperglycemia. And that's when the light bulb moment happened. The light bulb moment happened where I felt like, well, why isn't the uterus considered an end organ that receives inflammatory change just like any other organ in our body? Why not the ovary, right? So, man, that just opened up so much room for investigative discovery and creative thought that I really dove in, and I just immersed myself in this culture. And that was about 6 years ago. And so here I am, but just like you, Anjali, just feeling frustrated, feeling confused and wanting more. And that's where I am today. So. Oh, sorry. I think you're muted, my friend.
Sorry. Yeah. I said that is such a journey. I mean, it's so risky, especially during pregnancy, for someone to even change from or deviate from the normal care pattern, right? Or take any risk with their dietary patterns. I think that was something very brave on your side. So now you also mentioned that ever since you've learned about nutrition and you've learned about low carbohydrate and the uterus problem. So now you did mention that you use low carbohydrate therapy as a supplement treatment for gynecological problems. Can you help us understand a bit more about that?
That's right. Very good question. So the fundamental concepts are basically high insulin levels and inflammation. Okay. And so most problems within gynecology seem to stem from those
those two problems. So there's either an elevation in inflammation that can damage our blood vessels and lead to, fibroids or impaired receiving of the ovaries to receive oxygen and nutrients to have healthy ovulation. But also elevations in insulin can actually block our what we call the hypothalamic pituitary ovary axis, which is the signaling from the hypothalamus to your pituitary gland to your ovaries to cause ovulation. And a variety of factors can influence changes in the inflammation as well as the insulin level. And it's not just diet. And sometimes it is, simple carbohydrates and processed food. But other times it's not sleeping well. So other times it's stress, anxiety, intimate partner violence, low vitamins, sleep apnea. Sometimes it's even things like not a very good job, feeling a little bit undervalued. All of these things really do activate our trauma response, our inflammation response that damage our blood vessels, and our blood vessels will supply all of our organs, and they also elevate our insulin levels. And biologically, women, and I'm a professional woman, and I really support women doing lots of different things, but biologically and evolutionarily, we were made to have children. And so when our body senses that we're under a stress, then it's going to protect us from reproducing during a time in our life that might be unfit. And so that's where elevations in insulin come, and it's actually a protective factor. Insulin is a protective stress hormone for women particularly, so that we do not conceive at a time that is not appropriate. Because if you think about the nutritional investment of conception, pregnancy, and delivery, that's easily a 3-year commitment, right? And so for women, it really does impact our physical and mental health. For men, for a long time, we do really have to be ready to conceive. And so if there's anything that will influence or impact that negatively, insulin level will go up, inflammation factors will go up to really reduce our chances for ovulation and getting pregnant. But chronically, and that's okay once in a while, right? We all know that sometimes we're in stressful times in our life. Maybe someone passes away, or we're in our final examinations and we skip a period, and everyone kind of knows why that is. Oh, I was very stressed out, I missed my period. We understand that. However, chronically, over long periods of time, that really does impact a woman and can lead to polycystic ovary syndrome, other problems with heavy bleeding, but also fibroids. And then eventually, it can turn into uterine cancer when many years down the road. And so it's important to understand the impact of our lifestyle and on our womanhood. So yeah, absolutely. There's so many things.
True. So you did mention polycystic ovarian syndrome, PCOS. I think, let me go to that question. This is a very, very rapidly rising issue today. Going back 20 years ago, maybe people would never have heard of this term, but right now, in India, at least 1 in every 5 women, in fact, more in girls, adolescents, and teenagers. You see a lot of them having some kind of a PCOS syndrome or some kind of a symptom which gets pointed out as PCOS. And it is increasing as women age further as well, therefore resulting in complications of conception and so on and so forth. I think even in the US, it's on the rise. It's maybe the numbers may be slightly lower, but I think it's still there on the rise with Mexican. I think it has a connection with the race as well, because Mexican American and other different races have different numbers. So can you just give us some idea as to why there is such a rapid rise? And do you see any connect with the food, lifestyle, and this disorder?
That's a wonderful question. And a lot of times people think, well, why is PCOS even a thing? Like, what is that about our biology that has brought us to this point? And I am very interested in evolutionary biology. I've actually looked into a lot of evolutionary biology papers about the purpose of PCOS and why the gene has stayed with us for many years. And it is not just one gene. There's, different polymorphisms of our, DNA that kind of predispose women to having this PCOS disposition and not. And PCOS is polycystic ovarian syndrome. It is a syndrome. So sometimes that means that it kind of comes and goes depending on your metabolism and where you are in life. And so there are many different organizational bodies that actually argue over what the criteria is. But by and large, it is usually some function of irregular periods, hair, or extra testosterone features where you don't want them. So thickening skin tags, darkening of our neck area, chin hair, those kinds of things, or losing some hair on the top of our head. And very tiny cysts on your ovaries that can be seen on ultrasound that don't require surgery. And so usually we say that if you have 2 of the 3 features, you do meet the criteria for polycystic ovarian syndrome. And honestly, PCOS is really pre-diabetes. It is some of the first phases of diabetes as it relates to womanhood. And if we think about why that is, the evolutionary biology suggests that women who are more predisposed to PCOS have a little bit of a higher glucose level, okay? And if you have the higher glucose level, the function of that is so that your body does feel nourished. It feels that there are enough reproductive and nutritional stores to conceive during times where there's extended periods of fasting. And so when we have women from our ancestral cultures, thousands of years ago, there were times where there was not a lot of food. And so because of that, we were fasting for long periods of time. And so women with PCOS features or PCOS predispositions had a little bit of higher level glucose levels to allow us to continue to ovulate. Okay. And so that's why that PCOS has lasted so long, because that elevation in glucose has allowed our body to reproduce even under extended periods of fasting. Now, that being said, PCOS actually turned into a problem of modern civilization because food is so plentiful now. Okay, we can go down the store, get a stack for me and my culture, a stack of tortillas. We can get lots of bread very easily. But if you think about how long it used to take our ancestors to make rice, to cure the corn for corn-based foods, make bread, it was not something easy. It took a long time and a lot of care and a lot of just caring for the nutrients itself, that we didn't overeat on a lot of these things. And so but modern civilization, because of how plentiful the food is, it has really raised our glucose level, and then as a result raised our insulin level, and then it starts the cascade of elevated testosterone and blocking our ovulation. And so honestly, PCOS is a disease of modern civilization, because all of these genetic polymorphisms that have been present in so many women were present for millennia, but really are more prominent now in a pathologic way in modern times. But it was actually something that helped us, for thousands and thousands of years. And so you're right. People of color tend to express this a little bit more. The actual prevalence in the world is about 10 to 12%. However, particularly in diaspora cultures, so in cultures like the Mexican American folks that come from Mexico or Latin America to the United States, States, Indian families that migrate in other areas. And I think that one of the studies that I read in the United Kingdom showed that 50 to 60% of, South Asian Indian women have PCOS. That's a huge number. And it really has to do with so many multifactorial factors of not only diet, but the stress of the immigrant experience, right? The stress of the immigrant experience is also very prominent and causes elevations in insulin levels too. And so it's not just diet, but all of the other factors that are involved. But yes, it is definitely a disease of modern civilization.
So what I understand from what you're saying is the so-called PCOS, some of the symptoms, you're saying that is inherent, that was there, designed for protection, designed for the betterment of a body, but it's becoming, or it's turning into a wrong way simply because of the evolution of our society today, simply because of how we've shifted our food habits and moved to wrong or bad lifestyles. Am I right?
Yes, it's just, too much exposure to carbohydrates, plentiful foods, and the modern lifestyle. Absolutely.
And let's not forget the stress, right?
That's right.
So when you were saying primarily, because PCOS, you say, is a pre-diabetic case, and I do see patients, being prescribed metformin, which is a diabetic medicine, as one of the first steps in resolving this. I see a lot of women who are, which may be on the obese side, and you can see that they have overweight and they have some pre-diabetic symptoms, and you can see the insulin resistance there. But I've also seen, on the other hand, young women, girls who are not so obese. In fact, a few of them are underweight, and they still show a PCOS issue. They still show a lot of these symptoms. And these are all the young ones. I mean, college-going students, late teens and early 20s, those kind of a population. So could you just bridge the gap between these two?
That's an incredible question. And it's something that's always on my mind too. And I start to notice it clinically. You're right. And when I describe to patients about how their body deposits fat and inflammation, it really is a difference between how their genetic makeup has directed their ability to process sugar. Okay. And so some people, and these people, there are some people who are very thin, stick straight thin, and they can eat pretty much anything and they don't get chubby. And and you can kind of see a little bit on their tummy, that maybe they kind of carry it in their tummy, and it's very frustrating. And then there's the poor person who can barely even look at a piece of cake, and then they get round everywhere. And that's actually a thing. There is a difference between how we deposit our adiposity. And so there's the visceral adiposity, which is in our stomach area, and that's the thinner person. And we call these TOFIs, right? Thin on the outside, fat on the inside. And then then there's the more peripherally obese who tend to shuttle their insulin and glucose into their peripheral tissue. And so it really just depends on how your genetic predisposition of how you manage that. And you're absolutely right. There are thin people. Actually, some of the worst diabetics that we have are people who are quite thin because maybe their practitioner hasn't noticed, like, oh man, it's usually the thinner people that we have to be worried about, because the thinner people are the ones that actually deposit their adiposity in their midsection, and that is extremely inflammatory, and that actually will impair also our vital organs' ability to process and to function appropriately. And so because of that, their insulin levels are not able to keep up with the amount of carbohydrate load that they're having. And sometimes it's not even that much. And so these people have a little bit of a lower insulin level, but really high glucose levels. And those glucose levels will start to, cause problems in their entire body, usually, assisted by their vasculature. And then you get a lot of the end organ damage. So it's, these are the people that hear of the marathon runner who had a heart attack and was super thin. That person was likely diabetic and or had end organ damage and was probably carb loading. And then there are other people who are peripherally obese. Their pancreas works really well at shuttling, increasing insulin and shuttling all of their glucose into their peripheral cells. Their hemoglobin A1C is normal or below normal. And you look at them and you're like, how come you're not diabetic? But actually, the damage from the peripheral obesity is present because the peripheral obesity, the peripheral adipose tissue secretes cytokines and prostaglandins, which are inflammatory molecules that continue to wreak havoc on the rest of the vital organs as well. And so it just takes a little bit longer for that to happen. And so, yes. And then in gynecology, what we're noticing is that ladies who are thinner, the PCOS person tends to eventually get uterine fibroids in my observation. And those women, because they have such high levels of glucose in their vasculature, will have also similar inflammatory effect at the vasculature of their uterus, because the uterus is made of the same smooth muscle as our blood vessels in our body. And so if it receives that inflammation, it'll start to create these fibroid tumors. And so a little bit thinner women will start to get the fibroids, and then the ladies who are more peripherally obese will start to get the inflammation at the lining of the uterus, at the microvasculature. And so these are women who have normal appearing uteri, but the lining of the uterus is very inflamed and they have really heavy bleeding, or they eventually are predisposed to uterine cancer itself. And so absolutely, it really just depends on what your genetic makeup is and how your body, through the many polymorphisms, process sugar. And then that's how your manifestation of chronic disease will reveal itself.
That is quite insightful. I don't think we've ever looked at it from that angle when you look at a personal threshold, because you always tend to presume that when you say insulin resistant, they should be on the heavier side. They should be on the bulkier side, carrying a lot of fat. But then you suddenly see a very thin girl or a woman coming and, saying that she's diagnosed with PCOS. It gives you a little bit of a shake, saying, oh, this is possible. I think your explanation really clarifies that. Thank you.
Oh, yeah, you're very welcome.
I'll move on to the next topic, I think, which is also your favorite and close to the heart, and abnormal uterine bleeding, because you've done a couple of papers on that. So currently, in this kind of an issue, the abnormal uterine bleeding or a dysfunctional uterine bleeding, the current course of treatment is largely oral contraceptive pills, right? But in your study, you strongly connect it to insulin resistance. And you're also mentioning low carb as a therapy. Can you help us with some insight and help us understand why? Because you have on one side, you have all the pharmas, all the doctors and hospitals pushing pills and, really recommending young women who have this problem to go on a hormonal pill. But you put it very simple in terms of saying that, no, it's just a change in the dietary pattern. So if we need more information, please.
Yes, thank you. And this is truly the essence of what I am trying to promote, because as OBGYNs, as gynecologists, we've done so much training and investigative discovery in pharmacology and surgical technique. We're really good at it. We're really great at treating women's acute medical problems and chronic medical problems. But I think that as doctors, sometimes we have overlooked the impact of diet and lifestyle in the development of these diseases. And so the American College of OBGYNs, which does give a lot of guidelines of how we direct our care, does promote lifestyle changes as the first line treatment for polycystic ovary syndrome. The problem is that many of us doctors don't know how to promote what diet really does make a difference. And so from purely a physiologic standpoint, that's why I think low carb lifestyle really makes sense to me, because physiologically it makes sense. If you reduce your carbohydrate load, then you're going to decrease your insulin, and then that will help women ovulate more and decrease the inflammatory response that initially begins with PCOS. And so from that concept alone, then we're able to really apply it to many different factors. And so what I think has happened in gynecology, though, is, and in a lot of primary care, is that we've siloed women's health as a problem of our female hormones and not as a problem of our insulin factor. And so, I have every day, multiple times a day, I have patients coming to see me who said that they need to see their gynecologist because of their female hormones, that there's something wrong with their female hormones. And yes and no, really the big modulator of all of this is insulin, because insulin is actually what changes the signaling from our brain to our ovaries and our uterus. And so if we don't focus on the root cause of disease and just treat the symptoms, then we're not doing anyone any favors. But it really depends on where patients are at, because I have patients who are just in the beginning stages of problematic gynecologic problems, heavy periods, irregular periods, but their blood markers are by and large okay. They're not anemic, and so where there's a lot of room for lifestyle changes while they're trying to get healthy. Now, I have other women who are in the hospital needing blood transfusions or in severe pain or a large fibroid uterus at the size of a full-term pregnancy that they need more. And so, lifestyle is going to be a really important factor. But on the other hand, they do need medical and surgical management. And so my job is to really just share with women how they got there, because just because I can give someone birth control pills or surgery to help fix their immediate problem doesn't take away that this problem has been developing for years and years and years. And so it's a really great insight, because it brings a lot of patient satisfaction about how they got there. And then oftentimes when people have the choices of lifestyle, medication, and surgery, if they're in a stable position in their health, then they can choose, right? Because that's just what patients have the right to do. The patients have the right to choose what kind of treatment modality. But what really has made my practice incredibly fulfilling is that offering the lifestyle piece, or sharing how the evolution and the pathology of how women got to where they are, has been incredibly fulfilling for both myself and my patients, because they feel like it's not just because they're a woman that they are experiencing these problems. The way women manifest chronic disease is through problems with their bleeding. But that's just because they happen to be a woman, not because they are a woman, okay? And so that's really important. And men, they actually experience the problems very similarly, but in a different way, with erectile dysfunction and things. And they're starting to feel like, maybe I don't have enough testosterone, and that's only a small piece of the puzzle. It's years and years of chronic inflammation that has led to these problems, so. Oh, I don't think we can hear you.
Right, sorry. Yeah, I think the pills do have a side effect, right? Long-term usage, because they are synthetic hormones and they are externally had, So irrespective of the safety or whatever the doctors may say, is it right to presume that consuming these contraceptive pills over a period of time can create a problem in the later stages?
That's a great question. And so, does long-term, contraceptive use, cause problems chronically? That really just depends on the patient. There are some people who are not candidates for taking, estrogen-containing contraceptive pills. And there are people who have a history of an embolus or a blood clot in their leg or their lungs. There are people who've had heart attacks or strokes, people who have blood clotting disorders, people who get migraine headaches with vision changes. And those are people who really do need to steer clear from hormonal contraceptives. But then there are, everybody else chronically, is it okay to take them? Yeah, it sure is. Will it cause some chronic medical problems? Well, it does slightly increase your risk for hypertension and heart attack and stroke, just for the reasons that estrogen does thicken your blood a little bit, and so, yes, if you already have those predispositions, then yes, it can cause some problems. So when you share with people about about those adverse reactions, then you can say, hey, does this work for you or not? Now, does it reduce fertility? No, it does not, but what I will share is that the way oral contraceptives work is that they actually block your brain's signaling to ovulate. Okay. And ovulation is kind of like what makes women feel like women. It really does rise. It makes your ovaries cause a rise in estrogen. And estrogen is like the fountain of youth for women. It makes us feel beautiful. It makes us have really pretty hair. It makes our skin really nice. It gives us a lot of motivation, particularly during our ovulatory time. It makes people have a lot of libido and makes you interested in sex. And so when women are on birth control pills it blocks that, and it just keeps those levels stable. And so one of the big complaints that people have with being on birth control for a long time is that they have no interest in sex, or they feel a little bit depressed, or their mood just feels static. And so a lot of times people actually have like changes in their vaginal chemistries because of the lower estrogen levels from being on birth control for a long time. They will even have kind of complaints of like even menopausal symptoms of hot flashes, because the amount of estrogen that's in typical birth control pills is actually quite low. And so it actually decreases that to a pretty low state. And so a lot of people are very sensitive to that. And so birth control pills and, hormone therapies are very helpful for certain people who need a little bit of assistance. And a lot of times when patients are presenting to me with, pretty heavy bleeding, but they want to apply lifestyle changes to get themselves better. Remember, it took years for people to get to a point where they're at with heavy, painful periods. It's going to take a long time to also turn over the tissue repair and to heal those tissues. And so I always tell patients, this is not forever. We're going to be on this regimen just for a short amount of time, and then we'll kind of check to see how you do. We'll stop it. And so I think having that mindset of deprescription, of deprescribing something that maybe you might not need forever, really does make patients feel like, oh, okay, this isn't forever. This is just for a little bit of time while I'm starting to try to improve my lifestyle. And it really does help. And the reason why it helps is because it stabilizes the lining of the uterus. And so estrogen and progesterone, are really what cause a lot of the tissue growth with our uterus, but also in the lining of the uterus. And so if you stabilize those hormones, then there's not so much bleeding. And that's why patients feel a lot better in terms of their quantity of bleeding. It also addresses their painful periods, because then your body doesn't need to rely on so much inflammatory factors to push out the tissue that's overgrown in the lining of the uterus, because it's that your uterus is made to do two things. It's made to bleed and push babies out. And so your uterus is also a really strong muscle. And so as it's trying to push out the lining of the uterus, that can be exceedingly painful as well. And so birth control does kind of stabilize that. And, but it's fun. You just tell patients it's not forever, you're going to get better as long as you kind of follow the plan. And it takes some time, and I'm here for you. And it's going to be, one step at a time, because some folks are not looking for the quick fix, right? Some folks are really trying to help improve their lifestyle. And, as long as you have really good, healthy understanding of how long, sometimes it does take a little longer, but isn't that what we're looking for? We're not looking for a quick fix here. And so that's birth control in a nutshell.
All right. You're absolutely right. I think women today are more and more aware that they're not going to look for a quick fix, and they're not going to be pressurized by family or society to just go in for a pill blindly. And I think most of them, and I'm very surprised, and I'm actually very happy also to see younger women in their early 20s starting to take control of their life when they realize that there's some kind of a problem, and they just don't, crumble under parental pressure. So I think the combination of having a small pill along with a longer, lifestyle intervention does definitely work wonders. So in one of the earlier questions, and Dr. Andrew, you had mentioned that, these inflammatory factors do become stiff in uterus, and they show up as cysts in the later stages, right? And we've been having a lot of older women, let's say around after childbirth, 35 plus 40, many of them who are increasingly showing uterine fibroids and cysts. They're becoming quite common, actually. And in many such instances, when they go for a consult, the immediate solution that most of the gynecologists give them is, let's do a uterus removal. It's like your job is done. You've given birth to children, and what else do you have? So let's take it off. Now, now, what's your opinion on this? And I also have a question to ask: if you think, is this connected to lifestyle and food habits again? Does it have any connection with the dietary patterns that they may be having?
Absolutely. And this is one of my most favorite things to teach my resident doctors in training, is that the uterus is an end organ, and the uterus is made of the same smooth muscle cells as our arteries and veins. Okay. And so over time, with the impact of epigenetics, with basically our current gene polymorphisms, our predispositions because of our DNA, as well as our environmental factors that turn on a lot of these genes. And usually we see this in kind of thinner people, the viscerally obese people, that those inflammatory factors over time cause damage to the vessels and reparative mechanisms that over time will lead to what we call hardening of the arteries. And so that's called atherosclerotic disease. But in women with the uterus, your uterus receives that inflammation in a nearly identical way. And so when that happens, our smooth muscles of the uterus will start to experience tissue repair. And then that causes calcifications and the creation of these cystic lesions in the uterus called uterine fibroids. They're just balls of smooth muscle and inflammation. And so that happens over many, many years. But right now, we're actually seeing it a lot earlier. We're starting to see it in women in their late 20s and early 30s. And we used to just see this like in our 40s and sometimes even our 50s. But I'm starting to see it a lot earlier. I actually have a surgery scheduled for one of my patients who is like 24 and has like a 20-centimeter uterine fibroid. And she's not ready to lose her uterus. So we're going to go ahead and just remove that fibroid itself. But it's like, why, right? Well, the effects of chronic inflammation over time, has caused this tissue damage. And so, I think it's insulin resistance that leads to that. It's the experience of also, chronic stress and anxiety and even trauma that activates these inflammatory factors. And of course, carbohydrates that lead to the damage of the vasculature. So we do see this earlier. So I tell my residents, like, the uterine fibroids are just cardiovascular disease of the uterus. It's atherosclerosis of the uterus. And then once we look at it in that way, then wow, it just answers so many questions, because women who need hysterectomies are usually not the most healthy people, right? They do carry a lot of inflammation, a lot of chronic disease, hypertension. They usually have already had their gallbladder removed. They usually are either mostly viscerally obese, or peripherally if they have, heavy bleeding. And so, it really kind of just depends on how the diet or how the lifestyle is manifesting in their body. But, it is such a huge problem. It's starting to become earlier and earlier. I think when I was in training, 15 years ago, we didn't do as many hysterectomies, and now we're doing them more and more. And a lot of people ask, like, can lifestyle make these smaller? There is no study that reveals that, but I have many patients that anecdotally have said, oh yeah, I've done these kinds of lifestyle changes and my fibroid got smaller. And so I think that is just such an area for investigative discovery to really look into that. And, I don't think it could hurt. I think if really people are trying to be strict with their lifestyle, then it can only be a positive thing. And uterine fibroids, as burdensome as they are with, causing bulk symptoms and constipation and low blood pressure because of the pressure of the uterus on the vasculature, they're by and large very rarely would turn into anything cancerous. Okay. And so if someone decided to not do anything about it and really just delve into their lifestyle changes, I wonder if it could make a huge difference, and I'm still early in the field that I'm ready to do that study. I think we need to do that study. And, but there's nothing wrong with really pushing lifestyle as a treatment modality, because that's what we do for other chronic medical diseases that have the same manifestation of pathology. In fact, those papers that prove that the cells of the uterus behave similarly as our arteries have been present since the 60s and 70s. I mean, we've known this for a long time, but unfortunately, I think with modern gynecology and the utility of pharmacology and surgical technique, we've moved away from understanding the root cause of these diseases. And truly, it's metabolic problems that can lead to these things.
So I think then basically, like what you're saying, it should be the first lifestyle intervention rather than just go in for a shop and cut away, right?
It just depends. It really just depends on how impactful the fibroids are clinically, because I have one lady who can't even lay down flat because the fibroids are so big and she can't breathe because they're pressing on her vasculature. That woman, I don't know. I don't know how much low carb diet's going to be able to help her, and so, it's going to take a long time. And so, yeah, we're doing the surgery for her, but then now she knows and is armed with the information to prevent further problems. And so, I think if someone has smaller fibroids and they're not too impactful, why not? And if they're not bleeding, out, and I always kind of joke with my patients when we do hysterectomies, and they often feel like, thank you so much, you've saved my life. And I'm like, no, your uterus was trying to kill you, but it's because of the inflammation that happened. And so they're just so satisfied when we can offer surgical technique, but truly teaching them how they got there is the most important thing. So then they have their own choice of how do they proceed from there.
Absolutely. Brilliant. So my next question is on menopause, right? So there are a lot of challenges that women do face as they come closer to menopause, 40, 45 plus. So in your practice, what are the type of challenges you've seen, and what are some of the suggestions that you can provide that people of that age can, either manage these symptoms better or, get into an easy menopause or post-menopause?
Great question. So the way I like to frame it is that there are some very important transitions in female motherhood and womanhood, basically, that are associated with insulin resistance, insulin rises, hyperinsulinemia. So that's puberty, that's lactation, that's pregnancy, and menopause. Okay. And so what happens in menopause is that the decline in estrogen, and menopause, the perimenopause period lasts about 10 years. Okay. So it takes 10 years for all of these changes to happen. And so it's coming for me. I'm definitely, it's coming. And so, that being said, what happens is that the decline in estrogen will change our estrogen receptors in our adipose tissue. And so the adipose tissue will start to change, and the movement of adipose from our hips and our buttocks area will start to move into our abdomen. And so that adipose in our abdomen is very inflammatory and causes the insulin rise and insulin resistance. So women during the menopause period definitely need to be, I feel like a broken record. I'm sure you guys feel like that too, but like on a low carb diet, particularly during that time, because the insulin, there is significant insulin resistance that happens during that time because of estrogen and the remodeling of adipose tissue and estrogen receptors. And so, yes, it'll start to go into your belly. A lot of women who have, or in the menopause transition, have a lot of hot flashes, and, they're just so uncomfortable at night, they can't sleep. But we do see that women who have less insulin resistance have less vasomotor symptoms. They have less of those hot flashes, the soaking wet at night. And so really, truly being on a low carb diet, particularly during that time, is very important. But a lot of women during that phase have trouble losing weight. And that's just because they haven't really changed their lifestyle to meet the metabolic changes that are happening. So, some people, a lot of my menopausal women say, I'm starting to gain all kinds of weight. It's all in my midsection stuff. And I'm like, yeah, you really do have to stop the carbs right now. And you'll have a lot smoother transition. So yeah, so that's how it impacts in the menopause phase.
And how important is proteins at this phase?
Oh, yes, it's very important. It's because they will help with your satiety. And that's really the kind of the piece here, is that the fat and the protein is exceedingly important during this transition of life, because if you rely heavily on those, then you won't really rely so much on the carbohydrates and cause a lot of the, metabolic, negative metabolic effects that we're not interested in. So.
All right. I think just in connection with this, I have a question where someone wants to know is there any kind of a supplement or a food that would support these hot flushes? And does fasting also help during this phase?
Yes, fasting will definitely help, because it'll really reduce those insulin levels, and that's a big one. And so, fasting, but also nourishing your body with a lot of the electrolytes it needs during those extended fasting periods. So, I don't really do anything more than like an 18-hour fast. And I think there are some people who like to do longer fasting episodes because they have other chronic medical diseases, and that's totally fine. But you really do need to supplement with, magnesium oxide or magnesium glycinate, some sort of magnesium to help with your metabolic processes, and as well as salt. Salt is really important during this time, to keep, your chemistries intact, and your ability to just kind of have those electronic connections in your cells so that they're working appropriately. Now, in terms of herbal supplements, there's a lot of herbal supplement formulations out there that are very helpful. I'm not too familiar with it, because honestly, I get so much more bang for my buck by just telling people to reduce their carbohydrates, But yeah, for many, many years, there's been teas and herbs, and black cohosh comes to mind, vitamin E comes to mind. Those are really good, helpful supplements that I've heard that have helped a lot of patients. But honestly, the low carb diet really is how my patients receive a lot of relief during that time.
Now, when we talk about low carb diets, or when we talk about the ketogenic diets, you also read certain misinformation or statements that, say, let me not call it misinformation, but there are statements that say the low carbohydrate or ketogenic can cause irregular periods or cause amenorrhea or issues with periods in women. How true is this?
Yeah, I've not heard that. I think the only time that would cause amenorrhea or irregular periods, honestly, would be that initial phase when people are on it and their body is transitioning from carbohydrate metabolism to ketone metabolism for maybe 1 or 2 months. But if your period stops while you're on a low carb diet, it might be that it's not a very well formulated low carb diet. It might not be enough fat and protein, and it might be more caloric restriction. And truly, again, your body's very smart. And if it senses that you're under a stress or you're in starvation, right, then it'll start to protect your ability to conceive, and it'll shut down your ovulation, which is what happens with people with with anorexia nervosa and bulimia. And so when they have significant nutritional deficiencies, then your brain will say, no, it's not a good time to have a baby, and will shut down your ovulation. And so, yeah, I think, if understanding the chemistries and the metabolism will really shed light on what is happening, and having a deep dive into how a person is doing their low carbohydrate diet. It's not internet keto, right? It's not just looking at what the internet is saying and, social media, but having really good prescriptive advice about how to do a well-formulated ketogenic diet or low carb diet, makes the most sense. So
I'm glad I clarified that from you, because I was a little surprised when I saw this as well, because I've had people come to me and they say their periods have come on time without any medicine support, because they would earlier use medicines to induce their periods. And then once they shifted to a low carbohydrate, low sugar diet, the periods automatically sorted themselves. So I'm glad I clarified this question with you.
Thank you.
So, Andrea, we just have 5 more minutes, and then I have one last question. I'd like to hear a unique case study from your experience where you've been able to apply the ketogenic therapy or the low carb therapy, and you've been able to see a huge change or a large improvement in their health.
Yes, one notable case that comes up, because I think that we get a little focused on PCOS and irregular periods. And we know that, when we apply a ketogenic diet, works really well, and people do fine. But one case that really was exciting to me was this long-term patient of mine who had, she's probably in her mid-30s, and I've delivered, several of her children. She's had, 3 children, but the last 2 kids that she had preeclampsia, which is really high blood pressure, and protein in the urine, which can cause damage to our organs in pregnancy. But that occurred for her after she had her baby, which is not common, but it does happen. And so she was admitted to the hospital, and, she was super thin. She's kind of like, the thinner body type, the thinner PCOS kind of person. And she needed a lot